and my fellow colleagues. I am Dr. Asif Rahman, and it is my immense pleasure to welcome back you all to the second day of the conference, Clinics in Hepatobiliary Diseases 2023, organized by Institute of Gastroenterology, Liver, Pancreatobiliary Sciences, Sir Gangaram Hospital, under the aegis of Delhi Liver Foundation. Yesterday, we delved into a wide range of topics, discussed many day-to-day real-life clinical problems, and unraveled a lot of less explored field in the field of gastroenterology. Today, we will continue our journey of exploration and collaboration with even more enriching sessions ahead. We have a stellar lineup of speakers and experts who will share their experience and expertise with us today. Thank you all of you again to be a part of this gathering. So without any further delay, I would like to start the session. So to summarize, today we have a total of 11 sessions, including one panel discussion and one open house discussion, and in the end, the beautiful musical evening. So to start the first session, the topic of our first session is day-to-day problems in gastroenterology. For this, as the chairperson's seat, I would request to call upon the stage Dr. Apurva Siva, Fortis Hospital, Kolkata, Dr. Bisweswar Panda, Divisional Railway Hospital, Kota, Dr. Nitin Gupta, Satyabham Hospital, New Delhi, Dr. Geeta Rani Ray, ESI Hospital, Kota, and Dr. Praful Desai, Navsari, Gujarat. And for the seats of moderators, I would request to call upon the stage Dr. Nishant Verma, Jeevan Raksha Super Specialty Hospital, Bikaner, Dr. Sabir Hussain, Gastro and Gastro Clinic, Jodhpur, Dr. Prashant K. Padida, SCB Medical College and Hospital, Cuttack, Dr. S.B. Khalko, Ranchi, and Dr. Prashant Solanki, Tirupati Liver and Gastro Care Center, Meerut. I would request all the dignitaries to So I would now request the chairpersons to kindly call upon the stage the respective speakers.
Good morning. The first topic today is infection versus inflammation in alcoholic hepatitis. What's new? Speaker, Dr. Gaurav Pandey. Please come on.
Good morning, everybody. Sincere thanks to Professor Anil Arora and Professor Ashish for giving me an opportunity to present this topic. Respected chairpersons and moderators, to start with infection versus inflammation in severe alcoholic hepatitis. I'll present the talk on the following outlines. What is the need of biomarkers in the field of severe alcoholic hepatitis? It's an unmet need. What type of biomarkers are there? What are the options that we have? When to suspect and which biomarker to be used. Now, severe alcoholic hepatitis patients are prone for infections, and they may vary from up to 30 to 80% of patients. It's predominantly bacterial in origin. The problem is CHBD criteria are fulfilled because of the severe inflammation with which these patients are suffering. The control of infection becomes mandatory before start of steroids, and only in the case of resolution of infection does it have an impact on survival. So steroid treatment and altered host defense are the two important issues because of which it's very important to rule out infection in patients fulfilling the CHBD criteria in severe alcoholic hepatitis. There are multiple biomarkers for severe alcoholic hepatitis, maybe CTP, Madry's index, MELD, Glasgow index, EBIC score, but none of them tells you about the rate of infection, susceptibility of infection. They tell you about the prognosis of the disease. Once people do become infected, the mortality obviously jumps many folds. So what can be the potential biomarkers, the topic for discussion today? The biomarkers can be acute phase proteins, microbial biomarkers, or sepsis biomarker candidates and cell markers. So we normally use all CRP, procalcitonin, WBC counts, NLR ratio in our day-to-day process. What has changed? So coming to the infection-related mortality with microbial biomarkers, Bacterial circulating levels of bacterial DNA have been found to be effective to predict day 7 infection in patients treated with or without steroids. So they can give you a rough idea of the day 7 infection in patients who are going to be on steroids, but they do not prognosticate very well. Coming to acute phase reactants, CRP, Procal, WBC counts, NLR ratio we have been doing for ages. They are good in established clinical infection, where ROC curve for CRP and Procal are more than 0.8. But in subclinical infection, they are not discriminatory. And here, majority of the patients do have subclinical infection that flare on steroids. And here it lacks. They are not discriminatory when you have a subclinical infection, any of them. It may be CRP, Procal, WBC. Now, CRP is released from liver. So the level of CRP for infection varies with the CTP score. CRP for CTP A can be high, more than 20. CRP for B is lower and C is still lower. With that, for the same middle score, the probability of infection increases by 8 to 10% for each unit increase in CRP. So it's confusing and the numbers do vary. So people thought of combining multiple biomarkers and give a composite score. So they combined neutrophil, Procal, CRP, gave a point between 3 to 0 for each of them, as has been shown in the table, and formed a composite score. The specificity though was good, but the sensitivity was poor. As you can see on the right hand side, the sensitivity was only 6 to 10%, and though specificity was in the range of high 90s. The ROC curve for this combined biomarker score was 0.74. That was definitely not the best. This was combination of all the 4 biomarkers commonly used. Coming to cell-based biomarkers, one of the biomarkers that has been started using recently is presepsin. When lipopolysaccharides binds with the CD14 receptor on the monocyte macrophage, a small component of CD14 is released that is called presepsin. Obviously, it further goes on to release CRP and Procal, but this small fragment of CD14 that is released on expression of bacterial lipopolysaccharides because of proteolytic cleavage is released pretty early, within 2 to 3 hours of bacterial infection, compared to CRP and Procal that is released within 6 to 8 hours or more than 12 hours. So a biomarker that can be easily detected at a very early course of disease, within 2 to 3 hours, and obviously the problem is it starts declining within 4 to 8 hours. So in ACLF patients, 368 ACLF patients with more than 47% being alcohol, the sensitivity and specificity of presepsin was found to be better than Procal or any other biomarker used. The combination of presepsin and procalcitonin did better than presepsin alone. The area AU ROC was 0.95, as you can see here. Other studies have also shown significantly increased role of presepsin in sepsis. If the levels are low, they have actually risk stratified the presepsin values with the risk of developing sepsis. It could be low to very high depending upon the value of presepsin. The problem is presepsin is impacted with kidney disease. So if you have a high creatinine, it is not very reliable. Presepsin has also been added with SOFA score to increase its sensitivity specificity. Another biomarker is neutrophil CD64. This CD64 is an Fc gamma receptor which is expressed on macrophage, monocytes and eosinophils. In neutrophils, it's only 4 to 5% of neutrophils in a non-septic state that express CD64. It basically increases in response to microbial wall components, complement split products, and pro-inflammatory cytokine insult. So once this insult happens, lipopolysaccharide induces the expression of Fc gamma receptor in the neutrophils. So from 3 to 4%, they increase up to more than 90%. It increases rapidly within 4 to 6 hours and is a very early indicator of response to bacterial infection. This can be easily measured by flow cytometry and now by ELISA also, and costs around 500 rupees. And obviously once you give the sample, the results come within a couple of hours. It has been used in multiple immunological diseases previously with the pooled sensitivity of 87 and specificity of 89%. So a very good sensitivity, specificity to detect infection very early in case of severe inflammation. There has been very well-defined cutoff for SIRS, confirmed sepsis and suspected sepsis. So it differentiates between SIRS and septic conditions in many other immunological diseases. We did a study in patients with severe alcoholic hepatitis fulfilling SIRS criteria and looked at the utility of neutrophil CD64 percentage. So we compared this with Procal, CRP and all other inflammatory markers, and the ROC curve of CD64 was up to 0.9. It clearly differentiated the infection versus the non-infective group which fulfilled the SIRS criteria. The other important issue was response to antibiotics if patient had sepsis. So there was steady decline within 72 hours of CD64 once patient had infection. And it also suggested the prognosis. Patients who did not have a decrease in CD64 had a very high mortality compared to patients who had persistent CD64 decline. We validated this in ACLF patients, around 268 patients, of which 53% were alcoholic hepatitis. Again, similar results. CD64 again alone had a very high sensitivity and specificity with area under curve of 0.93 as shown here. And it also was not only diagnostic, had prognostic value and was useful in monitoring. So looking at CD64, Presepsin, Procal and IL-6, all of them have a decent area under curve, but CD64 does score in patients in a meta-analysis done between the three group of inflammatory biomarkers. Combining CD64 and Presepsin may further increase the sensitivity, specificity and ROC for diagnosing sepsis early in disease. This was one of the studies published in 2019 which showed the ROC curve increase up to 0.87 and CD64 of 0.94 to look at the rates of early detection of sepsis in patients fulfilling SIRS criteria. Coming to NLR ratio, that has been there for some time in patients with the infection. NLR ratio, high NLR ratio does suggest infection with this reasonable sensitivity, specificity and area of under curve of 0.7. People have tried to add ventilation requirements, SOFA score to NLR ratio to increase the ROC. It has gone up to 0.81. NLR ratio compared to Lil's model did perform poorly, but people have tried to combine Lil's ratio with NLR in patients with severe alcoholic hepatitis. That has improved the performance marginally for the patients in severe alcoholic hepatitis to detect sepsis early and recovery at day 4. So to conclude, infection is a common clinical problem in severe alcoholic hepatitis. New biomarkers like CD64 and Presepsin may help solve this conundrum. Thank you.
Hello, excellent talk. How do you see the use of CD64? Will it change the treatment? Suppose it is found high and we are giving steroids or any?
Yeah, actually, I found it personally very useful. So the issue is once you suspect sepsis, immediately if you send the values are pretty high. Baseline it may be to the tune of 10, 20, 25 and suddenly it jumps to more than 90. So to just give you an example, we follow this particular slow albumin furosemide infusion on patients with ACLF, severe alcoholic hepatitis who are admitted with AKI and maybe infection, may not be infection. Once the urine output decreases, even if the patient does not have any clinical worsening or lab worsening, you send the CD64 values to suspect a preclinical infection, they are very high. Start antibiotic, change antibiotic, and within 72 hours they do decrease rapidly. Apart from that, it's a test that's available within a couple of hours. It's done in 24 hours in a lab, and within a couple of hours you get the value. It can also be done on OPD basis if the patient with severe alcoholic hepatitis on oral steroids does come to you, and in a couple of hours you have this value. So very important to not only diagnose, but also monitor patients on steroids.
But having very high sensitivity and specificity means, it also means that it will pick up very minor infections which are not very critical. Yeah,
so this requires further tests. It's not only severe alcoholic hepatitis. We have done the similar study in ICU and in various rheumatoid conditions requiring immunosuppression. Most of the time it has stood the test of time. Does it increase on a very small infection? It's again multiple studies have to be done, but on day-to-day clinical basis where patient is extremely sick, fulfilling search criteria, it's one of the important indicators that you may find.
Thank you.
When you start steroids in patient of alcoholic hepatitis, we normally see that there is transient increase in your total leukocyte count, which also includes neutrophils. Suppose if we see the patient is on steroids and the neutrophil count has now increased and patient is not running fever because patient was on steroids. So how does C34, which you say because it will increase in the neutrophil count will also increase.
Yeah,
Does
but
this product will also increase?
No, it does not increase actually. Because multiple studies on immunological patients who are on steroids have shown that it does not increase. It increases when you have a GNB bacterial infection coming in contact. Only then does the CD64 count goes up. Without that, CD64 count does not go up.
Okay. And the second question is, in your clinical practice, do you use routinely antibiotics while you start on steroids?
Pardon?
Do you routinely use antibiotics prophylactically when you started patient on steroids?
Yeah, patients who are admitted, definitely we do that. But
how does it matter? Like, if the patient is on steroids, patient is on antibiotics, and you start with CD34?
No, CD64, yeah, so we look at CD64 at baseline. We have a baseline cutoff of 27. More than 27 we definitely initiate on antibiotics.
Okay.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you. We now call upon Shivam Khare. EU's guided liver biopsy overview. Call upon Dr. Shivam Khare, please.
Very good morning, everyone. So first of all, I would like to say thanks for getting this opportunity. So my topic is US guided liver biopsy in overview. So I'll discuss this topic in following headings. First, different route of liver biopsy, then why we need US guided liver biopsy, then various US LB strategies, then what is the optimal technique, then comparison of US LB with other routes, and also share our experience. So first, routes of liver biopsy. So there are three routes: percutaneous, transductal, and now US guided. So every route has few advantage and disadvantage. So advantage for percutaneous, it is quite simple, inexpensive and traditional method. And advantage for transjugular, can be performed in case of thrombocytopenia, coagulopathy and ascites, and we can also measure HBPG. A few negative aspect related to percutaneous, patient discomfort is there, sometimes complication can occur like pain, rarely bleeding, usually right lobe can be accessed only, and it is difficult in obese and children, and patient need to remain in right lateral position for 3 to 4 hours. And similarly in transjugular, there is need of radiation, patient discomfort because we have to give incision in neck. It is why we prefer US liver biopsy. So first is clinical efficacy, that is almost comparable with percutaneous, and we can take bilobar and targeted biopsy, and also we can perform US LB in case of mild to moderate ascites, and if patient undergoing concurrent upper GI procedure and US procedure, then we can do US liver biopsy simultaneously. Second is safety. So it is real-time procedure, we can apply the Doppler and we can follow the vessel-free approach, so complication is less with US liver biopsy. And third is better patient experience, because it is done under sedation, so comfort is there, so minimal pain or complication, and so it is useful in obese and children's, and there is no need of radiation during the procedure. So this is USLB timeline. First USLB is done in 2002. Then multiple reports are published, and a recent report showed we can do US LV along with US guided total pressure gradient measurement. So US LV strategies we can discuss one by one. What is better, aspiration or biopsy? Which gauge of needle is preferred? Type of needle? Then how many passes and actuation? And what is the optimal technique? So regarding the aspiration versus biopsy, based on published data, biopsy is obviously better than aspiration. Then needle gauge, obviously 19 gauge needle is better than 22 gauge needle. Then if we compare the type of needle, according to these three published study, Frautic needle and Francine needle gives the equal result. But another latest published study in which they showed the Francine is better than the fork tip. So we can use Francine needle in US guided liver biopsy. So these are the techniques for US liver biopsy. Out of all, weight heparin technique is the most optimal technique by which we can get optimum sample. So regarding the technique, these two studies published in GI endoscopy and in which they compare weight heparin technique with other technique, and the result of weight heparin technique is best in terms of complete portal tract and total specimen length. And one more thing, heparin priming does not alter the interpretation of the tissue, and it decreases the blood clot in the specimen and enhance the tissue processing and interpretation. Regarding the passes and actuation, based on these two studies, one pass 3 actuation technique is best to get best tissue specimen. Then regarding the bilobar biopsy, we know the in case of suspected NAFLD, if we actually in NAFLD, discordance of fibrosis can occur in both lobes. So in this study, they showed the unilobar assessment underestimate the fibrosis by 21%, inflammation by 13%, and steatosis by 8%. So in suspected case, we can prefer the bilobar biopsy to get better result. And there is no difference to get sample from right and left lobe. Tissue yield is equal if you take biopsy from any lobe. So now how to do US liver biopsy? Pre-procedural workup is almost similar like percutaneous, and contraindication is also similar like percutaneous. So this is the technique of weight heparin technique. First we have to remove the stylate from the FNA needle. Then we have to flush the needle using heparin mixed saline until the few droplet of heparin came from the another side. Then weight heparin suction is prepared by 2 ml of the saline followed by 20 ml vacuum created in this suction syringe, and this suction syringe is attached to the FNA needle. And after that, US examination done under the left lateral position, and we can take a biopsy from right or left lobe by the proximal stomach or the first part of the duodenum. After the applying the Doppler, first we should measure the path of the needle trajectory, so we can avoid the vessels, and it should be around 4 to 5 centimeter to get optimum tissue length. So after the measuring path, FNA needle punctured the liver, and we have to take 3 actuation. Actuation means a to and fro movement of the needle after the puncturing the liver. So we have to take 3 actuation, and after the 3 actuation, don't be in a hurry to remove the needle from the liver and liver capsule. First we should apply the Doppler and see flow. If there is any flow, wait for few seconds. In most of the cases, flow will disappear spontaneously, and only after that you can remove the needle from the liver and liver capsule. And after the removing the needle, sample is pushed by the using stylate and over the cell block cassette, and after the getting sample, and this sample is flushed with heparin mixed saline, so blood clot is removed, and this is the sample, and after that sample is shifted into the formalin container and sent for histopathological examination. These are similar slides. So this is one technique, blood patch technique, and this helps to reduce the bleeding risk after USLB. If you see needle tract in the liver, first apply the Doppler, and if flow is there, then wait for 30 seconds. If still you see flow, then wait for another 1 minute to 2 minutes. If flow is not gone, then you can deliver the tissue and blood clots that already you have taken and which is inside the needle, FNA needle. If you push the sample, that can create the mechanical barrier to stop the bleeding. So this is blood patch technique. regarding the tissue yield, if we compare the US LV percutaneous versus percutaneous LV, so this is the first randomized control trial in which they show the percutaneous LV gives a better result than the US LV. But in this study, they didn't use the optimal technique of the US LV. And these two studies shows the first one shows the US LV gives the better result, and second one almost equal result with US LV and percutaneous LV. So adverse event is almost equivalent in both group. Pain is more common in percutaneous LV. We see the table, yield is equal in both group, pain is more in percutaneous LV, bleeding is almost equal in both group, but cost is slightly higher in US LV group. And I also want to share data from our center. We did 110 patients of US LV. Most commonest diagnosis is NAS, and we get conclusive diagnosis in more than 99% of the patient, with median tissue length is around 4 centimeter and median number of complete portal tracts is around 15. And during the procedure, no adverse event recorded in any case, and also we got additional information in 24% of cases in terms of gallstone disease, chronic pancreatitis, significant lymphadenopathy and varices. So we also compared the US LV versus percutaneous LV. So yield is better in US LV, complication is almost equal in both group, and tissue specimen length and complete portal tract is more in US LV group. So who is the better candidate for the US LV? If patient need the concurrent upper GI examination for other indication, if patient require the sedation or wants the comfort, if patient require the bilateral biopsy, if patient require the US evaluation for other reason, and near future we can also perform measurement of the portal pressure gradient, and we can also perform the US LV in case of mild to moderate ascites. So conclusion of my presentation, US LV is non-inferior or equivalent to percutaneous LV, and optimal technique, weight heparin, we have to use 19, the FNB needle, Francine is better, 1 pass 3 actuation is better, and equal result with right and left load. So US LV to be considered over percutaneous LV. Need, if anyone need concurrent upper GI or US evaluation, bilateral biopsy, portal pressure gradient measurement and NCS patient. In this group, this US LV could be cost effective also. So this is my last slide. Percutaneous liver biopsy is well established technique from the many years in terms of safety and specimen adequacy. We cannot replace it by US liver biopsy, but we can use new US LV technique in certain group of the patient, and it could be useful technique in coming future. Thank you very much for your kind attention.
Hi, Dr. Shivam. So recent meta-analysis have showed 10% less diagnostic accuracy in US LV as compared to percutaneous. 98% diagnostic accuracy in percutaneous. So why do we get difference? Because our IR guys, they used 18G needle. You ask them, 75% in your experience is very low. Approximately 1500 to 2000 biopsies percutaneous are done by our IR team. It is not 75%. It is rare to have non-diagnostic. EUS LB is costly, no difference in side effects. So why do you want to do EUS LB rather than percutaneous LB?
So I already told you, we can prefer US LB in certain group of the patient. Actually, if patient come with ascites, if patient want procedure without pain, if patient want comfort, then we can prefer US LB.
So pain is at 1 hour only. It is not at 5 hours, 6 hours, 10 hours. The study by Bang et al., pain is different at 1 hour. If we do a procedure under sedation, obviously pain will be less. And portal pressure measurement and doing a biopsy requires 3 capsular punctures. Why TJLB and HVPG doesn't require any capsular puncture?
Biopsy doesn't require 3 capsular puncture.
No, EUS with PPG, it requires 3 capsular punctures. While TJLB and HVPG doesn't require any capsular puncture.
We can't compare the...
Narendra, can I answer your queries? First of all, EUS guided puncture, it requires 3 acquisitions, not 3 punctures. 3 acquisition, EUS, no, you don't put picture. No, we are not talking of PPG, we are talking of a new technique of 1 puncture and 3 acquisitions, number 1. Whenever you want to increase the diameter of the needle to get more tissues, doesn't matter. You can have a 14 gauge needle, you can have a huge tissue, you can have a 10 gram tissue, but there is good data to show anything more than 19 does not need. What you need is the minimum requirement of 10 complete portal tract, which is being given. So why need a bigger needle? You can use a 10 gauge, 10 millimeter needle, you will have a bigger tissue. And there is also meta-analysis to show they are equally effective. And so far as pain is concerned, you said 1 hour pain doesn't matter. Pain is a pain. If it occurs for 1 hour, it is equally important. So what we are trying to say is, we are not saying it is better. It is equally good technique in which, as a gastroenterologist, it is within your domain. If in future you are able to see it being done under your own eyes from a localized area without complication, I think that may be the future, especially if it is being done with your own, own hands under your own vision. We are not claiming it is better, but it is equally good. You don't need a bigger tissue. Say you can a 14 gauge needle, you will have a bigger tissue, but anything more than 10 to 12 you do not need. That way you can have a whole tissue and examine it.
Yeah, one question. If here,
any data on fibrosis?
Sorry?
Does it get complete nodules by 19G and suction? Any data on fibrosis? Because in patients with cirrhosis, suction type needles are not recommended. Portal tracts are fine.
Actually, if we use this Francine needle, that with suction technique, this needle gives adequate result regarding the fibrosis, absolutely. So there is no difference in suction after using this Francine needle.
here, after doing US guided biopsy, if the flow persists for a 1.5 minutes or 2 minutes, you told that we push the blood clot or some tissue by stillate or by how you push the?
Only by stillate. You can push the sample by the stillate.
And can you assess the sample on US image?
Sorry?
Can you see the sample on US image? How you see
yes,
it?
sir. So hyperechoic content, you can see the US image in the needle tract.
Okay, thank you.
Thank you, Dr. Shivam. Now I call upon Rinkesh Bansal. He'll be talking on management of NAS in diabetics. What's new?
Good morning. At the outset, I want to say thanks to Dr. Arora, Dr. Ashish and Dr. Praveen. So, my topic is management of NAS in diabetic. What's new? It's a quite new and hot topic nowadays. So, we have three scenarios in our day-to-day practice. The patient with diabetic with non-cirrhotic NAS, patient with diabetic with compensated cirrhosis, and patient with diabetic with decompensated cirrhosis. In management of diabetic, we have multiple options. We have metformin, we have sulfonylurea, thiazolidine, insulins, and newer anti-diabetic like DPP-4, GLP-1 and SGL2. But when we discuss about management of diabetic with NAS, there are few options like insulin, thiazolidines, glutides, GLP-1 and SGLT2 inhibitors. Rest we will discuss in subsequent slides. So, this is a recent table from an article in which there is a comparison of anti-diabetic drug in hepatic steatosis, steatohepatitis and fibrosis. So, pioglitazone is the only drug which can reduce the steatosis, steatohepatitis and fibrosis. GLP-1 receptor antagonist doesn't work for fibrosis, but there is role of steatosis and steatohepatitis. SGLT2 inhibitor decreases only steatosis but not steatohepatitis or fibrosis. DPP-4 and metformin doesn't have any effects, so they are not useful. And insulin have some effects to reduce steatosis but not in others. So in real-time case, we had the first one case is a 42-year-old male diabetic on metformin with sitagliptin combination. Has isolated diabetic, no other comorbidity like hypertension or dyslipidemia with BMI of 32. LFT were normal except that ALT was 82 and fatty liver on ultrasound. We have ruled out other etiology. So we are dealing with a case with non-cirrhotic diabetic, non-cirrhotic NAS. So now the options for non-cirrhotic NAS. First, we will discuss about the metformin. Metformin improve the hepatic and muscular insulin sensitivity, but there is no clinical evidence of benefit on disease activity and liver fibrosis, and there are multiple systemic review and meta-analysis which shows that there is no role. DPP-4, again, earlier data suggested there is some role in hepatic steatosis, but there in recent trial in which there is confirmed that there is no role. Regarding that pioglitazone, this metabolite was excreted in liver. Higher plasma level achieved in cirrhosis, they are proven for non-cirrhotic NASH. SGLT2 inhibitor, again, there are few trials, multiple trials now in which they are useful. They inhibit glucose absorption at kidney level. They lower the hypoglycemic risk and associated with additional weight loss also. But this is a trial from Medanta group in which they, ELIF trial in which they used 20 non-cirrhotic patients and compared with standard of care, and they assessed by the MRI PDFF along with AST, LT and weight. So there is a significant reduction in MRI PDFF fat, but ALT and weight it is almost insignificant. So regarding the GLP agonist, which is a new kid on the block, quite hot topics nowadays. It's a primarily anti-diabetic drugs. Liraglutide and semaglutide are the molecules, injectable molecules. They are evaluated in non-diabetic NASH. They causes significant weight loss. In fact, the semaglutide recently approved for the weight loss also. But again, it's a subcutaneous injectable. Liraglutide daily and semaglutide weekly, and it's obviously expensive molecules not available in India right now. Regarding the data, this is a study published in NEJM, 320 biopsy confirmed NASH, 72-week treatment with daily subcutaneous semaglutide dose, and primary endpoint was the resolution of NASH and the secondary was the resolution of fibrosis. So this diagram shows there is a resolution of NASH was significant in comparison in semaglutide 0.4 in comparison to placebo, but liver fibrosis was not significantly reduced in comparison to. So ALT significantly decreased in 0.4 group in comparison to placebo group, and body weight is also significantly reduced. So there is a significant weight loss improvement in NASH score, but there is no improvement in fibrosis. Liraglutide and semaglutide can be safely used in NASH, fibrosis and cirrhosis also. So these are the options. Now we are moving to another case, which is a 62-year-old female diabetic, dyslipidemic hypertension on multiple drugs. And there is evidence of cirrhosis also, but it's a compensated cirrhosis. In compensated cirrhosis, role of metformin again we can use for up to 1500 milligram per day in childish cirrhosis, but not in B and C. It's a weak anti-diabetic drugs and should be avoided in renal impairments. Sulfonylurea, we can use the short-acting sulfonylureas. SGLT2 inhibitor, again no dose adjustment requirement child A and B, but we should use with caution in renal impairment with increased effect of all diuretics, and there is a high incidence of UTI and melanoprostatitis. So they are safe in CTP-A, but use caution with other B and C. Regarding the glutide, again, no specific organ is present to measure routes of elimination. No dose adjustment required in A, B or C, but again data in cirrhosis CTP-A, which is by the Lumba et al. In recent Lancet study, semaglutide weekly didn't show significantly improved fibrosis or NASH resolutions, and it is not no recommendation right now for child B and C. So again, this case was followed after a year and it developed into the decompensated cirrhosis. We know that insulin is the only drug which can be used in decompensated cirrhosis. So to summarize, when we need to assess first the fibrosis assessment, if this is low risk by the FIB or LSM or ELF, then we can use multiple drugs like GLP-1, SGLT2. When there is indeterminate risk or high risk, we need to see the underlying things, like if there is a cardiovascular disease, we can use GLP-1 receptor antagonist SGLT2, and if there is a heart failure, we should use SGLT2 inhibitors. Preferred medications in low risk group is GLP-1, SGLT2 and pioglitazone. In indeterminate risk, this is the pioglitazone and or GLP-1 receptor antagonist, and again in high risk group, we can use pioglitazone and or GLP-1 receptor antagonist. Regarding other medication, we can continue metformin, DPP-4 and other medication in low risk group, but not in intermediate or high risk group. Regarding the recent two studies from the EAGLE, after GLP-1, we are moving to the new molecule, which is a GLP-1 glucagon receptor co-antagonist, and they are the two oral presentation in recent EAGLE. Both are the phase 2 study. One is regarding the peptidoglutamate. It's a 2-way randomized study. Again, around 1/3 patients were diabetic, and there is a significant improvements in this group. And another molecules, again, this is a dual receptor agonist, pemvidutide, again the better benefits. Thank you very much, sir.
Good talk, Rinkesh. My question is, if a patient comes with a long-standing diabetes and he is well controlled on sulfonylurea with HbA1c less than 7, and now he is found to have fibrosis, liver fibrosis, will you change his diabetes medication? Will you add or replace sulfonylurea with GLP-1 or SGLT2?
So yes, sir. For reducing fibrosis, because we need to our focus is to reduce the fibrosis if it's reversible. So we should use pioglitazone to reduce fibrosis, sir.
But that will lead to weight gain, and,
yes,
and
sir.
there's no definite evidence that it does reduce fibrosis.
So this is the only drug we can offer them, sir.
And what about SGLT2 with patients with recurrent urinary tract infection? How do you?
Then we should use another molecule, sir. We can't use in recurrent UTI, sir. Sir, there is no data, but in India we are using oral semaglutide because this is the only options available. So in real scenario, they are working, but still we need data, sir.
Yeah, Dr. Rinkesh, nice talk. So now SCC is emerging and NAS is the major cause. So how are you going to change your practice as far as this anti-diabetic drugs are concerned?
Sorry,
or the anti-diabetic drugs and the carcinogenic risk for the SCC.
So I am not aware about any particular carcinogenic effect of anti-diabetic.
Yeah, so sulfonylurea has the highest potential in long term, and then second is the insulin. So these two who are the backbone, and now we have to get into more in this area because they are now increase the risk of cancer per se along with NAS.
Okay.
Thank you.
Thank you.
Excuse me, Dr. Bansal, may I have a question? Many of the diabetics or pre-diabetic who are presented as non-alcoholic cirrhosis, they have a high triglyceride. Do you have any answer for this to tackle that before they go to cirrhosis?
Sir, please.
The high triglyceride level in diabetic or pre-diabetic, they go for non-alcoholic fatty liver disease or cirrhosis. So do you have any measurement option for prevent this cirrhosis in such patients?
Sir, the drug which is proved is only pioglitazone, which can reduce fibrosis. There is no other anti-diabetic drug which can reduce fibrosis. So this is the only drug with data. Regarding the SGLT1 and this GLP1, SGLT2 and GLP1, there is no data for reversal of fibrosis. But yes, they can be used to control the NAS.
Any data for N-acetylcysteine in preventing cirrhosis?
N-acetylcysteine, sir, no?
No.
Yeah.
Thank you, Rinkesh. for covering nicely the newer topic. Now I call upon Mr. Dr. Varun Gupta. Will be talking on assessment of liver fibrosis in liver clinic.
Respected chairperson, moderators, first of all I would like to thank my guides and mentors, Dr. Anil Arora, Dr. Ashish Kumar and Dr. Praveen Sharma, to giving me this opportunity to speak in front of you in a very important conference which we were associated since we were students from day one. So my job is to tell you about how we assess liver fibrosis in your liver clinic. So when we are practicing hepatology in today's time, it's practically impossible to prognosticate or send a patient without having an idea at what fibrotic stage he or she is in your OPD chambers. And how you can do this testing quickly and effectively sitting in your chamber is my job to tell you today. So what we are trying to find out? We are trying to replicate something which we get from liver biopsy, that is a metavert staging, like F4 no fibrosis, F1 portal fibrosis, F2 portal fibrosis with few septa, and then F3 septa without cirrhosis, and F4 cirrhosis. So ideally this is a gold standard, or let's say this is the best standard as of today to assess any patient for liver fibrosis. But it comes with limitations. Of course, it's an invasive procedure. We just had a discussion. It comes with pain. If you're doing a percutaneous major complication, mortality, we just have one track. And there is a lot of intra and inter-observer variation. So ask me, I am practicing at Jalandhar. So hardly I rely on any pathologist which can give me back a good liver biopsy report. I'm not talking about Gangaram Hospital, ILBS, M.I.C.E. When we are practicing at second town cities, it's very difficult to really rely on a pathologist for a good liver biopsy report. So we have all pushed ourselves hard to go away from biopsies, at least in 95% of our really practical cases. And then we need to assess our patient for liver fibrosis in the clinic. So we need to answer few questions. Which patient in my OPD needs fibrosis test? Does all my liver patients require? Which test should I choose? Will it change the management plan of my patient if I have the answer of F1, FO, F1, F2, F3, F4 fibrosis? And in my same patient, when should I repeat my fibrosis test on follow-up? Should it be 3 weeks, 3 months, 6 months, or whenever? So any non-invasive testing, no doubt, should be safe and simple. It should be reproducible in the same patient. It should be cost-effective and should be able to assess fibrosis and even advanced fibrosis with good sensitivity and specificity. And all the guidelines, and if we go about data and go to research and publications, there is n number of publications which have been there in our literature to assess fibrosis non-invasively. But my job will be to highlight you those scores which you can reproduce in your daily clinic very easily. The simple scores are NAFLD fibrosis score, the FIB-4 score, and APRI. And the imaging techniques which are available are transient elastography and shear wave elastography. So I will just go in detail about these scores. The first one is APRI. So this was the most earliest score which came into practice to have some idea about fibrosis in chronic hepatitis C patients. And then in this score, so we are not going how to calculate. All the calculators are easily available on all the apps, or even if you go to Google and type APRI calculator, you will have something like this, and you just have to type AST levels from your LFT levels, LFT report. You have to type AST upper limit of normal, mostly it's 40 or 35, and then platelet count. And you will have a score, and if it is less than 0.57 in your OPD, so you can be really pretty sure with a sensitivity of 90% that this patient of mine is very unlikely to have any fibrosis. And if it is more than 0.84, this is a patient where there is a good possibility of having advanced fibrosis, and this is a patient which can be subjected to further testing, probably a transient elastography of your choice. Most of our patients which we require in our OPD to assess fibrosis are from NAFLD or steatotic liver disease, And this is an important score known as NAFLD fibrosis score, where again by using a calculator you have to add age, BMI, fasting glucose level, AST, ALT, platelet count and albumin. And what we get here is that anything less than minus 1.4545 in our calculator, you can be pretty sure with a sensitivity of 89% that this patient of mine will not be having any advanced fibrosis. But recently some data has come, I will come to that slide also in my presentation, where this score has been further reduced to minus 2.9 to increase more sensitivity and specificity in our population in India. So if we use the same score for long-term prognosis, so any patient with NAFLD score less than minus 1.445 will have a long-term good survival probability. On the contrary, anything with NAFLD score of more than 0.676 will have a long-term survival probability will be less. Another calculator is the fibrosis 4 calculator. We called it as FIB4 calculator, which uses age, AST, platelet count and ALT levels. And any score less than 1.45 will tell you that your patient will be very likelihood there will be no fibrosis, and anything more than 3.25 your patient will be having advanced fibrosis. So what else? These are the scores from your lab investigations, adding age, gender and sugar levels. A very important modality, transient elastography, has come up in hepatology, and most of us have one or the other way to do it. The most renowned one is by FibroScan by EcoSense. They use shear waves through a vibration controlled transient elastography at a large explode volume of 3 cm cube and a depth of measurement of 15 to 17.5 mm, and the Young's module is expressed in kilopascals. So this is FibroScan, where we get two values, that is the kPa value and the cap value, and anything less than 7.9 in fatty liver disease rules out any advanced fibrosis, and anything above 9.6 kPa rules in advanced fibrosis in our patients. So they had some limitations of high BMI patient, which is overcome by using an Excel probe, where you add another probe to help us in high BMI patient. And similarly, if we follow up our patient of FibroScan with no fibrosis over long term, the overall survival with no fibrosis is significantly better than patient who has high fibrosis index in our FibroScan. So this is how we compared our liver biopsies metaverse score and FibroScan reading. Like if it is between 7 to 9.5 kPa, our fibrosis will be around F2 as compared to liver biopsy. And the Bavino 6 consensus workshop also tells us that if there is a transient elastography kPa value of less than 20 with high platelet of 1.5, we significantly rule out clinically significant portal hypertension. Another modality which is now increasingly available is the FibroTouch, which also uses transient elastography. This is a Chinese machine, but it needs to be mentioned, it is US FDA approved now, and most of our, many of the centers are coming up this modality also. They also measure stiffness by kPa value, and they have UAP instead of kP for fat determination. Shear wave elastography measures tissue stiffening applying ultrasound, and if you will ask your radiologist friend or if you will visit a radiology conference, they will vouch on this modality rather than transient elastography, and they say that is more specific. But as a clinician, we are not used to reading these reports, but we will keep seeing these reports from a ultrasound radiology centers. Two more scores I will like to highlight, Agile 3+ and FAST scores. So what has happened? They have clubbed FibroScan readings, kPa readings with some more parameters, and they have developed two scores, that is Agile 3+ and FAST score. This is a study from Arun Sanyal from Journal of Hepatology, where they have given area under the ROC curve for Agile 3+ score, which is much more 0.90 in comparison to FIB4 calculator and liver stiffness measurement by FibroScan alone. So what they said is that if you will use a liver FibroScan measurement along with AST, ALT, platelets levels, along with age, gender, diabetes, you will get something known as an Agile 3 plus score. And this will have a area ROC curve more than alone the value of liver stiffness measurement alone. So all these parameters you have to put in a calculator. So you don't have to do anything, just use a calculator from your smart mobile, and anything less than 0.45 rules out possibility of any fibrosis, and anything more than 0.68 signifies that patient will be having advanced fibrosis, that is around F3, F4. Similarly, there is a score known as FAST score, which uses 3 parameters: liver stiffness measurement in kPa by FibroScan, the CAP value from the same FibroScan machine, and the AST level. And this is the article from Lancet, where they have mentioned about this FAST score, and anything less than 0.35 rules out advanced fibrosis, and anything more than 0.67 rules in advanced fibrosis. A very important study came up from our country only. This is a group from AIMS, PGI Chandigarh and Singapore. The first author was Umang Arora. So what they did, they studied 4 cohorts in AIMS Delhi, PGI Chandigarh, Singapore, 641 patients, and they did liver biopsy in all patients, and all patients underwent non-invasive testing by transient elastography, NAFLD fibrosis score, APRI, FIB4, Agile 3 plus, and FAST. And this is a very important chart. I will just like you to spend a minute on this. So the area under the RUC curve, this is an Indian study with some population from Singapore, was equal and maximum in FibroScan group and Agile 3 plus. Agile 3 plus is FibroScan plus AST and other parameters. So these are the 2 non-invasive modalities which has the maximum area under the ROC curve. These groups said that the NAFLD fibrosis score and APRI and FIB4 were not as good as the other scores in our population. But the same group gave us a 2-step approach, which is quite justifiable, where they said that if you have a high volume patient and high volume center, you can use NAFLD fibrosis score with a lower cutoff value of minus 2.97. If you put a NAFLD fibrosis score and your lower cutoff value is less than 2.97, you can be pretty sure that this patient will not be having any fibrosis, and you can leave him alone. And if your NAFLD fibrosis score is more than 2.97, this is a patient where you need to do your further testing by using transient elastography of your choice. So to conclude, liver OPD in 2023 and beyond is incomplete without assessing liver fibrosis. Liver stiffness measurement is the single most accurate non-invasive test to detect the presence of advanced fibrosis. NAFLD fibrosis score and FIB4 calculator can be used initially to rule out fibrosis and to screen more patients. There is still no perfect surrogate or method able to completely replace liver biopsy, and liver biopsy will always retain its role in hepatology in selected group of patients. Thank you so much.
Any question, please? Thank you, Dr. Varun Gupta, for... Oh, sorry.
So whenever there is an acute inflammation, so if a patient has acute inflammation due to systemic illness, dengue, or acute liver hepatitis, so we cannot rely on these parameters at that particular time because there is a lot of inflammation occurring at that time. So if you do a fibroscan during in an AVH patient with high jaundice, and later do it after 3 weeks when he will be recovering, so we cannot really rely on this. But if the values are very high, we can just use this to know whether the patient has background underlying fibrosis over and above which we have the patient has developed acute viral hepatitis. I am not aware of that. So.
Dr. Varun, very nice presentation. I am Dr. Nipun from PGI.
Hi, Nipun.
Just wanted to, share our experience. around 1600 liver biopsy proven patients, we took this gut and obesity Asia group led by Professor Ajay Duseja. Across 16 centers, we also found that APRI and FIB4 are very poor in our setup, Asian patients. Around 65% was the AUC, as 67% in AIMS. But we could find that, artificial intelligence could be really helpful.
Sorry, come again, last line.
We could show that artificial intelligence using basic parameters without even LSM could be very helpful with an area under ROC curve reaching up to 80% with a 10 times better prediction. So I think AI on the clinically available parameters is also coming up in a big way.
That will be the future. Definitely, that will be the future, that AI will be helping.
And all these models are very good in negative predictive value because the population prevalence of significant fibrosis and the spectrum bias which happens in these studies is really to be looked at. Thank you.
Thank you, Nipun. Thanks for your comments.
Varun, in many of these patients, AST or ALT is required, which can be low due to use of many drugs. So how do you interpret there?
So basically, many drugs means when you treat
For example, when we are treating NASH, we are giving saroglitazole, and these all will.
So basically, the idea is to test them before starting any of these drugs when they come first to you, and then do a follow-up probably after 3 months to 6 months and follow up whether your treatment is effective or not. Of course, when you treat with somebody with some drug and the AST-ALT will go down, the values will definitely improve.
And just a comment, Dr. Kuru asked about if the patient has dengue, patient has an acute viral hepatitis, then fibroscan value can be fallacious if you measure with the liver. There is upcoming data on measurement of splenic stiffness now. It can be done maybe on clinical basis because there is another fibroscan, splenic fibroscan has now come up. The second question of acute viral hepatitis, if anybody who has an acute viral hepatitis and do a fibroscan, any value which is more than 30 probably means that patient has underlying fibrosis. So anything which is less than 30 normally excludes an underlying fibrosis. Okay.
Thank you. Thank you so much.
Conclude this session. I thank my co-chairmen, persons and co-moderators for presiding over this session, and thank to Dr. Anil Arora and his team of organizers from Sir Gangaram Hospital for giving me this opportunity to preside over the session. Thank you very much.
Thank you all our speakers for such wonderful talks, and our respected chairpersons and moderators for moderating the event. So the next session is Clinics in Hepatology. The next session is themed Clinics in Hepatology, and this would be a 30 minutes exciting panel discussion on the topic Pearls of Wisdom in Day-to-Day Hepatology. And for this session, I would request to come up on the stage our esteemed Dr. Patrick S. Kamath, Mayo Clinic, Minnesota, as speaker cum moderator. And as a panelist, I would request to come up on stage Dr. Ashok Chaudhary, ILBS Hospital, New Delhi, Dr. Amrish Sawhney, BLK Hospital, New Delhi, Dr. Narendra S. Chaudhary, Medanta Hospital, Gurgaon, and Dr. Rohit Mehtani, Amrita Hospital, Faridabad.
Anil, thank you so much for inviting me. I really enjoy my trips to India, as you know, and come here quite often. So, I've done so many of these talks that it's difficult to come up with new cases. So I thought I'll come up with something we've not discussed before, and that is reproductive health and pregnancy in patients with liver disease. So that will be the main focus, and then if you have time, a few other cases, okay? So protocol for the session, many of you know, usual. I'll present a case, then I'll give you choices, show of hands, then I'll ask the panel to discuss, then I'll tell you how I manage the case or what the recommendations would be, And then towards the end, we'll have some questions. Just because we have limited time, we won't take questions after each. Okay, so for those who've not been for any of my sessions before, we can always start off. It's amazing how quickly people forget the answers. Okay, so this I gave a question maybe 3 years ago. Highest number of career catches in test by an Indian cricketer. Let's see. Dhoni, show of hands. 5, 6, 7, 8. Rahul Dravid. Some more. Kirmani. 3. Rahane. 1. Azharuddin. Good. So all of them are associated with some records. Okay, so here we see. The highest is Dhoni, but wicket keepers generally have a separate record because they have an advantage in taking catches. So Kirmani was second highest. Dravid is the highest by a non-wicket keeper. Rane record, this is a world record, 8 catches in a single test. Azharuddin also world record, 5 catches in a single innings. Okay, so this is how we're going to go about it. Let's start. So this is a patient from India whom I saw maybe 2 months ago, and that's the reason I thought, let me discuss a little more of this. So she's somewhat obese. She's got cirrhosis, Child's A. She's of Indian origin in the US and wants to come back to India. And she wants to know, can I have assisted reproduction? Can I have in vitro fertilization? So question for the audience, who will say yes? No? Okay, few will say no. What do you think? Ashok? Do you want to use the mic?
Yeah, she can go for. Yeah, I think she can go for the pregnancy.
So generally what do you advise them? So when they want to go, what are the risks that you discuss with them? What are the chances it will succeed?
So this, if is well compensated, then I will say there is less than 20% chance of worsening of liver disease during pregnancy, and post-partum period will be a little bit troublesome. We need a specialized care. There are 2 things, and there is chance of little bit more as far as fetal complications are concerned.
So which group? So what do you tell them will be the likely success, and what will you tell them will be the likely side effects? So that's the important thing here.
Yeah, in this lady, it will be definitely viable pregnancy, and if he's compensated, I'll advise to go for the.
Okay. Rohit, do you want to add on anything?
So if the MELD score is less than 10 pre-conception, the MELD score is less than 10, there are very few chances that the patient will have any adverse outcomes related to the liver disease during the partum period or postpartum. Okay. But if the MELD score is more than 15, she is likely to have adverse outcomes.
Yeah, so generally you say yes, but they're going to be higher risk and lower success the worse the liver disease. Okay, so then they have to take chances. So when you say there are risks, what do you say are the risks? Rohit again.
So as far as the patient herself is concerned, there is risk of development of decompensations, and there is...
So when you say decompensation, what is the biggest risk?
Bleeding. What sort of portal hypertension related complications like GI bleeding.
Like bleeding. Okay, so bleeding is... And what about the baby?
So baby, there is risk of preterm delivery, IUGR.
Okay, so good enough. So there are those. So when you see a patient, and this is a question I want to know what you all do, because we know that pregnancy can occur in patients with cirrhosis, so it's always best to plan it. So what are Narendra, what are your recommendations? Do you generally discuss this when you see a young woman of reproductive age? Again, I'm learning, okay, because you have to tell me what you do here.
Sir, I asked to avoid pregnancy, specifically in patients with portal hypertension, even if compensated.
So you generally tell them, if they don't have portal hypertension, you don't recommend?
Still, my suggestion is to avoid. It is very rare situation actually. Young females coming with cirrhosis is very rare. But my suggestion is, ideally you should avoid pregnancy. If portal hypertension, then definitely.
Then, okay. So, So this is what we generally know about pregnancy and cirrhosis. So it's possible in well-compensated cirrhosis. I typically have a discussion with them because even if they have portal hypertension, sometimes they really want to have a baby. Then our role is not to say no. For me, it is to discuss options and try and help them through the pregnancy. So biggest concern is variceal bleeding. And so we're going to screen for esophageal varices. Anyone, we also have to do an ultrasound, which is not for hepatocellular carcinoma. We do an ultrasound always in a patient who wants to become pregnant. Anyone? Why? You have to do an ultrasound. And you're not even looking at the liver. Can you tell me why you'll do that?
This is for the gallstone.
So why will you do an ultrasound in these patients? Amrish, do you want to?
Sir, one thing is that we should look for gallstone, but I think I will also look for hepatic veins in these patients.
For?
I will also look for hepatic veins in these patients.
Bud carry.
So asymptomatic bud carry. Okay, I think the biggest risk why you must do an ultrasound is splenic artery aneurysms. Remember, pregnancy increases growth of splenic artery aneurysms. Cirrhosis is associated with splenic artery aneurysms, and if they rupture, it is fatal. Okay, so anytime you discuss, don't just focus on the liver, also look for splenic artery aneurysms in these patients. Okay, and 10% risk of complications if the MELD score is greater than 10. So generally, you can say yes to pregnancy. Just be very careful, follow these patients well. So these are the guidelines, the US guidelines for assisted reproduction in cirrhosis. No contraindication in women with cirrhosis or prior transplant. So we'll say go ahead. We also tell them that if they have got more advanced liver disease, their success is less and their risk is more. And liver transplant patients, again it's okay, pregnancy is again okay, as long function is good. Okay, now let's come to another case. Case number 1, 25-year-old primary gravida, 35th week of gestation, blood pressure 140/90, somnolent, not jaundiced, hemoglobin 11.3, platelets 140, AST 180, ALT 238, INR 2, creatinine, LDH, glucose you can see. What you're going to do next. And at the end of it, when I'm finished in pregnancy, maybe I'll ask Harshit to make a comment on pregnancy and liver disease, because I don't really see that many, because just the way we work there. So who will do testing for viral hepatitis in these patients? Monitor liver tests, blood pressure control, some prompt delivery, more. Okay, who wants to start? Rohit, we'll start from you.
First, the patient should be admitted, and because she is somnolent, there are raised liver enzymes, hypoglycemia. The INR
So what do you think is the diagnosis, most likely diagnosis?
HELP syndrome, sir. HELP syndrome.
HELP, okay. Any other possibility? There's an overlap with HELP,
Yeah,
and that's why I had something in blue. So we'll go over the overlap, it helps you
AFLP.
differentiate.
Acute fatty liver of pregnancy.
Yeah, so we'll go over why. So in fatty liver of pregnancy, what's the most important here? Management?
We have to deliver the patient.
Good. And I think you had a talk yesterday on that. So prompt delivery. So here is how you should look upon pregnancy. There's pre-existing disease and patients get pregnant. So autoimmune disease, viral hepatitis, they may have cirrhosis or Wilson's disease. And then there's coincidental, that is, patients didn't have liver disease before, they now have pregnancy, and they have diseases which come on during pregnancy. So viral hepatitis, gallstones, drug-induced bud Chiari, late pregnancy, postpartum. You have Dr. Kuru here who had done postpartum bud Chiari syndrome. But let's focus on unique to pregnancy. So anytime a fellow tells me pregnant and liver disease, I ask which trimester. So it's easy. If you go through trimesters, you know the problem. So hyperemesis gravida, first trimester, going early into second trimester, unusual beyond 20 weeks. Intrahepatic cholestasis of pregnancy, end second trimester, then third trimester. Preeclamptic HELP and acute fatty liver of pregnancy, third trimester. So just looking at which part of pregnancy they are, you can try and get an idea about what their liver disease is. Okay? Now, why should you know these which are unique to pregnancy? Because they tend to be very serious and lead to maternal and fetal mortality and morbidity. And there's a risk of recurrence, which we will go over a little later. Okay. So, Ashok, I think it was your turn. Coincidental disease. We're just summarizing what I said. Coincidental disease, which are the ones you're thinking of?
So coincidental
which can occur at any time?
So as much as possible to try that the pregnancy should continue till just completing the term. So if it is also coexisting, coincidental or pre-existing.
Yes, so which ones are you thinking of? Which diseases are you thinking of?
Most commonly pre-existing will be autoimmune hepatitis.
So it's going to be viral?
Yeah.
The coincidental disease which come on. So you can get, okay. So viral, drug, autoimmune, they can come on. Okay, and pre-existing disease are the same. Okay, Ambrish, fill up this. First panel, end first, beginning of second. Which disease are you thinking of, Ambrish?
Sir, in pre-existing as autoimmune and
no, we are talking about unique to pregnancy.
Unique to pregnancy, sir. First trimester, at the end of first trimester, intrahepatic cholestasis of pregnancy can present.
So first trimester is hyperemesis gravidarum. Okay, and
starting of
Narendra,
second to
what
third.
Do you think? Narendra, second trimester.
Generally ICP presents in third trimester, but it can present in second trimester also. Correct. Rarely in first
so
also.
Intrahepatic cholestasis, and the rest are third trimester. If you remember this chart, that's all you need to know about pregnancy and liver disease. Is that clear? Okay. Now, fatty liver is rare. There's microvesicular fat in the infiltration of the liver, and so Rohit, here is it. So we have different pathogenesis than HELP, but preeclampsia can be present in about 50% of patients, and that really makes diagnosis a little more difficult. And they may have mild thrombocytopenia. So here's how you should go about it. It's called definition, but I really think this should be called diagnostic criteria. Patients have multiple symptoms, and there is an overlap here. So let's look at it more carefully. What can be present in HELP? So as Rohit told you, you can get a little thrombocytopenia. These patients have vomiting, pain, elevated transaminases. So this is overlap. Both HELP and fatty liver can see this. But what do I look for to suggest fatty liver of pregnancy? Because what you need to know is when should I deliver quickly? And in blue, as you see in a patient, when you see encephalopathy, when you see hypoglycemia, when you see coagulopathy, that is suggestive of fatty liver disease. Okay? So remember, first trimester, second trimester, third trimester, those diseases. Next to remember, if you have encephalopathy, hypoglycemia, and coagulopathy, early delivery in these patients. So how do you manage? Intensive care, immediate delivery, liver transplantation, because most will recover, but some will actually do worse, and so they require liver transplantation. So back again, whose turn? Rohit, what should you look for in the baby? Now, baby born to mothers of fatty liver, is there any particular problem they're likely to have? Should you follow them closely for anything?
They have hypoglycemia. Hypoglycemia in the baby.
Very good. So what's that condition? You're right. So Ashok is right. They get hypoglycemic. Due to what? What is the deficiency? You can...
LCHA, fatty acid oxidation.
Very good. So genetic testing for LCHAD, both in the mother and the baby, and babies with LCHAD can develop non-ketotic hypoglycemic coma. Harshad, do we have testing routinely for this year? Microphone is just behind you.
The few reports from India have not suggested LCHAD deficiency, and LCHAD deficiency has not been replicated in many
So you
many
don't
countries.
see that here?
We have from the experience that I have from CMC Vellore and some other places, we have not seen LCHAD deficiency despite doing it in scores of patients.
Okay. And so the mechanism here might be a little
Perhaps
different.
could be a little different.
Okay. So I mean, this is generally...
But this test is available in India.
What's that?
This test is available in India.
It is available.
Yeah, it's easily available.
Okay. So if you get... So this is how it works. The mother is typically heterozygous. The baby is homozygous. They get deficient beta oxidation of fatty acids, and that gets fat in the liver. So here's a summary slide. So how will you evaluate patients with abnormal liver tests in pregnancy? Patient can be cholestatic. Consider the usual. Get an ultrasound. Drug is common in these patients, PBC, PSC, and do whatever tests that you need for these patients. They may have a hepatocellular pattern, viral hepatitis, autoimmune hepatitis, maybe drug-induced liver injury, fatty liver disease, and do whatever tests you need for that. The important is consider diseases unique to pregnancy, and again, like I said, based on gestational age, hyperemesis gravidarum, first trimester, ICP, end first trimester, end second trimester, third trimester, and the 3 bad diseases are all part of third trimester. And look at bile acid levels. We're going to talk about that in a bit, and all the other tests that you do. We'll come to another problem in pregnancy. So this is coincidental disease. So she presents to the emergency room, 30-year-old woman, 14 weeks gestation. This is biliary colic, okay? Right upper quadrant pain. Labs, only ALT is elevated. Ultrasound shows gallstones. No cholecystitis, no bile duct dilatation. Pain has subsided. So biliary colic, pain subsided, no cholecystitis, no biliary dilatation. Who wants to do cholecystectomy? Can we show of hands? Some. Conservative management. Some more. MRCP. Few. ERCP. Okay, no one ERCP. Good. Whose turn is it now? Ashok, is it yours, or Narendra, your turn, right?
Yeah. Sir, MRCP to look for biliary obstruction. If it is CBD stone, then it...
So you want to do MRCP?
Yes, sir.
And because you think there's CBD obstruction. Is that why you... And the pain has subsided, ultrasound is okay, you're still suspicious.
Yes, sir.
So your yield is going to be how much? High chance you have stones or low chance?
Low chance.
Low chance, okay. So generally these are the recommendations. For biliary colic, don't get too excited. So we'll go over the guidelines here. Gallstones are common. Postpartum, around that you will get 10% will have gallstones. Clinical manifestations, not that common. Complications, not that common. And we'll talk about when you have to get aggressive here. First episode of biliary colic, manage conservatively. Recurrent colic, cholecystectomy. Complicated biliary disease, you need to do something. So if you strongly suspect choledocholithiasis, cholangitis, then you have to have an ERCP and cholecystectomy. Who are the fellows here in training? No one in training? So one of the things I think all of you should read is management of pancreatitis in pregnancy. It's a little more difficult. Cholecystitis in pregnancy, and of course CBD obstruction in pregnancy that you need to know. Okay, so this is how you go about it. And if you're doing cholecystectomy for recurrent disease, try and move it to the second trimester. Coming back to intrahepatic cholestasis of pregnancy, so this will be the pruritus, second or third trimester of pregnancy, elevated liver tests, rarely jaundice. You have to exclude obstructive biliary disease, so you need an ultrasound in them. Okay. Bile acids. How are you going to use bile acids? Whose turn is it? Narendra, is it your turn? No, I think Narendra just finished. Rohit?
So bile acid more than 10 supports the diagnosis of ICP.
So do you take a certain... Oh, Ambrish, it was your turn, right? I forgot you. You had the...
Sir, bile acid, if it's more than 20, I will take it as a risk for fetus, and if it is more than 40, a definite risk I will explain for
so
the
remember
fetus.
the 40. Remember the 40 level, we'll come into that again. Over 40 associated with worse outcomes. So when you're talking about outcomes, okay, Rohit, you know. When you're talking about outcomes, you're worried about outcomes for the baby and for the mother. So cholesterol pregnancy, whom are you more worried about?
Baby.
Baby. Mother will age, but post-delivery, things will get better, okay? We're more worried about the baby, we'll go over that, and that's where the bile acid levels come when you deliver the baby. But if the mother delivers, what is she at risk for down the line? So mother's delivered, she's fine. What do you caution about?
Recurrence of symptoms in the second pregnancy.
80-90% will get it to the second episode. So tell them about that. Apart from that, do they have any other problems? Any of you looked after intrahepatic cholestasis of pregnancy?
They can have gallstones. Gallstones.
What do they have?
Gallstones. Cholecystitis.
Very good. So they have a higher risk of cholestatic disease. So they've got high incidence of gallstones. They get pruritus during periods. And there's supposed to be a small increased risk of cholangiocarcinoma in them, probably related to stones. And I think all this is related to the fact that they are PFIC. You know, they are in the same spectrum as that. So pathogenesis related to estrogen and progesterone, less transport of bile. There's a genetic predisposition of this, and there's a high recurrence rate with the subsequent pregnancy. Complications is for the baby, most important. Meconium passage. What does meconium passage tell you, Ashok? What does it tell you about the baby?
Usually babies should get past the meconium within 21st definitely.
Good, so it tells you fetal distress, okay?
Yeah.
It means that about half the babies have fetal distress in here. We know no immediate maternal complications, but long term they'd have a higher risk of, they also have higher risk of hypothyroidism in them. So management, ursodeoxycholic acid, liver enzymes decrease, pruritus decreases, not much benefit for the baby, but it's very safe for the baby. Titrate the dose to take care of symptoms. So elective early delivery. So early means when? What date you want to take? How many weeks?
And the 37.
Whose turn is it? Narendra, your turn?
35 weeks.
35? So 35 is still small. Remember, the babies already have growth retardation. So you don't want to deliver them too early. But you don't want to wait too late because they have problems. So you have to pick based on bile acids. Do you pick any timing?
37 weeks.
Whose turn? I've lost order. Rohit?
37 weeks.
For whom? With the bile acid level? I agree, but did the bile acid level tell you anything? Can you wait 39 weeks?
If the levels are more than 100, then we should do a prompt delivery.
Yeah, 100 is a lot. Okay, I agree. So, at 37, if bile acid's more than 40, this is really a higher risk. So deliver them earlier. But if it's less than 40, you can wait a little longer. Because we're worried about the baby, remember. If you deliver the baby too soon, we'll tend to have problems. Okay, so summary, liver disease in pregnancy, hyperemesis gravidarum, not more than, oh, we're done with 30 minutes, is it? Okay. Pruritus in second half, preeclamptic toxemia, HELP, and acute fatty liver of pregnancy at the end of it. Okay, I think maybe one last case. This is, I like this for fellows. Patient has jaundice in only one eye. Diagnosis, big liver and jaundice in one eye. Wants to guess. You must know this answer because you can trouble all your fellows after this, okay? Anyone? Oh, yeah, good, I heard it. Is what? Good. Good. So remember, this is classic of metastatic melanomas, okay? They have choroidal melanomas, the eye is removed. When it metastasizes to the liver gets big. There's a rule, big liver and glass eye metastatic melanoma. It's very interesting. I read there's a paper from Kerala on 4 patients. I've never seen this. They said they saw unilateral jaundice after a stroke. And that patient had edema on the hemiplegic side and jaundice on the other side. They said vasomotor phenomena. I don't know about this, I've not seen, but I'm just sending a report. So beware of the patient with glass eye and a big liver. Okay, good. I think I'm done. If there's 2 minutes more, any comments on pregnancy? Harsha, then, no? Anyone? Anil?
So the situation may be different in US, but in India, if the lady is having cirrhosis of the liver, they will leave the decision on to you. So I think we should step in, and in child B and C cirrhosis, we should tell them they should not conceive, because the ongoing complication, both because of the advancing liver disease and add-on stress of the pregnancy, is going to give her the problems. So we maybe have to be a part of the decision-making body to tell them, and B and C, no pregnancy. Any comments?
Yeah, I do. So I must say, I left India more than 30 years ago. To me, the biggest problem, Harshidi might remember, is non-cirrhotic portal hypertension. They're otherwise well, and they have variceal bleeding. You know, we've taken them through pregnancy. In the US, my biggest thing is portal vein thrombosis, portal hypertension, trying to take them to pregnancy. I have a discussion, I try and help them through it if they really want to go. I never say no. They have to make the decision. I have to only advise.
But 30 years down the lane, the NCPF has almost disappeared from India. So it's all cirrhotics.
Yeah. No. So the question is for cirrhotics, you say no to pregnancy?
B and C, child B and C, because you have to be a part of the decision making.
No. So that's the discussion. For B and C, we tell them, A, the risk is high, and B, the chances that anything will work is low. So that is the chance. But ultimately, you know, they have to make the decision. We only discuss with them.
So regarding your first...
Do we have time?
Can I ask one question?
Do we have time?
Yeah, 1 minute.
Okay.
I think this is a small question. Regarding the first case, suppose the patient has got large varices. So would you like to eradicate the varices and then ask the lady to get pregnant, or you want to put her on beta blockers so that she can take beta blocker rest of her during the pregnancy?
Oh, I forgot which the first patient was.
First patient was compensated cirrhotic, and she wished to get pregnant. Then you ask the panelists whether she can be pregnant or not.
So the hypothetical. So the question here is, if they want to get pregnant and they have varices, yes. So remember, there are 2 issues here. Beta blockers can cause bradycardia in the baby too, but we use beta blockers, yes. That's the answer. So if they have big veins, beta blockers.
So she can continue right from the beginning till the end, beta blockers. She can continue with the beta blocker throughout the pregnancy. Is this your answer?
So the question is, do you use it throughout the pregnancy?
Yeah.
Yes, we do.
Okay.
Yeah. I'm having a lot of echo.
Primary EVL, sir.
Primary EVL for variceal prophylaxis. Whether primary EVL
So primary?
I think endoscopic band ligation. But he wants to ask whether...
No, I heard band ligation. There's a lot of echo I'm getting here. So band ligation versus beta blockers. Yeah, I use beta blockers because with band ligation goes the sedation and the other effects for the baby. I always like simple and cheap.
No, the only thing is because she is not pregnant right now. She wished to get pregnant. Suppose we can, because the beta blocker has its own side effects.
Yeah, so the question is, if they want to get pregnant in the future, beta blockers versus ligation, which would you prefer?
Yeah,
so that's the question.
Yeah.
So that anytime you have 2 treatments, you have to say efficacy, both are about the same. Compliance, beta blocks you have to take at least once a day regularly. Endoscopy, you have to come back. Costs of the 2. And last of all, complications. So overall, when I look at all these four, I prefer beta blockers, but if you want ligation, that's fine. That's a preference. Yeah. Okay. Thank you very much. Thank you so much, Rohit, Ashok, Narendra, and thank you.
Thank you, our respected speaker, sir, and all the panelist members for conducting such a gripping session. So for the next session, the topic of our next session is tackling the NAFLD epidemic. And for this, as chairpersons, I would like to invite on the stage Dr. Bhupendra K. Basnet, National Academy of Medical Sciences, Nepal, Kathmandu, Dr. Nipun Verma, PGIMER, Chandigarh, Dr. Sagar Podial, NPI Hospital, Bharatpur, Nepal, Dr. Samarth Sharma, Elite Medicity, Bilaspur, Chhattisgarh, Dr. Vikrant Singh, Government Medical College, Jammu. And for moderators, I would like to invite on the stage Dr. Amit Sachan, Bareilly, Dr. Nitin Bharatiya, Aditya Hospital, Dibrugarh, Dr. Goldie Logayam, Shrija Hospital and Research Hospitals, Imphal, Manipur, Dr. Amit Basnotra, Gastroenterology Clinic, Jammu, and Dr. Rajendra Kumar, Acharya Sri Chandra College.
To start talk on fatty liver in donor implanting GRWR. Please, Dr. Subhash Gupta.
Can I have my slides, please? Thank you very much for inviting me, and thank you, Anil, for holding this every year to deal with the many problems that we face in our day-to-day practice. So this is a very favorite topic of mine, plummeting graft body weight ratio and fatty liver, of course, but I think that's a little bit solved as far as we are concerned. So the two aspects of my talk, one is steatosis in donors, and I'll go through that briefly and then focus more on the graft weight issues. So the impact of steatosis is mainly in diseased donor liver transplantation, where it is characteristically associated with long cold ischemic time. There's fat sort of solidification and sinusoidal obstruction. And in LDLT, that's much shorter cold ischemic time, and also brainstem death triggers inflammatory response, and graft is not as robust as in LDLT. So the greater worry really for us, as far as transplant physicians are concerned, that what about these donors who have fatty liver, and if they donate, even if they lose weight and become okay, what's going to happen to them later on in life? Because they are likely to face surgery maybe or intervention later on, and are we making them worse because they've donated in the past? And by definition, donors must all be healthy. So this is what point I was trying to make, that there's lesser impact of steatotic livers in living donor liver transplantation. There's a paper from China, and even, we would not be doing this with idiopathic portal inflammation, but the Chinese went on and reported their experience on not only steatosis but idiopathic portal inflammation, and they said that the recipients did okay. But actually we're not concerned with fatty liver with the recipients, but we're more concerned with the donor long-term issues. Now there are categories of hepatic steatosis. We heard about that in the preceding talk as well. The microvascular steatosis, which probably has little impact in our transplant decision making. But macrovascular steatosis, more than 30%, and particularly in diseased donor liver transplantation, there's increased complications, prolonged ICU stay, and perhaps graft dysfunction and primary non-function. And sometimes micro and macro may both coexist. We only focus mainly on the macrovascular steatosis when we want to calculate the fat percentage. Ultrasound of the liver pulse is very unreliable, but CAP score can quantify, and as sort of transplant physicians, we usually rely on CT or MR, proton dense fat fraction. That's a sort of protocol, current protocol, MR fat fraction, less than 12%, they go ahead, but of course, they will, all are advised to have lifestyle modification, exercise, change in diet, and I'll show you why Dr. Pamecha has published that elegantly from ILBS and a randomized controlled trial, 12 to 30%, they'll have liver biopsy, and if they have steatohepatitis, we'll reject donation from them, whereas if they have steatosis, they'll go on to lifestyle modification. And if it's more than 30%, then we reject. So that's a program over the years. Last year we did 437 transplants, and this year we've done 320 transplants. So based on this, we looked at the extent of steatosis in our modified right lobe graft. That's the only group it really matters. In left lobe donation or left lateral segment donation, fatty liver of the donor is really of little consequence, because right lobe donation is a big operation for the donor. So this is for one hand, this time period is only for the last 4 years, that's why the numbers seem smaller, 1382. So MR fraction less than 12%, majority of donors, between 12 and 30%, 4.5% of donors, and less than 30%, I think this must have happened by an error. So some, of course, data was missing. And then we looked at graft ratios and fatty livers, extent of steatosis in the donors, and the great majority you see are less than 0.8 and less than 20% fat. So that's a correct practice. Then we went on to look at MR fat fraction and whether it had an impact on discharge and death, and up to 5%, or between 5 to 12% and 12 to 25%, really there's no significant difference as far as discharge or death was concerned. But more than 25%, there's a significant impact on discharge as well as mortality. So lifestyle optimization, this has become very popular. We've been doing this for a long time, and has been published as a paper, as a randomized controlled trial by Dr. Pamecha. Excellent work. Has showed that improved liver regeneration happened and decreased allograft dysfunction happened with dietary modification and exercise. And I think this is a very important practice for all transplant surgeons. So now moving on to the next part of the talk, which is conventional wisdom for graft weight, is that the graft ratio should be more than 8, standard liver volume should be more than 40. This is a topic of great interest to me. And I'm going to first take you through history. This is based on Professor Tanaka's paper in 1999, which showed that the graft weight was greater than 0.8, then the outcome was better. And this was published in Transplantation 1999. Here I'm reproducing the abstract of the paper on graft size matching. And you look here that most of these were for pediatric recipients. And based on this, the recommendation was made. And the average graft weight was, and there are no right lobe grafts in this series, and the average graft weight was only 370 plus minus 66 grams. And adult to adult right lobe liver transplantation was first reported in 1997. But these conclusions derived from left lobe donations, so pediatric population was thought to be valid for right lobe donations as well. So therefore, you will find that there is a huge number of publications suggesting that good outcome can be obtained when the graft ratio is less than 0.8. Because most of them will have a graft volume greater than 370 grams. If in the current day, if we were to look at appropriate graft ratio for recipients, it would be impossible to agree on which is the ideal graft weight for success. A 30% remnant liver is sufficient for the donor, but 70% would not be adequate for the recipient. That's what is the current wisdom. And the reasons that are given are that the recipients need more graft volume because they have higher metabolic demand, they're sicker. But both these parameters are very difficult to measure. They're just arbitrary terms. So, but there are some differences in the recipient which may impact on the outcome. For ischemia reperfusion injury or hyperperfusion injury from increased portal hypertension, and of course inflammation, rejection may, you may need to have a liver volume and may come in way of regeneration. But none of these are related to graft weight. And if you look at the evolution of right lobe graft, the first right lobe graft was inadvertently done in an adolescent patient where the left lobe had multiple arteries. This was a standard right lobe graft. Then on Low and Fan from Hong Kong, reported successful transplant in adult with an extended right lobe graft was used. But of course, this we thought was not safe for the donor, and therefore we went on. Professor Lee from ASAN in his seminal work showed that modified right lobe graft was the best way to go forward. But across all these types of grafts, the ratio definition has not changed. So there are some differences, of course, which are related to graft volume, because in disease donor liver transplantation, ascites, post-operative ascites is really not a problem. But in partial liver graft or living donor liver transplant, regeneration is important. So there must be a certain amount of available graft volume to sustain life in the first few days while the liver is regenerating. And we felt that it may be it is quite possible that absolute volume may be more important than the ratio. So now let's look at this sanctity of 0.8. Many groups now have reported good results with graft volume. In fact, no donor will ever be rejected if the graft ratio is less than was between 0.8 and 0.7. And in 2016, we published in liver transplantation that graft ratio is immaterial when we were doing patients who were more than 100 kgs. And in our current practice, the ratio is little meaning. There more focus is on quality and reconstruction of the interior sector drainage. That's the paper I was referring to. Living donor liver transplant in patients weighing more than 100 kgs, and they all had a reasonably good outcome. And the mean ratio is 0.7 compared to the control group, and 17 of the 56 obese patients received grafts of less than 0.65, and the smallest graft in our series was 627, giving a ratio of 0.52 in a 120 kg recipient. Now there is a problem in calculating in a day-to-day basis the graft weight ratio. Which body weight to use? Many of these patients are very, very fluid overloaded. So do you use the graft weight that they have now, or when they were well, or the weight, their current weight? Fluid content, how do you calculate that? Fat content, does it have the same metabolic demand as lean body mass? And it's quite common that post-transplant these patients lose 10 to 20 kgs of weight. And recently with widespread albumin use, free fluid accumulation may not be obvious, they're more in the subcutaneous spaces. But graft weight has been sort of implicated in small for size syndrome, and there are many definitions for small for size syndrome. And as you'll notice, except in one definition, which is given in 2005 by Dam, that the graft, if the ratio is less than 0.8. In the subsequent definitions, none of them have actually said what should be the graft weight or ratio to define small for size syndrome. So why graft size not been included in the definition? Because impossible to portal hypertension may vary from patient to patient. Outflow reconstruction may not be adequate. There may be arterial hyperperfusion from splenic artery steal, big spleen, intestinal mucosal injury, and liver regeneration may be flawed for some reasons. Of course, there can be other factors such as age of the donor. Younger donors are supposed to regenerate better, but at the same time, younger donors tend to have smaller bile ducts, and there may be higher biliary complications in the recipient. This amount of steatosis will vary. Congested segment in the liver behaves as a sort of inflammatory nidus and alters liver function even if the volume may be adequate. Ischemic injury and perioperative recipient factors and portal venous circulation. So there are sort of right lobe graft limitations whereby this ratio becomes important. Usually taken without the middle vein. Extended right lobe grafts have been described, but nobody in the world does it anymore now. The best of anterior sector drainage cannot match an extended right lobe graft. And you see here is a picture of a middle hepatic vein with multiple tributaries, and if you, there are 4 of them, it will be very difficult to reconstruct them on the bench. So anterior sector congestion is a big problem in living donor right lobe transplantation. This is a nidus for inflammation, may cause bilirubin to rise in much the same way as that left lateral donation as compared to left lobe donation will have higher bilirubin as compared to a left lobe donation because there are no ischemic segments. Also, hepatic artery blood is drained from portal vein and results in worsening of existing portal hypertension. And there may be asymmetrical hypertrophy because one sector is not draining, but the other one is draining better. So these factors may result in small for size syndrome. And this is a work from Hong Kong, American Journal of Transplantation. They said that as experience accumulates, small for size syndrome kind of disappears. And although the grafts are smaller, so in this paper there are 2 errors. In the first error, the ratios were in the groups which had thought to have small for size, the sort of mortality and death was much lower in the second era, even when the grafts were smaller in size. So what's important, small foci syndrome or middle vein thrombosis? I think this is, once the middle vein thrombosis, the picture is akin to small foci syndrome. So the effort should be on middle vein thrombosis prevention rather than graft inflow modulation. I'll come to that in a little while. And our current strategy is to re-explore or stent the middle hepatic vein if we find it to be obstructed. This is a patient who had an uneventful transplant. Unfortunately, next day the lactate was not coming down. We got an urgent Doppler and we found that the reconstructed middle vein had no flow. So IR, we are a very excellent IR person, and he put a stent in the middle vein and the patient recovered and went home. Then we come on to another important aspect of graft weight versus ratio. So we are over 4,000 living donor transplants over 20 years. Graft ratio is not an important factor for patient mortality. And dual lobes are really not feasible in our series, but we found that when the volume was greater than 650 grams, the outcome was not dependent on the ratio. So we then analyzed on outcome in patients where the ratio is less than 0.8 but different graft volumes. So we looked at less than, this was based on a receiver operating curve, ROC curve, and those who had less than, more than 640 grams and those who had less than 643 grams. Obviously, in most aspects they were similar, but the less than 643, the patients were heavier, BMI was bigger, and they had sort of more females in that, in less volume. This is a big problem in our country because most donors are females, and the graft type was sort of more extended right lobe in the smaller grafts. So when we looked at the outcomes, clearly when the volume was more than 640, then the mortality was only 5.8%, whereas when it's less than 643, mortality was higher. And this we published in Clinical Transplantation, September 2019. So there's a lot of talk about low graft ratio and graft inflow modulation, and this is an important topic because some groups have suggested that small grafts can be successfully used with portal flow modulation. There's a problem with that because high portal pressure is also necessary for graft regeneration. Therefore, we don't know when to modulate, how to modulate, and also have no ill consequences of graft inflow modulation. So do you modulate based on graft weight, do you modulate based on portal pressure, do you modulate based on portal pressure volumes? And none of these factors are clearly known. And we also know that portal pressure and liver regeneration go hand in hand. The recipients actually have a rapid regeneration as compared to the donor liver. And so intuitively lowering the pressure may actually impair liver regeneration. And we really do not know at what point sinusoidal damage versus rapid regeneration becomes detrimental with portal pressure. So what we typically do is we look at the liver function post-operatively rather than intraoperatively. So some groups have suggested that portal volume flow if less than 150 ml per 100 gram tissue, then we should use it for modulation. However, this is very difficult to moderate because in a difficult living donor liver transplant, cardiac output, cardiac index may vary at different points, and portal flows will also be affected. So then portal flow measurements can also vary in the same patient from 2 to 4 liters in the same patient. And therefore you can see a wide range between 100 to 500 ml that's for which modulation has been accepted. What about pressure? We looked at our large series of patients, and those groups had a sort of corrected portal pressure less than 15 or more than 15, there was absolutely no difference in mortality. So really we don't know when to modulate. How to modulate? Do you do splenectomy? Do you splenic artery ligation? Do you do a shunt? And if you look at splenectomy, most surgeons would be hesitant to do it. And this is a paper from 2014 where there was complications of splenectomy, pancreatic fistula, intra-abdominal bleeding, even death, percutaneous drainage, splenic vein thrombosis, bleeding from hilum, and overwhelming post-splenectomy septicemia. Splenic artery ligation may not be effective as spleen has many collateral blood supplies. Ligation of branch may result in splenic infarct, and if you tie it proximal to the pancreatic branch, you may cause pancreatitis as well. What about hemiporocaval shunts for graft inflow modulation? The first reported by Boileau, and as would have it that he had to sort of go and reverse it because the patient had portal steal. So that the current moment, the experience does not seem to suggest that it's a completely safe procedure. And it's not clear from data whether graft inflow model will help or the fact that the outcome was better, because most of these recipients got a graft rate above a certain threshold. So in the end, I would like to summarize that fatty livers, less steatosis, more than 30% big problem. But I really worry not so much for them as from the donation point of view, but what's going to happen to them in long term, because many of them are younger people. So in our own practice, we've now shifted from using younger donors to sort of older donors, as has been the practice in kidney transplantation. The current accepted wisdom is to use a ratio greater than 0.8, but a graft rate more than 650 would mitigate against small size syndrome. And it is open to debate whether we should reject an otherwise acceptable donor on size alone. The role of graft inflow modulation is not clear. Emphasis should be on technical finesse of the operation rather than focusing on whether it's 0.8 or 0.7. Thank you for your attention, and I wish to invite you to the World Congress in Jaipur in mid-November this year. Thank you very much. If there are any questions, I can take them now. Thank you.
Now, the next speaker, Sivaram P. Singh, please.
Respected chairpersons, ladies and gentlemen, I have been asked to speak on NAFLD versus MAFLD versus MASLD. What's in the name? I think someone has already spoken on the nomenclature yesterday, so I won't go into details. My key disclosure, as a member of the Global NAFLD Nomenclature Committee, so people would expect that I would support MASLD. But let me tell you, I am a NAFLD man still. NAFLD has assumed pandemic proportions, and there is no doubt that we have to take the bull by the horns. We have to control NAFLD. And fortunately, and it's a rare thing that India has taken the lead in this. At the global level, India is the first country to take the lead and has incorporated NAFLD into its non-communicable disease program for prevention as well as for management of NAFLD. But all the work done by hepatologists in this country and outside globally has been derailed. The whole process has been derailed because of this nomenclature issue. And this issue is basically the reason for all this problem. The reasons are certain myths. I say myths, not facts. The world of NAFLD especially is replete with myths. A word about myth: the great enemy of the truth is very often not the lie, deliberate, contrived and dishonest, but the myth, persistent, persuasive and unrealistic. And it is therefore a mistake to regard myth as an inferior mode of thought which can be cast aside when human beings have attained the age of reason. Like a novel, an opera or a ballet, myth is make-believe. It is a game that transfigures our fragmented, tragic world and helps us to glimpse new possibilities by asking, what if? An example, a classic example of myth is, bulls get angry when they see the color red. But bulls are colorblind to red. They can't differentiate between black and red. So that is myth. One of the most important first myth of NAFLD. When there were reports of NAFLD from India, the learned NAFLDologist Dr. Sanyal said in the editorial, NAFLD in the Indian subcontinent is probably a medical consequence of globalization. Next important myth I know some of you will disagree with me. Insulin resistance is the key driver of hepatic steatosis, or I mean the major player involved. It is an important driver of steatosis, yes, but there are many more drivers, and all of them work together. The first, insulin resistance or dysmetabolism, that is there. And the second very important myth which is responsible for all this problem is fatty. Fatty word is stigmatizing to patients with NAFLD. This is again a myth which was created. Unfortunately, there was no such stigma. This has been created over the last couple of years, and people have become sensitive about fatty liver. The liver is fatty. You are telling the liver is fatty, not the person is fatty or whatever. There is no body shaming here. But people are selling this for whatever purpose. So once again to the derailment and the great NAFLD war. So now the world is divided into these three groups: NAFLD, MAFLD, MASLD. I am in still the NAFLD group. You have the MAFLD group, basically, powered by the Apazal people, and you have the MASL group by EASL and ASLD predominantly. I think in ASL there is probably a split between the president and secretary. I am not sure. So, you all know what NAFLD is. It's very simple. Amongst all the names, it's the simplest. Non-alcoholic, you have fat in the liver. You are not telling the person you are fatty. It is the liver which is fatty. Liver is not complaining. And these are guiding principles for selection of a new nomenclature. This is what the MASL group has in its publication has mentioned. And if you really go deep into it, almost all these are taken care of by NAFLD. NAFLD satisfies all of them. But yet, this problem arose. The fire was started by this publication in gastroenterology, and the key people, I mean, the photograph in that article were of these three people: Mohammad Islam, Sanyal, Jacob George, a huge group. How they were selected, whom did they represent, and how the consensus was held, that information is not available in details. And MAFLD came up. And MAFLD was supposed to be more simple, but where is it? You are not sure about alcohol, you are not sure. There are so many etiologies which can come into, which can be present. So basically, patient was either overweight, obese, or diabetes mellitus, having diabetes with fatty liver. And in addition, there was a group, fatty liver with dysmetabolism. Who were these people? How do you qualify dysmetabolism? The criteria for them were 2 out of 7 of these which they have shown. 7 criteria. From where did you get these 7? How do you justify those 7? Why you have left out others, or why you have included them? There is no scientific basis for this. Science, this is not pushing science. And no sooner that this group proposed MAFLD, you had this article. Just like the Maharashtra Shiv Sena, Shinde walks out with a group and becomes chief minister. So similarly, this big group of major NAFLDologists, people doing research in NAFLD, they walked out. They said it was premature. We also published this, and even Mary Rinella was part of this group. We published this in J Hepatology and said, NAFLD, it's not time for an obituary yet. And soon Ajay and Sunil from PGI Chandigarh published this. It was not only premature, it is confusing. So we decided one of the key factors why the change was required was what the patients feel, what they want to know. Okay, patient driven. but I think they were middlemen. It was not patient driven, it was middlemen driven. The patient groups do not represent patients. Without data they speak, they pull out rabbits from their hat and say, okay, this patient feels this and this needs to be done. And I found that the hepatologists in America are very, wary about tackling them. So we thought, what do our patients feel about it? 1/4 of the NAFLD population stays in South Asia. What do our patients feel? When we did this survey involving 5 South Asian countries, we found that our patients do not favor name change. They want non-alcoholic fatty liver disease because the word non-alcoholic destigmatizes them. Once they get the tag of non-alcoholic, when they go to another clinic, oh, you have NAFLD, so you don't drink alcohol. Now this is a problem even in America. Even in America, people I have talked to people who have had liver transplantation and were unhappy that even though they had a NAFLD tag, wherever they went, the doctors were asking them about alcohol. You must be hiding your alcohol intake. We then had this consensus meeting, Sadal-Inasal consensus. Those were COVID days, and it was a clear no. Should NAFLD be changed to MAFLD? The answer was no from this consensus group, and we published this consensus statement in Journal of Clinical and Experimental Hepatology. And the reason why we didn't change was, the reasons for not changing were many, but the most important was there was no cogent reason to justify a name change. Next, a name change from NAFLD to MAFLD was replete with demerits. There were a lot of demerits. But this continues. Pressure for changing continued. For people who were into academicians had a wonderful time, churning out papers, paper after paper. Every day you had a paper on the difference between, all this sort of round where they have overlap and all this. Every hepatology, gastroenterology journal had this. There was a competition. And did these articles serve science, serve the patient, serve anything? Nothing. It served nothing, I'll tell you. And see, MAFLD was the NAFLD. Let the contest begin. As if, Muhammad Ali was having his title bout. This was a balanced article in Annals of Hepatology. Evidence-based debate has come. Time to change. They are not saying that it is time to change. They are wondering. And when they did this study, they looked at the clinical and epidemiological characteristics of MAFLD and found that there was no difference between NAFLD and MAFLD. They also looked at the prevalence. It was similar. There was overlap. Then they looked at risk factors associated with all-cause mortality and cause-specific mortality. These, a sum total of different studies, and they found MAFLD increased the overall risk for total mortality to a greater magnitude than NAFLD. However, the difference was not significant when metabolic parameters were adjusted. The risk of cardiovascular neoplasm and diabetes-related mortality was similar between the two groups. So there is no difference in the outcome also in this study. And this is the last study. However, this study by Kim et al. Showed that there was greater mortality in the MAFLD group. But here what has happened is, they have taken pure NAFLD without, this metabolism, and they have taken only the pure. They have excluded people with NAFLD who had MAFLD. That is not what the NAFLD you and I see. Now here is breaking news. All of this thing is based on the premise, the pillar of all this on NAFLD is that insulin resistance is the key driver, and NAFLD is the hepatic manifestation of insulin resistance. Insulin resistance was not a predictor of liver mortality among MAFLD patients. This is in his article published in Hepatology 2022, last year only. So here they did an outcome difference between NAFLD and MAFLD, and the most important, because I think time is limited, the most important thing to note was that insulin resistance was not a factor to decide that. While this thing was going on, this, MAFLD group got together, and I was part of that. I was not part of that. They didn't consider us South Asians, South Asia, where 1/4 of these patients stay. They didn't think that we should be part of that. So, I forced my way after 1.5 years. I am showing this, normally I don't wear this shirt here. Someone asked me, you are wearing this suit and shirt. I said, just to show that this is in Chicago I was wearing that, so I thought since the topic was this, I would come with the Inasal tie. I wanted Inasal and Sazal's presence to be there. And that is how, because of the presence there, that in all subsequent publications, we forced Inasal's name to be there because, people were ignoring us. The only benefit of MASL for me was that Inasal is now part of decision making. So after 4 rounds of Delphi consensus process and then repeated meetings, we had this publication and MASL came into existence. You all know in details, but the key thing is, again, the problem with this is dysmetabolism. What is dysmetabolism? 1 out of 5, from where did you get that? Now let me tell you, we did a study in normal individuals without fatty liver, mind you. Normal, healthy 200 Indians without fatty liver. 97% of them had 1 out of 5 of these. So entire India is having dysmetabolism. What is this? This definition is wrong. You can't decide dysmetabolism like this. And when you compare MAFL versus MASL again, there are basically 2 differences. One is the F word is changed to S word, fatty is changed, steatosis comes in, and the definition changed 2 out of 7 for dysmetabolism to 1 out of 5. Because of problem, so there is need for unity, so there is now call for unity, but unity is not such an easy thing to come. You know that. It's like World War in hepatology. Now this is the editorial, a very, very nasty editorial published in Medical Science Monitor, which literally has lambasted this group, EASL ASLD group. It is worth reading, the content as well as the language. And just like the treaty between, South and, the Russians, East Bloc and the Western Bloc Americans, you had SALT treaty, but still you have the Ukrainian war going on. So war is on. I don't think the last word is out yet. And we had this meeting in Geneva where we sat down, and here again Inasal has become part of that. I and Professor Ajay Duseja, we forced our way in, and so that Inasal name comes up. And this is to create awareness about Inasal for prevention as well as the management, that WHO takes notice and takes action. And sometimes, when you seek a consensus, this is what happens in a consensus process. You have lopsided decisions, and that is what has happened. And this is a cartoon. Thanks, but I am sticking with consensus. It's a herd mentality thing. Lot of articles have come up now. If you do a reality check, you read this article in Medscape. 60 physicians. Now these are people who see NAFLD every day. These are not people, these academicians who see. I see in a year around 7,000, 8,000 NAFLD patients a year. Most of the people who are there in that group would not see so many patients in their lifetime. So confusing, no way, political, ridicule, these are the things people who are practicing hepatologists, this is what they have to say about the name change. And one of the physicians wrote, once again the specialists and other experts are changing the nomenclature to make the subject even more confusing for us primary care practitioners. They obviously have no idea what they have to put up with, what we have to put up with day in and day out. All such revisions do is increase the cynicism and anger so many practitioners have. And this was, they said, acceding to wokeness. Again, there are many articles. Can we use old NAFLD data under the new MASL definition? Again, this study, 99% of patients with NAFLD meet MASL criteria and natural history is therefore identical. Another article, changing from NAFLD to MASL, similar prevalence and risk factors in a large Brazilian cohort. So it is all similar, there is no difference. And best is this article, NAFLD, MASL. Cut the Gaussian knot and change the name to Ludwig disease. न रहेगा बांस न बजेगी बांसुरी. And this is a classic thing which Dr. Sanal has published in J Hepatology. And the best comment is, his whole article should be read by everyone in J Hepatology. The method itself is associated with various biases, he writes at the end, such as incentive bias, because the panelists would be authors of an impactful paper, impact factor 25, I am adding that from my side. Possible confirmation bias, Ben Franklin effect, courtesy bias and acquiescence bias. Biases and biases and biases. I think we should unite, not fight, come together and to prevent this disease and to better guide our patients for a better life rather than squabble over nomenclature. Thank you.
A very nice presentation, sir. Regarding the new term, that the alcohol has also been included in this MASLD or MET-ALD. So it is very confusing for the clinicians. So how much alcohol and how do we elicit the alcohol history exactly? The MET-ALD or including the alcohol in this MASLD? They
have brought in the now term. Dr. Raj Reddy always, pokes at me. Shivram, what is MET-ALD? What is this MET-ALD? And in MET-ALD, you have A. What is A? Alcohol. So you want to get rid of non-alcoholic and you have again put as part of, your MASLD MET-ALD. So it's a mess.
How is it different from alcoholic liver disease, like MET-ALD and alcoholic liver disease?
See, what they have done is, I rush to the slide, that in the group MASLD, you have then MET-ALD again, you have MASLD predominant where you have you have metabolic factors, but alcohol is not much, it is 20 to 30 grams, and at the other end you have ALD predominant MASLD, where you have alcohol intake 50 grams or more. So it depends upon the alcohol intake, they have divided it into two groups.
Hello, sir. So can we prevent future nomenclature changes? Can we put a stop here from NFLD to MFLD to MASLD now? Maybe next year something else will come up and then it will keep on happening.
Who am I to answer this question? Who am I?
Eliciting the history of alcohol from the patient is very different. When we say 20 to 30 gram per day or maybe 50 gram per day, patient may not be drinking that amount every week or maybe some binge drinking also. Some people don't drink that regularly. They drink like maybe in 2-3 months they drink regularly or maybe binge drinking. That's not included in it. So that's very confusing. 20 to 30 or 40 gram, 50 gram per day.
I agree. It's very difficult.
Extremely well presentation, sir. Isn't it good, sir, that everybody is talking about NAFLD, WHO, whole world, and the industry is moving, and a lot of resources are putting into the research and the awareness because of this controversy? What is your thought on that?
See, what I would say is, we were having, World NASH Day, we were organizing it, we were having meetings. Some more people have joined in this Jatra, I would say. But the key things, how many of these people who have joined in are really counseling their patients? Counseling their patient as to what they should do, what should be their BMI, what should be their weight, what they should eat. That is still not being done.
Thank you very much, sir. We have now the next presentation by Professor Anil Arora. to talk on obesity. Who is at fault, mind, brain or gut?
Good morning, everybody. Let me thank Parveen and Ashish for giving me this talk. The topic of my presentation, after a heavy duel of bite between three bulls by Dr. S.P. Singh, let me try to sort out, rather than trying to name the same disease with different names. Let's see, why does the obesity or the fatty liver occur? And who is at the fault? Is it the mind, brain or the gut? First of all, why should a gastroenterologist be interested in knowing about obesity? Is it our domain? If the patient is fat, let it be. How are we concerned? But I think we should remember the whole of the GI tract is riddled with almost all types of hormonal, neuroendocrine, endocrine and autonomic changes, which ultimately will decide whether it is the bile, enteric nervous system, the nutrients, as well as the microbiome, which will take afferent and efferent signals connecting with the brain. So as a gastroenterologist, you have to be a part and parcel of obesity, which is going to be the problem. How do we define obesity? This is the traditional definition that anybody who has a BMI of more than a particular value is likely to be fat. And there are different classifications of obesity. In India, as published by Dr. Ajay Duseja's group, as well as from the Asian group led by Dr. Anup Mishra, we have a bit of difference in Indian scenario. This is the Indian scenario. Anybody less than between 18.5 to 24 is the normal weight, and anything more than 25 is likely to be obese. And there are different classes of obesity. But if you just go by the BMI, the definition of obesity is not only crude, but is also incomplete, incongruous, and has limited capacity. So there has been some attempt by this scientific to have a proposal for scientifically correct and medically actionable disease classification, which tries to define the ABCD of obesity, which means by defining A, you tend to tell us whether the patient has a primary obesity or obesity has a genetic component. Are there any concomitant comorbidities in the form of endocrine causes for the obesity? What is the type of BMI and what are the associated complications? This is what Dr. S.P. Singh had been trying to refer to, various components of the metabolic syndrome and what are the complications associated with obesity. So hopefully with this new classification, we may be able to tell you more about the obesity and will have more meaningful purpose in defining the various medical components of the obesity rather than saying the person is obese or not. If you look at the data of increasing obesity in India over a period of time, we have been having a rapid progression of the people, and this over the last many decades, and there has been increase both in men and women of both mild as well as a severe type of obesity associated in different age group. Now, even in the world, if you look at the data, obesity is rearing like a rhinoceros in different parts of the world. And there are three major reasons why obesity tends to occur in different individuals. And we have this unholy trinity of brain, mind and the diet, which tends to come up in a different way. So which component is the predominant in trying to handle this monster, whether it is mind, brain or the diet? I am going to elaborate in the subsequent slides. As a rule of thermodynamics, as the first law of thermodynamics, we know very clearly that the difference between the food intake and the energy expenditure will decide how much of the fat is stored. If you look at the calories consumed over a year, we consume about 1 million calories over a period of 1 year. In a normal life of an individual, you consume around 42 tons of the water, 3 tons of the fat, 3 tons of the protein, and about say 10 million liters of oxygen. But in spite of that, a person of 70 kg still continues to have only 1 kg of carbohydrate in his body, 3.4 kgs of mineral, and about 10 kg of protein. So how is this balance so meticulously maintained? You are consuming so much, still you may try to maintain some a perfect balance in a given individual. In fact, if you look at the data, over a natural history of the disease in an individual, over decades, the weight change is not more than 10 kg. That is because God has created an excellent so-called set point in which once you start overfeeding, you will gain weight, but the moment you stop overfeeding yourself, you will come back to the normal set point. Similarly, if the person is underfed, he will lose weight, and at the moment you are able to regain your normal diet, you are likely to come back to your normal weight. So who decides what is this normal weight? Is it the mind which is behind the obesity? Let's see what mind does. In fact, once you start eating, there are two types of hunger. One is a homeostatic hunger and second is a hedonic hunger. Homeostatic hunger is when you are hungry because you have not eaten for 12 hours, your metabolic milieu is changed, you have hypoglycemia, you have more of ADP and AMP rather than ATP, and your body cries for energy. That is the time you have a metabolic hunger, you feel like going for lunch. But then there is something called hedonic hunger. That means you just had a meal and you want to have dessert. All of us know that today the lunch is fixed at a time of say about 2 p.m. So even if you are not hungry at 2 p.m. with lunch, you go to a lunch table. That is a hedonic hunger. So the energy balance regulation is done by the central nervous system. So you are hungry, you want to have more satiety, and you have a motivation reward, because every time you eat a particular sweet, like if you like ras malai, every time you eat ras malai, you know that there is some emotional reward given by the brain. So emotional reward, hunger, metabolic hunger, and the extensive interaction of the hormones released by the adipose tissue are processed by this central structure called hypothalamus, which maintains a good balance between food intake and energy expenditure, which decides what you are going to do. So this is what is called brain reward system. So there is a good interplay of the frontal cortex and the celiac neurons in the brain, as well as the interaction with the dopamine producing nervous system in the limbic cortex. Emotional and hedonic hunger can generate dopamine, which is a happiness hormone. Every time you feel happy, that means there is some amount of the dopamine being released in the brain, which overrides the hypothalamic balance which is provided and the food is when the food is easily available. So if you have a hedonic hunger, if you want to have a more release of the dopamine, that the basic capacity of the hypothalamus to control the energetic expenditure is exceeded. Sleep is another component which will decide how much you are able to eat for how long. If you have a sleepless night or inadequate sleep, within a period of 48 hours, there are changes in the body. You have less leptin, you have more ghrelin, and then you have a tendency to overeat. A simple 48 hours of lack of sleep will decrease your satiety, will increase your hunger, and you are likely to become fat. So in mind, you have a unholy alliance between the hedonic processes and the metabolic processes, which are again established by your content and the composition and the working of the hypothalamus. Depending upon the availability of the food and genetic predisposition, that will decide whether you are going to be fat or not. What about brain? That much was about the mind. What is the role being played by the brain? In fact, this was the classical experiment way back in 1901, that if you destroy your medial hypothalamus, which is satiety center, you tend to become obese. And if you try to disrupt your lateral hypothalamus, which is the appetite center, you will tend to become thin. So the regulation of the body mass and the composition, which decides your energy balance, your food intake, is a composite trinity of neuroendocrine function, fat metabolism, and glucose metabolism, which is maintained in this structure called hypothalamus, of which leptin is an important hormone. All of us know fatty liver disease, and Dr. S.P. Singh has very brilliantly talked about fat and the various nomenclature to define and redefine and undefined fat. But fat, as we know, is not an inert structure. It is made up of a number of structures which will have enteric nervous system, autonomic nervous system, and neuroendocrine hormone. So the moment you tend to eat fat, had food in the body, and if This food is not needed by the body, it is stored in the fat. Fat produces a substance called leptin, which goes into the brain, stimulates the hypothalamus, which gives you instructions to the effector organs. So as you eat a good amount of the food, it is stored in the fat, leptin is released, and as leptin goes into the brain, from the hypothalamus, you have the efferent stimuli, which do two things. It tends to decrease the energy expenditure and increase the food intake. If you have a person who is leptic deficient, other things are happening. You tend to continue to eat more and more, and your energy expenditure decreases. So whether you have a insufficient leptin or whether there is a resistance of the leptin which is occurring at the level of brain, that means even if you have a high leptin in the body and if there are receptors in the hypothalamus are not accepting this leptin, it is akin to hyperinsulinemia and diabetes. In both the condition, in presence of the lack of leptin response, you will keep on eating more, you will having less and less energy expenditure. That is what leads to hypertrophy of the fat tissue and development of this fatty liver disease. So in a normal course of the events, leptin will try to suppress intake of the food and inhibit the feeding habit. But once you have a leptin which is not available, you will continue to eat more and more and you will tend to develop obesity. In fact, it is believed that 10% of the morbid obesity which tends to occur in individual population is related to the alteration in the leptin response to the body. Leptin is not only related to the fat alone, there are a lot of environmental factors which will tend to decide whether there is a leptin insensitivity or leptin blockade at the level of the hypothalamus. Feeding, in addition to intake, is also related to the emotional factor, volitional factor, smell and vision. The very fact that you like a particular type of a food, your brain receives the visual stimulus, your appetite gets stimulated because of the previous memory that if you had rasmalai in the past that had given you pleasure. So that all will decide how much you will be able to eat at a given point of time. And mind you, these basics of intake of the food which is memorized is all heritable. In fact, of all the diseases which are heritable, obesity has the maximum chance of heritability in case you have genetic abnormalities. Anergic intake, as all of us know, is the basic, the total obesity is basically related to the balance between the anergic intake as well as the energy expenditure. And how do we expend our energy? We tend to underestimate the role of non-exercise energy expenditure. In fact, if you simply do the common household chores like tidying the house, gardening, mopping the floor, or even taking your pets out, you are spending far more calories than you will do by spending half an hour in the gym. In fact, including more in day-to-day activities is better than being sedentary, and that can make you lose weight. Can we have a control on this energy expenditure? The answer is yes. See, this is how we expend our energy. If you keep breathing, you will not be able to control your breathing for more than few minutes. If you want to sleep, you cannot sleep for more than 2 to 3 days at a stretch. If you stop drinking, you cannot drink for more than 2 to 3 days. If you want to avoid having physical contact, that may last for years. But eating is something which will have a prolonged and persistent effect over a period of time. And this is how we have a myth about Dr. S.P. Singh was talking about the energy expenditure and the myths. In fact, of the energy which is expended by us in the normal day-to-day activity, maximum is done in maintaining the sodium hydrogen ATPase pump, and exercise only requires 10% of the energy expenditure. What is more important is ATP, which is consumed for maintaining the integrity of the cell, energy which is consumed in normal day-to-day activities like household chores, energy which is consumed in physical activity like exercise. So mind you, exercise is not a very important reason for making you lose weight, and energy which is consumed during digestion is only 10% of the weight. So that is how human beings have evolved over a period of time. In ancient time, there was a shortage of the food, and the human beings had to hunt for the food. So because the food was not available, so the ancient human beings had to hunt their food, and because the food was not available, the energy had to be stored in the form of the fat. So only those species which were able to store fat, they survived. The rest of the species that ultimately had to be extincted. So with passage of time, it led to the natural selection of the people like human beings or the birds which were able to store the energy. If you look at the way we maintain our weight over a period of time, over 30 years, our weight has been constant in the range of around 50 to 150 kg. Does gut microbiome has any role in maintaining the normal homeostasis? Do we have the different bugs in the gut which need to be debugged so that we do not become obese? In fact, there have been studies in the germ-free mice that if you transplant the obese mice with the microbiota from obese mice and those who are transplanted with microbiota from the lean mice, it has been clearly shown that the fecal gross energy content in the lean mice is more. That means the obese mice are more able to have more extraction of the calories from the diet. So that has been convincingly shown. In fact, there is also human data to show that if you look at the fecal microbiome samples from the obese as well as the lean individual, there is a higher ratio of the firmicutes to the bacteroids. So that means the higher the firmicute, lesser the bacteroids, more likely you are likely to be obese. And how does this microbiome affect the development and onset of the obesity in a given individual? There are three proposed mechanisms. It can be acting through the bile acids, it can be acting through the short chain fatty acids, or by inducing chronic inflammation as well as the insulin resistance. So this is what happens. Once you have a combination of the primary bile salts which land up into the large intestine, these are acted upon by the bacterial cell, 7-alpha dehydroxylase get converted into secondary bile acids. Primary bile acid act on the FXR receptors, secondary bile acid act on the TGR4-5 receptors. And as these acids are acting on the FXR receptor, they produce a substance called ceramide which tends to go into the liver, and ceramide is something which once it enters the liver, leads to adipose hypertrophy. The reason is once these are landing into the hepatocytes, they produce a cascade of changes which leads to endoplasmic reticulum stress, production of the reactive oxygen species, oxidative stress at the mitochondria leading to fatty liver diseases and apoptosis. Once you have a stimulation of the TGR5 receptors with the secondary bile acids, that lead to increased release of the GLP-like hormones in the portal circulation and hence into the circulation, resulting in increased insulin secretion and improved glucose tolerance as well as increasing the energy expenditure. At the same time, once you have good quality bacteria in the gut, you will produce more short chain fatty acids primarily in the form of acetic acid, propionic acid and butyric acid. These short chain fatty acid, they tend to act upon the G protein coupled receptors which tend to increase the release of the incretins. They tend to have more of insulin sensitivity. They lead to increased consumption of the energy and try to decrease the insulin. Similarly, these short chain fatty acids like butyric acid, acetic acid, they try to cross the blood-brain barrier, act on the hypothalamus, and they will have a different acts on either the appetite stimulating or appetite suppressing hormonal changes. Similarly, the gut microbiome also will have some effect on the intestinal motility. As this intestinal gut dysbiosis results in increased motility, you have a transmigration of the bacterial products across the portal circulation into the systemic circulation, and hence there is a change in the milieu of the type of macrophages both in the lymph node as well as into the portal circulation, and it changes from M2 type of M1, which is a pro-inflammatory cytokines. But the problem in trying to implicate microbiota in patients with the obesity is that at the moment the evidence linking specific gut microbiota to the obesity, that fell short of establishing a causal relationship between the two. There are a number of studies which show contradicting results. Most studies are done on germ-free mice which at baseline have a lean hypermetabolic type of phenotype which are resistant to weight gain, and differences in the microbiota of small and large intestine as still are not known. This is a new upcoming field which may have a bright future. Thus, the knowledge of the gut microbiome at the moment is still primitive stages and still needs far more extensive result. To sum up, ladies and gentlemen, we know there is a rising prevalence of obesity all over the world. leading to a big bullfight as been presented by Dr. S.P. Singh. The dopaminergic reward pathways and the hedonic hunger processes altered the fine-tuned hypothalamic processes that will control hunger and the weight loss. So mind has a big role to play even when especially when the food is hunger, and the balance between the metabolic hunger and hedonic hunger will decide how much you are able to eat. Even if the brain tells you, and even if your body tells you that you should not eat because you are metabolically full, but your hedonic hunger will make you eat more and more, because you will have stimuli which are visual, which are memorized, which are auditory, or even smell, and even from the smell they will continue to have more and more food. Leptin, through its action on hypothalamus and regulation of the hunger and metabolic process, plays a major role in pathogenesis of the obesity, and control of the food intake is not only related to the leptin but also to the ghrelin. Diet has not much of the role in terms of control of the diabetes, because by default we know calorie is a calorie. There is some confusion as to which diet is better, but irrespective of what you eat, what decides your weight will be ultimately how much you eat. Gut microbiota as of now is still in the primitive stage, but there is good data to show that is a higher composition of the firmicutes to bacteroids, and alteration in the affects our metabolism and affects our stimuli, as well as the primary and secondary bile acid has an important role to play. In addition, the alteration in the gut microbiota by the gut microbiome and its intestinal permeability may have role. To sum up, ladies and gentlemen, I think a combination of the diet, stress, exercise and brain is important for causation of the obesity. If I have to rate, I think a combination of the brain, gut and diet will give you far more relevance and control of the obesity rather than the exercise alone. Thank you.
Excellent talk, sir, like always. So you have given an, why do we gain weight, you have told very elegantly. But why do we fail to lose weight? If someone's set point is, say, 95 kg, we try hard and it comes down to 90, but within few days to week it again goes. So how do we reduce that set point from us? So is there any method?
Yeah, you see, the problem is, as I said, there are two components to eating. One is a metabolic hunger and second is a hedonic hunger. Now that hedonic hunger has often inputs which are still not discernible. It may be smell of the food, prior pleasure because of the eating, or a depression or sleep deprivation. Now these complex neuronal pathways which link the hindbrain to the mesolimbic brain to the hypothalamic brain may have a lot of polymorphisms. As I said, that even if your metabolic need is not high, because of the hedonic hunger you continue to eat. So if you have to lose the weight, you need to have a combination of the two. You need to decrease your intake, at the same time expand your energy with exercise. Most of the time you will be successful.
No, but how do we reduce the set point, brain set point?
That is how, because initial every time this will happen for a short period of time. But if you repeatedly try to decrease intake and increase exercise, your set point will change. You need to be persistent in that. You have to do it repeatedly to reset the point. So answer is, we do not know where the set point lies. So there are three different areas. You have a visual cortex, you have a mesolimbic cortex, and a hypothalamus. That integration of the neurons, we do not know where exactly anatomically that point is laid down.
Anil, can I, in corollary to that question, ask you another questions? That obesity is a mental health problem. That is fine. There is no problem, and as gastroenterologists, we are not giving importance to the mental health problem. Because lack of exercise, overeating, sedentary habit, and also genetic. But studies and recent articles have shown intermittent fasting, right, in fact helps every systems, including animal studies. So what is your take on this intermittent fasting, right? It's an important intervention, right? And what is your take on it?
Yes.
Number one. Number two, even if you are obese, you don't lose weight. Even simple exercise
provides you benefit.
Yeah. Can I answer that? Yeah. See, if you look at the various studies which have been trying to define and redefine what is the best diet, whether it is a low carbohydrate diet, whether it is a low fat diet, or whether it is intermittent fasting, there are contradicting results. At the end of the day, most of the meta-analysis will show you what matters is the total intake, irrespective of what you eat. So going by this acronym called calorie is a calorie is a calorie, that is most important. There is no doubt that intermittent fasting is something which will help you, but there is a flip side to it. Whenever you tend to have intermittent fasting, you will tend to overeat prior to start of the intermittent fasting and tend to overeat once it is over, because you know it's like in a Kadwa Chauth, a lady will have more food at 6 a.m. and then more food at 11 p.m. Other more because you know you're not going to eat for 12 hours. So that is a bigger problem. Again, the problem, as you very rightly said, is problem lies at the level of the brain, the so-called hedonic hunger, which makes you take more food because you are going to be fasting for 12 hours. So at the end of the day, it does not materialize till you exercise enough to expend the calories and try to reset the feeding point again.
So now, and the question regarding gut microbiota, sir, you said that it has got important role in obesity and losing weight. So is there any way to modulate the gut microbiota in a better way so that we can lose some weight? I mean,
Yes.
using all these probiotics, I don't know whether they are useful or not.
Because of the constraints of the time, I did not develop into and dwell into that particular aspect. There are some drugs, like there is a drug which tends to increase the mycolic acid in the gut, which tends to produce more of secondary bile acids. So these secondary bile acids will prevent the stimulation of the FXR agonist in the gut. So there is some preliminary data to show that if you increase the mycolic acid in the gut, you are likely to have altered metabolism. But it's still in the preliminary stage.
Anil, excellent talk. Just I wanted to have your viewpoint on the psychology of that person as to set all these points on a particular set point and a repeated psychological stimulation or psychological setting to that person that yes, you have to lose weight, these are the importances of weight loss. What would your take on this?
Yeah, problem is, see, this is again a psychological component. If you look at the physical compartment, physical connotation and physical counterparts of that, that is not known. We do not know exact area where this stimuli of the hunger originate, what neuronal pathways do they take to travel to the hypothalamus, how does hypothalamus react to it, which are the neurohormones, which are the conducting neurotransmitter, we do not know. But fact remains, those who are having, say, less sleep, or those who are having stress, they tend to have more pleasure by releasing dopamine. And this complex interaction between the mesolimbic hormone and the thought-provoking hormones or the reward centers, they tend to stimulate hypothalamus, particularly those neurons which will lead to decreased satiety. The moment you have decreased satiety, you will tend to overweight. So a motivational process, psychological analysis and even psychoanalysis is likely to be helpful.
About that intermittent fasting, there was an article published last year in NEJM which says intermittent fasting is no better than low calorie diet. So as you said, at the end of the day, it is the calorie which is important, other rest, other things are not important. About what sir said, motivation is important, but telling someone not to eat is also not good, because they eat because of recreation. You ask them not to eat, then they go into depression.
Actually, as I said, these are called hedonic pathways. Suppose you like a particular sweet. Every time you eat that sweet, there is some pleasure, dopamine is released. So even if you are not hungry, like most of us, even if after finishing your dinner, everybody goes to a desert place, desert center. You are not hungry, you don't want more calories. But our brain is conditioned to having more calories after finishing your dinner, you go to a counter with desserts. So that is a hedonic thing. Otherwise, say at 2 p.m. everybody goes for a lunch, you may not hungry. Yeah. Your body is not craving to have more calories.
Exactly, eating in between the meals is more important. Don't eat in between the meals, and that is what we all do.
I agree.
Sir, what is the importance of keto diet in weight loss?
As I said, there are different, ways of trying to control your weight. You may have less calories, you can have less low carbohydrate diet, you have low fat diet. The only thing which has been documented is if you have a high protein diet, that is something which is going to increase decrease the intake of the food by increasing the satiety. The moment you have a satiety center which is stimulated in the brain, which is a medial part of the hypothalamus, so that is something which is going to decrease the intake of the food. So high protein, calorie restrict diet to me is the answer in the future.
Dr. Anil,
all right, sir.
My question is that we see a lot of people and patients who are very thin. They don't gain weight despite huge caloric intake. So what is the protective mechanism metabolically speaking, or as you have described, what is the protective mechanism in them? And what is the status of fecal transplant in fighting obesity?
Yeah, in fact, only yesterday we had this debate between Rupa Banerjee and Dr. S.K. Tyagi about the microbiota, fecal microbiota and its relevance in health and disease. At the moment, I think we have very few clear-cut answers and the association between the gut microbiome and the development of the disease. There have been a lot of speculation, there are a lot of association, but in terms of authenticity and confirmation of the Roberts-Cox postulate, it is not possible in majority of the patients. In fact, there are around 1100 genes which are associated with different diseases and the gut microbiome, of which only 7 have been confirmed to be associated and only 2 have been implicated in pathogenesis. The rest all is a speculation. So there is no doubt that it is an upcoming field. It may have a big role. As of now, the relationship in the gut microbiota and the definite development of the disease is still, we are far away from that. Problem is we do not know which microbiota are we talking about. Are we talking about microbiota in the mouth, stomach, small intestine, large intestine? Are we talking of the microbiota on the surface, in the wall, in the lumen? We do not know whether it is rectum microbiota may be different from the colonic, which may be different from the small bowel, which may be different from the oral cavity. So just by looking at the feces, you are looking at the end product. And whether it is a bacteria or a particular metabolic product or metabiome or a transcriptome, this is a huge area which still needs to be discovered. Regarding the lean patients who do not know, again the problem may be occurring in the polymorphism in the gene which stimulate your appetite, or they increase the energy expenditure. There is something called brown fat in the body. In fact, one of the ways of trying to treat obesity is look for obese and brown fat in the body, or as Dr. Ajay was also involved in trying to stimulate the so-called beta-1 receptors in the liver, thyroid receptors. So if you increase your energy expenditure, irrespective of what you eat, you are going to lose weight. Maybe people who are lean, they have more brown fat which is stimulating their energy expenditure, or their total intake may not become commensurate with what they are spending. So that imbalance will again lead to...
Has it been shown convincing?
And this is most of the time again, this is again heritable thing, like in obesity.
Yeah, so has it been shown convincingly that...
No, it has not been shown. Just a speculation.
Okay. Thank you so much, sir, for such a wonderful talk. Now,
can you ask?
I would like to invite Professor Ajay Duseja.
Ajay, one more question.
Sir, what is the role of Mediterranean diet in obesity or anything?
Yeah, you see, Mediterranean diet primarily means a composition which has a lot of green leafy vegetables, a lot of proteins, and animal proteins in the form of fish, and a lot of antioxidants. As we repeatedly said, what ultimately matters at the end of the day is total calories. Mediterranean diet will have more of whole grain, more of proteins, and less of fat. That is primarily the metabolic diet. And again, we are repeating the same thing. The type of the diet doesn't matter as much as the total calories which you consume.
Sir, just one suggestion. Everyone should have weighing scale in their bathroom. That is the main important thing, I think. So
everyone should
weighing scale, sir, in the bathroom.
Yeah, that's it. I agree with that.
Thank you so much. Now, may I request Professor Ajay Duseja for his...
Good morning, everyone, and I bring greetings to all of you from PGI Chandigarh. And at the outset, my sincere thanks to the organizing team, Dr. Arora, Dr. Ashish, Dr. Parveen, and the other members of the organizing committee for giving me this opportunity. But I must say that they have actually given me a difficult question to answer. So what they are asking me is to tell you that what should we be targeting in patients with NAFLD or MESLD. I'll not get into that, whether it should be fat, inflammation, or fibrosis. Because, you know, when you look at the literature, I think the literature probably will not give you this direct answer that what you should be targeting. But literature does tell us that all these three things, fat, inflammation, and fibrosis, they are so well connected, which means that if you have fat in the liver, with the help of cytokines, it does lead on to inflammation. And finally, the hepatic stellate cells, you know, get activated, and this leads on to fibrosis. So they are kind of interconnected. Now, what you should be targeting in a particular patient would depend on the phenotype you see in your clinical practice. You can see patients who can just have fat in the liver, so-called NAFL, or just simple steatosis. You can have patients with NASH, which can have just inflammation in addition to fat in the liver, or NASH with fibrosis, cirrhosis, HCC, and all that. So I think it depends on the phenotype that what should be your target in a particular patient. But yes, if you ask me what are the endpoints in clinical trials, they have been very well written and very well followed in most of the clinical trials, and everybody will talk about the resolution of NASH without worsening of fibrosis, or reduction in fibrosis without worsening of NASH as endpoints for most of the, you know, clinical trials which are happening in the area of NASH. Why this is so is because over the years we have all understood that if you look at the outcome and the natural history of those with only NAFL versus NASH with fibrosis, those with NASH and NASH fibrosis obviously would have poorer outcome, may it be related to liver-related mortality or may it be even overall mortality. So obviously the NASH people would do, you know, worse. And this applies more to that with fibrosis. This hierarchical model actually taught us this, and this particular study actually, and more studies like this actually taught us that in patients with fatty liver disease, it is the fibrosis which is the determinant of overall outcome. Even within NASH, those NASH with fibrosis will have the lowest survival in comparison to those with NASH without fibrosis. And obviously those without NASH and without fibrosis will have the best survival. So which means that yes, NASH and NASH with fibrosis obviously need to be the target, maybe even in the clinical practice as well. But then how about, you know, the clinical trials and the drugs which are working only and they are targeting only fat? Now, one drug which I think Dr. Anil just mentioned about, I will come down to this, resmetirom, but there's another drug called Ramchol, which we know is an SCD, you know, inhibitor. So, you know, what it does, and if you look at the synthesis of triglycerides here, you know, this is, there are various enzymes which are involved in the synthesis of, you know, triglycerides. So by inhibiting this, you know, palmitate 2 monoacetylacylate, you know, SCD1, you know, this Ramchol is the drug. So what it is reducing is it is reducing only fat synthesis. But then if you look at the data from this phase 2b study, finally when they looked at this was not only the reduction in fat as seen on MRPDFF, but it was also that they could show that there was a reduction in NASH, there was a reduction in fibrosis. So how that was happening is that when you reduce the synthesis of fat, the free fatty acids probably get, you know, deposited within the hepatocytes, and which may be protective, and the degree of free fatty acids which are thought to be the culprit for lipotoxicity probably go down. So just reduction in fat may also help you in improving your 3 to 5% of weight reduction, and that may be good enough in, you know, in reducing fat in the liver. If somebody has inflammation or NASH, you need to tell him maybe 5 to 7% weight reduction, and that may be good enough. But for fibrosis improvement, yes, the weight reduction recommended is 10% or more. And this applies also to, you know, lots of, you know, drugs which are available versus those which are in clinical trial. And the drugs, you know, you can actually, you know, kind of direct them towards what we call the metabolic pathways, which can help you in reduction of fat. You can have drugs which predominantly have anti-inflammatory activities, and then you can use them for patients with NASH. And similarly, you can have drugs, which can have anti-fibrotic activities, and you can use them in patients, those who have fibrosis. So again, as I said, I'm emphasizing on this. This would depend upon the, kind of phenotype you have, and then you basically do the selection of, these drugs. But having said that, I think I'll take it to another platform and say that what we need to understand is that fatty liver disease is not only limited to liver. This is not only a liver disease, this is now more and more we are understanding that this is part and parcel of what we call a multi-system disease. So in a patient, the people do call it fatty liver disease or NAFLD as a hepatic component or hepatic manifestation of metabolic syndrome. And we know that these patients, especially in the early part of the disease, when they have NAFL, they die more often from cardiovascular disease. They have more of renal issues and maybe more of malignancies. But as the liver disease progresses and goes into high fibrosis, advanced fibrosis, maybe F3 and F4, they start having liver-related mortality more than, than the extrahepatic mortality. So which actually means that whatever kind of treatment we are looking for, may this be lifestyle interventions and may these be on any kind of pharmacological drugs, you need to look at not only their hepatic effects but also their extrahepatic effects. So we know that lifestyle interventions, exercise has lot of extrahepatic effects. So we know that, as I said, that the exercise does improve fat, inflammation and fibrosis, but we know that exercise also help you in improving your cardiovascular or cardiometabolic profile in general, and thereby helping you for CKD, malignancies and all that stuff. Similarly, when you're looking for drugs in patients with fatty liver disease, I think you need to look at drugs which not only resolve NASH or steatohepatitis, which not only look at fibrosis, but also look at their glycemic control, look at their lipids control, look at their cardiovascular benefit, look at their renal benefit, and also maybe reduce the risk of malignancies. So I think this is the concept. I think this is very, very important. Because of this, I think 2 years back, Naim Al-Khoury has given this very nice concept of so-called the drug scorecard, which means that a drug which has to be used in patient with fatty liver disease should actually qualify this scorecard, which actually says that you are looking at not only hepatic efficacy endpoints, which means NASH resolution, fibrosis improvement seen by MRPDFF or ALT, but you also need to have these drugs which are working on cardiometabolic risk factors, improving your body weight, improving your lipids, improving your insulin resistance, and should have minimum adverse events. Now we know that obeticholic acid as a drug, just as a prototype I'm saying, does have an anti-fibrotic effect, does reduce hepatic steatosis, but we know that it increases your risk of dyslipidemia. It causes a major adverse event of pruritus. So I think we need to look at that what is happening to your cardiometabolic profile when you are actually selecting a drug in a particular patient. So I think let me summarize, ladies and gentlemen, what I said in the last 15 minutes or so, that I think what should you be targeting in a patient with fatty liver disease would depend on the phenotype of that particular patient. If you have a patient with NAFL, yes, reduction of fat may be good enough. But if you have a patient with NASH, yes, then you need to look for resolution of NASH. NASH with fibrosis, you have to look for resolution of NASH as well as improvement in fibrosis. But mind it, we understand because that NASH and the fibrosis, they are major determinant of not only liver disease, but they are also very important determinants of extrahepatic disease. So yes, targeting fat, inflammation and fibrosis is very, very important, but I think we need to have so-called the holistic approach where we need to look at and take the help of lifestyle interventions, not in improving only your liver health, but overall health, which means your cardiometabolic profile, your renal and cardiovascular. And also when we're looking at drugs, I think they should be taken or they should be explored, not only looking at their hepatic effects, but also, as I said, their cardiometabolic, cardiovascular, renal, and the risk of malignancy. So thank you very much for your kind attention.
A nice talk and summary of what should be targeted. But if you see 100 patients of fatty liver disease, 95% will have only fat. And other than diet and lifestyle modification, is there any pharmacotherapy? You are talking of Aramcol and Resmetirom. Do we have any progress on that front as yet?
I think the guidelines are very, very clear. May these be guidelines from NASL, EASL or ASLD, that if you have only fat in the liver, NAFL, lifestyle interventions are only to be recommended, no pharmacotherapy. Most of the societies would recommend pharmacotherapy only once you start having NASH or maybe significant fibrosis, which is defined either non-invasively or invasively with the valvular biopsy. So other than that, if you have only NFL, which you said majority of the patient would have, only lifestyle interventions.
But then why wait for it? Tomorrow if you have a good drug which decreases fat, after all NASH will never occur in the absence of fat. So why are we waiting for fat to have a second hit? So you have a good drug which can decrease fat, why not grab it with both hands?
You have a point there, but I think we still do not have data to support that if somebody only has fat and whether you should be using drug only to that whatever drugs people have used or which are in pipeline, I showed that on to Aramcol and Resmetirom, right? They are also, if you look at that, their entry point inclusion criteria for patients was always NASH with or without fibrosis. They never took patients only with steatosis. So the point I'm saying is the entry point as per today for clinical trials is always NASH with or without fibrosis, and till today I think we do not have clinical trials which are using only patients with NAFL.
So,
yes,
in continuation with Dr. Nil's point, most of the patients who come to us today are having something or the other with them in the form of either triglycerides coming up or an LDL coming up, or the patient is obese or whatsoever. In such a case, normally it is no more a NAFL, it's a MASLD. So sir, we have to anyhow treat those patients, and some of them they come to us already with some drugs on. So where do we say that there is an entry point in such a case, sir? We are only basically talking all about what we have got in our clinical scenario in the books, but on the clinical front, sir, it's entirely different, sir. So I basically would just like to ask you, shouldn't we treat patients right from day one, as Dr. Nil said, or we need to keep on just waiting, because lifestyle modification in our country probably doesn't make a sense in many others.
I'm sorry, I'm not able to hear it well. Maybe there's a problem with the code, but I could understand was what you're saying is that if a patient comes to you and he already has dyslipidemia or some cardiovascular
or diabetes
issue,
or whatsoever,
and he's already on statins, right? So obviously, I think if his lipids are well controlled on statins and on your fatty liver assessment, the algorithms are available, you think that he does require only lifestyle interventions, no drugs are required, please continue on statins. Even if he has elevated liver enzymes, statins are not contraindicated or are not harmful. But then on your liver assessment, if you find that this patient, in addition to lifestyle interventions, is also a candidate pharmacotherapy, may be vitamin E or maybe saroglitazar, then suppose it comes down to saroglitazar and this patient is already on statin and you think that the lipids are there, you start saroglitazar basically looking at the liver, and tomorrow there is a possibility that the statins may not really be required because your lipids are also getting well controlled with saro. I think those kind of decisions may have to be taken in clinical practice. But the second part of the question, if I got it right, is that somebody is already there, somebody wrongly started, some drugs and all, and today you do the assessment. This happens in patients with hepatitis B.
So where do we stand on that?
So I think obviously you can do the reassessment, and I think you are free to stop any kind of drug there. Yeah.
Ajay, again, if I take you correctly, suppose in your assessment, patient only has a fat. So are we justified to continuing following him up, or hand it over to people who can do a better job in lifestyle management, like physician or a general practitioner? Why should we hang on to them?
Absolutely. I think I absolutely agree, and most of the algorithms would say that these patients, those who have just fat in the liver, no significant fibrosis or inflammation or NASH or non-invasive assessment, maybe simple scores like APRI, FIF4 should either be managed at a primary care level, all by the general physicians, all by the diabetologists, or by the endocrinologist, and there is no need to refer them to a tertiary care for further testing. Yes, this could be a dynamic process, and with the change of metabolic profile, their liver disease can worsen. It can, deteriorate over a period of time. So 1 to 2 yearly follow-up is what is recommended in these patients, but yes, they can stay with their physicians.
Sir, if
Dr.
may can ask a question. So I have a problem with just the resolution of fat in liver, because patients with fatty liver disease have pathogenesis is basically based on free cholesterol, the free fatty acids, and the inflammatory milieu which these fatty acids lead on to. So just the resolution of fat using CAP values without any resolution in ALT or the fibrotic markers, how good is a therapy? Because many of these trials these days in phase 2, phase 3 studies demonstrating fat reduction, just fat reduction as a efficacy endpoint.
I think what I showed was these 2 clinical trials basically meant that only. The Ramcol and Resimetrom are 2 prototype drugs which we know tackle only the synthesis of fat. But the data shows when they were looking at the synthesis of fat, in addition to reduction in fat as shown by MRPDFF, there was also improvement in inflammation and fibrosis. How this is happening is your question. So the question is, when you have reduction in fat, more of these free fatty acids, which are the culprit in causing lipotoxicity, indirectly inflammation and fibrosis, they make, you have a space now in the mitochondria and elsewhere for beta oxidation for these free fatty acids. You have a space within the hepatocytes for these free fatty acids to go there. So they will cause less of lipotoxicity, less of inflammation, and indirectly less of fibrosis. That is the hypothesis behind it. Yeah.
Okay, thank you, sir. So we're running short of time. So the next we'll just
thank you.
We'll just proceed with the next topic, that is lifestyle modification in patients with NASH cirrhosis. Do they work? And I'll invite Dr. Anil C. Anand. The dice is yours.
Thank you very much. It's a great pleasure to be here, and I must thank Dr. Anil Arora and his team for giving me this privilege. He has asked me a question whether lifestyle modification in patients with NASH cirrhosis will work or not. Generally, I know him for about 35 years, and I know that most of his questions do not have enough evidence to prove or disprove. But let me try my best what I can do. On the face of it, there appears to be no controversy at all. But I know everyone knows that NAFLD is a lifestyle disease, and the lifestyle modification is the only effective treatment for it. Most of the drugs have very minimal effect on NAFLD. And why has he asked me this question? Do they work? So I tried to analyze it, whether there is any hidden trap in this question or not, and therefore I decided to analyze what could it mean. One is, it could mean that whether lifestyle measures are feasible once the cirrhosis has developed. Do they benefit the patient in terms of preventing disease progression, reducing the disease severity, reducing the complications, improving the survival? Will it reverse the disease? And finally, should we really recommend lifestyle changes in patients who are already cirrhotic? But I think his main point of interest is, does it work when the cirrhosis has already developed? Because as far as I am aware, lifestyle changes are not known to work when the next step has been achieved, that is HCC. So lifestyle changes in cirrhosis are usually advised because of 4 particular aims. One is to reverse the NASH, fibrosis, cirrhosis. Fat and inflammation are the driving force for fibrosis and cirrhosis progression. And question is, will it reverse if the cirrhosis has already developed? Second is to reverse sarcopenia, which is known to enhance the NASH progression and worsen the outcome of cirrhosis. Third is to reverse frailty, which leads to poor quality of life and increases the risk of complications. And lastly, to reduce mortality, both related to liver as well as cardiovascular disease. Most of the systematic reviews and guidelines and review articles mention that NASH cirrhosis patients should be advised lifestyle modification. And most of them quote Villar-Gomez's paper, which has shown that about 10% weight loss with lifestyle changes can lead to 81% improvement in fibrosis. Regression can be shown. This paper alone should have settled the issue, but when you read little more closely into this paper, you realize that the study did have excellent results, but had excluded cases where cirrhosis has already developed, so we need to look elsewhere. We all know that NASH is a lifestyle disease which takes several decades to progress to cirrhosis, and possibly anywhere in between, if we carry out the lifestyle interventions, it can reverse the process. But what about if the patient who has already reached the stage of cirrhosis? Do such people have additional factors involved like genetics or even multiple hits, and whether they have disease progression hastened in any way? Because we already know that once the more risk factors are present, fibrosis progression is proportional to the number of risk factors which are present. For example, this study has shown that additional risk factors such as diabetes will significantly hasten the fibrosis progression. One may raise doubt that lifestyle modification in such a patient alone would be doubtful to have equal benefit. That's why possibly Dr. Arora has asked this question. And so what is the other evidence? Let me start by giving you one example. For a long time we have been talking that we do not have a randomized controlled trials to prove that parachutes save our lives. A person who jumps out of the plane with an empty backpack will survive equally well or not. And similar is possibly the situation of NASH cirrhosis. We believed all this, that it was not possible to carry out a randomized controlled trial till we had this paper published in BMJ about 2 to 3 years back. Parachute used to prevent death, major trauma when jumping from aircraft, a randomized controlled trial. What has it shown? It has shown that whether you jump with an empty backpack or with a parachute, it does not make any change in the mortality or morbidity of the jump. Don't get worried. There is a fine print also attached to it. However, this trial was only able to enroll participants on a small stationary aircraft on the ground, suggesting cautious extrapolation to high altitude jumps. The real message from this paper is that researchers often tweak the inclusion criteria to get exciting or publishable results. And the same thing has happened with NASH also. For example, they have shown benefit, but to have quick results in the short term, NASH cirrhosis would be excluded. Or NASH cirrhosis will be included and they show good results, but it will be a mixed bag, NASH and NASH cirrhosis, and no group analysis would be carried out. Diet and exercise combined are superior to these interventions alone in improving the liver enzymes and HOMA-IR. Or they will include NASH cirrhosis in the inclusion criteria, but focus not on fibrosis reversal, but only on the activity. Cirrhosis is included, but not separately analyzed, and the interventions are for 48 weeks, and they have shown very great benefit. But there are papers which have shown even the NASH cirrhosis reversal. For example, this paper, small number of cases, have shown reduction from F4 to F3 fibrosis, even with less than 10% of weight loss. But the skeptic that Dr. Arora is, he will say that sample size is too small and there can be sampling errors. And therefore, what I'm trying to say here is that every cirrhosis can be reversed if the cause can be treated. This has been shown. It has been shown for hepatitis C virus, for alcohol. And effective treatment for NASH is lifestyle change. This has already been established. It is known to reverse fibrosis, known to prevent progression to cirrhosis. But I'll concede that dramatic evidence for quick cirrhosis reversal does not exist as it exists for hepatitis C virus infection. And this is the cover of Journal of Hepatology few years back, which has shown that people on the transplant waiting list are getting out and going home because they have been cured with the HCC treatment. So most of the experts agree, and I'll quote Caldwell at this, the results support the fundamental tenets of NASH management to advise aggressive lifestyle changes with encouragement of weight loss through dietary changes and exercise. And I must add to this that most of the clinical research is dependent on research fellows with a half-life of about 1.5 to 2 years. It's unreal to expect a biological process to reverse over 2 to 3 years when it has taken about 40 years of progression with multiple hits. Situation is nearly impossible as in case of parachutes. Let us move on to the second point, that is sarcopenia and frailty. We all know that sarcopenia and frailty are very common in NASH cirrhosis, and so is myosteatosis. They are independent predictors of adverse clinical outcomes in cirrhosis. They increase the chances of hepatic encephalopathy. They have longer hospital stay, waitlist mortality, higher frequency of infections following liver transplantation, increased healthcare cost, post-liver transplant mortality is also increased in them, and there is higher cardiovascular mortality. And therefore, all the guidelines mention that patients with NASH cirrhosis should be advised lifestyle intervention, and I'm just showing the picture of EASL guidelines here. Whether they are feasible in cirrhosis or not can be shown by this study very well. This is a study carried out at PGI Chandigarh on decompensated cirrhosis, not only compensated cirrhosis, but on decompensated cirrhosis, and it has shown that results are an eye-opener. 6 months dietitian-supported home-based intensive nutrition program led to statistically significant and clinically relevant improvement in frailty, liver functions, and also demonstrated reduction in mortality. Another study showing nutrition and exercise with branched-chain amino acid supplementation showed improvement in quality of life within a period as short as 16 weeks. Another study showing nutrition alone improves sarcopenia within 6 months. And then there is this systematic review of 24 studies working basically on nutrition, on exercise, and combined interventions, and most of them are randomized controlled trials. And all the studies have shown significant improvement not only in muscle strength and physical function. Some studies have looked at another dimension, that patients with cirrhosis are frail, and studies have shown physiologically they are 30 years older than their biological age. And it has been shown that as little as 8 weeks of exercise can bring down their physiological age from 80 to 67 years. A series of studies have indicated that patients who have reached the stage of cirrhosis should definitely exercise, because within 8 to 16 weeks, the improvements are very clear. They show increased peak VO2 max, 6-minute walk test distance, increased muscle mass, improved quality of life, and reduced portal pressure. Then exercise induces significant but modest changes in liver fat, and inflammation is very well known. There is another version to this reason to exercise in these patients. It not only reduces the liver fat and inflammation and fibrosis, but also has strong cardiovascular benefits. We have already discussed cardiovascular disease is commonest cause of death in NAFLD, and the benefits of exercise and lifestyle changes on cardiovascular mortality are proven beyond doubt. Let me conclude by saying that lifestyle changes can reverse NASH and fibrosis. Robust studies to address cirrhosis reversal have not been done, and possibly they may not be practical. Although fibrosis reversal from F4 to F3 has already been reported. Lifestyle measures are feasible in all stages of NAFL, NASH, compensated cirrhosis, and even in decompensated cirrhosis. Lifestyle measures are beneficial in decompensated as well as compensated cirrhosis, as they improve sarcopenia and frailty. Improvement in quality of life is there. This also means improvement in nearly all complications of cirrhosis. Reduction in the risk of cardiovascular mortality as well as liver-related mortality has already been reported. Sustained and strong efforts must be made to educate the patient about benefits of lifestyle changes even after the cirrhosis has been developed. Thank you. Thank you for no questions.
No questions, thank you.
I have a question, sir. Sir, Manav. Sir, you talked about, here sir, center mein. So, on one hand, we are talking about losing weight to improve NASH cirrhosis. On the other hand, we are talking about more nutrition to improve sarcopenia. To me, it looks like an oxymoron. Actually, it's a major problem. In a NASH cirrhosis patient, the guy is overweight and he has sarcopenia. How do we come to the middle point? I'm not able to understand
It's not an oxymoron at all. Exercise is not done to reduce weight. Exercise is done to build muscles. Muscles are what is responsible for your well-being. And diet reduction is advised only for people who are obese. Otherwise, it's just diet modification. You increase the protein intake and not carbohydrates and fat.
So, so that's exactly what I was trying to ask, sir. NASH cirrhosis patients generally tend to have sarcopenic obesity. Generally. Especially when they reach a decompensated stage. How do we balance these two facts in that situation? This guy is overweight. He's got low muscle mass, but he's got a lot of fat.
Yes, we reduce the calories but increase the protein.
Okay, we'll discuss over lunch.
Right.
It's a more debatable question actually.
Now, AC, I just wanted to ask a very practical question. You have a clinical experience of more than 50 years of managing cirrhosis, decompensated and compensated. How many patients you have advised exercise? What is the duration of exercise? What is the type of exercise? Along with the nutrition, and what is the adherence? Because you see, adherence is a big problem even in screening of cirrhosis to detect liver cancer. Sensitivity of ultrasound and alpha-fetoprotein from 63% increases to 80% if there is adherence, instead of searching a biomarker. Now that's a very important concept. It's all right, good lecture. It's all right. Studies you showed for fellows 1 to 2 years. The results are short term. Has it been translated, because there is a short term follow-up, translated to the end stage like transplant or death? That's the most important, crucial outcome. So the question is, what is the exact way to do exercise? Right, in say decompensated cirrhosis who is already sarcopenic, and what intervention increases their muscle mass? They cannot do aerobic, they have to do resistance, right? And what is that degree of resistance? It's a very practical question because we know this.
So I have been advising all patients to exercise.
Now,
and how I advise them exercise is, they will start by doing something that can easily do and increase by 1 minute every day. They can do the exercises that they are capable of doing. It can be resistance exercises, it can be aerobic exercises, whichever one they can do. It needs to be supervised. Therefore, there is a caregiver which is required at home. A person on his own probably will skip doing exercises.
Exactly.
As Dr. Arora was saying, that motivation is not there. Exactly. Therefore, there needs to be a motivating person, a motivating interviews, and behavioral therapy, which has to be done along with that.
And another thing I want, I will also ask, there are a lot of Americans and very top class fellows like Patrick and Sanjay who are sitting there. Do they have for cirrhosis in their clinic specific caretaker to induce exercise and the results?
The question is not for me, it's for Dr. Satpathy.
Yeah, I think this is a very important question as well. You know, the patients with cirrhosis, when they're routinely when you're seeing the patient coming to the hospital, what we advise is they need 4 to 7 days of aerobic exercise if they're able to do it. Again, they're compensated cirrhosis, and depending on the level of their severity, whether child A, child B, child C, you have to, of course, understand a patient's situation. And 3 to 4 days of resistance training. They need to have at least 1.3 to 1.5 kilocalories, gram per kg body weight of the protein intake, and they need about 35 calories of total nutrition that needs to take. Now, how do we do this? If the patient come into the hospital, they are admitted and they are not even able to walk, they were not going to ask for exercise. So we do their liver frailty index measurement and graded this patient into sarcopenic, like whether they're frail, pre-frail, or they're non-frail. And based on that, we send this patient to supervised inpatient rehabilitations. If the patient is unable to do it, they cannot do it. You just can't send the patient home and say, do the exercise. They're not going to do it. So some of these patients go supervised inpatient rehabilitation. Some of them will go as an outpatient rehabilitations, where the patient can walk into the center where they can do supervised exercises. But if they are a child, say they are able to perform on their own, then home physical therapy is something that we adopt in our setting. And that's what we actually do.
And there is enough evidence to show that it requires at least 3 to 4 weeks of supervision, after which once they start seeing the benefit, they automatically become motivated to do it.
Yeah, I fully agree with Dr. Anand. See, the key in these patients is a protein, and the control of ascites. 80% patients will come to you with the ascites, which is not controlled. So once you control ascites, give the proper advice and ask them to exercise, then maybe you can see changes even after 2 months. And they do very well. I'm not saying that this way you can withhold the transplant. Transplant, of course, is the final. But if they cannot undergo the transplant, this is the key. Give them protein, motivate them for exercise. Most of us are not having time. That is a problem. They'll just write down the diuretics, do LVP. That is not the treatment. You have to explain them. So that is why we are not able to see the effects of the lifestyle modification and the nutrition therapy.
I agree. The caregiver has to be trained.
Sir,
Yes.
Sir, in the lifestyle modification schedule which you normally set, do you also think of estimating the brown fat and the white fat in patients? Will it matter any change in it?
No, I don't think we do it at all. We don't.
Because most of the patients are, as you said, are cirrhotics or compensated or decompensated, most of them would not be able to, adhere to any exercise, whatever we say.
We are not doing any estimation of type of fat which is there. It is the muscles which have to be developed.
Last question, Dr. Ajay.
I think very nice talk, sir. I think, weight reduction with lifestyle interventions is always an issue, not only in cirrhotics, but otherwise also. And in cirrhotics, and then looking for reversal of cirrhosis or reduction of fibrosis would be, asking for too much. Because I'm aware of only one study on lifestyle interventions in cirrhosis, so-called the sport diet study from the Spanish group Barcelona, where they had taken all cirrhotics with portal hypertension, measured by HVPG, all more than 6 millimeter, and then they were given 16 weeks of so-called intensive lifestyle interventions with around 60 minutes of exercise, hypocaloric, normoprotein diet, and what they could show that those who reduced 10% weight reduction, which happened I think in 20-30% of them, they could actually show reduction in portal pressure by HVP.
Yes, I quoted that study.
Yeah, that's what I'm saying. But I'm saying this is the only study which actually showed that yes, the portal pressures can come down, but looking for the reversal of fibrosis.
I mentioned that there are no robust studies to show reversal of fibrosis in NASH cirrhosis. But there is enough evidence to show that cirrhosis can reverse if the etiology can be treated.
Thank you, Dr. Anand, for engaging discussion. Thank you very much. Now we have a next presentation by Dr. Amit Mandor on GLP-1 agonist in non-diabetic NASH, the way forward. Dr. Amit, please.
Thank you, organizers and Professor Arora, for this opportunity. So we've been talking about NAFLD, and we all probably would agree that obesity is one of the key drivers, if not the only driver. So, and we have spoken at length about lifestyle modifications and how to lose weight. Why not have a single drug or an injection which can make you lose weight and give you all the metabolic benefits? So the GLP-1 agonist in non-diabetic NAFLD, the way forward. The first GLP-1 agonist was exenatide, which was approved for diabetes. But the unique mechanism of action of these agents is that it increases insulin secretion and inhibits glucagon only in response to increased glucose levels. So it can potentially be used even in obese and non-diabetic individuals without the risk of hypoglycemia, unlike the other anti-diabetic agents. So does it have a role beyond diabetes management? We all know that NAFLD is a multi-system disorder or a part of a multi-system disorder, and GLP-1 agonist also has multi-system effects. So it has an effect on the brain to reduce the satiety levels. It has cardiovascular benefits. It has anti-inflammatory actions, reduces myocardial ischemia injury, and has a favorable effect on the blood lipids. And of course, it acts on the pancreas to increase the insulin secretion and decrease the glucagon secretion, thus reducing the insulin resistance and reducing the glucose levels. It is not directly there in the liver, thus these receptors are not there in the liver, but based on these actions, there is decreased liver glucose production, liver fat content, and hepatic steatosis. And the major action is on the GI tract, where it reduces the gastric emptying. So basically, it would reduce the satiety and it would reduce the gastric emptying time, and that is how it would the patients would lose weight and have beneficial effects. So which are the GLP-1 which are available? The short-acting ones, exenatide, the intermediate-acting one, which is liraglutide, which has been approved for obesity, acting for 12 to 24 hours, and the long-acting one, the semaglutide one, which we all know. What is available to us in India? We don't have the injectable semaglutide as yet. We have the injectable liraglutide, and we only have the oral semaglutide. And we have seen this pyramid that if you lose more than 10% of body weight, there would be an improvement in fibrosis more than 50 to 80%, as have been shown. So the key point is to try and reduce the weight in management of NAFLD as well. So how do we just go through the literature which is available? The first major studies which was done with liraglutide, once a week, daily 3 milligram injectable. This was the scale group of patients, scale studies, almost 3,000 patients. The scale 1 and 2 did not take patients with diabetes. They were only obese and pre-diabetic. And there was a weight loss to the tune of 8% as compared to placebo, which was 2%. There was also one group wherein there was a hypocaloric diet given for a run-in period of 12 weeks, and then so as the patient would be motivated to lose weight only by placebo effects, only by diet, and there also the liraglutide effect was more than the placebo. So clearly liraglutide based on this study showed a significant effect on weight reduction, and there was also a study comparing semaglutide with liraglutide, and there was a 8% weight loss in the liraglutide group. Semaglutide of course was much more superior. So along with weight reduction, what was clear was that there was a reduction of both fat mass and improvement in the lean mass, and that is where the crux of the matter is. It is about the sarcopenic obesity which Manav was talking about. We have to reduce the visceral adiposity and increase the lean or the skeletal muscle index. It has also been proven to be beneficial in children and adolescents. A meta-analysis of 574 patients showed the impact on reducing weight, BMI, glycated hemoglobin, and systolic blood pressure. So GLP-1 based on this studies, this scale group, have been well placed as a forerunner of pharmacological intervention for obesity in both diabetic and non-diabetic population. Then came the STEP trials which showed even better results, again 2,000 patients across various groups, across various nationalities. There was a study in Japan, in China, and it showed significant weight reduction. This was semaglutide. It was started at a dose of 0.25, and over 20 weeks a dose of 2.4 milligram per week was achieved, and it showed significant benefit. If you look at the benefit, almost 16 to 18% weight loss was seen in this study, which is which is phenomenal, which is fantastic. This is what we have all been talking about, how to lose weight more than 10%, and can we achieve this weight loss with medicines. So this is where the effect was on obesity was seen. The placebo fared much worse. It showed only 2 to 5%. And again, in this group also, there was one study wherein there was an intensive behavior protocol where patients were made to exercise and be on a hypocaloric diet as a run-in phase. Again, both in non-diabetic and diabetic, this was studied, and the weight reduction was superb. But we don't have injectable semaglutide as of now. We have the oral semaglutide. Is there some evidence with oral semaglutide? Very modest benefit, not as good as the injectable semaglutide, but there is a 5% weight loss in half the patients who took oral semaglutide. This was a pioneer program, and mind you, this is not approved for weight management. Only the injectable semaglutide is approved for weight management. Going ahead, the way forward may be a combination. There is a drug called as tirzepatide, which is a combination of GLP-1 and glucose-dependent insulinotropic polypeptide. Both are incretins but act on different receptors. And again, a phase 3 double-blind randomized control trial of 2,500 patients showed very significant improvement in obesity with almost 20% or more weight reduction in 50% of the patients. So 50% of the patients could reduce more than 20% weight loss. And the early phase 2 studies comparing tirzepatide with semaglutide showed that there is a better weight loss with it. So there is a synergism of action of different receptors being acted upon. So then can this be translated into the management of NAFLD? Yes, it was shown with the liraglutide study, which was the first GLP-1 agonist randomized control trial in management of NAFLD. And here the trial was conducted with a injectable dose of 1.8 milligram daily, and 39% of patients achieved the primary endpoint of resolution of NASH without worsening of fibrosis. As Dr. Duseja mentioned, that is the first primary endpoint, and there was not much benefit on the fibrosis. So there was resolution of NASH in 40% of the patients, better than placebo, but not much improvement in fibrosis. Again, 50% of the patients were non-diabetic, and the RR for non-diabetic patients achieving primary endpoint was 3.4, thus showing that it is useful in non-diabetic patients as well. We all know about this landmark study published in NEGM in 2021 on semaglutide. The resolution of NASH, again being the primary endpoint, was achieved in 59% patients who received a dose of 0.4 milligram per day. The fibrosis here was shown to reduce in 43% of patients, but it was not clinically significant because the placebo showed a very significant benefit in reduction of fibrosis. So these results were not significant when it came to management, reduction of fibrosis, but resolution of NASH, almost 60% of patients showed benefit in this study which was carried out and published in NEGM. Again, in this same study, the change in body weight, there was a reduction of almost 12% body weight in the group of 0.4 milligram daily. Again, showing that obesity and improvement in NASH went hand in hand. There have been other studies on semaglutide. I won't go into details, but various different parameters have been used. There have been studies with MRI-PDFF to see the fat reduction, and there has been a significant reduction in fat mass index, visceral adipose tissue, and skeletal muscle index improvement, which again shows that these metabolic benefits are very important in the overall management of these NASH patients. The next step, of course, is cirrhosis. If there is benefit in F2, F3 fibrosis, is it beneficial in cirrhosis? So this is the only RCT which is available, which was published this year in Lancet Gastrohepato by Dr. Rohit Limba and multi-center trial. It showed that there was an improvement in body weight. In cirrhotic patients also, there was 8% reduction in body weight, again, which we were talking about in the previous talk. There was improvement in fat and non-invasive markers of disease activity, but over 48 weeks, there was no significant difference which was found in resolution of NASH and liver fibrosis. So there was improvement in NASH in 34%, but it was not statistically significant. Again, this was just a 48-week. Again, and if we can follow these patients up for a much longer period, because we know that fibrosis resolution may take some time and it may still have a role to play. So to summarize in the next 2 slides, the compelling indications of this group of patients is in a group of patients who are obese. All these studies took BMI more than 27, the NEGM semaglutide took more than 25, where we want to reduce weight, reduce appetite, reduce weight gain, and at the same time control the sugars and other metabolic parameters. We have to be careful if there is severe hepatic or renal impairment or diabetic gastroparesis or past pancreatitis, then we should avoid these drugs. And if there are risks of cancers, we should avoid these drugs. So the GLP-1 agonist in my practice today, we don't have much option. We only have oral semaglutide, but in select patients, obese patients with F2, F3 fibrosis, I think we can consider oral semaglutide as one of the drugs of choice. And if injectable GLP-1s are available, that would be an important agent against this group of patients. Further long-term follow-up studies would be needed to evaluate the beneficial effects on fibrosis and cirrhosis. We need longer studies because fibrosis regression takes time. The metabolic benefits of GLP-1 agonists are significant. Even in diabetic population, those with cardiac issues, renal issues, GLP-1 is preferred because of the benefits on the heart and the kidneys. So if we are looking at a metabolic syndrome patient, this class of drugs will definitely have a role to play. And in the future, the dual and triple agonism like GLP-1 GIP, GLP-1 GIP glucagon have synergistic effects. It has shown that in early studies, and it would probably be preferred over only GLP-1 agonist in management of obesity in NAFLD patients. And as Dr. Duseja also mentioned, and the concept is these things never occur in isolation. Steatosis, fibrosis, inflammation, they all occur together. It is a continuum. And that is why maybe the future is a combination of drugs. A combination of something like a GLP-1 agonist, which has metabolic benefits, reduces inflammation, reduces fat, and an anti-fibrotic like an FXR agonist. And early studies with this combination has shown some benefit more than semaglutide alone, at least in non-invasive marker of NAFLD. This is not a biopsy-proven study which has been published. So a combination of semaglutide with FXR agonist and or firocostat, which is ACC inhibitors. So to my mind, the way forward is a combination of drugs acting on different pathways, and GLP-1 agonist will definitely have an important role to play. I thank you for your kind. And I invite you for this hepatology conference in Mumbai on 21st, 22nd October.
Dr. Amit, excellent talk. Just a comment that oral GLP-1 agonist semaglutide, there's now a recent trial on oral Oasis trial, which has got 50 milligram of semaglutide as against 14 which we give, and that has led to similar weight loss as compared to the injectable semaglutide. So this has just been released by the Novo Nordisk in press release. I think the full paper will come in JAMA.
Yeah, the only problem is the tolerability of these patients. So even in these studies, the adverse events, nausea was to the tune of 40 to 50%, constipation. So the tolerability is a big problem. Even in clinical practice, we have used in some patients, I'm sure everyone here have used in some patients, the tolerability, we just can't go beyond 7 milligram, 14 milligram. Very few patients can tolerate that dose.
Very nice talk. I think again 2 points. One is the recent recommendations, guidelines which have come from ASLD. So we know that there are no drugs which are approved, but most of the societies would recommend either PIO, vitamin E, and INAZL recommends SARO also. So in addition, ASLD has recommended that if there is an indication, which means somebody who has NASH or is also obese or diabetic, semaglutide can be considered as treatment in those patients with NASH, because it not only improves, as you rightly said, liver disease, but also give you the other cardiovascular and other benefit. That's number one. So we have recently again completed a study on oral sema, and maybe we'll share the results in the next meeting.
Sure. No, so I completely agree. In the sense, it is none of the drugs have been approved by the US FDA for NASH, but I think this is one of the drugs, at least in obese patient with metabolic syndrome. If not cirrhotic, we should definitely consider. Cirrhotics also, we will have to wait for further data. Thank you. Thank you.
Hello, may I welcome Dr. Manav Madhavan.
Thank you, Dr. Arora and team. So, I've been given a good clinical topic, managing obesity in cirrhosis. What I'd like to brief you upon is, what would I do if I'm sitting in my clinic and I come across a brief cirrhotic patient? So to answer that question, I first ask myself, how do you manage obesity? Let's not talk about cirrhosis. Let's talk about what are the interventions to manage obesity. There are 4. Lifestyle changes. You have pharmacological interventions. I'll talk about that. You have endoscopic procedures like intragastric balloon. You have endoscopic sleeve gastroplasty. And finally, you have bariatric surgery. So what I'll try to highlight is, if your patient has cirrhosis, how would each of these apply and what we can do for these patients. And the disclaimer is, whatever I discuss is not applicable for decompensated child C patients, including lifestyle changes. I have my take on that. Dr. Anand told us that even in decompensated patients, you can advise weight loss and it may help. I have my doubts about that, but let's go ahead and talk about it. The second question I want to answer is, when do you intervene in an obese cirrhotic patient? So is a BMI of 25, 28, 30, when do you want to do? So lifestyle changes are applicable whenever you have an overweight patient status. But when you're talking about pharmacological intervention or endoscopic intervention or surgical intervention, your bar has to be higher. You don't want to do a surgery for somebody who has a BMI of 28. You don't want to use pharmacological. See, the idea is not very clear. When do you want to give medications? What EASL tells you is, any patient who has a cirrhotic and a BMI more than 30, after correction for water retention, nutritional and lifestyle changes should be implemented, ideally to achieve a 10% weight loss. All speakers have made that clear. We understand that. EASL also says that endoscopic and surgical intervention should be used for class 2 and class 3 BMI. So they talk about BMI more than 35 for endoscopic and surgical interventions. What we don't know is, when do you want to give medications for these patients? I personally would give medications if the patient is obese and child A. Late child B, child C cirrhotic probably may not be a candidate. First intervention, lifestyle changes. Dr. Anand has discussed in detail. I don't want to go through it. The simple thing to do is decrease calorie and increase exercise. Although it's easier said than done, but that's the aim. You want them to lose weight if they are child A cirrhotics. It will help them in the disease. I'll talk about child C cirrhotic and sarcopenic obesity towards the end of this talk. I don't want to confuse the things here. There are 5 drugs which are approved for treatment of obesity in all patients. I'm not talking specifically about cirrhosis. There are 5 drug or drug combinations. You have phentermine topiramate combination, you have naltrexone bupropion combination, orlistat, semaglutide and liraglutide. Let's talk about each one of them in detail. So this is the first combination which has been proven to lead to almost 5% weight loss if you use them in a patient who does not have cirrhosis. There are 2 drugs. Phentermine is an amphetamine-like drug. It's a hypothalamic adrenergic agonist agent. It stimulates the sympathetic nervous system and decreases appetite and increases resting energy expenditure. You add to that anti-epileptic medication, which basically does GABA agonism and glutamate antagonism. What they do is, they increase satiety, decrease appetite. Problem is, all the studies which talk about this combination have not included cirrhosis. The label says that mild hepatic impairment, you don't change the dose. Moderate hepatic impairment, you decrease the dose. And severe hepatic impairment, you don't use it. Now the question here is that hepatic impairment is not defined. So what would you consider a cirrhotic patient? Whether he has a severe hepatic impairment or not? To me, any person who has cirrhosis has severe hepatic impairment. So can you use these drugs in those patients? I would not be happy using them. Moreover, topiramate has significant drug interaction. It works through CYP P450. So this combination would not find much use in patients who have cirrhosis, at least in my clinical practice. So much so that I'm not even aware whether it is available in India or not, because I've not used it for last 20 years. The second drug combination is naltrexone bupropion. We know naltrexone, it's a opioid antagonist. Bupropion is an atypical antidepressant, basically acts through dopamine and norepinephrine reuptake. Both lead to appetite suppression again. The problem again is the same. There are no trials in cirrhosis. All liver disease patients have been completely excluded in the publications of these medications. Moreover, both these drugs have been independently associated with significant liver injury, hence cannot be used in patients who have cirrhosis. So the first two drugs are completely out. The third drug is orlistat. It's a safe drug to use. We have, I think most of us would have some experience in using orlistat, but we have to remember how it acts. It basically inhibits gastric and pancreatic lipase, hence blocking the absorption of fat, dietary triglycerides in your body. It has been shown to be safe in cirrhosis. You have data on patients who have cirrhosis who have F4 fibrosis. The problem here is the weight loss is only modest. 3 to 4 kg weight loss in somebody who's 100 kg, a 3 to 4 kg may or may not matter. The adverse effect profile is simpler to manage. Basically, it is drug which is not absorbed. It inhibits absorption of fat. So what will it cause? It will cause flatulence, cramps, it may cause steatorrhea, and also deficiency of fat-soluble vitamins. There are some reports of drug-induced liver injury. The premise of drug-induced liver injury is that a very small proportion of the drug is absorbed and it may cause an allergic reaction, which has not been substantiated. Again, weak drug to use, not very effective, but it is safe to use in cirrhotics. That brings us to the drugs, the poster boy drugs these days, glutides. Amit has very eloquently discussed about the use of liraglutide as well as semaglutide in patients who have cirrhosis. The good thing about these drugs are both have evidence of use in cirrhotic patients. They have neither hepatic or renal excretion. They are not hepatotoxic. Well documented safety profile in CTP-A and possibly early B. And in case of liraglutide, you have one study in CTP child status C also. The problem is they're expensive and both are injectable. Oral sema is available. I'll discuss that. The data, however, is not very convincing. I thought sema is the drug we are using these days and we should discuss slightly in detail. So Amit did talk about this trial which was published 2 months back in Lancet Gastroenterology Hepatology, use of semaglutide in cirrhosis. Mind you, this is injectable semaglutide, once a week dose, used in 71 biopsy proven patients, but all these patients were CTP-A5, MELD varied between 6 and 10. So early child A cirrhosis, not even child B. Primary endpoint, there was no significant difference, we talked about that, but look at weight loss. 9% weight loss in patients who are child A cirrhosis and obese, right? So you are looking at a significant weight loss with this drug. We know that 5% weight loss or more improves in histology. Up to 10% weight loss, there is improvement in fibrosis. So it may entail an improvement. The problem is injectable drug is not easily available and it's very, very expensive. So all of us have used oral semaglutide. Dr. Duseja was talking about that. Oral semaglutide is not a bad option. It may not lead to a 10% weight loss, but it does give you a 3 to 5% weight loss in these patients. And it may be the drug to go to in patients who have child A cirrhosis at least. But there are other potential candidates. Amit did talk about tirzepatide. I would like to draw your attention to one more drug, retatrutide. I'll talk about this in the subsequent slide. And then there is an oral GLP-1 agonist, a recently published trial in M.I.C.E or for glipron. This is an orally available GLP-1 agonist, again shown to have good weight loss properties. The problem is each of these drugs have not been tested in cirrhotics as of now. But if semaglutide is safe, it is likely that the other GLP-1s also should be safe, but that's extrapolation. So I said tirzepatide and retatrutide, these are two new drugs. Both have phase 2 trials published, one in Lancet, one in NEJM. Tirzepatide acts through GLP-1 and GIP. And retratutide goes one step further. It inhibits all three, it is an agonist on all three receptors responsible for weight loss, GLP-1, GIP and glucagon receptors. And you have documented weight loss up to 25%. So if these drugs are proven to be effective in patients who have cirrhosis, you are actually looking at stopping bariatric surgery completely in patients who have cirrhosis or patients who don't have cirrhosis. So that's the potential of the newer drugs which is likely to be available in some time. And we are looking forward to results of these medications in patients who have cirrhosis. Finally, endoscopic treatment, we have intragastric balloon, we have ESG. There are two trials published from India, not trials, I should say studies. These are not randomized controlled trials. One was published in 2016 by our dear friend Narendra. 6 patients with decompensated cirrhosis, all of them were late B, none of them was child C. They induced weight loss and 5 out of these 8 actually could undergo a transplant. Intragastric balloon in compensated cirrhosis, this is recently published from ILBS, again shown to be effective, 5 to 10% weight loss. So this is something you can consider in your patients who have child A cirrhosis. It is reasonably safe. Of course, you have to make sure that there is no severe coagulopathy or high risk esophagogastric varices. Mind you, even in child A patient, if you have high risk gastric varices or high risk esophageal varices, it may be a contraindication. You have to first eradicate the varices. ESG, no convincing data, but this is a trial which is ongoing as of now, listed on clinicaltrial.gov, that endoscopic bariatric surgery may be used in NASH patients. We'll come to know the answer of this in 1 year from now. I'll just briefly talk about bariatric surgery. There are 2022 guidelines were published from American Gastroenterology Society. Bariatric surgery is well tolerated and can be performed safely with minimal increased risk in well compensated, carefully selected obese patient with cirrhosis. Mind you, this is basically cirrhosis without clinically significant portal hypertension. Once you have clinically significant portal hypertension, the risk rate increases, and it is not recommended to be performed at centers which are early on in their bariatric surgery experience. Now this is a question which I asked Dr. Anand about. What do you do in a patient who has sarcopenic obesity? You can extend that to child C patients also. See, what I understand is body has metabolic switches. Either the body is in a catabolic phase or in an anabolic phase. You want somebody to lose weight, the patient will lose muscle mass. You want somebody to gain muscle mass, the patient will gain weight also. So it's actually an oxymoron in a patient who has sarcopenic obesity or is a child C. It is virtually impossible to increase muscle mass and lose weight simultaneously. That's the physiology behind the concept which I was going to ask about. So the question I ask you is people to think about, should we do anything for a patient who has sarcopenic obesity? Should we ask him to lose weight at all? We know that increasing sarcopenia increases mortality, increases complications. And by asking for weight loss, you are actually increasing sarcopenia in these patients. So should we do it at all? That's a question I want to ask everyone. Now this is an algorithm I took from AGA 2022 guidelines. I completely disagree with the algorithm, but I took it for the sake of simplicity. You see a patient with cirrhosis in your clinic, classify these patients between compensated cirrhosis and decompensated cirrhosis. If the patient has decompensated cirrhosis, I would not ask for weight loss. When I say decompensation, I don't mean upper GI bleed. I mean decompensation as in late child B or child C status. I would refrain from asking for weight loss. I actually may be increasing sarcopenia. Counsel him for transplant and do whatever you want to do after transplant. On the other hand, in a compensated cirrhosis, I will divide into 2 parts, with portal hypertension, without portal hypertension. Both categories, semaglutide may be a safe option. Without portal hypertension, you have endoscopic interventions like intragastric balloon or a bariatric surgery, which may be an option. If the patient has clinically significant portal hypertension, I think only semaglutide drug therapy would be what I would choose for these patients. I would end here and thank you for your patient listening. I was going to thank you for no questions. Please, sir, go ahead.
Yeah, Manav, that was an excellent talk, but I'd just like to differ with one of your conclusions. I fully agree with you in decompensated cirrhosis. It's extremely difficult to achieve both the goals of weight loss and muscle gain. But that does not apply to non-decompensated cirrhosis. You have healthy, normal obesity and even child A cirrhotics. The whole purpose of lifestyle interventions is to reduce fat and improve muscle mass, which is achievable. So that part is, it should not feel that when you lose weight, you're going to lose muscle, or when you try to increase that intake, you're going to also gain weight. The whole idea is to balance your intake, and it's not just reduction of calories and increase in expenditure. You have to do all three. That is caloric restriction, and then the diet restriction. I mean the quality, the composition of diet change, and also the time and other factors. The entire gamut of interventions are required. Just by burning more calories or reducing calories, we may not achieve the goals.
So I completely agree, sir. You do whatever you can do, but to say that you can lose weight and increase muscle mass, that is not possible, at least by physiology which we have read. So losing weight and increasing muscle mass may or may, I don't think it can be done simultaneously. Dr. Anand, please.
I'll be making some statements which are general and some statements about the cirrhotic patients. First thing is, this is from my personal experience also, gaining weight is pleasurable activity. You enjoy yourself while eating and then you gain weight. You feed your brain dopamine. All right? Losing weight is always painful. There is no other way. Whether you take drugs, whether you do endoscopy, it is going to be a painful process because you are withdrawing dopamine from your brain. The only way you can counter lack of dopamine is by giving endorphins, by giving exercise. Exercise is a very inefficient way of losing weight, but exercise is inescapable requirement when you are trying to lose weight. Exercise is important for decompensated cirrhosis, not to lose weight, but to gain muscles.
So that's exactly what I wanted to highlight.
Yes.
So exercise is not to lose weight.
They're
exercise
not to lose
is
weight.
To gain muscle mass.
Very true.
When you're gaining muscle mass, you will also gain weight.
Yes, you may gain weight, but you may not gain weight. But basic thing is, once your muscles have improved, you will be more capable of losing weight.
Right, sir.
Yeah.
Agree completely.
Just to elaborate on that point, we'll probably in cirrhotic population need to look beyond weight as a number. We would probably need to have other parameters. So like we have a paper which has been accepted for oral presentation at ASLD, where we realize that it's a psoas muscle density index, where how much is the fat in the muscle and how much is the actual muscle density. So we'll probably have to look at the visceral adipose tissue, we'll have to look at the skeletal muscle index, we'll have to look at the psoas muscle density index, myosteatosis, and these parameters probably would be more important than only the weight, which is a number and which has multifactorial reasons. There may be edema feed, there may be ascites. So that is something we will need to do, incorporate in our practice.
Very nice talk. Manav, you do a lot of transplant hepatology, though you said in the beginning you are not dealing with the decompensated cirrhosis and the management of obesity. But my question to you is, what do you do in somebody who's a decompensated cirrhosis, who's obese and is waiting transplant? So what are the options? Because I happened to review this subject few years back. None of these drugs which you said are actually been tried in cirrhotics and none recommended, not even orlistat, not recommended in child C cirrhotic, number
So
one.
that was the first slide,
Yeah, first
not
slide,
applicable.
yeah.
Right.
There was one drug, and if there was one case report, that drug now has been withdrawn. That drug was called
Larcoserine.
And there was one case report that time when I had done, which actually was used in a patient with BMI of more than 50 waiting for transplant, and they could actually transplant that patient after using Larcoserine, but Larcoserine had a lot of issues that it was
It's been withdrawn, sir.
It was
It's been
withdrawn. So no drugs, right? The balloon which you said, I don't know Narendra if he's there, he can correct me, but they use this balloon in 5-7 patients only to improve the GRW,
So
eight
not
patients,
to not
reduction.
to lose, basically to lose weight so as to make the GRWR acceptable.
Acceptable.
So
That's
if you
one.
have transplant in the line, then you can actually think of making the patient lose weight to make him acceptable for transplant. But otherwise, by asking them to lose weight, you are doing them a disfavor. To answer your original question.
And the last question is, bariatric surgery, obviously you
No,
will not
Karin is
do.
active, sir. No.
So what do you do in a
exactly. So the original question is, what do I do for somebody who is child C decompensated and obese? Whether or not transplant, what I would advise them is to do weight training with whatever small weight they can. I don't ask them to lose weight. I never given them any medication to lose weight. I don't even ask them to fast. I tell them take your normal calorie meal and please do some weight training. You want to increase
How do
your
you make
muscle
them fit
mass.
for transplant?
Fit, okay, you mean to say, so if I have a transplant in line, then I would, then probably what I would do is put an intragastric balloon unless they have large high risk esophageal varices. What Narendra did in the trial.
Yeah, so gaining weight or losing weight, retaining muscle, maintaining muscle, this is very complex issue, very multifactorial, because I am listening to these talks this morning, but other factors they have not been taken into consideration, like age, because doing exercise, taking nutrition and gaining muscle, it will not be as good as in 25-year-old if you compare with 55-year-old. So age is the factor. Then timing of intervention, when patient is already sarcopenic and if you are intervening, so prevention is basically easier than gaining muscle, especially in child C. So what are your thoughts?
Agreed.
Yeah.
Doctor.
Thank you.
Thank you. One single statement, I think, if I am allowed. I think we are concerning more on weight. If a person who is a muscular weight of 90 kg is not equivalent to a person who is fatty who is 90 kg. So in an obese person, we need to see whether he has muscles or he has more of fat. It may be possible that with exercise we may increase the muscle and we reduce the fat and the weight remains the same. So I think weight is not the prime criteria. One should focus on whether the patient has muscles or patient has more of, I think, the visceral fat. That is more important.
So that's the reason I listed sarcopenic obesity and not child status C.
So we are just
even a child A
focusing
patient
on weight,
may
reduce
have
the
maybe
weight,
obese.
reduce the weight. Weight is not the only thing.
I agree with you.
Yeah.
We are saying the same
Thank
thing.
you. We are saying the same
Yeah,
thing.
yeah. Thank you very much, sir. Now we close this session. Thank you.
Thank you all the speakers, chairpersons and moderators for such an elaborate session on NFLD. There is a little announcement actually. We are actually running quite behind schedule. So we are skipping the tea break. You can have your tea or coffee from the outside stalls while the session runs. I'd also like to request our respected speakers to kindly stick to the given time schedule, and we'll also try to optimize the post-discussion question and answer sessions. So moving on, the next session topic is standing at the precipice and unraveling liver failure. So for this, I would like to invite the chairpersons on the stage. Dr. Ramesh Garg, Liver and Gastro Clinic, Shalimar Bagh, Delhi. Dr. Balbir Singh, Yashoda Hospital, Sikandarabad. Dr. Anil Shankdev, Kathmandu, Nepal. Dr. G.S. Saluja, Sri Devi Talam Mandir Charitable Hospital, Jalandhar. Dr. Binod Karki, Vayoda Hospitals, Kathmandu, Nepal. And for moderators, I would like to invite on the stage Dr. Dibas Khadka, National Academy of Medical Sciences, Kathmandu, Nepal. Dr. K.N. Singla, Jaipur Golden Hospital, Rohini, Delhi. Dr. Amarpal S. Anand, Brijlal Hospital and Research Center. Dr. G.N. Ramesh, Astra Medicity, Kochi. And Dr. Deepak Lahoti, Max Super Specialty Hospital, Delhi. I would request the chairpersons to kindly call the speakers on the stage.
We straight away, I think, start with the proceedings of this because we are already running late. The next presentation is future therapies of alcoholic hepatitis beyond corticosteroids. And the speaker is very eminent person, Dr. Ashwani Kumar Singhal from USA. He will be highlighting what are the points regarding this. I call Dr. Ashwani Singhal. Thank you, sir.
Please excuse me if I run into some of the upper respiratory issues during my talk. That's why I have, this is water, I can assure you. And I may have to use it in between the talk. So I want to thank Anil Arora for this opportunity and his team. And over the next 20 minutes or so, we'll talk about some of the future therapies for alcoholic hepatitis, what is beyond corticosteroids. And these are my disclosures, and none of them is related to the presentation I'm giving today. So over the next 15 to 20 minutes, we'll recognize what is the current medical treatment options and how unlimited and what are their limitations. and then talk about emerging data on promising newer therapies, pharmacological therapies and targets, recognize the role and selection criteria for liver transplantation or early liver transplantation, and finally, how do we move from here and what is the future. So this is a slide, and I think we had a hot debate on nutrition in cirrhosis patients, and that applies to alcohol-associated hepatitis. And I would give a rider here. The caloric intake in a cirrhotic patient can range from 25 to 35, completely agreeing with Dr. Anand that NASH, obese cirrhotic or obese sarcopenic patient may be kept at a lower caloric range, which is 25, and a thin or a normal weight may be at 35 kilocalories per kg per day, keeping the protein intake same, which is 1.2 to 1.5 grams per kilogram per day. And these are the recommendations from some of the guidelines by the societies, and we are involved in probably by next year, early next year, the guidelines will come in the Red Journal on American College of Gastroenterology. And this is the slide I took from the data which was analyzed by one of my friends in Indiana. And the importance is that hospitalized patients with alcoholic hepatitis, almost over 100,000, and this is the data in 2019, are waiting for newer therapies. If I take you through this slide, there are 136,000 odd patients who were hospitalized in 2019 with the diagnosis of alcoholic hepatitis. Half of them, so eligibility for steroids, almost 62,000. Responders, again half of them, about 30,000. And a very small segment of non-responders are eligible for liver transplantation. Puts a number, 106,000 out of 160 or 136,000, which are waiting for newer therapies. You can probably increase the precision of use of steroids in alcoholic hepatitis patients by focusing on a group of 25 to 39, and this is a slide in which we were involved in the study in JHEP. That MELD score of 25 to 39 gains the maximum benefit of steroid, which is also very modest, up to 30%. What about N-acetylcysteine for severe alcoholic hepatitis? And this is the seminal study published almost a decade ago. 174 patients failed to reach the primary endpoint at 6 months, although at 1 month there was a difference in the two arms. However, N-acetylcysteine is not out of the game because it did reduce infections and hepatorenal syndrome. And that brings to the guidelines by the American College of Gastroenterology. We were involved this 5 years ago, and Dr. Kamath was one of the co-authors. Patients with severe alcoholic hepatitis should be treated with steroids if eligible. Pentoxifylline has no role. What has changed in 2013, the same group bringing the guidelines again. In patients with severe alcoholic hepatitis, recommend treatment with steroids. So more stronger guideline may be focusing to increase the precision of efficacy, MELD score 25 to 39, pentoxifylline no role, and may consider IV NAC in more severe patients in combination with corticosteroid. So a little bit change there. Again, telling you the frustration as hepatologists we're going through because there are no therapies. So we're kind of bringing guidelines to add more and more drugs which are maybe a marginal benefit like N-acetylcysteine. And this is the algorithm I've taken from our JAMA review paper 2 years ago, where we focus on mainly nutrition in moderate alcoholic hepatitis. In severe alcoholic hepatitis, those who are non-responders, if they are eligible for liver transplant, may be considered liver transplantation for them. And these are the guidelines on liver transplantation in ALD patients. And why I say ALD patients, because early liver transplantation not only amenable to alcoholic hepatitis, but even non-AH precipitant of ALD could be considered for early liver transplantation. And this is ACG 2018, in which we were involved in early liver transplantation by EASL and these ASLD. So all the three societies are recommending that should be considered in highly select patients. How to select that population? And this is a very objective assessment, but there are scores here, and this is one of the scores. I have picked up the major problem with these scores is that they have an excellent negative predictive value, so that you are very confidently can say this patient is probably not going to drink after transplantation, but these scores are very poor in predicting the person who is going to drink after transplantation. That, I think, is the goal while you're talking about liver transplantation selection for early on in alcohol-associated liver disease. And this is the most important slide, I think, which makes this talk very, or this presentation very relevant. And we have the first randomized controlled trial on steroids in alcohol-associated hepatitis in 1971. We have come almost half a century through since that first published trial. And look at the 28-day mortality, 90-day mortality, 6-month mortality has not changed over 50 years. So clearly telling us as hepatologists, as researchers, we need to do a better job and develop drugs for these patients. And what can we do? And these are the buckets in which you can investigate and therapeutic targets, whether it is inflammation, whether it is oxidative stress and hepatocyte death, regeneration or fibrosis or a gut-liver axis. And why we have failed in the last 50 years in developing drugs, and I think in my mind this is one of the most important reason for failure of drug development. Until 2010, 40 years since controversy about steroids in alcoholic hepatitis, we have focused on animal models in drug development, and animals don't die with alcoholic hepatitis. They don't develop organ failure, and the phenotype in humans is completely different from what we see in mice. And we recognize that in 2010, and since that in 10 years, I'll show you the slide where we are in terms of the drug development. Some of the other issues in drug development for alcohol-associated liver disease, whether this is disease-related issues, many of these patients, the majority of these patients will have alcohol use disorder and associated issues in recruitment of this population into clinical trials. And finally, complexity of the trial and other trial-related issues have hampered the drug development in this field. And this is the snapshot of where we are in the last 10 years or 12 years since the first clinical trial other than steroid was done in humans. And if you look at the left-hand side, every year we are adding a drug to the pool of negative clinical trials. Whether we talk of the latest antibiotic, selonsertib, anakinra, canakinumab, and acetylcysteine also, I think, was a negative clinical trial. However, there is always a silver lining in the clouds, and I think in this cloud the silver lining is that there are some encouraging targets, mostly focusing on regeneration, whether we talk about GCSF or IL-22, DR928, and also fecal matter transplantation. And this is the results on fecal matter transplantation from ILBS. Small study on 8 patients, historic controls comparison, excellent data on survival and liver disease improvement. Just Bajaj from VCU did this study showing not only benefits in patients with liver disease, but also benefits in the gut-brain axis. It improves the psychometric analysis, improves the inflammatory profile, and not only it acting on the liver, but also on the brain, so killing 2 birds with 1 stone. However, a small study and also very moderate disease, I think the MELD score was below 18 or so, which was included in this population. And as we learned that regeneration is a promising target, whether we talk about regeneration through the hepatocytes, and more importantly in alcoholic hepatitis through non-hepatocyte regeneration, which is mainly mesenchymal bone marrow derived cells, and in this process many cytokines, hormones, growth factors are helping. One of the growth factor is GCSF. However, this drug remains a controversy in the treatment of alcoholic hepatitis. In spite of very encouraging data, the drug remains out of recommendations by most organizations. And the reason is here, this is a meta-analysis of 7 randomized controlled trials on GCSF in which we were involved in. And the data is the positive mostly from Asia, but 2 studies in this meta-analysis from Europe were negative, and therefore nobody knows the difference why Asian population gets benefit and not the Western population, and why it remains out of recommendations of GCSF in management of severe alcoholic hepatitis. There are 2 emerging studies in USA on GCSF, one randomized controlled trial, one retrospective, again negative. Small studies, larger trials are coming, one on 270 patients, 130 patients. I think these 2 large trials from USA will establish once and for all whether GCSF will make it to recommendations or not. Moving on, interleukin 22, excellent data. This is phase 1 study, dose finding study actually, but look at the 83% LIL score. So response to treatment, LIL score 83%, never heard of in any clinical trial before. Also improved regeneration by extracellular vesicle measurement and also inflammation by cytokine measurement. Similar data by DOR928 in alcoholic hepatitis patients, again a dose finding study, 19 patients, excellent response, 89%, similar to IL-22. Everybody survived, including those with severe disease. So 28-day survival, 100%. Never seen in a clinical trial before. This is the currently ongoing, and I think this study has stopped recruitment, phase 2B. It's also called AH-FIRM trial, which is 2 doses of DOR928 against placebo, 300 patient study, and by I think early next year we will know how encouraging that data is. Is it as encouraging as the phase 2A study I showed you in the previous slide? What about the other drugs? And I think there is a huge amount of number of drugs being tested, which is encouraging in alcoholic hepatitis, but gut-liver axis, inflammation, regeneration, oxidative stress. But I think 2 areas where I want to focus on in the next 2 slides is how we have learned from NASH, and there are some NASH molecules which are emerging as metabolic targets in this condition of alcoholic hepatitis, and the drug development field and industry is after researchers on alcohol-associated liver disease, whether it is fatty acid metabolism, glucose metabolism, and bile acid metabolism. And I'm not going into details of what drugs will make it there into clinical trials in that particular bucket. Alcohol use disorder, and we heard about GLP a lot, and I want to tell you here the GLP-1 agonists, as we all know, are also having an added benefit of addiction, whether it is food addiction or alcohol use disorder addiction. And this is what I was telling you, learning from NASH, glucose metabolism, bile acid metabolism, and lipid metabolism. Drugs are being, and you will see in the next few years, these drugs are not only investigated in NASH but also in alcoholic hepatitis. And this is the editorial from Science, which was published just last week, that weight loss drugs are coming a big way in as a clinical trial in managing addiction, whether it is smoking or alcohol or even cocaine or food, for example, in the management, GLP-1, GIP-1 and everything, mostly semaglutide. And finally, we'll move on to how we can move from here after learning what the future is what the current status is and how the future can change. And I think this is an excellent data from Alex Louvet from France, showing you that whatever drugs we use, steroids or emerging drugs, the benefit lasts only maybe maximum 3 to 6 months. But after that, what happens to the patient is what the patient does to himself. So recurrence of alcohol use is something to target upon. And I want to bring you here, which is something not new, concept here of integrating care of these patients to help the dual pathology of not only the liver disease but also their alcohol use disorder. So if we have to look at the alcoholic hepatitis algorithm again, once we have made the diagnosis of alcoholic hepatitis, either clinical or histology, the next question is the patient's severity of the disease. And if it's a moderate disease, the only thing you can do is the nutrition supplementation. In a severe disease, you can use steroids and consider transplant in non-responders in a very select population. But I think right from the beginning, we should focus on the multidisciplinary care for alcohol use disorder. As soon as the patient is out of ICU and patient is able to communicate, you should bring on your addiction team and talk to the patient, involve them. Alcohol use relapse remains a concern even after transplantation. We have heard that, recognized that from France, that these are the transplants after 6 months of abstinence, so traditional cirrhotic transplants, relapse rate 25% of alcohol at 2 years. And on the left hand side you see 68 patients where the transplantation was done early on because they were actively drinking, less than 6 months of abstinence, look at the relapse rate, and even after a rigorous selection process. So you cannot eliminate it completely. So the alcohol use relapse will remain an issue in transplant recipient patients. And the integrated or multidisciplinary care for alcohol use disorder has been documented in a scientific fashion, and this is meta-analysis we were involved in. Look at the left-hand side, 5 studies, integrated care versus routine care by hepatology, reduces alcohol use relapse. And on the right-hand side, the mortality from 2 studies also improves mortality. So it's a strong evidence, at least in transplant population, that integrated fashion works. So once you have selected a patient for liver transplantation, and I want to tell you the dream of every hepatologist for managing alcohol use disorder and alcohol-associated liver disease is an integrated multidisciplinary care which should be present at every center, and every provider should be able to use it, but it remains a dream, and I think once we get there, we can provide better care to our patients. Not only it helps in the clinical care, I want to bring this workshop which was conducted last year, and proud to be associated with this, both by NIH and FDA, so it's a combined workshop by NIH FDA, telling us that not only the clinical management has to focus on integrated care, but also the clinical trial design. So we're developing a drug for liver disease, you cannot ignore alcohol use disorder. Or vice versa, if you're developing a drug for alcohol use disorder, you cannot ignore liver disease. Integrated drug development for alcohol-associated liver disease and alcohol use disorder. So here are my take-home messages. Nutrition and steroids are the current therapies, which are limitations. There is emerging data, so there is hope that at least fecal matter transplant regenerative targets will be showing some benefit, and maybe drug approval in the next year or 2. And finally, integrated multidisciplinary management should be promoted not only after transplant but also pre-transplant, kind of a longitudinal, starting from pre-transplant, taking them through and after transplantation to address dual pathology, similar to what Dr. Anand pointed out in terms of managing their sarcopenia before transplantation, so they can have a good outcomes after transplantation. So I'll stop there, and thank you for patient listening. Happy to take questions.
Thank you, sir. Thank you. And another questions, please.
Excellent lecture, sir. Yeah, this is Ashish here. So, as in the NASH trials now, people are moving towards combination therapies now, instead of searching one panacea drug. So, are there any trials which are going on for combination, like combination of IL-22 plus DUR928 or any other combination therapy?
The only combination trials which I am aware of and have been published are trials steroids plus something else, like steroids plus NAC or steroids plus nutrition. Those are the steroids plus antibiotic which I showed you. And most of them, at least the NAC and the other one, the antibiotic, were negative. But I think I agree with you, there should be more and more combination trials, either anti-inflammatory or a regeneration. I think regeneration is something, and we have learned that from this anti-TNF studies, where we only wanted to knock down the inflammation, and we burnt our fingers that we were knocking down regeneration also. So in my mind, I think whenever you do a study in a combination way, try to combine an inflammation target and a regeneration target, and I think that will be a positive trial. But that's a good question.
Professor Singhal, in clinical practice, how do you finally decide on steroids? As in, is it only going by the MELD, like MELD more than 50 contraindication, or would there be more granularity to the decision making of, because the crux of the matter is steroids being a double-edged sword. We have patients where they do very well, and there are patients whom we lose and they are not ineligible for transplant also with bad sepsis. So could you just tell us, in practice, is it only by MELD or some other way to decide on indications and contraindications?
Yeah. So the question is how you can, because at this moment, steroids, you can only gauge the response after you have given them for 4 to 7 days. The question Dr. M.I.C.E is asking is whether you can, there are ways to increase the personalization of steroid use beforehand, other than the MELD score. Yes. So the MELD score 25 to 39 I showed you, that has the best outcome. But I think there have been many, many biomarkers. Cytokeratin 18 has been one. People have used gene expression studies to look at how much regeneration or baseline regeneration is going on. There have been some mitochondrial, we have done some mitochondrial work looking at their baseline bioenergetics to see whether the patient is likely to respond or not. NLR ratio has been looked at. So there have been some, and branched DNA from bacteria coming, but these are only in an experimental phase. They are not available to us in the clinic. But the hope in the future is, hopefully we'll get a better drug like DR928 or IL-22, and maybe in a year or two meetings, we will probably not be talking about steroids more, talking about those drugs more.
Thank you.
Thank you, sir, for the excellent presentation and discussion.
Thank you.
Now we close this session and move forward. Thank you, everyone.
Thank you, our respected speaker, chairpersons and moderators for such a good discussion on alcoholic hepatitis. Moving on to our next session, the topic of our next session is addressing medical challenges in cirrhosis. For this, as chairpersons, I would like to call on the stage Dr. Anil Rastogi, Clinic Meerut, Dr. Arun K. Singh, National Liver Cancer, Kathmandu, Nepal, Dr. M.P. Sharma, Meteor Hospital, New Delhi, Dr. Avdesh Narayan, Ruben Memorial Hospital, Patna, and Dr. Niyanta Karki, Norvik Hospital, Nepal. And for moderators, I would like to invite on the stage Dr. Pradeep Newpain, BP Koirala Memorial Cancer Hospital, Nepal, Dr. Devendra Viddi, Apollo Hospital, Bilaspur, Dr. Ramesh Satarkar Gastroenterology Center, Aurangabad, Dr. Jagdeep Singh, Dr. Jagdeep's Gastroenterology and Liver Disease Clinic, Amritsar, and Dr. Pavan Rawal, Artemis Hospital, Gurgaon. I would request our chairpersons to kindly invite the respected speakers for the talks. Thank you.
Hello, good afternoon. Let's start this session. The first speaker is Dr. S.P. Mishra, who is going to talk about efficacy and duration of ATT in patients with cirrhosis. Dr. Mishra, please.
Thank you, sir.
Anil.
Good afternoon, everybody. We come to a very practical thing. Thanks to Dr. Arora and the team. I'll be talking about safety, efficacy, and duration of anti-tuberculosis therapy in patients with cirrhosis. It's a very common problem. The problem is because there's a higher prevalence of tuberculosis in patients with cirrhosis. That's the first thing. The second thing, a study showed that the prevalence of TB in cirrhotics is about 8.1% as compared to 1.6% in the general population. The other problem is that the problem of drug-induced DILI in patients with cirrhosis is very high. So you all know about this, the first, second, and the newer drugs, second-line therapy and first-line therapy and newer drugs. Most first-line drugs have hepatotoxicity except for ethambutol. Isoniazid has hepatocellular injury, it does hepatocellular injury, as well as it's cholestatic in nature. Rifampicin is mostly cholestatic and hepatocellular. And the problem with rifampicin is that it enhances the toxicity of other drugs rather than having problems alone. Pyrazinamide is hepatocellular and there's massive hepatic necrosis and should be avoided in cirrhotics. These are the risk factors. These are very important for prevention. Age more than 35 or less than 5 years of female sex, concomitant ethanol consumption, slow accelerators, malnutrition, CLD, HIV and tuberculosis, and concomitant hepatitis B or C infection. I'll come to it again. Deranged baseline transaminase and some HLA markers, as well as gene polymorphism, and post-liver transplant patient. You should be very cautious in using ATT in these patients. So if you prescribe ADT in patient with cirrhosis, you may end up with liver failure due to hepatotoxicity, and pyrazinamide, I said, that's best avoided in patients with CLD. Patients who are well compensated, child A, MELD score less than 10, they tolerate it very well, and you can prescribe all three. I'll come to it later on, how we practice at our center. Again, patients who have liver toxicity, the chances of recovery in these cirrhotic patients is very low. So once they have this problem, their liver results is bad, and therefore the recovery is poor. So once you use isoniazid, there's asymptomatic elevation of aminotransferase in about 1/5 of the patients. That's idiosyncratic and hypersensitivity reaction. INH alone has clinical hepatitis in 0.6%. Any other drug except rifampicin is 1.6%. And as I said, rifampicin potentiates the problems. And therefore, if you use rifampicin and INH, the toxicity comes to about 2.7%. Rifampicin with any other drug but not INH is only 1.1%. So per se, rifampicin is safe. But once you use with isoniazid or any other drug, it potentiates the And you all know about this slide. Hepatotoxicity occurs more commonly in patients who are slow accelerators. So on the left-hand side, if you can see, that is on your right-hand side here, acyl hydrazine formation is non-toxic. But once the slow accelerators are there, this hydrolysis takes the upper hand, and you have isoniazide hydrazine, which is toxic, and all the metabolites of this agent is toxic. So slow accelerators have more problems to anti-tuberculous agents, especially INH. Rifampicin is a potent inducer of P450, and there's transient elevation of bilirubin 0.06%, minimal. But again, I said, if you use rifampicin with INH, the toxicity increases. On the liver function test, mostly the increase in the conjugated bilirubin and mild elevated in the ALT. Pyrazinamide causes clinical hepatitis in 1%. Liver injury may be severe and prolonged. It should not be used in patients with underlying liver disease. That's the WHO recommendation. And you should have close laboratory and clinical monitoring of these patients. The second line drugs, cycloserine has low rate of asymptomatic transaminitis, no definite hepatotoxicity. Capreomycin again, no definite hepatotoxicity. Ethionamide, there's self-limited small rise in the ALT that can be managed. Rifabutin, again hepatitis is very uncommon in the dose of 150 to 300 milligrams per day. Fluoroquinolones, again mild elevation. Moxifloxacin, again there's 1.5 times rise of UL, the upper limit of normal, is reported in about 1% of the cases. Not a big problem. Out of these three drugs, delanamide is reported to be very safe. The others have small elevation of LFT, but pretomanid has elevation in about 1/3 of the patients and should be very cautious. How do you diagnose that the anti-tuberculous agent is causing the problem? You have to exclude other causes. This is a big problem. You have to investigate the patient. But clinically, we have all been mature and we can diagnose them clinically. So you have to rule out acute viral hepatitis, any other drugs, relief or because of any other drugs, and liver dysfunction which persists or progress after stopping anti-tuberculous agents. Consider something else. You can do a liver biopsy, you can investigate these patients because they have something else. There's a chronological relationship also. The time lag is between weeks to months. If somebody develops it the next day, you have to be very cautious something else is happening. Again, there's a recurrence of symptoms. If you stop the drug, there'll be improvement, and if you restart the drugs, the same thing can recur, and that shows that the anti-tuberculous agent is at fault. So you have, how do you manage this, the problem? You have prevention. I've already talked about treatment, reintroduction of therapy and second line therapy can be given. Something is known as adaptation, that if you continue to have small rise in bilirubin or ALT, if you follow them up, they'll normalize. That's adaptation to INH and anti-tuberculous agents, and that's a good example of adaptation. But mind you, you have to be very cautious, especially in cirrhotics. To prevent, you have to, I told you the risk factors over there, if the patient has pre-existing liver disease, chronic alcohol consumption, pregnancy and recent childbirth, age more than 35, malnutrition, and concomitant use of any other hepatotoxic drug. If cirrhosis is identified, consider a modified regime. So in cirrhotics, one have to be extra cautious. Perform a baseline liver function test in one of the high-risk groups. Obtain HBV and HCV serology. Educate the patient about the symptoms and side effects. Try to stop alcohol consumption. Avoid hepatotoxic medications and limit the dose of acetaminophen to less than 2 grams a day. So what do you do if there's a rising liver function markers and ALT is rising or ST is rising? So stop all medication if the following occurs. Transaminitis of more than 5-fold. Absolute stoppage of all drugs. If the transaminase levels rise by 3-fold and there are symptoms, stop it. Elevation of conjugated bilirubin levels and or INR, you have to stop it. Hepatic encephalopathy. In patients with chronic liver disease, even if there's a double rise of ALT, please stop the medication, regardless of the transaminase level. The conditions which are not fulfilled over here, you can monitor frequently every 2 weeks and then every 2 weeks until liver function is normal. So you have to be very cautious in these patients. What about reintroduction of therapy? There's a contraindication to reintroduction of therapy in life-threatening hepatotoxic effects, fulminant hepatitis, underlying decompensated liver disease. Please don't reintroduce therapy. The timing of reintroduction is also very important. When the liver functions are normalized and liver enzymes are less than the double or upper limit of normal, you can think of reintroducing the ATT. Liver enzymes return to baseline if the levels were already raised owing to underlying liver disease. And how do you reintroduce this? So there are 3 guidelines basically. The ATS guidelines has sequential ATS as well as BTS guidelines. They have sequential re-challenge regimen, but AIMS Delhi, and that is what we do at our center, is simultaneous reintroduction of all the 3 drugs in patients who have normalized ALT, and they are clinically followed. And most of the patients, they don't have any problems. So the 2 guidelines from abroad, they say they introduce rifampicin at the maximum dose from day 1, INH at maximum dose at day 8, and then pyrazinamide from day 15. We in India mostly reintroduce all the 3 drugs simultaneously if the patient has normalized ALT and is clinically okay. There are some methods by which you can minimize the hepatotoxic effects of these drugs. Co-administration of N-acetylcysteine, tocopherol, vitamin C and silymarin, but most of the studies are with N-acetylcysteine. How do you use anti-tuberculous agent in chronic liver disease? So once the CTP score is less than 7, the MELD score less than 18, that what is known as stable liver disease, you can start with 2 potentially hepatotoxic drugs, rifampicin and INH, and you can continue with rifampicin, INH and ethambutol for 2 months, and rifampicin and INH for 9 months. If the CTP score is 8 to 11, MELD score 18 to 25, moderately advanced disease, you can only have 1 hepatotoxic agent, either INH or rifampicin, and INH is the backbone basically. So we use INH. Then you can have rifampicin or INH with ethambutol and streptomycin, or you can have a quinolone or cycloserine for 12 to 18 months. So duration also increases basically. And if the patient has very advanced liver disease, then you cannot use any of the hepatotoxic agents. So you have to use ethambutols, streptomycin, quinolones or cycloserine for more than 18 months, about 18 months. So to summarize, the risk of TB in patients with liver disease cirrhosis is very high because of the immune dysfunctions. Baseline liver function test monitoring is required in all these patients. Elevation of liver function test to 2 times above baseline requires stoppage of therapy. ATT should be started according to the CTP score or severity of the disease in the patient, and the duration of therapy depends on the drugs given. Thank you very much. If you have any queries and questions, I'll be glad to answer them. Harshad, why are you leaving? You are an expert on this. Harsha has done some seminal work on this. Harsha, any comments from you?
Any questions or comment, please?
Yeah, your last couple of slides were very important, and that is when you have patients with liver disease, we have to be careful with the institution of drugs. Now, with child, the easiest way to do it is to divide them into childs B, C, and A. And child C, you don't use any of the hepatotoxic drugs, as we mentioned. And child's B, you can use one hepatotoxic drug. And as we mentioned, rifampicin is the least hepatotoxic. You said INH you use, but we tend to use rifampicin because it's the least hepatotoxic. And in order not to put these patients at risk, all we have to remember is to continue these whatever drugs we give for 12 months or 18 months. It's better to have a live patient rather than have a dead patient with tuberculosis. So that's
once we use, see, the INH is the backbone, and once we use, we have a very close monitoring of these patients. And we'll be publishing it very soon. Most of our patients do very well, even with INH. And the response is much better as compared to rifampicin. Rifampicin, INH is the backbone of ATT.
INH and rifampicin, all guidelines sort of say that. It all depends on the individual preference. And the other question is, few patients develop ATT hepatotoxicity and permanent liver failure and worsening liver disease and undergo a transplant. The question is, should we transplant a patient who's got a florid pulmonary tuberculosis? The answer is yes. And then after transplant, you please avoid rifampicin and just continue them with the first-line anti-TB drugs.
So any patient who has undergone transplant, you don't use any hepatotoxic drugs, especially if it's done for tuberculosis and fulminant hepatic failure.
Especially rifampicin, because it interacts with all this cyclosporin as well as tacrolimus.
So shortest in these patients, the immune system is not working. So a short dose may not lead to a complete eradication of the mycobacteria. So that's a big problem in cirrhotics. The duration has to be extended. So normal healthy individual 6 months is good enough. But we are using INH in most of these patients. And fortunately, most of them they're doing very well. Not most, all of them are doing very well. So we have first-hand experience of using INH in these patients. But the recommendation is rifampicin, as Harshad said.
Dr. Mishra here. Most of these cirrhotics could be having abnormal LFTs to begin with. So, as we say, more than 2 milligram bilirubin or more than 3 times the upper limit of normal of SGOT, GPT, you stop the drugs. So, when these patients have abnormal LFTs to begin with, so what will be the take on the...
So that is the baseline. If it has to be more than 2 from that, basically. But most of the cirrhotics, they don't have very high ALT. Cirrhotics I'm talking about, not hepatitis. Most cirrhotics have moderate rise of, very mild rise of ALT. But that should be taken as the baseline. So do an LFT before starting anti-tubercular therapy in these patients. And closely monitor it.
How much bearing the nutritional status of the person has on the toxicity by ATT?
Can you have
how much bearing the nutritional status of the patient has on toxicity?
Of course, I said the malnourished patients have higher toxicity and they fare badly. So nutrition has to be good.
Sir, in child C cirrhosis, you have mentioned ethambutol plus streptomycin plus quinolones or cycloserine. So in child C cirrhosis, patients may have INR very high. So they are going to take the streptomycin not every day into hospital, probably in a...
Many of them have renal problems also, so that you have to, this is a special consideration what you are talking. So there you have to have your clinical acumen whether to use streptomycin or not.
So instead of streptomycin, other aminoglycosides can be given?
So you have 4 drugs over there, you can...
Amikacin can be given if there's...
It has a similar problem, but if you have 4 drugs are there, you can use 3 drugs for a longer duration of time. The healing may not be that good.
Dr. Mishra, any guidelines regarding management of MDR tuberculosis in these patients?
So getting MDR and XDR in these patients, there's no studies that I can quote off. But again, I think that the guidelines will be the same as that for any other MDR. You may even have XDR in these patients. What to do then?
Thank you, sir. Thanks for the nice lecture. Next, we move on to the next lecture. How should a gastroenterologist be managing diabetes in cirrhosis? May I invite Kaushal Madan for that.
Good afternoon, everyone, and thanks to the chairperson, thanks to the organizers for inviting me for this wonderful meeting. So, how should a gastroenterologist treat diabetes and cirrhosis? Let me start by this. Why should a gastroenterologist treat diabetes? Why can't we just focus on our area and want to trespass on an endocrinologist's area? That's because these two problems are very common and they definitely are going to overlap in your practice. So this is a recent prevalence data of diabetes from India. More than 1 lakh patients sampled, persons sampled from 31 Indian states. The prevalence of diabetes was almost 11.4%. That means 1 in 10 were diabetic. And this prevalence is higher when you come to metropolitan cities. So these are studies, published studies from Delhi. Almost 20%, that is 1 in 6 or 1 in 5 patients are diabetic. Now what about non-alcoholic fatty liver disease, the most common cause of cirrhosis in our country and possibly around the world. This is a recent meta-analysis of all these studies, prevalence studies from India, and you can see in adults almost 40% people are having non-alcoholic fatty liver disease. So 40% MAFLD, 20% diabetes. So definitely you are bound, these two are bound to overlap, and when you go into your practice, you are going to see patients who will have both. And this is not static, it is progressively rising because of the kind of lifestyle we live in. This is data from 3 large names survey from USA. As the prevalence of NAFLD is rising, so is the prevalence of type 2 diabetes, and they are paralleling each other. So again, the gastroenterologist is bound to see both of these problems together. And not only that, if you are following a patient, a gastroenterologist is following a patient of non-alcoholic fatty liver disease, a proportion of them in future are going to develop diabetes. So this is how it evolves. So to begin with, no normal glucose tolerance, no NAFLD, and as it progresses, the insulin secretion increases, insulin sensitivity, insulin clearance goes down. At the peak, the beta cell dysfunction starts with advent of beta cell failure, hyperglycemia. Here you diagnose diabetes and then it progresses further. And clinically, there is data to prove that. This is from South Asia. 1914 Sri Lankan subjects followed up over time. The incidence of diabetes mellitus developing in non-alcoholic fatty liver disease was double as compared to those who did not have NAFLD. And the only factor among all risk factors of metabolic syndrome, it was NAFLD which was associated with development of diabetes. Another population-based study from Korea, more than 1.75 lakh person years of follow-up, 2000 developed diabetes. Those who had NAFLD had a higher risk of developing diabetes, and it was double if they also had advanced fibrosis. Not only that, gastroenterologists are frequently called upon by diabetologists when they are following their patients up and they get a fibroscan done, and a large proportion of them, almost 1/3, have advanced fibrosis and 7.2% have cirrhosis. So gastroenterologists are definitely in their practice, and you would all agree, bound to see patients who have diabetes and NAFLD as well as cirrhosis. So we must learn how to treat them. Now the issues in managing diabetes in presence of cirrhosis is brittle diabetes, and the most common test we use for diagnosing diabetes is HbA1c, which may be falsely low in cirrhotics due to reduced lifespan of RBCs, hypersplenism, GI blood loss, and altered RBC membrane fragility. The issues with using anti-diabetic drugs, there is altered drug metabolism, distribution and excretion, there is renal impairment, insulin clearance gets delayed, insulin levels increase, risk of hypoglycemia increases. Patients who have hepatic encephalopathy, it may be difficult for them to manage their diabetes on their own. The drugs which are used are these categories. Most the classical drugs were sulfonylureas and insulin. The recent ones are incretin based. We've all been hearing about them in the previous talk. The DPP-4 inhibitors, GLP-1 receptor antagonist, those that interfere with glucose absorption, SGLT2 inhibitors and alpha glucosidase inhibitors. Let me put to rest the use of sulfonylureas and cirrhotics. These are all metabolized in liver and they're albumin bound. So liver is not working well. Obviously their metabolism is decreased, level goes up. They are not being able to bound to albumins and albumin levels are low. So more free plasma concentration leading to higher risk of hypoglycemia. Therefore recommendations are not to use sulfonylureas and cirrhotics. If at all, prefer shorter acting like glipizide or ripaglinide, and that too only in CTPA. Now in short, what about newer anti-diabetics and their safety in cirrhotics? The DPP-4 inhibitors, most commonly used drugs in diabetes, mostly excreted through kidneys except linagliptin, which is secreted in bile. They are safe in CTPA-B but to be avoided in CTP-C. There is some concern about use of vildagliptin because hepatotoxicity has been reported, but we will come to that later. Thiazolidine again safe in child's A. Second problem is they can cause fluid retention. They can even cause or precipitate congestive heart failure. Therefore, best avoided in patients who have decompensated cirrhosis because fluid management may become difficult. Also reported is the side effect of osteoporotic fractures with long-term use of thiazolidine diones. SGLT2 inhibitors, no dosage adjustment required in CTP-A-B-C, but still they are not recommended to be used in CTP-C because their levels rise. You have to be cautious when you are using in patients who have cirrhosis and renal impairment. There is a risk of increased frequency of UTIs, especially if the diabetes is poorly controlled. And you have to be cautious when you are co-prescribing them with diuretics because their effect by inhibiting the absorption of glucose and sodium, they act similar to loop diuretics. So if you're already giving diuretics to them, they may lead to dehydration. GLP-1 receptor antagonists, again, no dose adjustment required, but they are not recommended officially to be used in CTP-B or C. Although you heard the previous speakers that there are studies in which it has been used effectively and safely in CTP-B patients, and none of them are metabolized in liver. Now what stops or what scares a gastroenterologist from treating diabetes in patients with cirrhosis? One is the risk of hypoglycemia. But if you look at these newer drugs, starting from the first line metformin, as well as all these newer second line drugs, none of them are hypoglycemic, they are euglycemic, and when used alone and also in combination, they rarely cause hypoglycemia. And if you look at this systematic review of 140 trials and 26 observational studies, you can see all the hypoglycemia happens if you are using sulfonylureas or if you are using combinations which contain sulfonylureas. If you use other combinations, there is no increased risk of hypoglycemia. So it is the sulfonylurea either alone or in combination which is the culprit. Second thing which scares us is the knowledge about metformin in associated lactic acidosis, but let's see whether that's true. These are non-cirrhotic patients, meta-analysis of 347 trials in diabetics, 7,000 patient years of metformin use versus 55,000 patient years of non-metformin use. No episode of fatal or non-fatal lactic acidosis seen. What about diabetics with cirrhosis? This is a study retrospective as well as prospective. 34 diabetics with cirrhosis who were on metformin, 24 diabetics with cirrhosis who were started on metformin given for 6 weeks. And as you can see, the lactate concentrations, although they were higher in cirrhotics, but they were well below the safety threshold of 5 micromoles per liter. So in cirrhotics who use metformin, the lactate concentrations are higher, but they are still safe. And there was no correlation between the plasma lactate levels and the steady state metformin concentrations which were achieved. Second, when you treat these patients, always choose drugs which are also effective against non-alcoholic fatty liver disease or fibrosis or cirrhosis. This is just water, by the way, and I don't drink in during daytime. So anti-diabetic drugs which benefit MASLD, So apart from DPP-4 inhibitors, all newer anti-diabetic drugs are effective against non-alcoholic fatty liver disease. And we'll just put this to rest. Although this is the most commonly used drug, one of the very effective anti-diabetic drugs, but it has no impact on the liver disease component of non-alcoholic fatty liver disease when used in diabetics. Vildagliptin has been reported to cause hepatotoxicity, so therefore it is not recommended for patients who have cirrhosis. However, there is data from pooled 38 studies, more than 7,000 subject years of exposure to vildagliptin versus other drugs. Both mild elevations of liver enzymes and marked elevation of liver enzymes with a rise in bilirubin was similar in the two groups, although still the recommendations are not to use vildagliptin. What about metformin? Another common problem is once these patients, a diabetic patient develops cirrhosis, do we continue metformin or stop it? So this was a trial in which 172 continued metformin, 78 stopped. Patients who continued metformin had a better median survival than those who stopped. This was best seen in patients who had child's A cirrhosis, but even in child B and C cirrhosis, although the effect was smaller. Another retrospective study, 191 diabetics, metformin users, non-users, 81% of these patients had underlying cirrhosis. Metformin users had a better transplant-free survival, the blue line, lower risk of liver decompensation and lower risk of development of liver cancer in the future. However, there is some tempering to this enthusiasm. This is data from a population-based study, Taiwan's National Health Insurance Database, compensated cirrhosis, decompensated cirrhosis with type 2 diabetes on metformin versus no metformin. Patients who were metformin users had a lower survival as compared to non-metformin users, but this difference was only significant in patients who were using higher doses of metformin. So metformin you can use in cirrhotics easily, but keep the dose low to less than 1000 milligram per day. Coming to SGLT2 inhibitors, we've already talked about this. What about the data? 57 patients with type 2 diabetes and NAFLD, dapagliflozin versus controls, randomized open label study. The liver stiffness value at 6 months after dapagliflozin use was significantly lower in the DAPA users as compared to controls. Again, a meta-analysis of 8 studies, 686 patients on use of SGLT2 inhibitors and its impact on liver fibrosis, and SGLT2 inhibitors were associated with favorable effect on liver fibrosis. Another useful mechanism is since they act by inhibiting sodium and glucose absorption, they may act similar to loop diuretics and therefore help in improving ascites. But is it true in clinical studies? This is a retrospective matched case control study, 423 SGLT2 inhibitors versus DPP-4 inhibitors. The control of ascites was numerically better in patients who were on SGLT2 inhibitors, but it was not significant. However, the survival was significantly better. So SGLT2 in clinical studies also showing better survival as compared to DPP-4 inhibitors among patients who have cirrhosis. Finally, alpha-glucosidase inhibitors, acarbose, voglibose, less than 1% are absorbed, can be used in CTP A, B and C, inhibits the intestinal alpha-glucosidase, reduces postprandial hyperglycemia. Another advantage in cirrhosis is reduces ammonia by inhibiting proteolytic bacteria. And this is a randomized controlled trial of 107 cirrhotic patients who had grade 1 to 2 encephalopathy and were given acarbose. And patients who were given acarbose by 8 weeks had a significant reduction in their ammonia levels, both in the initial trial and the crossover trial. And it led to reduced postprandial hyperglycemia, well tolerated with no episode of severe hypoglycemia. Again, data from Taiwanese National Health Insurance Database, alpha-glucosidase inhibitor users versus non-users. Those who were using alpha-glucosidase inhibitors, lower risk of decompensation and lower risk of dying. GLP-1 receptor antagonist, you've all heard all the data, so I'll not spend much time here because the previous speakers have already told you about the LEAN trial, the DLIFT trial, and this recent semaglutide trial, that it is effective in improving not only the biochemistry but also histological NASH However, there was no impact even in this study in terms of reduction in fibrosis, and also this particular study which was done in cirrhotics, there was no improvement in liver fibrosis, but it did have a beneficial impact on NASH. Before you finish, before you start, know your limits. This is especially for the beginners who want to start treating diabetics. Patients who come with HbA1c more than 10, may be better to refer them to a diabetologist. Those who have child C and are difficult to treat, again better to refer them to a diabetologist. All drugs are safe in CTP-A. Most drugs are unsafe in CTP-C except insulin. As I told you, alpha-glucosidase inhibitors and metformin can be easily used in CTP-B also. All other drugs you have to be cautious in their use. Finally, take-home messages. Gastroenterologists are encountering more and more patients who have type 2 diabetes, non-alcoholic fatty liver disease with or without cirrhosis. Managing diabetes in these patients is a bit of challenge. Most drugs are safe and effective in presence of cirrhosis. Almost all are safe in patients who have child's A cirrhosis. Avoid sulfonylureas if patient has CTP-B or beyond. Fear of lactic acidosis with metformin has been debunked even in patients who have cirrhosis. New OHAs like GLP-1 agonist, SGLT2 inhibitors, alpha-glucosidase inhibitors are effective and safe in patients with cirrhosis with added advantages. Beginners can start treating patients who have CTP-A and hemoglobin A1c less than 10 to begin with. You can start with metformin or a combination or an add-on with SGLT2 inhibitors, GLP-1 receptor agonist, AGIs or DPP-4 inhibitors, but be cautious among patients who have CTP-B cirrhosis. Among patients with CTP-C, insulin is a drug of choice. If you are having difficulty in controlling diabetes or it is brittle, please refer to a diabetologist. And like a good physician, remember to take care of these 5 Fs: fundus, filtration, foot, failure of the heart or congestive heart failure, and fibroscan. Thank you so much for a patient here.
Thank you very much, Dr. Madan, for such a wonderful talk. Because of paucity of time, this session is being closed, so there will not be any question answer. And thank you very much, Dr. Mishra, for this talk.
Thank you, respected speaker, moderators and chairpersons for conducting this session. So moving on to the next session, the topic of the next session is words of wisdom from our teachers. It will be an open house panel discussion on common GI problems. For this, I would like to invite on the stage our respected panelist members, Dr. Ramesh Roop Rai, Fortis Hospital, Jaipur, Dr. Subrat Ki Acharya, Fortis Escorts, New Delhi, Dr. Mohammad S. Khuru, SKIMS, Srinagar, Dr. V. Jayanti Ma'am, Clinicus Global Hospital, Chennai, Dr. C.C. Chauval, PCMS, Bhopal. And for moderator, I would like to invite Dr. Praveen Sharma on stage.
So good afternoon, everybody. I know we are slightly late for our lunch, but this would be an interesting session. It is not any session where we have a PowerPoint presentation. This session is specially designed just to ask queries. You know, we see normally day to day in our clinical practice and in our ward rounds, number of patients. There are certain queries which we normally have, and if we go by the books, we do not find a correct answers. So we go by our teachers, so whatever our teacher says, we follow those. So if this is open house discussion, we have our teachers over here. So anybody who has any questions which they find in their clinical rounds, or maybe they find there's some difficulty, they want to ask some queries, so all are free to ask any questions from our teachers.
Praveen, first thing I want to counter one of the statements, that you always follow the teachers. That's not true. Now you people are teaching us, right? You have become the teachers. So start with, you start the question.
So it is our privilege to be in front of you, because this is all because of you people that we are talking about all the things.
Yeah, yesterday's teachers are today's students, right?
So, during my rounds and during my other interaction with our colleagues, so I have collected few questions. If anybody has any question, they are free to ask. So the house is open if anyone wants to ask and some questions. If no, then I just formulate some questions and then ask our respective teachers. Maybe the first one is by Dr. C.C. Chauba sir. I think in our day-to-day clinical practice, often we receive calls that patient has come with a varicose bleed, and our resident asks what to do now. So they have started with vasoactive drugs, they stabilize the patient, and the next question, because in a private setting, if the patient is get admitted, there are always cost is an issue. So the question for you, sir, if the patient who has come with acute varicose bleed, and if somebody asks you which vasoactive drugs which you prefer and for how long, if you have achieved hemostasis after, if you have done an endoscopy, you have achieved hemostasis and patient is started on some vasoactive drugs. So the question asked by the maybe fellow, because the cost is a constraint, which vasoactive drugs would you use and for how long before discharging the patient?
See, primarily if you see, there are 3 vasoactive drugs which are primarily used for managing acute variceal bleeding with or without your endotherapies. You use either a somatostatin or octreotide, that is a vasopressin analog, and a vasopressin analog, that is terlipressin. You have a choice between these 3 things. We had 2 scenarios. One was prior to starting endoscopic variceal ligation, endoscopic injection sclerotherapy was used. Since the time these drugs were to be continued, it was mentioned that these drugs should be continued for at least 5 days. Now with the availability of endoscopic variceal ligation, where you have a very effective kind of a hemostasis which achieved, this duration is now being questioned. There are still Europeans like Robert T. J. Francis studies, if you see, they still continue to use it for 5 days, but there are others now who are saying that you can shorten this period to about 48 hours if you are satisfied and if you are 100% confident that you have done an effective endoscopic variceal ligation. So it could be anywhere between 48 hours to about 5 days. That is a recommendation that is mentioned over there.
What should be the take-home message? Suppose the patient of child A has come with variceal bleed, the patient of child C has come with a variceal bleed. Is there any difference in the duration of the...
Yes, because the chances of rebleed would be higher in patient with child C, because first 5 days you have a higher chances of bleed. So in that situation, of course, you can use it in more advanced patients, you can use it for about 5 days. But in other situations like child A patient who has come and you are confident of your variceal ligation, I would use it for about 2 days. Any of these for terlipressin, or usually I go for either somatostatin or octreotide, continues as a continuous IV infusion for this particular duration of time.
I think one more thing which can be done is that if it is HRS1, we might have to continue, because these are the common problems. If you have a bleed, you tend to have HRS1 also along with them. So we have to continue them for a longer period of time, maybe till the time they have normalization of their creatinine.
Yes.
In that situation, terlipressin, of course, I would prefer.
Well, clinically, if you are asking the question, the important variable for early failure to control bleed is important, because that increases the mortality. Early rebleed is again important, right? That because that increases further mortality, and of course rebleed beyond 1 week, according to the Bible. So it's very important to understand the major determinant of this early failure to control bleed and early rebleed or even late rebleed is not only amount of the child function, but also the degree of liver pressure, that is HBPG, right, which you may not measure immediately. Invariably, indirectly, if you see in such patients, you will find evidences of splenomegaly and amount of bleed, the massive bleed. If there is a severe bleed, in elderly patient with a hypotension indicating a large bleed, if his child say, then also you continue terlipressin for 5 days. There had been a study from PGI which is compared 1 day versus 5 days and has shown 1 day is enough. That is in a whole group. But if you do a subgroup analysis, it is probably wiser to continue in child C. While you are continuing in child C terlipressin, you have to also remember, and you just discussed about fatty liver disease, the cardiovascular morbidity mortality, the intestinal ischemia, and the induced diarrhea, change in gut microbiome, hyponatremia, because terlipressin is a vasopressin analog, which also work on V2 receptor in the basolateral tubule and prevent the antidiuresis effect, increased water absorption, and can cause hyponatremia. So all these things has to be kept in mind in a while you are treating patient with a terlipressin.
Okay, I think the take-home message is the patient is advanced liver disease, maybe child C, patient has hyponatremia, patient has AKI, or patient has a massive bleed in hypotension. I think we keep the patient for maybe 5 days and continue the vasoactive drugs for continuous of time. If the patient is child A, I think we can stop in between.
Always check for hyponatremia. That is probably not done because you concentrate on variceal bleed, endoscopic sclerotherapy, or a glue injection, continue terlipressin, right? And continue terlipressin is already child's B or child's is cirrhotic, his GFR is low, right? Water clearance is low. Hyponatremia can be fatal.
In pregnancy, I think SOMAT would be better.
Yes. Okay.
Can I add on to Dr. Praveen? Something I have to ask. Two things come into such a scenario of a GI bleed, which we normally have to address. One is, each of us clinicians, we normally go for an INR. So how much does the INR matter, sir? Number two, terlipressin has also got one side effect called mesenteric ischemia. So how do you address that, sir?
His question is, in a patient with advanced cirrhotic liver, INR may be prolonged. Now, do you think correcting INR will assist in controlling bleed or preventing rebleed? Is that your question?
True, sir. True, sir. Yeah.
I don't think INR has been correlated at all with variceal bleed. The single correlation is HBPG followed by child's functions, right? Where INR is included. So when INR you were included in CTP score, right, or in a MELD score, that is the total reflection of a liver function. And if your liver function is bad, rebleed chances are bad.
Definitely.
But terlipressin do not affect INR. It causes splanchnic vasoconstriction, reduction of blood flow, and reduction of portal pressure, while you are mechanically blocking the site of the bleed. So INR per se need not be corrected in such patients. And I told you, when you are giving terlipressin, hyponatremia is a problem. And over-infusion using fresh frozen plasma, which is the only way to correct it, vitamin K will not work, right? May increase hypervolemia. Be careful about it. It doesn't help much.
So FFP also, sir, actually doesn't play much of a role in correcting.
I don't think it helps much. I don't think any clinical trial evidence exists to that it helps much. It is empirically used by many people, but I don't think it helps. But that's my point.
Sir, in case of bleed, we should use packed cells or we should use whole blood in variceal bleed?
Sir, it is a restrictive blood transfusion. And it has been seen in variceal bleed, you need not increase the hemoglobin more than 8 grams, because there had been study, there was a 10-year-old study, but that holds true. High hemoglobin and high blood transfusion increase your portal pressure and increase the rebleed. It may be counterproductive. So your hemoglobin level should be between 7 to 8, and that balance has to be maintained. And packed cell is probably better, always better, because you are avoiding more volume.
So, So my question is on alcoholic hepatitis. Should we use steroids or not? And if we use steroids, how to exclude infection? Because at times it becomes very difficult to exclude. We need to exclude infections. So at times, if there is a simple scenario that there is a patient who's having 10 to 15 WBCs in urine routine microscopy, so shall these patients be given steroids, or we should treat first in this UTI? Because if the patient is not having any systemic effects of UTI, no fever, no rise in PLC.
That's a very old question, is being addressed repeatedly by various people.
Yes.
That
So
in
that will be a
alcoholic
definition of-
hepatitis, whether to use steroid and infection is a problem. You see, number one, there had been 46 trials of steroid in alcoholic hepatitis. And the latest and the best study that has been done, that is the STOPA trial, the famous STOPA trial. Antigen, right?
Sir.
In which, if you remember, overall, there are 4 groups, including the pentoxyphylline groups, right? There is no difference in outcome in using steroid in alcoholic hepatitis. And in that study, 19 to 20% develop sepsis who are using steroid. But when you did a subgroup analysis, where there is no infections, their kidneys are okay, right? There is significant improvement, right, in survival, hospital survival. And the meta-analysis favors steroid. Now, next question is, so obviously steroid is the only drug that is available for you in alcoholic hepatitis. There is no other drug. There is nothing. In fact, there is no drug for liver. You are treating all symptoms. There is no drugs for liver.
So we have few more questions.
But a question your answer, infection must be ruled out, and people are using now PCR for various bacterial, multiplex PCR, for various bacterial DNAs, and if they are negative, then you can use steroid. But multiplex PCR, I don't think any of us use anywhere in clinical practice. So you use clinical, the radiology, urine culture, blood culture, probably repeatedly before you start alcoholic hepatitis. Another rider is there. Once you stop alcohol, even the Liles model, which is used to guide your steroid therapy, that at 7 days, the Liles score less than 0.49 or 45 as associated with better survival than who have failed it. But remember, if we stop, the early change in bilirubin level, which people don't remember, which is the first publication of Mathurin who published this STOPA trial, is the most significant parameter to show the improvement. So wait for 7 days, see that they don't have infection, treat their fluid overload, treat their diabetic status, and at 7 days, if there is no infection, you can try steroids. That's a practical approach. But most center and big shot experts like Anil or Praveen will probably start on 3rd, 4th days of steroid after ruling out infections.
So
Am I right?
by your advice, I think do not jump for the steroids, wait for some period of time, optimize the patient, and the patient is still deteriorating after your optimization. I think by day 7, as Sardar said, we can think of starting steroids. The second question is for Ma'am Janti Ma'am. Ma'am, hyponatremia is a common problem. And normally when we see on day-to-day practice, patient has come with cirrhosis, they have ascites, and we just got a parameters, and patient has a hyponatremia with sodium of 128. So how do we manage this type of patient who have ascites and hyponatremia, and significant you need to put him on diuretics?
Yeah, so the basic hyponatremia could be either due to GI loss or due to excess of diuretics. So that should be taken care of. And the other group is when you have conditions between 128. So cutoff of 135 is now taken as hyponatremia. Less than 20, 120 is severe, and between 120 and 135 is mild to moderate.
Ma'am, if the patient is not symptomatic, suppose that
so
sodium
majority are
is 130,
asymptomatic.
patient has an ascites, you want to give diuretics, still we want to do some precautions should be taken, or we can start with diuretics?
So first would be to stop the diuretics, number one.
The patient is not on diuretics.
Yeah,
Patient has
and
come
then
with
if the
sodium of
patient is
130,
on
patient has
non-selective,
significant ascites, how do we manage such type of?
non-selective beta blockers also should be stopped because the MAP would be lowered. And then of course albumin is one thing that we can give to improve the mean arterial pressure. And less than 120, of course, we have the sodium chloride, hypertonic. So the value is between 128 and 135, you said.
His question is there is a hypervolemic hyponatremia, isn't it? Now, hyponatremia can be hypovolemic or
Hypervolemic. Hypervolemic is most common. 90% is mostly hypervolemic. And
the steps are, Madam has suggested, steps are clear. If he is on diuretics, stop diuretics.
And correct the hypokalemia.
The correction of hyponatremia with IV albumin therapy, he has ascites.
Correction of
right.
hypokalemia.
Albumin itself increases, right. People have used hypertonic saline, but I will caution you because you are treating ascites and you are using hypertonic saline to jack up the sodium. And best is you are trying to combine fluid mobilization with correction of sodium, right. So one of the very good method is ultrafiltration, right. Okay. You can use the CRRT machines, right.
No, sir. Patient is not admitted. Patient is on the OPD basis. Patient has hyponatremia, which is patient is not symptomatic. And you see the day-to-day in our practice, we find that sodium is 130, patient has an ascites, you want to continue with the diuretics.
One will need to restrict the fluid consumption to about 1 to 1.5, not exceeding, or check the insensible loss and the amount is passing, and then based on that triage the intake of salt restriction also would be there. But restriction of fluid would help in letting us know whether the person has got hyponatremic, hypervolemic.
But Praveen, that is the extended thing, restriction of fluid.
Okay.
But if
so I think we go by the restriction of fluid. Sir, is there any role of midodrine or any role of adding something else in this type of patients?
See, I am not here to promote the midodrine. See, this is regarding the management of hyponatremia. Dr. Acharya pointed out that terlipressin causes hyponatremia, especially when you are giving it for the GI bleed. But on the other hand, many patients with the HRS will have hyponatremia, but we treat with the terlipressin. There it doesn't cause. This is a controversial issue. 20% patients with the bleed, when they are given the terlipressin, they do develop hyponatremia. So we will have to be very careful. Then regarding the management of hyponatremia in a patient with the ascites, this is dilutional hyponatremia, and we will have to find out the cause why the hyponatremia has developed. See, many of these patients will be having underlying SBP. So do a diagnostic tap, and then if there is SBP, you treat that. The hyponatremia will improve. If they are receiving diuretics, first you have to stop it, and then you have to find out the cause. Many of these patients may be receiving beta blockers. So you will have to stop beta blockers because the MAP is low, and that is why it is causing the hyponatremia. And there is no point in restricting the fluids. See, the restriction of the fluids is indicated only when it is less than 125. So we don't restrict the fluid. Then in these patients, the hypertonic saline, it is dangerous. See, the ascites will worsen and the hyponatremia will further worsen unless you are pressed with a situation when you need to give the hypertonic saline for the correction of hyponatremia, especially when this patient is on the transplant list. So you are correcting the hyponatremia in a faster way. In that case, you can of course give the hypertonic saline. Otherwise, manage these patients, remove the cause, give albumin, and if required, in the end, I will not say that you give the tolvaptan. Tolvaptan is a very effective drug in these patients, but you will have to be very careful. If there is slight doubt of encephalopathy, don't give it, and if there is a low MAP, don't give it. So build up MAP, there you can take help of midodrine, but be selective in these patients.
So your message is well taken. I think we should evaluate the cause of hyponatremia. If patient is on diuretic, suppose, then you try to hold them, reduce the beta blockers, restrict the fluids if possible, and then you treat.
So in this case of
correction of hypokalemia.
Okay.
Dr. Praveen, ma'am, as the scenario was of the OPD basis, in this case can be used Vaptans as said by sir, for a small period of time, for a long period of time, and how much?
See, Veptans usually we use for a very short time, that too in a very small dose, usually not more than 15. If
15
the 30 is
milligrams
the
a day.
usual one, we use only 15
Yeah.
or even less.
And that
And
too
only
just
for a
one
very
time.
few days.
So you have to give it, you know, I mean, see, you consider, as madam said, 120 to be the cutoff, or you want to make it 135?
125 is the optimum.
125
we
is,
try to
usually.
maintain at 125.
Okay. So the next question is for Dr. Guru sir. So you have an extensive experience on hepatitis C. So if the patient has come to us with severe acute viral hepatitis and he is come out to be positive, his INR is deranged maybe 2, still she is conscious, and say bilirubin is 10, and on the next day you find that patient is now in the altered sensorium and going into the ALF, and patient has no transplant option. So how do you have some predictors, some management protocols that these are the patients who probably will improve or who probably will deteriorate over a period of time?
This is, we're talking of hepatitis E?
E positive.
Okay. Now, in this scenario, most of the times, I think Professor Acharya has a lot of experience. Hepatitis E with an impending liver failure or an acute liver failure, majority of them will be pregnant. That's the first important statement we have to make, that this group of people, majority of them would be pregnant and would have an acute liver failure. Now, for this patient with an high bilirubin, with an high INR or a rising INR, obviously probably a liver which may be getting shrunk, and with changes of consciousness, the patient is an acute liver failure and needs to have all the mechanism to manage acute liver failure as by protocol. That means management of hepatic encephalopathy, that's number one, and there are several scenarios for that. Cerebral edema, that is second thing which you've been, you have put a protocol. Then obviously the other thing would be other metabolic causes, coagulopathy and GI bleed, renal failure. These all we have to put protocols to manage them in the intensive care unit. That's number one, and I think they are documented. Now, important thing is that this patient normally should have gone for a transplant. Now, you don't have an option for a transplant. For hepatitis E, the mortality with acute liver failure is slightly less than if you have a non-E acute liver failure. The mortality is about 50%. If the patient is pregnant, one of the very important issue is whether we should or we should not deliver this patient. Now, if you see the patient early and you have a choice to do an delivery, and if you can do that within 2 days or 4 days, I think there will be a reversal of liver disease. Now, we have seen it many times. But if the patient has gone beyond few days, then the chances of the therapeutic delivery will not probably have any effect on the acute liver failure. Now, you have a scenario in this patient, so treat him as an acute liver failure. Obviously, you don't have a transplant setting, and manage all these things. Very important thing is if once in a situation of pregnancy, the neonates and the fetus get, there's a high chance of a vertical transmission, and if the neonate is born, majority of them will have a hepatitis C virus, liver disease, and a very severe encephalopathy and death, which presents as hypoglycemia, hypoxia. So the management is between a hepatologist, an OBG, and a neonatologist, and an intensive care setting to manage such a patient. Ideally, this patient should have had a transplant, but the question is that you don't have a transplant. I'm sure Dr. Acharya will probably expand on it. He has considerable experience, but that's what we do in our setting if we don't have a transplant.
I don't want to say anything after you have spoken, sir. We have learned from you.
Okay.
But the only thing I want to tell you that you can follow the course with Alfred score, which you described from the institute.
Okay. Then we agree, sir. Okay.
That's the,
So
that you know that we will improve,
Yeah.
we will know. Alfred score more than
So I
4.
think it's a, as Dr. Acharya study, we have all know, so we are not debating on that, we just continue with the another question. This is for
Dr. Praveen, 1 minute.
Yeah.
Kuru sir, one thing I want to clear out, nowadays we are getting the pathology reports where B and C are negative and we see that A and E are positive. Is it possible that we will have both the viruses? And what is the incidence if we get both?
Oh, you talk of a combined
A and E, sir.
Yeah. That's, I think there are situations where, because both of them are enterically transmitted, and I think there are several reports that you can have an A and E infection together, and even some of the epidemics have been also reported, and even sporadic disease that you can have a combined infection of A and E, and even an acute liver failure. I haven't seen so many of A and E together, but it is possible. So we should be aware of that. One of the very important things I wanted to mention for hepatitis E, particularly if you have a progressive liver disease, ribavirin is good. The only problem is that in the pregnancy it is contraindicated. But if you are seeing a third trimester pregnant woman, I've used ribavirin also in a rapidly progressive liver disease, and sometimes it does work. It brings down the HEV RNA viral load. So that was another thing. The drug therapy also should be kept an option in patients who have hepatitis E virus infection, progressive liver disease, and pregnancy.
Sir, okay. I have got 2 patients of hepatitis A positive, and they are having it for last 3 months. Very high bilirubin, 25, 28, 26, and ALTs are only in the range of 100, 120. But they are having severe pruritus, and they are admitted they could not sleep whole night. What to do with them?
The problem we are facing, I think I have similar experience now for hepatitis E, particularly when it comes in an, not in children, but in adolescents or in adults.
Adults, they are adults, they are eating all right.
You will have some group of patients of hepatitis A who will have a cholestatic liver disease.
Yes.
And the bilirubin is very high, the disease is quite prolonged,
yes,
and itching is a dominant factor.
What
now,
to do with
these, in these patients, usually their liver functions other than bilirubin and cholestatic is not bad. I sometimes give a therapy with steroids, and it does work in these patients.
That's what I want to ask, how much and how long?
I think it depends upon if you cannot control it with bile acids and some drugs to reduce the itching, and if you are forced and if it is prolonged, worthwhile to start with steroids. I usually start with 40 milligrams of prednisolone and continue till the itching settles, and then over a period of 3 to 4 weeks you will need steroids, you cut it down.
I too agree with Professor Kurusa. We reported in World Journal of Gastroenterology that prolonged hepatitis A course in which they have cholestatic hepatitis and the bilirubin is very high and the pruritus is the main thing. We gave it for 7 days, usually for 40 milligrams of steroids, and then depending on how much they have improved, we have tapered them in next 4 weeks. Usually they respond very well. So this was a series of about 24 patients which we reported.
My question is for Dr. Kuru sir. China has come up with the hepatitis E vaccine. So what is the status of hepatitis E vaccine in India? Because our socio-economic status has improved for A and E, because having hepatitis A or E later in the life, not in the childhood, has more risk of liver failure. So what is the status of hepatitis E vaccine in India?
So I think because of that is a bit difficult, but if you're talking of HEV vaccine, that's the Chinese vaccine available now in the market in China and in several countries around us have, like Bangladesh has it, Pakistan has it. We will probably have it very soon, I'm sure, in a short time, HEV vaccine. It is utility. There are several scenarios you can use it. The problem is you need to use 3 doses. So you will have to use it, set up your setting, when can you use hepatitis C vaccine. In a high-risk group, you can't use it during epidemics, you can't use it during acute infections because you need 3 doses. But there are several scenarios where hepatitis C vaccine can be used. Particularly young ladies, you can use it, immunize them. You can use it for people who already have chronic liver disease to prevent hepatitis E superinfection like chronic hepatitis B or chronic hepatitis C patients, and also in other high-risk groups where hepatitis E would be commoner. I think the final word on when to use hepatitis C vaccine has not yet been sorted out, but these are the scenarios where you can use it. And the problem is you can't use it during epidemics because it takes a long time to control, to immunize the population. So that is but once it is available, probably we'll have more data available on it.
Thank you.
So a short question to Dr. Ramesh Rupai, sir. Since morning we are hearing a lot about nutrition, sarcopenia. A practical tips to all of us who are sitting here, how do you screen in your own practice sarcopenia, nutrition, and any practical tips to all of us, how we should monitor and treat these type of patients?
It's as we have been hearing, it's a tough thing to do this practice every day because we do not have time to do it. But I would urge everybody that everybody should give at least 10 to 15 minutes to such a person once in one sitting, so that you can give nutritional, because they have many problems as to how much thing they should eat. Usually what I do is that I give them good calorie diet and gradually build up their diet. They have distaste for food. So we try to give what they want to eat, what type of food they want to eat. So usually I give about, if they are non-diabetic, I give about 100 grams of shahad or honey, which is very palatable to them. Add something to that, that gives about 400 calories to them. Then again, I give sprouts. I make them to make the sprouts and grind them, make जैसे आलू की टिकिया बनती है, I usually give them this type of food, and then I give him almost about 100 grams of proteins in this form. That means sprouts and the roasted one. Then I give almost about rasgulla is usually this diet which I give them, because it's most palatable to them. If they are diabetics, I ask them to squeeze, put them in water and then give it. Then protein diet is the most important, and we have to make it palatable. The grams which we use is often the chila, which I then tell them to use. And then in last 2 occasions in which we have done about the branch chain amino acids, and we have used them, that if they are given these type of proteins and along with the branch chain amino acids, what we procured is from Delhi. There is a agent which gives us in kilograms the branch chain amino acids, and we make them packets, and then in 2 of our studies we have done it, that we have given them branch chain amino acids along with the proteins, and we have shown in randomized control trials that their the mass increases, their validity increases, their quality of life also improves, and this study has been conducted for 1 year that we have given. And then, as yesterday we heard that butter is a very important thing for diet, so I advise them to use deshi ghee, or what we call as butter, white butter, and I give them almost about 50 to 75 grams, gradually increasing their diet. And I feel it's a very practical thing to give them diets which are palatable to them, they are using it every day, and fish is another thing which I often advocate them, all those who are using it in this practice.
So I think fish, honey, desi ghee and sprouts, I think this should be given to every cirrhotic patient. So if the patient is child C, there is any need to screen for sarcopenia, because we know if he is coming to our OPD, he is not able to walk properly. Is there any need of screening these patients for any sarcopenia and nutrition, because they are already malnourished? We know that.
No, it's all right. Sarcopenia has become a now hot topic, the buzzword now in cirrhosis. Sarcopenia. But you see, when a cirrhotic with child's B and C comes to you, you see sarcopenia. You did not do a CT scan at L4, L, L5 to measure the quantity of psoas. Second thing, General Anand always teaches me when we see patients, he says, don't look at them, see their functions. Do a hand grip test and see whether they function. See a chair standing test. Take a 6-minute walk test. Those are probably important because you have some objective parameters to assess in future what Professor Ramesh Rupra say. Give honey, give butter, give sprout, give cheese, give fish, and probably you can assess that. That may be a more important for child's B or cirrhosis rather than doing a CT scan or doing a...
So we totally agree with you, sir, because if you see the patient is not able to walk properly, patient is coming and 2 caregivers are just holding him, there is no need to screen for all these sarcopenic measures in your clinical practice. Just advise a good diet, desi ghee, fish, honey, sprouts, which Dr. Ramesh Rupra advised. I think we continue to give that. Now, because this is our lunch time, so I think we hold on then and we finish this thing. Thank you, sir. Thank you.
I must thank the organizers to have given this opportunity to listen to all these stalwarts whom we have heard. We are grateful to Professor Anil Arora and Praveen and other people. Thank you.
So we have our lunch for 30 minutes and then we can come back.
Hello, sir.
Hello. The lunch is for 30 minutes. We expect all of you to assemble by 3 p.m. Yeah. Thank you.
हनी सबको अच्छा भी लगता है सर, खुश भी हो जाते हैं सर।
जागते हैं, मतलब मैंने तो ये देखा है सब उसका जागते इतना खराब होता है
Welcome back everyone. Hope you got refreshed for yet a lot of intelligence coming up next. So continuing with the momentum of the session. So moving on, the topic of our next session is Cirrhosis Unveiled, Understanding the Silent Battle. For this, in the seat of chairpersons, I would like to invite Dr. Shailendra Kishore, IIT Kanpur, Health Center Kanpur, Dr. Amitava Goswami, Medicity Guwahati, Dr. G.K. Pathak, Sukh Sagar Medical College and Hospital Jabalpur, Dr. B.R. Medhi, BM Healthcare Shillong, and Dr. Sharad Malhotra, Akash Healthcare Hospital New Delhi. And for moderators, I would request to come up on the stage Dr. Kalidas Biswas, Lifeline Medical Center Kolkata, Dr. Hemant Patel, Lion Tarachand Bapa Hospital Sion, Dr. Amitman Joshi, BND Hospital Kathmandu, Nepal, Dr. Manish Kak, Manipal Hospital Ghaziabad, and Dr. Amol Patil, Shivaya Advanced Gastro and Liver Center Indore. We have a slight change in the schedule. So first we will be having this talk of Dr. B.D. Goswami, Indications and Safety of Long-Term PPI in Cirrhosis, and after that we will continue with the debate. I'll request now the chairpersons to kindly call on the respective speakers. Thank you.
Respected chairpersons, moderators, and my friends, I'm sorry I have to leave, that's why I brief on the topic. So these are indications and safety for long-term PPI use in cirrhosis. That is the topic we should discuss now. Since the introduction of the omeprazole in 1989, the PPIs have revolutionized the whole treatment scenario of upper GI disorders in human being. PPI is indicated all these conditions, all of us we know about it: peptic ulcer, GERD, non-variceal GI bleed, prophylaxis for NSA users, Barrett's esophagus, GERD, prevention of GI bleeding, all these are known to us. But the point is, initial safety profile was very nice, so that's why it ultimately broadened the use of the PPI, and that's why ultimately there is also the inappropriate use of the PPI is going on. Now coming to the cirrhosis of the liver, it is GERD, peptic ulcer, GI bleed, prophylaxis of NSAID use. So we have to use the PPI, there is no doubt about it, but there are reports coming up today that there is a lot of issues along with the use of the PPI, like the diversity of the gut microbiome. There is SIBO, there is bone fracture, CDI infection, then encephalopathy, SBP. So all lot of things are coming up along with this PPI use in cirrhosis. Coming to the use of PPI in cirrhosis, the fact what we have got, almost 37 to 86% of the patients with cirrhosis, they used to have the PPI, and as much as almost 34 to 70% of them, it is of unclear use or indications. That is the fact. The use of proton pump inhibitors, even the reports coming from all over the world that there is unintentional, even undesired indications going on. For example, from Praveen Sharma and his group from Delhi, again almost 67% cases they have got the use of the PPI in cirrhosis, and 1/3 of them without any indications. In PPI use, the risk of severe infection in cirrhosis after PPI exposure, and there is also 64% increase in the hepatic decompensation. This is one study, systematic review and meta-analysis. They took up almost 47 up-to-date studies all over the world, high number of participants, and ultimately they looked into these points: SBP, hepatic encephalopathy, infection, mortality, even hepatocellular carcinoma. The strength of the association of the PPI is very weak. That's what the conclusion they got. And maybe it has got some role in association only, not the cause of these conditions. Coming to some particular points, for example, the osteoporosis and the bone fracture. What the studies they are showing that bone fracture is observed in a dose and the duration response effect of the PPI in cirrhotic patients. Maybe the PPI have some role in the bone metabolism. But by contrast again, the reduced relationship of the PPI and the bone fracture after adjusting the confounding factors, this is already a fact to look into. Then we have got 3 meta-analyses showing the use of PPI as a risk factor of the bone fracture, but the occurrence of the bone fracture might not be related to the dose and the duration of the PPI. Coming to CD infections, the retrospective study of 162 patients admitted to a tertiary care hospital, there is the significant higher number of the patients with CDI used to have the PPI. There may be association. Besides a multivariable analysis demonstrated the PPI also may be a promotional effect on the CDI infection in the cirrhotic patients. Coming to important point about the SBP, whether it has got some relation or not. PPI can promote SIBO, already it is a known fact. Also it has got the effect on the alteration of the GI motility. And that's why there are some studies they are showing that treatment as a predisposing factor for the development of SBP. The studies I have mentioned here. There are 2 case control studies again showing the association of the PPI use and the SBP. 3 meta-analyses again supporting the same issue. In contrast, from Argentina, one study was published recently and they showed that there is no relationship of PPI use and the SBP. A larger meta-analysis of 8,145 patients, they have got the association of the PPI use and the high risk of the SBP, but it is in case control study only, not in the cohort study. Hepatic encephalopathy, this may be possible because of the GI motility alterations. Barrier of the mucosa, again it is affected by PPI. There is increased absorption of the nitrogenous products, substances, bacterial overgrowth, and also bacterial translocation. Along with there is decreased absorption of the B12 as well as the magnesium, and also it impairs the cognitive ability. That's why it can predispose to a hepatic encephalopathy. This may be the proposed possible relationship of the PPI use and the encephalopathy. This is another study showing clearly with the stratified PPI, different PPIs, it hepatic encephalopathy, showing the pantoprazole, lansoprazole, omeprazole, esomeprazole or rabeprazole, and the OR value with pantoprazole is the highest one, definitely a significant one. Maybe there is possibility. This is study, a population-based study from Taiwan, showing again the increased risk of hepatic encephalopathy after PPI use. This is United European Gastroenterologic Journal in 2018 showing the same way the increased risk of hepatic encephalopathy in post-tips. Then again, they showed the initiation of the PPI as an independent risk factor for hospital readmissions. And 30-day readmission, those patients who are discharged with the PPI use, 50% comparing 32% those who are not on PPI. What about the HCC? Different studies showing again there is a risk of high risk of HCC in cirrhosis patients who are on PPI. But this is another study showing from Taiwan, again in Hep C or Hep B related cirrhosis on PPI, there is no relationship between each use or it is used or not. Increased mortality with PPI use, again showing similar data, I am not going in details about it. Yes, there is a chance, definitely increased mortality is high with PPI users, almost twice as the non-users. 61% more likely to have the hospitalization for hepatic decompensation after PPI use. Then longer duration of the PPI use can lead to increased mortality and also increased occurrence of the hepatic and decompensation. And first patient in is 2021. It will end up in March 2024. And after this particular study, probably we'll get the exact answer, because those people who are having cirrhosis, they are already on PPI.
The chairperson, that means in the early stage of the cirrhosis. Now, the one morbid symptom they often complain is the fullness, starting in the morning, and that remains till throughout their work time, that is morning to evening. Now, they are already on PPIs, and you had very clearly shown the intestinal motility effect. Now, what we should do again? What extra we should add? They have gone through the dietary changes, all those advices, that doesn't work. Even laxatives also doesn't work much comfortably. So what extra you advise that we should add to control their motility, intestinal motility pattern?
No, the point is, first of all, we should ask whether there is clear indication of using the PPI is right or not. If it is not any clear-cut indication, then I think we should stop it. If suppose the patient has got this complication, SBP or encephalopathy or so many things what I have mentioned here, if it is coming up in these patients, we should ask the question, justification of the use of the PPI. That's the most important point. And otherwise you have to go for the treatment part of it. Encephalopathy, suppose the patient has got the encephalopathy, you have to treat as it is required. But use of the PPI should be judged whether indication needs it or it is not.
Agreed. Then what we should do extra for their fullness part, the abdominal fullness which they experience?
I don't think so anything we can extra do.
Okay.
Because at this particular point, whether PPI is the culprit or not, we are not sure about it. We do not have any guideline till today about its use, or we should stop it even. But whatever the message from the data what we have got, if it is indication justified or not, that is more important one. Always you should try to use it whenever there is any clear-cut message or justification. Then also only we should use it.
Thank you.
Dr. Goswami, excellent talk. As you have recently reviewed the literature, so my question is there any specific situation like recurrent HE, recurrent SBP, or a combination where one should avoid PPI? Or one should say no to PPI?
I could not got it.
Cirrhotic with recurrent SBP or recurrent HE or other complications, where you should be using PPI judiciously. But is there any situation when you should say no to PPI with decompensated cirrhotic?
Patient is not taking the PPI.
No, no. Where you should say no to PPI. No, stop PPI. With decompensated
PPI
cirrhosis.
No, no. The point is where you should use the PPI in a cirrhotic patient. That is the first thing I have shown in the
You have shown
slide.
everything, yes.
If there is concrete evidence that patient has got a GERD, patient has got the peptic ulcer, patient has got the GI bleeding, we should use it.
Yes.
We should liberally use it, there is no question about it. The next point is a for finite period of time, not for a long period, finite period. Because of the long time, that is the question, that is the problem of the SBP or the complications are coming up whenever there is the long time PPI use is going on. So we should see these particular points. That will be helpful one.
Thank you.
Another small but incriminating factor could be PPI-induced interstitial nephritis. That may increase the side effects of PPI, prolonged PPI especially. We should remember that PPI may induce interstitial nephritis in some cases. That may be an incriminating factor for added side effects for prolonged use of PPI.
Yeah.
Dr. Saab, if you are forced to use PPI, which PPI you would prefer in cirrhosis? Any particular preference?
Yeah, esomeprazole is a better option because the slide I have shown there, in the stratified PPI use in these complications what is showing, the worst was is the pantoprazole, but esomeprazole is a better option.
Thank you, sir. Thank you so much for your kind deliverance. We move on to the next topic, which is a very specific debate. The topic for the debate is, do all patients of cirrhosis need endoscopy in the era of non-invasive assessment of CSPH? And speaking for the debate would be Rakhi Maiwali, and against would be Dr. Madhumita Prem Kumar. So we expect a lot of fireworks here. Dr. Rakhi?
Thank you, respected chairperson, and thank you, Dr. Anil Arora sir, Dr. Ashish and Dr. Praveen for inviting me. So what I'll be doing in the next 10 minutes is to debate on whether all patients of cirrhosis need endoscopy in the current era of non-invasive assessment of clinically significant portal hypertension. So there is no doubt in decompensated cirrhosis we need endoscopy and we are all doing it. But the question comes in compensated cirrhosis because here the clinical prevalence of clinically significant portal hypertension is seen in 60%, varices are seen in 30 to 40%, and prevalence of varices needing treatment, that is the high risk varices, is seen in just 10 to 20%. So why do we need a screening endoscopy? Obviously we are trying to pick up clinically significant portal hypertension and the high risk varices which need treatment. We also need to identify gastric varices, and that can only be determined because there are lack of studies looking at the non-invasive test, and they cannot tell us about the gastric varices because we know how they are, how they develop is different in these patients. So the presence, location, type, and additional information which is really not picked up with anything else is you can pick up GAVE, you can pick up portal hypertensive gastropathy, ulcers and other concomitant lesions which are additionally picked up when you do endoscopy in such patients. So when we are specifically talking about clinically significant portal hypertension, we have all these tools with us which can tell us about the presence or absence of this syndrome in the context of compensated cirrhosis, and there is nowhere that the endoscopy is put up over here. So we know that endoscopy is an add-on factor, it is not a tool to identify. So you have the invasive tests like biopsy, and people are now gone up to HVPG. So people are doing portal pressure assessment because that is the gold standard to pick up a clinically significant portal hypertension. But here we are talking about the non-invasive tests. So let's look at what the guidelines tell us. The guidelines tell us that if you have a compensated patient with cirrhosis and you're trying to pick up clinically significant portal hypertension, that is the compensated advanced chronic liver disease, you do a liver stiffness assessment, and if you have a liver stiffness assessment of less than 20 or a platelet count above 1.5 lakh, this patient has a very low risk of having varices requiring treatment, and you can avoid an endoscopy. So it is not about when to do, it is about when we can not, when we can avoid an endoscopy. That is where they tell us, because previously we were all doing endoscopies for all such patients. And yearly they say that because these parameters may change and they may vary from lab to lab variations, there can be so many things that may influence. They always say that you do that at 2 repeated measures and also follow them up annually so that you identify patients who you need an endoscopy there. And again, TE also has false positive results, and that is what I'll be showing here, that how these parameters will not tell us anything about what the useful information we'll get from an endoscopy. The same group of experts sat again and they revised the same criteria, because when they had laid down these criteria, they found that it was just 20 to 30% of the patients where we were not doing endoscopy. So they revised it, and this is the expanding consensus where they expanded these criteria, and they were very specifically saying that in virus related, so the etiology specific criteria for compensated advanced chronic liver disease, you can take a cutoff of 20 to 25 for LSM, and if your platelets is less than 1.1 lakh, this is where you can avoid doing an endoscopy. So let's look at the performance, and this is a systematic review and meta-analysis which looked at the performance of both these criteria. And they looked at 30 studies enrolling large number of patients, 8,000. And so when they looked at the initial Baveno 6 criteria, they found a sensitivity of 97%. So this is not 100%, just to let you know. And the specificity was very poor, just 32%. And when you look at the expanded criteria over here, again the sensitivity falls down to 90%, the specificity is better, but again it is not 100%. And when you look at the high-risk varices, 20% of these patients who had compensated advanced chronic liver disease, you were still missing with these criteria, 0.6% with the initial criteria, and 2% of patients who were having high-risk esophageal varices, and this is where you can actually prevent a bleeding event in these patients. So this is we can see here, only 50% of these studies had a sensitivity of 100% and very poor specificity. So obviously you need endoscopy in these patients to identify, not only just to identify, but also to stage the severity and varices needing treatment. Again, this is another very important paper which looked at 1,000 patients. Compensated advanced chronic liver disease were 282, high-risk varices were seen in almost 20%, and they showed that the miss rate was as high as 6.8%. So you were able to avoid more endoscopies. Almost 40 to 50% of the patients did not get an endoscopy, but you were also missing high-risk esophageal varices. And again, it was varying. The performance of all these tests was varying based on the etiology. It was best for the hepatitis C and was not performing so well for other etiologies like hepatitis B, the non-alcoholic fatty liver disease, and alcohol-related liver disease. Now let's look at why these biomarkers. They are very useful because they are easily acceptable, very cost effective, can be easily measured. All the patients have no problem, and this is a routine. We are routinely doing all these tests in a clinical practice. But the disadvantages. So when we look at the platelet count, it is just not a marker of portal hypertension. The platelet may be low because of so many reasons. The platelet on the same time may not drop down in a patient who may have clinically significant portal hypertension. So these markers, they are very good, but they lack sensitivity and specificity. And this is what has been shown for the APRI index, which is a marker of fibrosis. It tells you in this meta-analysis that if you look at this, to say advanced fibrosis or F4 fibrosis, the sensitivity and the area under the ROC was just 83%. And similarly, using expensive panels like ELF and others, you are not able to pick up, and you're not 100% sensitive that you're looking at. So if you see a varix on the endoscopy, you're almost there that this patient has clinically relevant portal hypertension. The other problem is when you look at the etiologies also for which it has been said that you should be using these tests. This is a paper for hepatitis B, and we see that very often these patients have necroinflammatory activity, and they can have a falsely elevated fibroscan. So a fibroscan value above 15 may not tell you about portal hypertension. It may mean so many things in a different clinical context. Similarly, in patients with non-alcoholic fatty liver disease that we see very often in our clinics, the severity of steatosis may influence the LSM values, and it may not be reliable to say that this patient is having a clinically significant portal hypertension. Similarly, when you look at autoimmune hepatitis, it is not reliable, and the data suggests that you should not be relying on the LSM values to identify clinically significant portal hypertension. Now, when you look at this paper, this is letter to editor, and this is just a small letter, but a small center with not so much of expertise from larger groups of expert centers and tertiary care hospitals. Here, if you see, based on their units data, 29% of the patients were missing, were having a miss rate of identification of esophageal varices using the Bevino criteria. This is the data from Asian cohort, very recent publication by Dr. Shalimar and his group, where clearly it has been shown that in the Asian cohort, the NIT based, the cutoffs are not reliable in the Asian population, and therefore we cannot go by the same cutoffs in our set of patients. And the limitations of FibroScan, as I already alluded to, you cannot use it in obese patients. The other comorbid diseases, which you cannot say that the patient will only come with cirrhosis. He may have a concomitant cardiac disease, chronic kidney disease, and all these things will influence your stiffness values. The flares of necroinflammation, cholestasis, the presence of SOLs in the liver, high iron content, and many a times people are not checking when the operator has not been trained to take that relevant history of 2 hours of fasting. So you get falsely elevated values with FibroScan. So if you're going with that, most of the times you may unnecessarily also do endoscopies. So you cannot go, the crux is that we cannot go by these tests, and we have to look at several other factors when we are treating these patients and deciding the need of endoscopy. What about patients who are on treatment patients, and this is important study, a multicentric prospective study from 6 liver units in Spain. And if you see here, all these patients had hepatitis C, they were treated, they achieved SVR, their portal pressures were measured before and after treatment, and the important message here was they showed that despite treatment and despite achieving SVR, 78% of these patients were still having clinically significant portal hypertension. But when you look at their FibroScan values, they were below 13.6. And 42% of these compensated patients who had FibroScan values below 13.6 had clinically significant portal hypertension. So this again signifies that these tests have not been validated when the patients have been on treatment, even in the context of viral related etiologies. Now we are living in an era of precision medicine, and we are doing personalized therapies. So we cannot put an umbrella cutoffs to all our patients and put them to say that this patient needs endoscopy based on this cutoff and this patient does not. So this is where you have to see where your patient needs a clinical, more detailed invasive test like a liver biopsy or liver pressure assessment, and this important decisions have to be individualized, and endoscopy is a very simple test which gives us a lot of useful information. And with the help of this, even in a stage of compensated cirrhosis, this is how you should be risk stratifying your patient further. The patient may have clinically significant portal hypertension. The patient with clinically significant portal hypertension may have just low-risk esophageal varices, they may have high-risk esophageal varices, they may have stigmata of bleeding which requires endotherapy, and the patient may have to be risk stratified for repeated risk of bleeding. Now this is an important trial, the Predesky trial, and we know that in this trial it was clearly shown that patients who were put on beta blockers and had an initial response to beta blockers, they had a reduced events of decompensating events. When they did a subgroup analysis, they found that the patients amongst all who had clinically significant portal hypertension, if you had small varices, this was the group actually which was doing very well with beta blockers, and the incidence of the development of liver-related events was much lower. And the pictures tell us all. So if you know that both beta blockers and banding could be done, we know that we are dealing with a high-risk esophageal varix, but which one would you like to band and give an immediate treatment? For a fundal varix itself, now people are going to endoscopic ultrasonography and not letting the patients bleed. So you're preventing complications. So I would say that in the end, endoscopy is better. It is almost always accurate because it is not done by any operators. It is done by experienced gastroenterologists and hepatologists. Only issue is where you may not require. That is a small set of patients where we can clearly say that these patients do not require. For rest of the patients, it gives us a lot of information. We have to be very carefully analyzing these non-invasive tests and just not going by absolute numbers. And we should be looking in the clinical context and do a repeated assessment for these patients to decide an absolute need of these tests. Thank you.
Against the debate, Dr. Madhumita.
Thank you, Dr. Arora, Dr. Ashish sir, and Dr. Praveen Sharma for inviting me. So it's great to be speaking next after one's teacher, in fact. So she's already covered most of the issues. So the question, which is the motion for the debate, is: do all patients of cirrhosis need endoscopy in the era of non-invasive assessment of CSPH? The answer is no. I already win. All patients don't need it. Madam's first slides clearly said that you don't need it in all patients, and Bavino has given us which patients in which it is essential to do it. So she's already covered what is essential when we are talking about portal hypertension. Please remember, portal hypertension, the gold standard is HVPG. It is not endoscopy, because you can have clinically significant portal hypertension and have no varices at all. So the whole idea of altering the clinical course is to prevent portal hypertension from turning into varices which need treatment. Also, you have liver biopsy, which is invasive, and obviously we're not going to recommend it in all. Endoscopy. And the reason I'm showing this particular picture is, what do you do about these 4 kinds of PSG? There are no varices, there's just PSG. How do you distinguish or, course correct for this? And then, of course, we have imaging, which is, she picked up the right point, gastric varices, which is not really well seen on transient elastography. So yeah, we are going to be doing an HCC assessment in these patients anyway, so it's easy enough to pick up a gastric varix there. So the drawbacks of an endoscopy is, and I think COVID-19 really taught us, that if we centralize our assessment, it's going to be really difficult to pick up clinically significant portal hypertension, and it's really going to be difficult to give that wonder drug, beta blockers, which can actually prevent mortality and actually prevent progression or new decompensations occurring in these patients. So it's invasive, it is expensive. Please remember, these tests, which are non-invasive and rule out the requirement of an endoscopy, don't preempt you or prevent you from doing one. They're just saying that these are patients who are unlikely to have varices needing to treat, and you can wait for an endoscopy. It's expensive, because once these patients are put on surveillance endoscopy, they keep having it again and again. And of course, there's a lot of inter-observer variability. Not everyone is going to have beautiful varices. They'll have various grades of mosaic appearance of mucosa. So the Bavino actually gave us the answer to this. So where should we do an endoscopy and where should we not? So coming to the newer assessment that is available for clinically significant portal hypertension, we know we need to predict variceal bleeding, and we know that we need to be giving beta blockers. So in whom? So there are a whole lot of new things beyond elastography that have come up in the past 2 years following the Bavino consensus. So HVPG is the gold standard, and our idea is that we prevent patients going from this 5 to 10 stage to the esophageal varices stage. So this is where endoscopy becomes relevant, but this is where 40 to 50% of our patient population lies. We have been talking all day about NAFLD, about alcohol or chronic Hep B or Hep C, and most of our patients lie here. How is endoscopy going to help us predict the progression or the regression or recompensation, as it may be? It's useful where there are varices needed to treat, but we need to define the subgroup where beta blockers need to be given. So that's where the concept of CSPH came up, and this is data which shows that as it progresses over the spectrum, we have worsening of outcomes of various kinds. So the concept of CSPH and compensate and advanced chronic liver disease is new. So the problem comes out here where more of our patients lie, and between 15 to 20 is where we have a gray area where there could be uncertainty, and where I defer to ma'am and say yes, maybe an endoscopy might be done once. But we need to know that in patients who are having a KPA which is really low and a platelet count which is high, then that's great. We just avoid an endoscopy and wait for annual surveillance. Now the question that Madam raised about platelet count maybe falls low because of clumping or giant platelets, and transient elastography might overestimate But that's fine. If we have a lower platelet count, they would go for an endoscopy anyway. If we have a false high or a change in the elastography, they would go for an endoscopy. So the idea is who should not undergo an endoscopy, and the CSCLD concept covers this quite nicely. We need to know this concept of the clockwork. So between 5 to 10, you can largely exclude CSCLD. And if it is more than 15, we assume, and definitely about 20 and less than 1.5 lakh platelet, we go ahead with an endoscopy. And of course, this is where we would also institute beta blockers even before the appearance of varices. So it's great for looking at progression or regression. Endoscopy annually is not going to give us much change. But here, if an LSM is done, it gives us a quantifiable change in the degree of portal hypertension in these patients. And we also know now about the concept of recompensation, where we have a reduction in LSM after treatment with DAAs or Hep B therapy, weight reduction, or any of the other protocols that we use for alcoholic liver disease. So we now know that this can also give us an idea about who's getting better. CSPH is HVBG driven, which is a centralized tertiary care philosophy, whereas what we are trying to talk about is at a population level. So patients, obviously I agree with Dr. Rakhi that NAFLD and autoimmune liver diseases such as primary biliary cholangitis, due to the inherent nature of the nature of inflammation and fibrosis, yes, NITs may not be reliable, but those are the patients where I would scope them. I wouldn't be so insistent or reliant on NITs in such individuals. And of course, in autoimmune liver diseases, we would have a biopsy. We would just not be looking at non-invasive tests. And in NAFLD, now we have additional parameters, which I'll come to. So in NAFLD, there is an idea of the anticipate NAFLD model, where other than the LSM, platelet count, and BMI, that can also give us a risk of CSPH, but this needs to be looked at in future data, especially after treatment is given. Patients who avoid an initial screening endoscopy can just be followed up annually, and then they will end up with the surveillance endoscopy as soon as they progress to that state. So ma'am covered the Prodisky model, and that is the whole idea. If you have CSPH, they may or may not have varices, they may or may not have varices which need treatment, but they are eligible for beta blockers, and the CSPH model gives us an idea. If we start beta blockers early, even before the appearance of varices, we can prevent further decompensation or new decompensations. So avoiding endoscopy in diseases like Hep C and the Punjab program, where we were giving large-scale DAs, we relied entirely on non-invasive tests. Only in patients with decompensation did we call them to PGI for management. Otherwise, we were happy to use non-invasive tests, and it really reduced patient times and enabled physicians in the periphery to also treat. And we have an excellent treatment outcome. We have a large data set of recompensated individuals, which we'll be presenting at ASLD this year. So HCC surveillance would continue in these patients, but NITs actually help you to decide who are the patients who are going to get recompensated later. Even in Hep B, most of the treatment algorithms also incorporate NITs, and we are not really looking to biopsy all these individuals. And of course, here an endoscopy would be done at the appropriate stage, because these patients are anyway on follow-up for HCC. Survival in these patients, so this data from a large multi-center cohort, 248 and 2,000 individuals, used a combination of two things. So the MEL score, which looks at the synthetic functions and the overall disease severity, and they combined it with shear wave elastography. So they could identify the individuals who are having high MELD, high transient elastography, and they followed them up over many years, and they found they could actually classify using an NIT on large-scale population-based models to figure out who would be the people with worse prognosis. So CSPH survival can be determined on population databases, not just on endoscopy. Coming to NAFLD, again there is data. If you stratify as per the NIT, they work perfectly well, similar to those which are based on scores, which were spoken about. There's one more new technology that has come here, and that is splenic stiffness. So splenic stiffness more than 50 kilopascal, and of course here the probe is slightly different. This is 100 hertz, whereas the normal VCT is done with 50 hertz. So CSPH, if there's an LSM of 50 kilopascal, this will also cover another cohort which was not spoken about, which is portosinusoidal vascular disease. So even patients who have INCPH or EHPVO, who will not always be picked up on transient elastography, can be picked up on splenic stiffness. So there's another parameter that can be looked at. Again, splenic stiffness can actually help us classify where the patient should undergo an endoscopy. So if the LSM is low and the splenic stiffness is also low, you can actually determine which patient does not need an endoscopy. So there you go. We do not require an endoscopy in all individuals. Coming to what is new in the last few years, yes, the biomarkers at a very early stage, but in NAFLD they have been looked at liver-related outcomes, and we are very comfortable now with MR elastography, not just transient elastography. Let's take it one step further and combine it with fibrosis scores or biomarkers, and then one step further. So we now look at MR elastography and radiomics to look at response to beta blockers. So all this can be combined into one HCC surveillance MR with an abbreviated MRI protocol. Look at the elastography, look at the sol, and then also look for stiffness. Radiomics are going to come in a big scale using artificial intelligence. So we have a deep learning network where we have an artificial intelligence HVPG. And so even in a patient sitting in the periphery, a central database supercomputer can actually give us an answer as to who is going to have higher portal pressure. So this is all to do with machine learning, and believe me, this will be here in the next couple of years. So to quantify people as per HVPG, they found that the artificial intelligence HVPG had excellent positive predictive and negative predictive values. Von Willebrand factor has also been used in its infancy, but this will also come up. So in 2023, CSPH and CACLD are not really synonymous, and we do want to avoid endoscopy. If we can avoid 30% of endoscopy in individuals and give beta blockers in time, that's a win-win situation. Imagine the amount of costs that will be saved and patient contact time that will be saved. I agree with my colleague, or my teacher really, that there are issues of looking at gastric varices, there are issues of PSVD, and of course autoimmune liver diseases, and we are not really sure what to do with NAFLD. But if we can exclude patients from undergoing an unnecessary invasive test and enable peripheral physicians, we can actually revolutionize liver disease care in this country. Thank you.
I think there should be a rebuttal from Dr. Aki.
So I would agree that it's a very small set, which is, we know that this patient does not need endoscopy, but most of the compensated cirrhosis, you need an endoscopy, and it's a small test. I don't feel it's a big test. And with FibroScan, obviously you need all these tests, and then you need to decide where you need an endoscopy. And I may have a show of hands of all cirrhotics who all would prefer to do an endoscopy to identify portal hypertension rather than going by platelets and all. So almost everybody. So we would all like to do an endoscopy because it gives us so much of information, gastric varices, other things, other complications of portal hypertension, which adds on to a lot of meaningful information to these set of patients.
So I agree with you. All cirrhotics need an endoscopy. That's the right question to ask the room. The question is, do all patients with clinically significant portal hypertension need an endoscopy for their diagnosis? The answer is no.
For the diagnosis, no. For all clinically relevant, to say they have significant portal hypertension, what is the varices stage, whether the varices need treatment, all that is important, and that information can only come from an endoscopy.
Yeah, I think this statement should be seen in the context of availability and cost of endoscopy in individual countries. Really speaking, if you take our country, we stand at a situation where the cost, availability and access is much better than many countries in the West because of other factors, or underdeveloped countries also, because we're there, they may not be having access. And I might stick my neck out and say that access to endoscopy is more available than access to a good LSM across, if you take across the country. So it's really, any study that I see how to select patients to do a diagnostic upper GI endoscopy, I really feel is not much relevant in our country. That decision is made by the person who's evaluating the patient, and if he feels that endoscopy is required based on, usually it's an ultrasound findings that suggest CLD, you say, okay, I'd like to also do the endoscopy, and it just happens. Yeah. So I think in our country, selection of patients for a diagnostic upper GI endoscopy, whatever be the criteria, is not much relevant.
Sir, and you raised a very important point, because all these studies are from the Western world, and they have this challenge because of the non-availability, the cost of the procedure. But for our country, it's easy to do an endoscopy and get a lot of useful information which is helpful to the patient's care in the compensated stage, because that is the most relevant information that we're looking at.
Dr.
So if
Raki,
you're,
you actually asked to raise hand to a biased population. All these are gastroenterologists.
Exactly.
They'll definitely say.
The endoscope is our stethoscope.
Majority of patients are being managed by physicians.
Sir, but when you're treating clinically significant portal hypertension, the first statement is this patient has to be referred to a hepatologist.
So if you are detecting clinically significant portal hypertension, how does a physician actually refer? The idea is they should know how to use NITs. Yes.
The only point I was also making, and just carrying on further to Dr. Shiva Prasad's point, that we in India have access to endoscopy. It's very cheap. Everybody knows it, and even physicians are referring for endoscopy. They're not referring for LSM or anything. They still are far away from knowing what is LSM, but everybody knows endoscopy. So, but surprisingly, Indian societies, whenever you have a society of gastroenterology and all those, they are never making this point. So it's high time that we make our own sort of rules and regulation and not go about Western, which Dr. Raki pointed out. We should, from the societies, get it that now we can do endoscopies rather than catching the ear all the way around. When we have the direct access, why shouldn't we do it and get put to so many things which we have to know about portal hypertension?
So I will agree with your point, sir. An endoscopy is really easy. It's a stethoscope for us, and nothing's preventing us from putting it into every individual who comes.
We should
It's
not be
easy.
afraid to own up.
However,
that we are doing them.
So once you have an endoscopy, the chances of a regression of varix or a disappearance is not going to help. And what do you do if there are no varices or there's only PSG? So that's where a question comes of which patient should we quantify for continuous surveillance or not. So that's where
another
NITs
point,
would help. They're
but-
complementary.
Okay.
Secondly, once the patient is already on therapy or is having varices needed treating, then one needs to know whether they're going to recompensate. Are they going to have further decompensation? So these kind of philosophies of CHBH, spectrum helps. And we are talking about pre-endoscopy stage.
We are practically trying to work
So
in
for
their
us, it's a
philosophies.
stethoscope. Look, I would scope every single individual who would come. It would make it much easier.
That will come as repeated assessments, looking at response to treatment. That's a separate scenario altogether, where you obviously need non-invasive tests.
The patient may agree for blood test again, but he may not agree for repeat endoscopy. So that
First endoscopy.
Required or
no,
not,
that is
the
fine. First
question.
endoscopy we have done, but that in case
But
we need
all
to.
the things they suggest, because the progression of varices is an important thing, and there are guidelines. How often you need to repeat your endoscopies once you have detected varices or no varices.
I think the House will thank Dr. Raki and Dr. Madhumita for an excellent debate. Thank you so much. We'll have to close it.
Thank you.
Moving forward, may I request Sunil Taneja to go ahead with his next talk.
Thank you, sir. At the outset, my sincere thanks to Dr. Arora, Dr. Ashish, and Dr. Praveen for inviting me here. So I'm going to switch gears, and I'm going to talk about dyslipidemia and cirrhosis, cause or effect, and how to manage. By definition, dyslipidemia is the imbalance of lipids such as cholesterol, LDL cholesterol, triglycerides, and high-density lipoproteins. And in clinical medicine, it is the levels which go up for cholesterol, LDL cholesterol, and triglycerides, and HDL level comes down. The flip side is, in cirrhosis or in liver disease, these levels tend to come down. The plasma lipids and lipoproteins, they both will decrease as the parenchymal liver disease will go on. And this is because the level and composition of the lipoprotein depends on the activity of enzymes which are involved in the lipid metabolism. And these three important enzymes are the lipoprotein lipase, lecithin cholesterol acyl transferase, and hepatic triglyceride lipase. So just let's look at the lipid metabolism and the liver. The lipid metabolism is a complex issue, and the cellular and the plasma lipid hemostasis is maintained through tightly controlled mechanisms. In this, the liver plays a central role, and there are various mechanisms how it works. Two simple mechanisms are that what goes into the liver, the lipids which go into the liver, how they are dealt by the liver, and how they come out of the liver, and how they are dealt in the circulation. So let's look at how this happens in the liver. 60% of the non-esterified fatty acids which come to the liver, they come from the adipose tissue. And okay, so 60% comes from the adipose tissue, 15% comes from the diet. The lipids are taken up by the intestine, hydrolyzed, emulsified, and converted into chylomicrons, which go into the circulation. From there, they are converted into HDL, LDL, etc. And the rest will go into the liver, where they will form the non-esterified fatty acids. 25% is by de novo synthesis in the liver. So 60% by adipose tissue, 15% by the diet, and 25% by this de novo lipid synthesis in the liver. And all these fatty acids will either be stored in the liver as triglyceride or lipid droplets, or they will go back into the circulation as VLDL. Again, the same cycle is followed. So this is how the liver works. Now what happens if the liver is not working? Obviously this function will be impaired, and the three key pathogenic aspects of lipid alterations are decrease in the lipoprotein synthesis, the parenchymal loss is happening, the protein synthesis will go down. There is degradation of the lipoprotein complex by the liver, and as I said earlier, there is reduction in the enzymes which are involved in this lipid metabolism. Now, let me draw your attention to this very nice paper. This is from Vienna. They screened 3,000 patients, out of which 2,700 patients were included, and they divided them based on the etiology of the liver disease and based on the LSM. LSM less than 15 and more than 15. And let's look at the results. Baseline, obviously BMI was high in NAFLD. 60% patients had hypertension, and diabetes was seen in around 30% of the patients. Now let's look at the lipid profiles in these patients. Irrespective of the etiology, non-ACLD versus ACLD, there was a difference between the two groups. In all, alcohol, HCV, AIH, NAFLD and all. So they demonstrated that there is a reduction as compared to patients who have low fibrosis. The second aspect in which they saw in this paper was, though there was a reduction in the level of the lipids, but still there were patients who qualified in the treatment range. Now let's look at the second figure. In alcohol, 21% patients had total cholesterol more than 200, 12% had LDL levels more than 130, and 8% had triglycerides more than 200. And similar for other etiologies also. NAFLD obviously had more, 24, 18 and 17%, making a case that even if they have cirrhosis, they might require treatment. So this is what the spectrum is once the liver disease tends to progress, whether it's NAFLD, alcohol or autoimmune liver disease. Initially the lipids would be high, and as there is parenchymal loss, this tends to come down. Now this is the crux of all the studies. These are all old studies. We do not have any recent data on lipid profiles in patients with cirrhosis except for non-alcoholic fatty liver disease. But in all these studies, the primary etiology was viral, alcohol and cryptogenic. And what they have shown, this is universal, that cholesterol, HDL, LDL, triglycerides all will go down over a period of time in patients with liver disease. Now what are the implications of dyslipidemia? Earlier it was thought that cirrhotic patients are protected against the atherosclerotic disease. Now this is not true, and there are studies now available which talk about the prevalence of coronary artery disease among patients with cirrhosis, and this is similar if not less than the general population. Now depending on the cardiovascular risk and the etiology, this will also vary. So NASH has the highest, alcohol followed by alcohol, and then you have viral hepatitis. So they are prone to atherosclerotic cardiovascular disease. Now let's look at this. The prevalence and prediction of coronary artery disease in patients with liver cirrhosis. Now this is the paper from the Asan Institute from Korea, and they looked at 1,000 cirrhotic patients, and healthy controls were from the insurance database in people who had undergone coronary angiography as a routine checkup. So 30% were child A, 39% were child B cirrhosis, and 30% were child C cirrhosis. The mean MELD score was 14.7. Here the etiology of liver disease was primarily hepatitis B and C and followed by alcohol. Now presence of obstructive cardiovascular disease was seen in around 7.9 versus 7.7% of the population. That means that cirrhotic patients are prone to coronary artery disease. It's not that they are completely protected. And insignificant coronary artery disease was seen in 30% versus 24%. So this is what we have analyzed. All the pre-transplant patients were evaluated for coronary artery disease and its kind of risk stratification before transplant. 105 patients. Age was 48. The mean male was 19. Primary etiology was alcohol and NAFLD. We all know that NAFLD is going up, and obviously they have other risk factors for coronary artery disease and atherosclerotic cardiovascular disease. Now 20% of patients were diabetics and 11% were hypertensive, and 18.75% patient had evidence of any CAD, and clinically significant CAD which required intervention was seen in 13.5%. And this was more in patients who were hypertensive, diabetic and older. So is there an effect of these lipids on the prognosis of patients with liver disease? There is some data on this also, and this is from China. 198 patients, decompensated cirrhosis. They looked at the lipids at day 1 and MELD scores and followed these patients for 1 year. 45 patients died within 3 months, 83 patients died within 1 year, and look at the trend of lipids. As the MELD score increased, the level of all the lipids came down. And let's look at the survival. 3 months survival, they looked at the MELD score and the triglycerides, and they came to 2 cutoffs. If the MELD is more than 21 and if the triglyceride total cholesterol is less than 28, they had the highest mortality. But obviously we need more data on this. Another paper again from China. In this they looked at the HDL levels and survival. And in these patients there was also evidence of portal vein thrombosis. So again this was a retrospective study. 117 patients, they look at the lipid profile and correlated with the CTP MELD score. Similar trend, as the CTP score worsened, the lipids came down. And here they said that if the HDL level is low and along with the CTP and MELD score, it correlates with the mortality. So this is the crux of all the studies which are available in literature. Primarily they have looked at the cholesterol levels, triglyceride levels, HDL, ApoA1 and triglycerides. So all have shown they are predictors of survival, and over a period of time as the disease will progress, these levels will come down and they will have poor survival. But then we do not have good studies on this so far. And theoretical part, how they try to analyze lipids in patients with cirrhosis. So if you have liver cirrhosis, the enzymes which metabolize the lipids will come down, the levels of lipids will come down. This can go on to lead to develop anemia in patients. This is because of accumulation of cholesterol in erythrocyte membranes. They can develop adrenal insufficiency because adrenal steroidogenesis can be deficient. It can lead on to infections because there is reduced endotoxin levels, and malnutrition can develop because of increased free fatty acid oxidation. So this is all theoretical. There is not much data on this so far. Okay, coming to the treatment part. So if you have evidence of dyslipidemia, it has to be treated as the general population or patients who are at risk for development of atherosclerotic cardiovascular disease. You have to stratify your patient, and in this the metabolic syndromes comes here. So low risk, borderline risk, intermediate risk or high risk, depending on the stage, they might need treatment. So how do you treat dyslipidemia? Initial management is obviously lifestyle modification, diet, exercise, and you need to identify patients who are at high risk for development of cardiovascular disease. Statins still remain the first line of therapy for lipid lowering in patients with dyslipidemia, and they can be safely used in patients with childish cirrhosis for cardiovascular risk reduction if indicated. Now they should or they can be avoided in patients with child B or child C cirrhosis. The rationale is that generally grave liver related prognosis of patients in child B and C makes it unlikely that they will benefit from the cardiovascular benefits associated with lipid lowering therapies. And there is a concern that if there is moderate to severe impairment, statins may cause liver dysfunction, which has not been proven so far. So there are also other pleiotropic effects of statins in liver disease, which will be discussed in the subsequent talk. So let me just summarize here. The relationship between serum lipids and liver cirrhosis is complex. There is some evidence to suggest that abnormalities in lipoprotein levels may play a pathogenic role in several clinical manifestations of cirrhosis, whether it is bacterial infections, hematological complications, malnutrition and adrenal function. And detection of serum lipid levels could represent an additional tool to stratify the degree of liver damage. However, future studies are needed to evaluate the potential impact of the new prognostic scores, including lipoprotein profile assessment for addressing and having a better stratification of cirrhotic patients, and additional efforts should be made to find the therapeutic strategies in the setting of dyslipidemia in patients with liver disease. I'll stop here and happy to take questions.
Thank you, Dr. Taneja. Due to acute shortage of time, we are skipping question and answer session, and we may proceed to the next lecture, that is role of statins in cirrhosis beyond dyslipidemia. How it come of the age. Our speaker is Dr. Bhaskar Nandi. So without going much details, may I ask Dr. Nandi to kindly proceed.
Thank you. Thank you, sir, and good afternoon to all of you. Sincere appreciation to Dr. Arora and team for holding this conference every year, the wonderful conference. The question asked to me is role of statins in cirrhosis beyond dyslipidemia. I think it's more of a debate rather than a straight question, and a very quick conclusion that one can draw from such a debate will be that the jury is still out. Over the last couple of decades, I think the role of statins for reducing the cardiometabolic risk factor is well known and well documented. There is no doubt about it. But I think our focus today is that do we use statins in patients with cirrhosis beyond its cardiometabolic effects? Does it change the natural course of cirrhosis? Let's put it this way. For that, if we look at the cholesterol metabolism, we all know that statins are HMG-CoA reductase inhibitors, and that's how it inhibits the formation of the cholesterol. But today our focus will be on the intermediate metabolites, that is the farnesyl pyrophosphate. I think these are the isoprenyline compounds which are formed during the metabolism of cholesterol, and these molecules can be either incorporated into sterols, that is cholesterol, vitamin D and A, or into non-steroidal compounds. I think our focus is on that, the non-steroidal compounds in which this lipid attachments can take place, because they influence a lot on cellular and molecular signaling, and which have got far-reaching effects as far as inflammation and oxidative stress is concerned. So without going much into the molecular details, just to summarize, we can say that it has been seen that by blocking the cellular signals, there can be improvement in endothelial function, there can be stabilization of atherosclerotic plaques, reduction of inflammation and oxidative stress, and inhibition of thrombogenic response. Now, today, with the concept of cirrhosis-associated immune dysfunction, we all know that the progression of compensated cirrhosis to decompensation and finally to ACLF, I think the entire gameplay is because of inflammation, SIRS, which takes place over there. And if we have these effects which have been shown, which are combinedly called as the pleiotropic effects of statin, that is the non-cardiometabolic effects, and if it can address these two issues, I think there is a little bit of, quite a bit of logic and reasoning as to why they should be used in cases of cirrhotics. But having said this, whether it is actually used or not will depend on two questions. One, is it safe to be used in liver disease? And the other is, what is the evidence that it is effective in real life situations? As far as safety is concerned, I think we take the help of three very large prospective cohort studies. One is of Iceland, follow-up of 2 years. The second one is of the Spanish registry, of a 12-year follow-up. And of course, the largest one has been the US Delhi network registry. And if we summarize the findings of these three large prospective cohort studies on statin safety in liver disease, I think some things are very much apparent. One, clinically significant statin-induced DILI is really rare. It is in fact less than 3%, 3 to 5%. And second, manifestations may be delayed after starting statins, that is about median of 155 days, 3 to 4 months. The pattern that you get depends on the type of statin you are used. Mostly it is cholestatic, which we get with atorvastatin, which we use these days, and hepatocellular pattern has been with simvastatin. I want to remind here that most of the studies of statins in liver disease, both for its safety and efficacy, have been simvastatin based rather than atorvastatin. ALF has been reported, but it is extremely rare. Most patients recover after statins are stopped, except a very small subgroup wherein you develop autoimmune phenotype antibodies, and it has been seen that this particular small group of patients actually go on to have persistent chronic liver disease. But I think if we just talk of numbers, statins are safe, and in fact this task force 2014 update clearly mentions that CLD and compensated cirrhosis are not a contraindication for use of statins. Second, statins can be used in patients with NAFLD-NASH or autoimmune hepatitis, but the caveat is decompensated cirrhosis and ALF, they remain a contraindication for the use of statins. So, and one more recommendation what they had given is that today it is not necessary to monitor LFT if a patient is on statins. I think that's a big statement that they had come out with. Now coming to the more difficult question, that is it really effective? That should we use it or not? We can take the help of large cohort studies which have looked into this aspect, whether the statins can actually influence the natural course of cirrhosis. Most of them are retrospective cohort studies, and we are all aware the limitations of a retrospective study, and moreover the cohort population studies, the main problem lies in the heterogeneity of the population studied, because there are too many confounding factors which can actually influence the cirrhosis outcome. But having said this, if we look closely into a couple of studies, 2 or 3 of them, this one has been largely on chronic hepatitis B patients, and this has clearly shown that there is decreased cumulative incidence of cirrhosis, and if we look at the adjusted hazard ratio, so they have adjusted for the confounding factors, and as it is shown, it is quite less. And secondly, it has also decreased decompensation. Statins independently reduce cirrhosis and its decompensation in chronic hepatitis B. This protective effect was stronger with higher dosage and longer duration of statin use. In this study particularly, they have been using simvastatin, actually, it has been used here. If we look at the other study, this is the US veteran study on hepatitis C related compensated cirrhosis. Here too, the conclusion has been that there is decreased decompensation when you look at the composite endpoint, that is both varicose bleed and ascites, and of course there has been a decreased death or increased survival in such patients. And these conclusions were valid even when they were adjusted for differences in the MELT, CTP, albumin and the FIB-4 scores. So apart from decompensation and survival, there are studies to show, though very few, that statins are associated with a reduced risk of hepatocellular cancer. Now this meta-analysis of 10 studies and over 4,000 cases has shown that statin users were less likely to develop HCC than statin non-users. And the results of course were heterogeneous due to the study location, Asian population, Western populations, and of course the study design and the limitations of meta-analysis which is there. Are there any randomized clinical trials? Now, if we want a more stronger evidence, they are there, but the numbers are too low, and there are many limitations and issues on their design. One study stands out, and this is the BLEB study, but where the primary endpoint was to see whether simvastatin had reduced the recurrence of a rebleed after your index bleed. What they found, the answer was negative. It didn't do anything about the rebleed. But what was interesting was the survival was more in the statin users, 22% in placebo versus 9% statin, and of course the hazard risk ratio was much lesser. Of course this was not valid for child score C. The maximum data that we have, I just wanted to show in this slide that acute liver injury we need to leave out. Similarly, acute and chronic liver failure, again, I think goes out of our consideration as far as use of statins is concerned. Most of the data, though it is observational and cohort-based and few randomized controlled trials, are basically for compensated cirrhosis. I did a small unofficial survey among our colleagues in our real-life practice, and in fact, almost all, if not everybody, they said that they do not prescribe statins in their clinical practice to patients with cirrhosis to change the clinical outcome. Yes, people have used in NASH related cirrhosis, but that was, I think, because of cardiometabolic requirement. what we are discussing is totally different. Non-cardiometabolic effects of statin were used here. Now, if we ask as to what is the reason why we have not accepted statins, because what I believe is, as I have shown in my initial slides, that there is a molecular basis. Reasoning is there, so it is not absolutely without logic that statins, why can't we use statins in cirrhotics? There are studies to show about its efficacy, but I think one limitation is that it's mostly cohort-based, and we do require much stronger studies to convince us. But at least one inference that we can safely draw is that statins are safe. We can use it. So whether we don't know whether they are going to be a benefit or not, but definitely they are not going to harm. And I think the need of the hour is, rather than discarding statins, we should actually design appropriate studies with good homogeneous population, defined endpoints, and actually settle these questions that can we use statins in cirrhosis to influence their outcome. We must remember that today most of the management of cirrhosis is reactive, it is not proactive. Apart from beta blockade and of course nutrition, there are hardly anything we have to actually change the natural course of cirrhotic patients. So if we get a drug or if we get a mechanism by which we can do it, that should be a big advantage for us, and it definitely merits consideration. Thank you so much for your patient listening.
So thanks a lot for a very lucid presentation. We won't be taking any questions due to paucity of time. So the next speaker of the day is Dr. Manisha Dwivedi. She is coming with the topic, treatment of pruritus and cirrhosis. The dais is yours, ma'am. Thank you.
Good evening, ladies and gentlemen. First of all, I must thank Dr. Anil and his team for an excellent meeting and for inviting me over. I'll be talking to you about the management of pruritus in chronic liver disease. Pruritus is a sensation of discomfort or irritation which provokes a need to scratch. This in chronic liver disease often begins in the palms and the soles and then becomes generalized. It tends to be intermittent, chronic, and worse in the evening and in warmer temperatures. The various chronic liver diseases which are associated with pruritus include primary biliary cirrhosis, cholestasis of pregnancy, primary sclerosing cholangitis, viral hepatitis, obstructive jaundice, and drug-induced liver injury with cholestasis. Pruritus is reported in about 70% of patients with primary biliary cirrhosis, 2.5 to 30% in patients with hepatitis C, and 8% patients with hepatitis B were found to have pruritus. Intrahepatic cholestasis of pregnancy classically presents with pruritus in pregnancy due to increase in serum bile acids more than 10 millimoles per liter. Benign causes of obstructive jaundice tend to be associated with a lower rate of pruritus as compared with malignant causes, that is 16% versus 45% respectively. The prevalence of pruritus in autoimmune hepatitis, alcoholic liver disease, and non-alcoholic fatty liver disease has not been clearly established. There are certain culprit molecules which are involved. These are bile salts, lysophosphatidic acid, autotaxin, and endogenous opioids. Accumulation of bile salts leads to mast cell degranulation, causing pruritus. Elevated bile acids also give rise to hepatocyte toxicity, spillage of contents, and pruritus. Talking about the pathophysiology, lysophosphatidic acid and autotaxin induced pruritus is there in patients with chronic liver disease. Autotaxin is an enzyme which is involved in the production of lysophosphatidic acid. Although the exact mechanism leading to pruritus has not been elucidated, autotaxin levels have been shown to correlate with the degree of itching. Opioids, and it is thought that activation of M-opioid receptors may elicit pruritus by reducing pain signaling. This is the basis of utilization of opioid receptor antagonists with some efficacy in this condition. Talking about the mechanism of pruritus, they are itch selective pathways in the periphery. They are slow conducting C fibers which are insensitive to mechanical stimuli, which convey the itch signals which are distinct from pain transmission. Mechanical stimuli such as pain and touch sensations are transmitted through a large diameter myelinated conducting A fiber which completely inhibits itch transmission. Thus, itching is reduced by scratching. But scratching, on the other hand, causes skin damage with release of substance P and CGRP, thus inducing pruritus. So that's why it is a vicious cycle. In the CNS, cirrhosis causes reduced hepatic elimination of blood-derived opioid peptides, which leads to increase in the opioid receptor agonists like methionine, enkephalin and beta-endorphin. Nitric oxide is increased in cirrhosis and PBC, thus enhancing substance P-induced scratching. There are certain risk factors which are involved. These are advanced age, diabetes, it's more common in women than in men, active hepatitis B, and of course primary biliary cholangitis. Once you have pruritus, you have to determine whether there is a rash associated with it or not. If there is a rash, immediately you will think of a dermatological cause. The next thing to ascertain is whether this pruritus is generalized or localized. If it is localized, then you will have to think of a neurological cause or a psychological evaluation. If it is generalized, then we evaluate for systemic disorders, rule out diabetes, and then see whether this cause is extrahepatic or it is hepatic. If it is hepatic, then you have a certain group of medical therapy which we will be talking to you later. And if there is an extrahepatic cause of obstruction, then of course you will relieve that by biliary drainage. In the history, you see for the presence of risk factors for liver disease, comorbidities, constitutional symptoms, and medication or substance use. Physical examination should include an evaluation of stigmata of chronic liver diseases, and the lab evaluation includes a liver profile, coagulation profile, viral serologies, autoimmune serologies, estimation of bile salts. If biliary obstruction is suspected, then an ultrasound or cross-sectional imaging is warranted. In the management strategies, you have general measures, medical therapy, alternative therapy, and surgical management. As a general measure, use moisturizing and cooling ointments. You of course shorten the fingernails to avoid secondary skin damage and avoid using hot water bath. The medical therapy contains antihistaminics like hydroxyzine, atarax that you have, diphenhydramine, and then you can use UDCA. This alleviates pruritus in intrahepatic cholestasis of pregnancy. The dose is 10 to 15 milligram per kilogram per day in 2 or 3 divided doses. Cholestyramine is the other drug that you can use in other causes of pruritus. It relieves cholestatic pruritus in a dose of 4 to 16 grams per day in 2 divided doses. But the problem with this is that it can bind to other medications. So other drugs should be given 1 hour before or 4 to 6 hours after cholestyramine intake. Rifampicin is another drug that can be used. It reduces autotaxin expression and decreases the pruritus. It is helpful in refractory itching and malignant cholestasis. The dose is 150 to 300 milligrams twice a day. Other drugs which have been used with some promise are naloxone, naltrexonol, nalfurafine, and sertraline. These are mu receptor antagonists. They are effective in treating cholestatic pruritus in prospective trials. However, they are not given to patients with narcotics. Naltrexone 25 to 50 milligrams per day is the dose. Nalfuramine is an opioid antagonist primarily metabolized by the P450 to inactive metabolites, and a randomized controlled trial of 109 patients treated with 5 mcg of nalfuramine was undertaken. 105 patients treated with 2.5 mcg and 103 received placebo. It was found that patients on nalfuramine showed significantly better itching control. Sertraline has also been used. It is well tolerated. There is a modest reduction in pruritus. However, it is used cautiously in CLD patients due to its primarily hepatic metabolism, and should not be administered with disulfiram and within 14 days of giving monoamine oxidases. Surgical therapy entails partial biliary diversion. It could be external, it could be partially internal, and of course in the case where you are stuck up and nothing is working, then liver transplantation is advised for refractory pruritus associated with chronic liver disease. So this is the order. If you have a patient with pruritus, first you ascertain whether she is pregnant. If she is, UDCA is the drug of choice. If not, cholestyramine. If it doesn't help, then go on to rifampicin. And if the problem with rifampicin is that you have to monitor the LFT carefully, be cautious in that. And then you can use opioid receptor antagonists, and as an alternative, phototherapy, plasmapheresis, albumin dialysis, and a nasobiliary drainage could be done. And finally, a biliary transplant, biliary diversion, and a transplant. If there is pruritus, ascertain for bile duct obstruction. If it is present, biliary drainage. If not, then the other medicines that we have talked about. Alternative therapy consists of thalidomide, which is an immunomodulator with an antipruritic effect, ondansetron, phenobarbital, plasmapheresis, UV phototherapy, albumin dialysis, and nasobiliary drainage. To summarize, pruritus in chronic liver disease occurs due to complex, incompletely understood pathophysiology. Starts with acral distribution, then becomes generalized. Localized pruritus without rash suggests a neurologic or psychological cause. UDCA is very effective in intrahepatic cholestasis of pregnancy. Cholestyramine, first line treatment for itching in CLD. Medication administered 1 hour or after 6 hours of taking it. And CBC LFT should be monitored, especially on rifampicin therapy. Plasmapheresis, phototherapy, albumin dialysis considered in patients with refractory pruritus. Thank you.
Thank you, ma'am. It was a very lucid presentation. Okay. Thank you. The session ends here today. I mean, the treatment of non-malignant portal vein thrombosis and cirrhosis is not to be taken now. Thanks a lot thanks a lot everyone, the moderator as well, the chairperson, and thanks to the whole team of this conference for inviting us and being a part of it. Thank you very much. Thank you.
Thank you all the speakers for such wonderful talks, and our respected chairpersons and moderators for the session. So we'll be continuing with the next session. The topic of our next session is cirrhosis unmasked, confronting decompensation. For this session, I would like to invite on this stage as chairpersons Dr. Abhinav Arora, Primus Hospital, Panipat; Dr. Mukul Rastogi, Fortis Hospital, Noida; Dr. Vibhas Mittal, Max Super Specialty Hospital, Delhi; Dr. Amit Soni, Shri Mahant Indresh Hospital, Dehradun; and Dr. Jatin Agarwal, Zydus Hospital, Vadodara. For moderators, I would like to invite on the stage Dr. Siddharth Srivastava, GB Pant Hospital, New Delhi; Dr. Shaukat Chaudhary, Jammu Kashmir; Dr. Mushahid Khan, Gastro, Liver, IBS and IBD Center, Bareilly; Dr. G.N. Yattu, Sher Kashmir Institute of Medical Sciences, Kashmir; and Dr. Anira Vaidya, National Academy of Medical Sciences, Nepal. I would request our respected chairpersons to call their respective speakers on the stage for their talks.
It is an honor to ask Dr. B.C. Sharma to come on the dais. He'll be speaking on decompensated AIS cirrhosis, how to manage.
Thank you, Chairpersons. Good evening, ladies and gentlemen. I am thankful to organizers for giving me this opportunity to talk on how to manage autoimmune hepatitis-related decompensated cirrhosis. Around 1/3 of adult patients with autoimmune hepatitis have cirrhosis at presentation, of which around 9 to 50% present in decompensated state, majority in form of ascites followed by variceal bleed or encephalopathy. In Indian series, presentation with decompensation cirrhosis in autoimmune hepatitis is very common because of referral bias to tertiary care center. Presence of decompensation at presentation is associated with very high liver-related mortality or need for transplantation. Also, development of decompensation subsequently on follow-up or while on treatment is also associated with liver-related and or cause mortality and need for liver transplantation. ASLD and EASL guidelines suggest treatment of autoimmune hepatitis if ALT, AST levels are elevated more than 10 times the normal, or if ALT or AST levels are elevated more than 5 times the normal, in addition to 2 times elevation of serum gamma globulins, or evidence of high inflammatory activity or liver biopsy. According to EASL and ASLD guidelines, treatment should not be given in decompensated, burnt out cirrhotics unless there is a high inflammatory score on liver biopsy, because these patients are not benefited and have more serious side effects of drugs. There are many studies published on treatment of autoimmune hepatitis related decompensated cirrhosis. However, these studies are mainly retrospective, lack control arm, have different inclusion criteria, different treatment schedules, and different criteria for labeling remission and relapse. In this study, 82 patients with autoimmune hepatitis related decompensated cirrhosis were included. Diagnosis was established by International Autoimmune Hepatitis Group Diagnostic Criteria, and patients with the pre-treatment score more than 10 were enrolled. Most of patients presented with ascites, variceal bleed, and hepatic encephalopathy. They were started on prednisolone 25 mg per day, range 10 to 50 mg, and were followed up for median of 18 months. It was found that reversal to compensated state in 40 of 64 patients in steroid group as compared to none of the patients in no steroid group. And also non-reversal, mortality, and need for liver transplantation was lower in treated group as compared to untreated group. Probability of survival was higher in treated group as compared to untreated group. This is another study from China in which 87 autoimmune hepatitis related cirrhotics, of which 3/4 were decompensated, were included, and they manifested mainly in form of ascites, variceal bleed, and hepatic encephalopathy. Indications of treatment were according to ASLD guidelines for autoimmune hepatitis, and patients were given prednisolone 40 to 60 mg per day and tapered down to 20 mg per day in 4 weeks. And in addition, azathioprine for 50 mg per day. And with this treatment, it was found that complete remission in 80% of patients with cirrhosis and in 88% of patients without cirrhosis. And also, incomplete remission and treatment failures were similar in patients with cirrhosis of which 3/4 were decompensated, and in patients without cirrhosis. Disease progression was similar in treated cirrhotics and non-cirrhotics, and also disease progression was lower in treated cirrhotics than non-treated cirrhotics. On multivariate analysis, presence of cirrhosis denoted a poor outcome. In this study from Apostle ACLF Research Consortium, the role of steroids was evaluated in autoimmune hepatitis related ACLF. Patients treated with steroids and not treated with steroids at baseline had similar Child-Pugh score, MELD score, SOFA score, and ARC score. However, baseline sepsis was around 50% in patients not given steroids as compared to none of the patients who were offered steroids. 90-day survival was 75% in patients treated with steroids as compared to 48% in patients not treated with steroids. 90-day survival in non-treated patients was similar in patients without sepsis and with sepsis. And also 90-day survival was higher in patients given steroids without sepsis as compared to patients not given steroids but without sepsis. New onset infections were 21% in steroid group as compared to 13% in non-steroid group. And on univariate analysis, advanced age, baseline high values of bilirubin, high MELD score, presence of hepatic encephalopathy, and high degree of liver fibrosis were associated with bad outcome. This is a study from India, 35 patients, AIH-related decompensated cirrhosis, mainly from ascites, varicose bleeding, encephalopathy. And they were given prednisolone 0.5 milligram per kg, maximum 30 milligram per day for 4 weeks, which was tapered 5 milligram every 2 weeks till dose of 5 to 10 milligram was attained and was continued for a prolonged period. Patients were also in addition given azathioprine if bilirubin was less than 3 milligram per deciliter, and follow-up was done for 1 year. Of 35 patients, 23 patients received both steroids plus azathioprine, 5 patients prednisolone only, and 7 patients no immunosuppressive drugs. And overall survival was 85%. In this study, patients not started treatment, given prednisolone alone or given combination of prednisolone plus azathioprine, survival was around 85%. It means there was no significant difference in survival rates based on treatment received or not and type of treatment. And most common cause of death was sepsis. Also, rate of infection between patients with and without immunosuppression treatment was no difference. And use of immunosuppressant in AIH-related decompensated cirrhosis did not offer any improvement in survival. This study from AIMS, New Delhi, 94 patients with cirrhosis, 24 having gross ascites, 38 having mild ascites, and 32 with compensated cirrhosis were treated with immunosuppressants. Patients with compensated cirrhosis who had HAI 4 or more were treated with prednisolone 0.5 milligram per kg and azathioprine started 2 weeks after initiation of steroids. After 4 weeks of initial treatment with prednisolone, if biochemical remission occurred, the prednisone was tapered by 5 milligram every 2 weeks to lowest dose required to maintain the remission. Patients with decompensated cirrhosis with HAI 4 or more were given, they were pre-optimized for control of ascites, and infection was excluded by standard criteria and cultures. Patients were given prednisolone, however, they were not given azathioprine or any other immunosuppressant. Tapering of prednisolone was done as begun in compensated cirrhosis, and if no response or deterioration, patients are enlisted for liver transplant. 66% of patients in decompensated cirrhosis with gross ascites, 16% of patients in mild ascites, and none of the patients in compensated cirrhosis died over follow-up. 4% of patients with decompensated cirrhosis with gross ascites, 8% of patients with mild ascites, and 3% of patients with compensated cirrhosis needed liver transplantation. 4% of patients with gross ascites, 31% patients of mild ascites, and 53% patients of compensated cirrhosis had biochemical remission. 12-month survival was 35% in gross ascites, 75% in patients with mild ascites, and 97% in patients with compensated cirrhosis. Liver transplantation is another mode of treatment in patients with autoimmune hepatitis related decompensated cirrhosis, and indications are if there is no improvement in serum bilirubin or MELD score during treatment, or if baseline score MELD is more than 15, or there is hepatocellular carcinoma. 10-year survival in AH related decompensated cirrhosis is more than 90%. However, in around 1/4 of cases, the autoimmune hepatitis recurs after liver transplantation, and these patients are managed by steroids, azathioprine, mycophenolate, sirolimus, and some patients may require retransplantation. To summarize, ladies and gentlemen, there is variable incidence of autoimmune hepatitis related cirrhosis at presentation. Presence of decompensation indicates short survival. Treatment is indicated in autoimmune hepatitis related cirrhosis if they have active disease in form of raised transaminases or HAI4 or more. In decompensated cirrhosis, mostly prednisone alone is used and azathioprine is avoided. Remission, reversal to compensated state is higher in treatment group of patients with decompensated cirrhosis. 90 days transplant-free survival is also higher in treated group as compared to non-treated group. Relapse rate after drug withdrawal is similar to patients with compensated cirrhosis and patients without compensation, the patients without cirrhosis. 7 and 14 days reduction in activity predicts better response to steroids or long term. And remission rates and survival in some studies have not been found to be better with treatment in decompensated cirrhosis. However, these studies have included mainly patients without high inflammatory activity. Thank you, ladies and gentlemen, for your kind attention, please.
Thank you, sir. So, questions we can take later as we are running short of time. Next, I would like to call upon Dr. Virender Singh, sir, for the talk, and the topic is management of refractory ascites.
Thank you, Mr. Chairman. I am thankful to Dr. Arora's team for giving me this opportunity. How much is the time given to me? 15 minutes? So I'll try to finish up in 10 minutes and would like to take some of the questions. Okay? So, because this is a very important topic. So I'll not go into the details of pathogenesis. You all know why the ascites develops in these patients, because there is in portal hypertension, there is a splanchnic or the systemic vasodilatation, which leads to the activation of the vasoconstrictor systems, and then there is a sodium and water retention causing ascites. So we can intervene at various levels: sodium restriction, diuretics, LVP, tapes, or transplant. Refractory ascites can be a diuretic resistant ascites when we have reached the maximum dose of diuretics, that is 400 mg of aldactone plus 160 mg of furosemide, or it can be a diuretic intractable ascites, where the complications prevent use of adequate doses of diuretics. There is something in between in these two entities. The recurrent ascites also is very important. When do we call the refractory ascites? Once we have started the diuretics and we are not able to control within 1 week with the full doses of diuretics, we call it the refractory ascites, and the weight loss is not occurring properly, or there is a reappearance of the grade 2 or 3 ascites within 4 weeks of initial mobilization. And then if there is a diuretic induced hepatic encephalopathy, and in that case also we call it the refractory ascites. And diuretic induced renal impairment is if there is an increase in the serum creatinine by 100% to a value of 2 milligram per dl in patients with ascites responding to treatment, and diuretic induced hyponatremia when it is less than 125, or hyper or hypokalemia, then we call it a refractory ascites. See this patient is having a grade 3 ascites with a low protein and high sec ascites. There is no SBP, sodium is 129, creatinine is 0.8 in this. He was receiving spironolactone 50 mg plus torsemide 5 mg, increased to spironolactone 100 mg plus torsemide 10 mg. He was also receiving propranolol. See, in this patient, this patient was requiring the LVP every 2 weeks, and when we increase the diuretics in this, the spironolactone 150 mg or torsemide 15 mg means 3 tablets of 5 and 50, and in that case the sodium again is coming down 126 and the creatinine is rising 1.5. But see, still we cannot call it a refractory ascites, but there is a problem in increasing the dose of the diuretics here. So this is the flaw in this definition of refractory ascites. So in the last, the APASL guidelines on the management of the ascites, we have proposed the new criteria of refractory ascites, in which we have taken the new definition of AKI. That is, we should also include the newer definition of AKI. That is, in the older definition it was the diuretic induced renal impairment is an increase of the serum creatinine to more than 2 mg in patients with ascites responding to treatment. But not only that, if they fulfill the criteria of the recent definition of AKI, we should call these patients as having refractory ascites. And once these patients develop refractory ascites, the survival goes down, and these are various options in these patients of the refractory ascites. If they are on beta blockers, you have to stop it, and if the MAP is low, you can use midodrine, do a therapeutic paracentesis, or you can send them for TIPS or liver transplant, or we can do the newer trials also. The LVP is very effective, and in this study they compared the role of the paracentesis versus the LVP, and this was useful. And see, why do these patients require paracentesis every 2 weeks? This is a calculation given here. And once we do LVP in these patients, a major problem is the paracentesis induced circulatory dysfunction. And to prevent that, we have to give albumin in these patients, and even when we give albumin, 15 to 20% patients will develop the PICD. The terlipressin has been used in these patients for the prevention of PICD, and we also use the terlipressin, and it was quite effective as compared to albumin. And then the NORAD also was tried. The midodrine we used in these patients for the prevention of PICD, it was quite effective. See, this is a meta-analysis in which Bernardi compared the albumin versus the various vasopressors, and he concluded that the vasopressors were not so effective as albumin in the prevention of PICD. We use the midodrine in these patients with the refractory or recurrent ascites, and used it for 3 months at least. The midodrine was given 7.5 mg 3 times a day, and then it was very effective. We followed these patients for 1 year. There was a better survival also. This is another study in which they used the midodrine, and there was a reduction in the body weight, increase in the mean arterial pressure, and then 24-hour urinary volume also. But on the other hand, in this study, the US multicentric study, this midodrine was not able to prevent the development of PICD. We also use the combination of the midodrine and the clonidine. In these patients, the refractory or the recurrent ascites, the combination did not, there was no superiority of the adding the clonidine in these patients with the refractory or recurrent ascites. We also use the midodrine and the tolvaptan. The control of ascites was little faster, especially during the first month. But overall, the tolvaptan did not have a beneficial effect in the later part. And this is another way of dealing these patients with the refractory ascites, give long-term albumin in these patients. And then this is proven in the answer trial in which they use the albumin in this group, and then initially they give the albumin 40 grams twice weekly for 2 weeks, a loading dose, and then 40 grams weekly for 18 months, and the overall 18-month survival was better, and hyponatremia episodes were lower, and the ascites, the cumulative incidence of the first paracentesis and the refractory ascites was decreased. On the other hand, when they used the midodrine along with the albumin, this was a negative study in which, although there were many flaws, and this was not proven to be better than simple albumin. And this is another way of tackling these patients with the refractory ascites. Tips can be done. And these are the various studies, the major studies done, and in this they compared the tips versus the LVP, and tips was useful. The only problem was the encephalopathy, which of course in this study of recurrent ascites, they showed that the encephalopathy was almost similar in 35% patients in these two groups. This is another way of tackling the refractory ascites, the automated low flow ascites pump. In this, the ascites is drained into the urinary bladder and then this passes through the urine. And this pump has been used. This is a pilot study in which they used it, but the complications were quite high. And this is another study where they used this alpha pump. Again, the serious adverse events were again quite high in these patients. So this is the approach to the management of refractory ascites. A patient with the cirrhosis with ascites not responding to usual measures, do the diagnostic tap. Many a times these patients may be having SBP. Look at the 24-hour urinary sodium, spot sodium or the potassium ratio. Then look at the dietary sodium intake, or look at the alcohol if he is taking. Then stop NSAIDs. You may have to stop beta blockers. And if the MAP is low, you can give them the midodrine or send them for the tips. And you can take help of the LVP with the albumin, or you can take help of the long-term albumin, or send them for the liver transplant. Thank you very much.
So we are having 5 minutes for discussion.
Yeah,
so
that is, especially I left it, so there must be many questions. So
excellent talk, sir. So my question to you, that refractory ascites patient require LVP very frequently, and they are very prone to have infections. So did you advise regular antibiotics for them, and when is the point when you refer them for tips?
See, this all depends on the center. The center who is very aggressively doing tips. In them, there is if they are requiring the LVP very frequently, then it is better that they send them for the tips if the facility is available. But in my case, I manage majority, 90% patients with the diuretics, midodrine, doing a repeated paracentesis. I don't send them for the tips.
So once they become refractory, so which diuretics you prefer?
Yeah, see, once they are refractory at a certain dose of diuretics. You come just lower to that and then continue them and look at the various factors. If they are receiving beta blockers, stop it. Measure the MAP. If the MAP is low, you can put them on the midodrine. And many times these patients will have SBP. So the major problem with the physicians or the gastroenterologists or hepatologists is they are sitting in OPD, they are hesitant in doing a diagnostic tap. This is a major problem. See, any time if a patient comes to you, you have to do a diagnostic tap. And in majority you will get the SBP. Maybe first time if you are not getting it, you look at again the response. If the patient is not responding, again maybe after another 5 days, you do a repeat tap, you will see the SBP is there.
Dr. Nijavan, please.
Yeah, nice talk, sir. Regarding hydrothorax, actually there are few patients with ascites, those who have hydrothorax. They have significant pleural effusion, and is always it on the right side or at times on the left side, and what is the preferred mode of treatment if they have associated significant hydrothorax?
See, there is no difference in managing in such a patient the hydrothorax. I manage them as I manage patients with the ascites, the refractory ascites, and majority of these patients will respond unless this is a pleural effusion which is infected, and in that case of course you have to take other measures. Otherwise a plain and simple, maybe we treat them like the refractory ascites only.
And there are few patients who come with a drain. They go to the periphery and somebody puts a drain into the thorax, into the pleura.
This is not done. See, if they put a drain into the pleural cavity, then it will be permanent almost.
Yeah, how to remove it? That is the problem, because it continuously drains.
You try to control the ascites. Treat it like as if this is ascites only. So if the MAP is low, build it up. If receiving beta blockers, stop it. Receiving NSAIDs, stop it. And then if there is infection, treat it. Treat the similar way.
So most of the hepatic hydrothorax do not have ascites. Most of the patients do not have ascites. They are having only hydrothorax.
No, so it is majority will have the ascites and they will have the pleural effusion hydrothorax also. But in the later stage, sometimes it may happen that the ascites has disappeared, but the pleural effusion is still persisting. But you treat them as ascites only. Because this is, the pathophysiology is almost same.
Sir, while tapping, the blood pressure fluctuates and goes down. You said you want to do large paracentesis. Up to which low BP one can tap? See,
this is a problem in these patients. When they come to you in OPD,
if BP is 90, 100.
If the MAP is low, this is almost 100% this patient is having SBP. You do a diagnostic tap, look at the ascitic fluid and then treat the infection. There is no cutoff that this patient is having a low BP, I will not do a diagnostic tap. Do a diagnostic tap. Not only that, if this patient requires therapeutic paracentesis, you can go ahead with the therapeutic paracentesis also, but under the albumin cover.
Thank you.
And when do you start midodrine? Do you continue that full dose of diuretics, standard diuretics, and then you start the midodrine? At what doses you start it till you achieve the full dose of midodrine?
See, these patients, the midodrine should not be started in the beginning. Once you are giving diuretics and they start developing the side effects, the hyponatremia is there, or these patients come with the SBP, treat SBP, and then stop diuretics, and then slowly these patients will improve, and then start the low dose of diuretics. Once they are tolerating that, and if they are not improving, they are again and again coming to you and there is hardly any improvement in the ascites control. That is the time, look at the map, add the midodrine and give full dose of midodrine. You can start with the 5 mg 3 times a day, and then of course you can slowly increase it.
Sir, in the case of CKD, patient on maintenance hemodialysis with combined decompensated cirrhosis, diuretics don't work in the cases of CKD on maintenance hemodialysis, and also the patients are already on multiple hypertensive drugs in which midodrine will be contraindicated. Already the MAP is high in those cases. So those with massive ascites and the refractory ascites, how do we manage in these patients?
It is a very difficult. They are having CKD, they are having decompensated cirrhosis, and this ascites is a combination of two. The best treatment is the liver transplant and the renal transplant.
Combined liver and kidney transplant, but those who are not affordable, we have to just carry on with the paracentesis every 2 weekly.
Dr. Viren, my question is very basic, back to basics. So sodium, I am always confused with sodium, how much to give. So 2 gram per day. So how do we calculate that 2 gram? Because if we say added salt 2 gram, then how much does a normal diet contain? And is it that 2 gram on the added salt or the normal diet added? And
this is not the added salt. This is a total sodium intake should be either at 2 grams or 88 millimoles or 5 grams of the common salt.
Better 5 grams common salt contains 88 millimole. So what about the diet already given, and how much sodium does contain? And are we giving more sodium than that because of the 2 gram we are adding?
No. We should not give. We should not give 88 millimoles, 2 grams of sodium or 5 grams of salt.
So 88 millimoles.
I think I will refer it to the APASL guidelines which we have published. Go through that, everything is given there.
Okay, and the second point, is there merit in reducing it to less than 88?
See, this is a problem. If you start using less than 88, he will not eat anything. There is no taste. So in that case, maybe you are temporarily able to control ascites a little bit, but ultimately his nutrition will suffer.
Thank you, sir.
Dr. Singh,
can I just
make a point?
Dr. Praveen, last question.
Okay. Dr. Singh.
Sorry.
Dr. Singh, just one comment and one question. Comment is that we had 2-3 patients of hepatic hydrothorax. We tried everything, all the diuretic dose didn't help, and we had no option but to put a chest tube in these patients, but the recurrence was very common, and possibly these patients finally might need tips or some maybe a liver transplant. The second question I wanted to know is that, do you do serum aldosterone levels in these patients with refractory ascites or ascites?
Yeah.
Do you check serum aldosterone?
I don't do routinely. Why should I do?
No, see, when we start with the diuretic, like
we are not doing it routinely.
No, when we give a combination of spironolactone and the furosemide, we know the furosemide acts by natriuresis. So there is lot of sodium delivered to loop of Henle. Now, if this patient has also secondary hyperaldosteronism, now this sodium will get back absorbed by the high aldosterone level.
That is the
so
point.
If we are increasing
we are always giving a combination of two. Never use the furosemide alone. That will not work, because whatever the sodium is going to the distal tubule, it will be reabsorbed. So you have to, the drug of choice is not the furosemide. The drug of choice is the spironolactone. But for the rapid action, we'll have to give combination, and to reduce the side effects, we'll have to give both.
Thank you, sir, for the excellent discussion. We are moving forward to the next talk. Rifaximin in cirrhosis, role and limitation beyond hepatic encephalopathy, by Dr. Neeraj Saraf. He is transplant hepatologist at Medanta Medicine.
Thank you, chairpersons. Thank you, Dr. Anil Arora, Ashish and Praveen for inviting me here. In the next few minutes, I'll be talking of the role of rifaximin in cirrhosis and what are the limitations beyond hepatic encephalopathy. I think this is a very carefully crafted topic because when I went through the literature, I realized that there are a lot of limitations. So there is a role, but with a lot of limitations when we talk of rifaximin beyond hepatic encephalopathy. So I'll talk of the pathogenic mechanisms of CLD, of rifaximin in CLD, what is the established role in recurrent hepatic encephalopathy, and the emerging roles or the roles with limitations like prevention of SBP, prevention of variceal bleed, reduction in renal dysfunction, some studies showing decrease in all-cause mortality when you use rifaximin, some effect on progression of fibrosis in alcoholics, what are the current recommendations beyond hepatic encephalopathy and what are the future directions. So this is the structure of rifaximin, which differs from rifamycin with an extra pyridol imidazole ring, and this reduces the systemic absorption to less than 1% after oral administration, and that is where, you know, that is the main point of rifaximin, that it is very little absorbed orally. But we must remember that in advanced liver disease, this is not true, and there is significant absorption in patients with child C cirrhosis. So how does rifaximin act in chronic liver disease or liver cirrhosis when we talk of encephalopathy as well as beyond encephalopathy? So it has an impact on liver fibrosis and portal hypertension. It affects the gut-liver axis and systemic inflammation, and it has effects on the gut microbiome. So let's first talk of rifaximin on liver fibrosis and portal hypertension. So there's preclinical data that rifaximin modulates the toll-like receptor 4 activation by lipopolysaccharides, thus resulting downstream in less fibronectin generation from activated stellate cells and endothelial cells. Rifaximin, through modulation of fibrosis and gut microbiota, could be expected to lower portal pressures, and there are studies showing that with the use of rifaximin, the portal pressures were lower at 4 weeks, associated with decreased plasma endotoxin levels. So there's preclinical and clinical data showing that rifaximin affects or improves the portal hypertension. What about the gut-liver axis? So we know that rifaximin helps in lowering the pro-inflammatory state in the liver. So if it has effect on microbiota, so if you look at the hexagon is the rifaximin, and it acts at various points. It has effect on intestinal bile acid biotransformation, effect on the gut microbiota. It decreases bacterial attachment and internalization, and it decreases a host of pro-inflammatory markers like NFK beta, IL-6, IL-10, decreases lipopolysaccharides, and hence helps in improving the pro-inflammatory state in the liver. Again, if rifaximin has effect on the gut microbiome, it has been seen that there are changes of microbiome composition of various bacteria, and these are sufficient to reduce hyperammonemia and endotoxemia in cirrhosis. Rifaximin decreases small intestinal glutaminase and increases cecal glutamine content, and probably therefore decreases ammonia production. So rifaximin can act by decreasing portal hypertension, by the gut liver axis, and by the changing the gut flora and the gut microbiome. Now I'll first talk of encephalopathy, and although that is not part of my talk, this is a landmark paper published in 2010 which showed that over a period of 6 months, treatment with rifaximin maintained remission from hepatic encephalopathy more effectively than placebo. So the time to breakthrough HE was significantly lower in rifaximin versus placebo, 21% versus 46%. And on the right side, the time to first HE related hospitalization was also significantly lower, rifaximin versus placebo. So we know that rifaximin prevents recurrence of hepatic encephalopathy. Now what about other indications? So rifaximin probably has a role on bacterial infections. It has a broad spectrum antibacterial action covering gram-positive and gram-negative aerobic and anaerobic bacteria. Rifaximin elicits its antimicrobial properties by binding the beta subunits of DNA-dependent RNA polymerase, thus inhibiting bacterial RNA synthesis. And this is probably, and this is a table showing its action on various bacteria, and this is the basis for using it for preventing spontaneous bacterial peritonitis. So let's look at data of rifaximin on preventing SBP. So this is a meta-analysis published a few years ago, which showed that rifaximin may be effective in both primary and secondary SBP prophylaxis in patients with cirrhosis and ascites compared to systemic antibiotics and compared to no intervention. So if you compare rifaximin with a systemic antibiotic like ciprofloxacin, and if you compare rifaximin with no antibiotics, it probably is effective against in both the scenarios. So this is a meta-analysis showing various studies, and most of these studies showed a favor of rifaximin when compared to other antibiotics, and also favor of rifaximin when compared to no antibiotics. But what we must remember and see is that most of these studies are retrospective, they are small, and there are very few randomized controlled trials comparing rifaximin with other systemic antibiotics. So this is a study which was published recently from PGI Chandigarh. This is a randomized a controlled trial. All patients who were followed for 6 months, with the primary endpoint being the development of incident SBP. In patients on primary prophylaxis, the occurrence of SBP was similar, but in secondary prophylaxis, SBP was significantly lower with rifaximin versus systemic antibiotics, 7% versus 39%. And patients receiving rifaximin as secondary prophylaxis also had fewer episodes of hepatic encephalopathy, but the overall 6-month survival was similar. So this is a good study from India, which shows that rifaximin is probably can be used more effectively as compared to a quinolone like norfloxacin with probably lesser side effects. And again, the same study showing that secondary prophylaxis was better with rifaximin, and hepatic encephalopathy was also better with rifaximin as compared to norfloxacin. So what is the current status of rifaximin in SBP prophylaxis? Well, conclusive indications cannot be given. Retrospective studies have shown benefit, but there are less consistent results with prospective studies and very few randomized controlled trials. So we cannot really, and I'll show you later that most guidelines till today don't recommend it in SBP prophylaxis. What about other complications of portal hypertension? So this is again a systemic review and meta-analysis of use of rifaximin in prevention of varicose bleed. And again, you can see that there are two types of trials in this meta-analysis, RCTs and observational studies. And in both, the use of rifaximin is favored in patients undergoing to prevent varicose bleed. But again, very few randomized controlled trials, very few patients, and this is an abstract which was published in the American Journal of Gastroenterology in 2022, still is not a full paper almost 1.5 years later. This is a paper showing the use of rifaximin in preventing all-cause mortality and admissions in patients on the liver transplant list. This is from King's College. And again, this paper showed that rifaximin prescribed for HE in patients listed for liver transplantation improved outcomes with significant reduction in admissions related to SBP, ascites, and varicose bleeding. So again, a paper, but again, not a large number of patients, and again, a retrospective study. And so this study showed that there was less varicose bleeding, less admission with ascitic complications, and less admissions with sepsis. Again, some small studies showing the use of rifaximin in preventing or decreasing acute kidney injury and hepatorenal syndrome. Again, small studies, most of them retrospective in nature. Some more studies of rifaximin. Again, this is on primary outcomes in the control of ascites. another study, large study by Kang et al., but again, retrospective study showing that rifaximin was associated with a lower risk of death in patients with, in the entire cohort as well as in patients with, in the non-HCC group. Now, this is an interesting study published in Lancet a few months ago, in which they showed that rifaximin can decrease the progression of fibrosis in patients with alcohol-related liver disease. So they had two groups. So they looked at per protocol analysis and intention to treat analysis. So it did not regress fibrosis, but it prevented further progression of fibrosis. And the group which got rifaximin actually had a more self-reported use of alcohol. So what they conclude actually is that in patients in whom you don't have abstinence, probably giving rifaximin can decrease the progression of fibrosis. And if you look at the table above, there was less fibrosis progression and less steatosis progression in patients who got the rifaximin group. So they conclude that it could be useful in patients who are actually non-abstinent because this group was taking more alcohol. So what are the current recommendations for use of rifaximin beyond hepatic encephalopathy? So obviously it's recommended in preventing the recurrence of HE. It is recommended on a case-to-case basis for chronic hepatitis, for chronic hepatic encephalopathy, but for SBP recurrence and for preventing other complications, actually it is not recommended in any guideline. And most of the data we have is not high quality RCTs, but mostly meta-analysis or systemic reviews. So even the latest Bavino guidelines say that rifaximin is not indicated beyond indication for hepatic encephalopathy, including primary or secondary prophylaxis of SBP. And again, EASL and ASLD also don't talk of rifaximin in anything except preventing hepatic encephalopathy. So just last slide, what are the future directions? So cirrhosis is characterized by, a sustained pro-inflammatory state and pro-oxidant milieu resulting from PAMPs and DAMPs from gut and diseased liver. The deep alterations in the gut-liver axis favoring translocation of PAMPs as well as viable bacteria have been the rationale for use of rifaximin. Rifaximin has direct effect on bacterial function and virulence, and it is not just bactericidal. So I think rifaximin has a future, but as of today, I think we don't have enough data and good quality data to suggest the use of rifaximin in indications except for hepatic encephalopathy. And there are trials going on, and these are trials in clinicaltrials.gov, which are ongoing right now. So there are a lot of trials on SBP, chronic hepatic encephalopathy, and in preventing complications on decompensated cirrhosis. So my take-home message is that rifaximin prevents complications of cirrhosis with impact on fibrosis, portal hypertension, gut-liver axis, and gut microbiome. Its indication is established and recommended in prevention of recurrence of hepatic encephalopathy. It may have a role in prevention of SBP, variceal bleed, and AKI/HRS. One paper showed that it prevents fibrosis in alcohol-related liver disease. It has shown in some retrospective studies to decrease all-cause mortality in patients listed for liver transplantation. But like I said, most data is not from high-quality, prospective, large randomized controlled trials, and at present, no guidelines recommend the use for any of these indications except for hepatic encephalopathy, and I think we need more data, better designed trials aimed at hard endpoints to establish its role in other indications beyond hepatic encephalopathy in liver cirrhosis. Thank you.
Thank you, Dr. Saraf, for an excellent talk. Because of paucity of time, we move on to the next.
No questions or questions?
So one question.
Okay, one question. Dr. Saraf, so you said that it is only indicated for treatment of hepatic encephalopathy and not even preventing recurrence.
No, it's indicated in preventing recurrence of hepatic encephalopathy.
So now, in preventing recurrence, how long do you give? what is the longest duration given, and what are the side effects of long duration So because that will impact my sort of clinical practice.
Well, so I mean that was not part of my talk because I was talking on beyond hepatic encephalopathy.
You are the expert here.
Yes,
who is
but I don't know. I don't think there's any recommended duration of rifaximin for preventing recurrence of hepatic encephalopathy.
Because preventing means then that patient will have sort of
yeah,
lifelong risk.
People have used it long term without too many side effects actually. But
So-
yes, we must remember, like I showed you in my earlier slides, it is systemically absorbed in patients with advanced liver disease, child cirrhosis. So we should be careful in those patients in giving long term.
Okay, so clinically we can sort of practice 6 months or so after achieve,
Easily,
and then sort of go
Yeah.
with that. Thank you.
Thank you, sir.
Thank you.
I'll invite Dr. Akash Shukla for his talk on treatment of non-malignant portal vein thrombosis and cirrhosis.
Good evening, everybody. At the outset, I must thank Dr. Arora for having me once again here for this wonderful meeting. So I'll be talking on non-malignant portal vein thrombosis. I'll be discussing the risk factors, diagnosis and classification. Then how can we predict portal vein thrombosis? How does it impact the natural history? What thrombophilia workup we do? When do we anticoagulate? What are its complications? How we handle them? And finally, when do we offer radiological interventions for opening up the portal vein thrombosis? And how do we do it? So portal vein thrombosis happens in cirrhosis because of multitude of reasons. The commonest being reduced portal flow, vascular endothelial injury, and altered coagulation profile, plus a host of other precipitating factors. The lifetime risk of portal vein thrombosis in general population from autopsy studies is around 1%. In compensated cirrhosis, across different studies, it has varied from 0.6 to 16%. In decompensated cirrhosis and HCC, it can be as high as 35%. In a longitudinal study, almost 28% of patients with cirrhosis, as they progressed, developed portal vein thrombosis. And the cumulative incidence of portal vein thrombosis in cirrhosis is 12.8% at 1 year, 20% at 5 years, and 38.7% at 10 years of follow-up. How do we diagnose portal vein thrombosis? So whenever you look at a report which says portal vein thrombosis, we should first be able to differentiate whether it is malignant or non-malignant, and if it is non-malignant, whether it is acute or chronic. So malignant portal vein thrombosis would be hypoechoic on ultrasound. It will show internal vascularity on Doppler. The contrast will show an expansile thrombus, which will enhance, which will show neovascularity and would be contiguous with the tumor. On MRI, it will show a T1 hypointensity, T2 hyperintensity, and enhancement on arterial phase in the T1 phase. Plus, it will be hyperintense on diffusion weighted imaging. While these characteristics will be absent in benign thrombosis. In benign, we need to differentiate between acute and chronic. Some features which will help you to differentiate is presence of collaterals and cavernoma that would suggest a significant duration. And on MRI, if it is a T2 hypointense, then it is likely to be chronic, whereas if it is T1 hyperintense, T2 hyperintense, it is acute. How does development of portal vein thrombosis impact the outcomes in liver diseases? So while there were initial data from Europe which showed that it does not alter the natural history of cirrhosis, the UNOS registry from 2002 to 2013 of over 66,000 patients demonstrated that while PVT was not associated with an increased risk of death or reduced chance of undergoing transplantation, there was little influence on prognosis by the Maruyama study, but in the Inglesby study, they showed that spontaneous resolution or unchanged appearance was the most common outcome of thrombosis. So this study, which was by from the UNOS database, looked at presence of portal vein thrombosis, absence of portal vein thrombosis, and amongst those with portal vein thrombosis, those who have undergone transplant or not transplanted. And presence of occlusive thrombus at the time of liver transplantation was associated with an increased risk of death at 30 days. So not only it caused increased morbidity and mortality in the waitlist population, but it also impacted post-transplant outcomes. But this was when occlusive thrombosis was included. If you look at the Maruyama study and the European study, the Philippine area study, it had included all thrombosis of portal vein, including the non-occlusive thrombosis. How can we predict that this patient is likely to develop portal vein thrombosis in a patient with cirrhosis? So you have major criteria and you have minor criteria. Major criteria are presence of CTP class B or C, prior history of resolved portal vein thrombosis, and presence of a thrombophilic disorder. And minor criteria are presence of portosystemic shunts, active hepatocellular malignancy, history of systemic venous thrombosis or abortions in women, recent abdominal intervention, portal flow velocity less than 15 centimeter per second, and clinical presentation with acute abdomen or worsening of portal hypertension in cirrhosis. If you have 2 major or 1 major and 2 minor or 4 minor criteria, it indicates a high probability of development of portal vein thrombosis. Most patients are asymptomatic. However, those patients who develop acute occlusive portal vein thrombosis, they may develop decompensation due to reduction of hepatic blood flow leading to ischemic liver injury. Although they have a hepatic artery buffer, and over a period of time the compensation happens. But because of this phenomenon, the early cirrhotics are more likely to be symptomatic than those who have got advanced cirrhosis. Once the portal vein thrombosis extends into SMV, it can cause bowel ischemia and abdominal pain. How do we classify portal vein thrombosis? There are different ways in classifying in terms of time course, recent and chronic, in terms of percent occlusion of the main portal vein, completely occlusive, partially occlusive, minimally occlusive, and cavernomatous transformation, and response to treatment or interval change, progressive, stable, or regressive. What thrombophilia workup do we do in patients who have portal vein thrombosis? These are the Boveno 7 recommendations. Various combinations of different risk factors for thrombosis can be present, so that identification of one risk factor does not deter from a complete workup. In all adult patients, myeloproliferative neoplasia should be searched for by testing for the V617F JAK2 mutation. In patients with undetectable JAK2 mutation, additional investigations for MPN should be sought, including calreticulin and the exon 12 mutation and next generation sequencing. In those who have got primary thrombosis of splanchnic veins without any biomarker of MPN, bone marrow biopsy is recommended for a diagnosis of MPN, irrespective of peripheral blood cell counts. And these were based on this study from Poisson et al., published in JHEP 2017, where they demonstrated that almost 5% of the patients will be detected by this additional testing with bone marrow biopsy, and around 7% will be detected on the NGS. Coming to management, anticoagulation in patients with portal vein thrombosis. Again, we go back to the Boveno guidelines. In the absence of cirrhosis, portal vein thrombosis resolves rarely, spontaneously, and therefore these patients should be anticoagulated. In recent EHPVO, because of the increased risk of heparin-induced thrombocytopenia, the use of unfractionated heparin is not generally recommended and may be only reserved for special situations. Start with low molecular heparin and switch to vitamin K antagonists when possible. DOACs can be considered as primary option in selected cases in the absence of APLA. Anticoagulation should be given for at least 6 months in all patients. After 6 months, long-term anticoagulation is recommended in patients with permanent underlying prothrombotic state and should be considered in patients without underlying prothrombotic state. If anticoagulation is discontinued, a D-dimer less than 500 1 month after discontinuation may be used to predict a low risk of recurrence. What will be the efficacy of such systemic anticoagulation? The recanalization rate, if the anticoagulation started within 1 week of the thrombosis, can be as high as 70%. If you delay it to the second week, it comes down to around 25%. But there's still some benefit if you start within the first 4 weeks of the thrombosis. The next issue comes whether you can do band ligation in a patient who is on anticoagulation therapy. And these are the 3 studies which have clearly shown that it is safe to do band ligation in patients who are on anticoagulation therapy without actually discontinuing the anticoagulation. So there is no need to stop the anticoagulation if you are planning band ligation in these patients. How do you manage these anticoagulation related bleeding? So for vitamin K antagonists, we can use PCC or we can use FFP if PCC is not available. For low molecular weight heparin, protavine sulfate will reverse most but not all the effects of low molecular weight heparin. It should be given within 8 hours of the last low molecular weight heparin dose. For dabigatran, if idarucizumab is available, it should be used, or you can use activated PCC. For factor Xa inhibitors, adixanate alpha is recommended. If it is not available, then we can use IPCC. What are the interventions in portal vein thrombosis that we can do? There are several percutaneous techniques of portal vein recanalization. Direct methods like transhepatic, transjugular, transclinic, transileocholic, or indirect methods like intraarterial infusion of thrombolytic agents in the superior mesenteric artery. Mechanical recanalization is the most effective method using either balloon angioplasty, or if the patient has undergone an angioplasty, then you can do a thrombus aspiration pulling by the balloon. And if you find that the portal vein branches are occluded, then TIPS is preferred over all other modalities, although it may be technically more difficult because you may not visualize a portal vein radical to be cannulated easily. So patients with cirrhosis who have portal vein thrombosis, splanchnic venous thrombosis, what is the data with TIPS? This was a study with 70 patients where recanalization attempted with using TIPS. 57% had complete recanalization, 30% had partial. The extent, de novo diagnosis and absence of varices, that means basically if it was a recent thrombosis, was the most likely predictor of recanalization. The risk of encephalopathy at 1 year was around 27%, and 1 month survival was 99%, and 2 year survival was 81% in these patients. So when do we offer these radiological interventions? These are the recent inasal portal vein thrombosis guidelines presented under the leadership of Professor Ajay Duseja at the recent inasal meeting. A multidisciplinary approach with early image-guided intervention, thrombolysis and surgical interventions should be considered in select patients at referral centers. PVR with TIPS improves outcomes of controlling refractory bleed as compared to recanalization without TIPS. PVR TIPS is recommended in patients listed for transplant with thrombosis of the portal vein trunk without recanalization on anticoagulation. Avoiding portal vein stent placement is recommended in patients undergoing TIPS if they are transplant candidates. Portal vein recanalization may be considered in acute symptomatic portal vein thrombosis with persistent symptoms despite adequate anticoagulation. And portal vein recanalization may also be considered in acute symptomatic PVT with persistent thrombus if the main PV is thrombosed despite anticoagulation, but the primary and secondary branches of PV are patent, even in the presence of mild symptoms. Patients with refractory complications of PVT or EHPVO should be referred to expert centers to consider percutaneous recanalization of the portal vein for other vascular interventional procedures. TIPS is more effective than standard therapy in preventing rebleeding and in recanalization portal vein thrombosis in cirrhosis without increasing the risk of hepatic enceph and adverse effects. TIPS PVR with embolization of varices may be done in patients with failure of standard therapy for varices. Last part, portal vein thrombosis and ACLF. What is the combination? Type A, where portal vein thrombosis precipitates ACLF. Type B, where ACLF develops in a patient who has got pre-existing PVT and chronic liver disease. And type C, where patient has developed ACLF and then develops PVT, usually within the first week of the ACLF. And of course, for each of these three, the aim of therapy is different. In type A, you have all attempts at recanalization immediately within the first week. Type B, you would give anticoagulation if there is no contraindication. And in type C, there is not much you can do, but once PVT develops, you have to treat it like type A. To summarize, my dear friends, portal vein thrombosis is often associated with thrombophilic disorders, and therefore we must really look for thrombophilic disorders in patients with cirrhosis also. The most acceptable and clinically relevant classification of PVT is by Northup et al., which is what is now recommended by the ASLD as well as by Bovino. Extensive thrombophilic workup is warranted, including next generation sequencing wherever indicated. Anticoagulation should be started immediately, and its complications must be managed promptly in patients with recent thrombosis. Radiological interventions are reserved for those patients who have portal hypertension complications or persistent symptoms or abdominal ischemia. These are safe and successful in expert hands, although they are not yet widely standardized. And PVT ACLF needs to be classified and managed on a case-to-case basis. Thank you very much for a patient hearing.
Thank you, Dr. Akash, for the elegant talk. One question I want to ask you. If a patient of child C cirrhosis and with PVT, and he is on the waiting list for transplant, would you like to treat him, or what treatment you should give? Bland PVT.
So I think if a patient is waiting for transplant and if it is a complete thrombosis, we would almost always want to anticoagulate this patient, even if the patient is child C cirrhosis, irrespective of the INR, unless the platelet count is really below 30,000. So if you look at the Tripodi paper, they found that if the platelet count is above 50,000, the thrombin generation is still sufficient. If the platelet count is above 30,000, it is still 80% of what it is of the normal. So at that level, you can still have a prothrombotic state. So unless the platelet count is below 30,000, I would almost always want to anticoagulate these patients, irrespective of the child's.
Good evening, sir.
Sir, my question is band ligation in patient with portal vein thrombosis in whom anticoagulation is going to be started, whether it is done for only high risk varices or in case of small varices.
You know, for band ligation in which you are trying to start anticoagulation, do you do ligation for all or only for high risk varices?
I think a very important question. So the current recommendations do not say that you have to do prophylactic band ligation. You can start the patient on beta blockers and go ahead with the anticoagulation. If you want to, if the monitoring is not going to be possible, you can do the band ligation for high risk varices, and you can start the patient on anticoagulation. You don't have to really wait for the varices to be eradicated, because you lose precious time and the thrombus will become organized and the efficacy of your anticoagulation will come down. In fact, if you start early, you will recanalize the portal vein, the portal pressure will drop, the portal hypertension will reduce, and actually the varices reduce in size.
So what is your take on drugs like apixaban and rivaroxaban in P?
So these DOACs are pretty useful, but again a word of caution, in CTP-A cirrhosis you can use them safely. In CTP-C they are contraindicated. In CTP-B you have to use them judiciously in much lower doses. Also, do not use them if the patient has antiphospholipid antibody syndrome. Do not use them if the serum albumin level is below 2.5. Do not use them if the platelet count is below 50,000. So I think those are the absolute rules which you must follow. Sir.
I just wanted to make a slight clarification on that point about child C cirrhosis and PVT complete. In a practical way, I have realized, in my practice with my surgical colleagues who are really, much more technically advanced, in cirrhotic child C with PVT, if they're going for transplant, we would not actually anticoagulate these guys, patients. Mostly they are sick patients, they have varices, risk of bleeding. And I've seen that they're more comfortable doing intraoperatively, declination procedures, and then put them on an anticoagulation post-operatively. So pre-operative anticoagulation in PVT, I think Akash,
I think
we are
so,
not doing it practically.
I understand, sir, where it is coming from. You are talking of a LDLT setting, whereas I am talking of a DDLT setting.
Right.
So in a DDLT setting, if I have a patient who has developed, who is waiting for a transplant, he is CTPC, he has portal vein thrombosis, I would always anticoagulate. But if the patient is going to get transplanted next week, it is a LDLT setting, then probably it is, you leave it to the surgeons to,
so I think
to
that
do a
makes it clear.
thrombectomy. So I think that is the difference between the two that we were talking about.
Yeah, great.
Thank you, sir, for the wonderful talk.
Thank you.
Next, we move on to the debate. Albumin infusion in decompensated cirrhosis, hope versus hype. Dr. Ruvina will be speaking for this topic.
Good evening, everyone. Thank you very much to the organizing committee for inviting me once again. And this time round, I'm given a task to talk on albumin infusion in decompensated cirrhosis, and I will be advocating the use of albumin here. So we are all very much aware that the usage of albumin is arguably the most important therapy for most of our liver cirrhosis patients. The benefits have been proven definitely in the setting of prevention of PICD in LVP, in SBP, and in AKI-HRS. But let's look at the evidence or role of albumin in long-term albumin. Let's look at the role of long-term albumin infusion in patients with decompensated liver cirrhosis. I'd like to talk about the ANSWER study. This is a study that was published in Lancet back in 2018. So this is a multi-center randomized open label trial which was conducted in 33 hospitals in Italy. The aim of this study was to look at the long-term albumin administration effect on overall mortality as well as management of ascites and incidence of complications in patients with decompensated cirrhosis. Patients were randomized into two arms. The first arm was the standard medical therapy who received moderately high dose of diuretics, whereas the treatment group received standard medical therapy with albumin infusion. So the albumin infusion was given in a manner of 40 grams twice weekly for the first 2 weeks, followed by 40 grams weekly for up to 18 months. So the key exclusion criteria for this paper was refractory ascites, ongoing alcohol abuse, as well as usage of albumin for treatment of ascites prior to enrollment. So looking at the results, those who received albumin therapy showed a significant increase in the mean serum albumin concentration, rising from 3.1 gram per deciliter to about 4 grams per deciliter within the first 2 months of the therapy. And this high albumin concentration was sustained throughout the study period. The primary endpoint of this study was an 18-month mortality. So the 18-month survival was actually significantly higher in the treatment group, about 77%, versus the standard medical therapy group, which is 66%, resulting in a hazard ratio, mortality hazard ratio of 0.62. What does this mean? When patients were given albumin therapy for 18 months, the mortality was reduced about 38% in this group of patients. When we look at the secondary endpoint of this paper, the management of ascites, you can see that those who received the albumin therapy, 62 of them were paracentesis free for up to 18 months, whereas only 34 patients were paracentesis free in the standard medical therapy group. With a hazard ratio of 0.48, this means there's a 52% chance of patients who receive albumin therapy for 18 months being paracentesis free. And when looking at the cumulative incidence of refractory ascites in this group of patients, obviously it was lower in the treatment group, with a hazard ratio of 0.43, which implies that there's a 57% reduction in the incidence of refractory ascites as long as these patients were getting albumin therapy. The cumulative incidence of frequent parasynthesis every month, meaning more than 3 parasyntheses per month, was also significantly lower in the treatment group. When you look at these other secondary endpoints, such as other cirrhosis complications, SBP, non-SBP bacterial infection, grade 3, grade 4 NCAF, renal dysfunction, HRS type 1, hyponatremia less than 130, hyper-K more than 5.5, was significantly lower in the treatment group. However, there was no difference in terms of bleeding in the both groups. The other secondary endpoint would be hospital admission. From this study, we can see that the incidence of hospital admission due to any cause, specifically liver-related cause, was much lower, and the total number of days spent in the hospital was also lower for the patients who received the albumin. So from this paper, we can conclude that patients were given weekly dose of 40 grams of 20% human albumin infusion for up to 18 months in decompensated cirrhotics with ascites who were also given moderately high dose of diuretics will improve 18 months of survival by 38%. There's also a reduction in the incidence of refractory ascites by 57%, and there's also a reduce in incidence of frequent monthly parasynthesis by up to 67%, and up to 52% of them can be parasynthesis free for 18 months. And also reduces all the other complications of liver cirrhosis except for GI bleed, and it definitely reduces the hospitalization rate and duration of stay. Another study that I'd like to highlight would be the Pascoli study, which was published in 2019. This is a single center study which was conducted in Padova, Italy. It is a non-randomized study, but it's a prospective study. And what's interesting about this is they recruited patients with cirrhosis and refractory ascites that was excluded in the ANSWER study. So the primary endpoint was 24-month mortality. Secondary endpoints were looking at the rate of hospitalization due to other complications of cirrhosis, looking at number of parasynthesis executed and the volume as ascitic fluid drained out monthly, and also looking for rates of asymptomatic SBP. So patients who were in the treatment arm were given human albumin 20 grams twice per week, as well as standard of care treatment. So when both groups of patients were admitted for a large volume parasynthesis, they were given albumin as per guidelines. So again, the inclusion criteria is of importance because this study, even though with small numbers, included refractory ascites, and the exclusion criteria would be HCC beyond Milan's criteria and severe extrahepatic diseases. Interestingly, no patients even though TIPS was not a contraindication, there were no patients who had TIPS in this study. So the results of this study shows that the amount of mean albumin that was given weekly to patients who got the albumin therapy was about 60.7 grams, whereas in the standard treatment group it was only 20 grams. The cumulative incidence of 24-month mortality was significantly lower in patients treated with long-term albumin administration compared to those who did not get it. So for those who received albumin, the mortality rate was only 41.6% in that group versus 65.5% in the standard group, and these numbers were statistically significant. Looking at the secondary endpoints in terms of ascites, again, there was a reduction, but it was a non-significant reduction, but nevertheless still a reduction in the numbers and the volume of parasynthesis was observed in the group of patients who were given albumin. Looking at the hospitalization rates for complication, all complications rate were definitely lower in the treatment group, but hepatic encephalopathy, ascites, SBP, and non-SBP infection was significantly lower in terms of statistics. Next, we'll look at the pilot Presocia study, which is a proof of concept, open-label, multi-center, non-randomized study, prospective study, phase 4, looking at the use of albumin in patients with decompensated cirrhosis without bacterial infection. The aim of this study was to get some preliminary results to actually design another study called Presocia study to look at the long-term effect of albumin approximately 1 year in the prevention of ACLF as well as mortality in the decompensated cirrhosis group. So patients were given albumin for 12 weeks and they either received low dose, which is 1 gram per kg body weight every 2 weeks, or high dose, which is 1.5 grams kg every week, and looking at the effect on serum albumin, plasma renin, portal pressure, cardiocirculatory function, as well as inflammatory markers. So the inclusion criteria here was decompensated cirrhosis and severe circulatory dysfunction, and most importantly, they are patients who do not have any infection. The exclusion criteria would be HRS, refractory ascites, and those with recent bacterial infection or even GI bleed. So when you look at the results, the average baseline albumin level was same in both the groups, but patients who received the high dose albumin was able to achieve and maintain an albumin level of 39.2 grams per liter, whereas it was much lower in the low dose albumin group. There's not much change in terms of plasma renin activity compared to the high dose and the low dose group. But looking at the IL-6 concentration, what is interesting is patients with high dose albumin started with a higher baseline compared to the lower albumin dose group, but the on-treatment average value was so much lower in the high albumin dose group. And the absolute change is significantly different in the high albumin group compared to the low albumin group. When you look at the other inflammatory markers such as VEGF, GSEF, and IL-1RA, all these had a lower levels of inflammatory marker at 6 weeks for patients who were given high dose albumin. Patients who received the high dose albumin had also achieved a higher mean pulmonary artery pressure, cardiac index, systolic volume, LV stroke work index, and they achieved a lower AST levels and lower child score levels as well. So the conclusion from this pilot study would be a weekly dose of 1.5 gram of albumin per kg of body weight for even 12 weeks in decompensated cirrhosis without bacterial infection and on moderately high dose of diuretics have been able to demonstrate that these patients are able to achieve a normal value and a sustained levels of serum albumin, which then results in reduction in child score, and it's also found to be able to lower the levels of inflammatory markers. Why is this important is because when patients are able to achieve sustained and normal levels of serum albumin, this actually results in reduction in inflammatory markers, which then gives rise to the improvement in clinical parameters. So in summary, I would like to say that long-term albumin infusion clearly has benefits, but we have to choose the type of patients who will benefit from this. So these would be decompensated liver cirrhosis patients with ascites and no bacterial infection. The small study by Di Pascoli also showed that even refractory ascites patients may benefit from albumin infusion, but the caveat is it has to be given in a high dose in a frequent enough manner, at least 40 grams on a weekly basis, given for a long duration of time. From these studies, we derived that at least 18 months. And this is so that patient is able to achieve a normal and sustained level of serum albumin in hope that it will improve the inflammatory markers and subsequently result in clinical benefit. With that, I thank you all for your attention.
Thank you, Dr. Rubina. Please join us. Now I invite Dr. Sanjeev Sehgal for against.
Thank you, Chairpersons.
I must say that albumin is an integral part of any hepatologist. We use it day in and day out, and all of us are extremely familiar with its benefits. So what are the uses of albumin in hepatology practice? There are established uses, LVPs, AKI, and hepatorenal syndrome, SBP, long-term albumin use, which Dr. Ravina just mentioned. Well, we'll discuss that part. There are possible uses, and there are potential uses. You could have, benefits of its hemostatic effects, cirrhotic cardiomyopathy, ACLF patients, albumin dialysis, and which I practice, which is a liver transplant setting. There is a given, set of patients who benefit post-transplant with the controlled albumin use. But where is the problem? The problem is long-term albumin therapy in decompensated cirrhotics with ascites. Now, these patients, should we be using albumin injudiciously, or should we be using it in a selected manner? So the debate here is that who needs albumin in that cohort of cirrhotic patients? That we must understand. So what is happening is there is a theory called filling the gap hypothesis. So you have this disease which is progressing. As your cirrhosis progresses, your pre-treatment albumin level comes down. Now these two lines, which are broken lines, they are the lower limit and upper limit of normal, which is 3.5 and 5 gram %. And this red line is what we try to achieve. We try to make it at a given level which is more than 3. And it is presumed that if you fill this gap, if you load this patient with albumin, your patient will do well. Now let me tell you why it is a myth. Now let us discuss 3 important trials. Now I am aware that we just heard about the ANSWER trial, but the most important trial which actually dispels the long-term use of albumin, which has just been published in NEJM, was not discussed in my previous speaker's lecture. That's the entire trial. Let me come to it straightway. Now this is a randomized trial of albumin infusion in hospitalized patients with cirrhosis, done from multi-center UK study from United Kingdom, published in NEJM. These authors had done a pilot before this also. So what was happening? In this study, nearly 777 patients with decompensated cirrhosis, they received 20% albumin for up to 14 days or until discharge of standard care. Treatment was commanded within 3 days following admission, and the composite primary endpoints were new infections, kidney dysfunction, or death between days 3 and 15 following treatment initiation. Majority of these patients had alcohol as the cause of cirrhosis. So let's see what was happening here. Now, a median total infusion of albumin of 200 gram per patient was administered in the target albumin group. What is the target albumin group? Target was to keep the albumin above 3 in these patients during the study period. And this was, we can see here, compared to 20 gram per patient, which was administered to the standard care. Now these standard care patients would receive albumin if they have SBP, if they have HRS, and so on. But the patient targeted population who were not having SBP, were not having HRS, were in the other group where they would be loaded with albumin to bring the albumin level above 3 and actually sometimes above 3.5. And this is what we see here, that the daily mean serum albumin level was definitely higher in the target population as compared to the standard control. So what's happening? It was interestingly seen that in the target albumin group, 113 patients out of 380, which is nearly 29.7%, they met the primary endpoint, while 120 out of these 397, which is 30% in the standard care group, met the primary endpoint. What it means? It means that the composite endpoints, incidence of new infection, kidney dysfunction, death, mortality at 28 days, 3 months and 6 months, everything was actually similar to the two groups, albumin or no albumin. So in a time to event analysis where researchers, they censored the data at the time of discharge or at day 15, they found no difference between the two groups. And actually more worrying was that there were more severe or life-threatening serious adverse events which occurred in the albumin group as compared to the standard care group. So what was these? There were a lot of events which happened in the albumin group. With the standard care group, they were actually much less, but most worrisome was the pulmonary edema and fluid overload which happened in those patients who continued to get albumin as compared to the standard care group. So therefore, these authors, they were very clear that one is that there is no benefit of targeted albumin. You want to keep it above 3, given for 2 weeks. This was not superior to the standard medical treatment in reducing complications or 3-month survival. And there were significant adverse events like there were fluid overload, pulmonary edema in the albumin group as compared to the standard care group. So these investigators, they clearly mentioned that albumin routine use in these patients in absence of SBP, absence of HRS, does not support its use in these hospitalized decompensated cirrhotics. Now let me come to one more study. Now this again is an elegant study. I think it's a wonderful study which is a multi-center randomized double-blind placebo-controlled trial done from Spain. Now these authors actually had a different study. They used midodrine and albumin as compared to albumin alone in patients who were actually sick, decompensated cirrhotics and may be needing liver transplant. And this was what they found. Well, when you give midodrine and albumin, you have this decrease in renin and aldosterone levels. But an interesting point was that the probability of doubling complications was similar in the midodrine and albumin group as compared to placebo. And if you also look at this part, the survival was similar in the midodrine and albumin group as compared to placebo alone. So again, the M.I.C.E study, it says that 40 gram albumin was given for 2 weeks regularly for these patients who were on wait list for liver transplant, did not show any benefit. Now this is a trial which we just heard, the ANSWER trial. I'll actually dissect it further and tell you why what these authors were published in Lancet does not hold true for our daily practice. We just heard that the multi-center trial, 2 groups. Important point to note was that albumin 40 gram twice weekly given for 2 weeks, then 40 gram weekly for 18 months. And a primary endpoint was 18-month mortality. So we have heard that the survival was better in this red line, which is the albumin group as compared to the non-albumin group. And the 18-month survival was 77% versus 66%, which was significant. And long-term albumin, which is also important thing to consider here, was that the standard medical treatment had higher incidence of death as compared to the albumin group. But I'll tell you what are the flaws in this study. Now, if you start comparing these trials, I would compare. Now, let me put ANSWER trial published in Lancet as the benchmark. It is published in 2018. And these other trials which have been published are from subsequent period, 2020, 2022. Now, these ANSWER trial actually had a major issue that the MELD at enrollment was much lower. It was for the albumin group it was 12 and the standard medical treatment was 13. Whereas in the study from Sola et al. From the Spain, the MELD was 17 and 18 in the 2 groups, which is albumin and non-albumin group. Other point was the number of patients undergoing liver transplant during the follow-up. Only 9% of patients actually had a liver transplant in the ANSWER trial as compared to 61% patients in the Spanish trial. Definitely patients in the Spanish trial were much sicker. And outcome according to the interventional treatment, which is albumin infusion, we had some reduced mortality in ANSWER trial, but those in this M.I.C.E trial, there was no effect on mortality or complications when albumin was given in these patients. Now, next important comparison I'll do between the ANSWER trial and the ATTIRE trial. Just to recapitulate, the ATTIRE trial is a UK trial, which is the one which I'm talking about, published in NEJM, and ANSWER trial is published in Lancet, which is from the Italian group. Now, we have just heard the various details of these trials. Again, the baseline MELD score was only 12 in this in the ANSWER trial as compared to 19.5 in the ATTIRE trial, the UK group of patients. Impact on survival, which was seen in the ANSWER trial, in this UK trial, there was no difference in the 2 groups. And the risk of pulmonary edema actually was there in these patients who were sicker and were receiving albumin in the UK group. So, possibility exists that albumin is less efficacious in patients who are sicker and have more severe liver insufficiency. So as you become sick, patients are sicker, it is likely that these patients have poor tolerance to albumin, have higher risk of pulmonary edema, higher risk of fluid overload, and may not be benefiting from this albumin regular routine use.
except if they have SBP, if they have AKI, HRS, and so on. Also, we must understand there are a lot of contraindications to albumin use. It is to be taken with caution that there are many patients who are allergic to albumin. It leads to fluid overload. Anemic patients have trouble with albumin, can precipitate coagulopathy and pulmonary hemorrhages if given rapidly in some patients. It is known that those patients who are severely anemic, you give albumin in a faster load, they can develop cardiac failure. And those who are on terlipressin, they actually have another unique problem. We may not have appreciated it in our practice, but if you are very careful, just look into this. Albumin will increase the preload, whereas terlipressin increases the afterload, is a vasopressor. And if patient has got some sort of cardiomyopathy, which is not obvious, these patients actually have a poor cardiac reserve and go into liver failure, cardiac failure. There are many unanswered issues with albumin use. The target population is not defined very well. Who needs it? The biomarkers are not there, which can say that, well, this is the best way to know if the patient is benefiting. What is the dose? How long to give? What is the frequency? When to stop? And cost effective. You must understand the cost of albumin west versus east is a huge thing. I will tell you in my own practice, sometimes the bill of a patient who's been in the hospital for 10 days, if you break it up, I've done it personally, albumin would contribute to about 20-30% of the total cost of these patients. So be very, very careful. So, what are the other things which we must understand in my concluding slide? We must understand that albumin use in a routine way in a cirrhotic who's decompensated, you just go on giving it just like that. It is very clear that it is probably less efficacious in patients who have more severe liver deficiency. So be very cautious when you're using it. There is no clear recommendation on the daily infusion rate and duration, how long to give. Potential complications with long-term use, we are aware of this. It can lead to pulmonary edema, heart failure. A lot of logistic issues with long-term therapy. Patients, there's a practice that people are giving it at home. I know many of my doctors, they say you can take it albumin at home only, which is I think not the right thing to do. There's a potential overuse and misuse of patients in non-oncotic benefits. There are lack of clear benefits which we have understood. There's a huge cost involved with albumin use, and especially if we are not sure of a benefit, why use it in any patient injudiciously just because he is decompensated cirrhotic? And also in our practice, I've seen that there's a huge variation in the drug standard between various brands. And I've seen that one brand is selling at a given price which is maybe 3 to 5 times the standard brand or the brand which is available from the market in some other resources. So we really don't know what is the right brand which we are using. Are we using the right thing or not? So in my opinion, there's always a right and a wrong way in our practice. We are very comfortable with using albumin. We know it is an integral part of our treatment, but should we be using in all decompensated cirrhotics in a long-term way injudiciously? I think that this has been hyped. We should not be using it in all patients except in those patients who have got typical indications like SBP, HRS, etc. So with this, I would conclude my talk, and I would really expect you to understand this use and see what you would do in your own practice. Thank you.
Dr. Sehgal, please join us. Dr. Rubina, any rebuttal? Debate?
Thank you, Dr. Saigal. So, as Dr. Saigal has elegantly compared all the studies, he has also done my job, because what I would like to say is comparing answer trial to attire, answer trial to M.I.C.E trial is like comparing apples to oranges. You clearly know the population group that were recruited for both these trials are different. Attire trial, M.I.C.E trial were clearly, they were sicker patients compared to the answer trial, and the amount of albumin given in both these groups were not sufficient enough, by knowing that the patients in the attire group and the answer group, attire and the M.I.C.E trial group did not achieve a substantial increment in the albumin level as shown by the answer trial. So, as Dr. Saigal has rightly put, not everyone should get albumin long-term therapy. It's not a blunderbuss treatment. It should be tailor-made. And so far, from the answer trial, we know that patients who will benefit from it would be cirrhotic with ascites who are not ill, who do not have ongoing bacterial infection, and these patients should achieve an albumin level of at least 40 grams, and this should at least 4 grams per deciliter, and this level should be maintained for a good time period. Thank you.
Well, I will tell you that the drug which is used most injudiciously in our hepatology practice is actually albumin followed by antibiotics. And I wish there was a way of finding out the right answer. I totally agree that albumin is a useful tool and we really have to use it in our patients. But I've seen that there is a practice that anybody who's cirrhotic, child B, child C, you give a weekly albumin. But how long you give? You really don't know. If you don't have a genuine benefit, then I think one should not use. Secondly, that we are aware that those who are sicker patients, you also agreeing to that, sicker patients who are really the ones who may be on the wait list for liver transplant, if they are not benefiting, then why should I use it just like that? So I agree that in my practice I use it if my patient has SBP, if the patient has got acute kidney injury, HRS, or there's some other need where I want to use it. But I've seen that many patients actually are getting it by the practitioners when there's no strong evidence. It has its own limitations. The cost is huge, and the practice of giving albumin on an OPD basis, patients if they come, they have to spend in the daycare time in daycare, and home albumin therapy certainly should not be done. So I think there are a lot of caveats to albumin use, routine albumin use, and I think we all are hugely experienced, and everybody will have his own opinion. But I personally would not use it routinely in decomp cirrhotics if they have no complications.
Yeah, may I make a few comments? Yes, comments are invited, but no question because this is a debate. Yeah, this is a comment only. See, regarding the use of the albumin, the M.I.C.E trial, there was a flaw in that trial. In that, initially they included 100 plus patients, and in that, only 9 could complete the total trial. In the end, majority of the patients underwent the transplant. So you cannot compare that. And the dose of albumin, as you said, was lower. The entire trial, again, the albumin was given only for 2 weeks. You should not compare it. In the long term or the complications, you cannot. The answer trial is the one. And see, but that is there is also a flaw that majority of these patients were not having refractory ascites. So the final answer is yet to come for the patients with the decompensated cirrhosis and ascites. Regarding the use of albumin, you will have to be very careful in if you are giving it for 20 grams of albumin over a period of 1 hour, this patient is likely to develop the pulmonary edema. See, you have to be very slow. Give it over a period of maybe 2 hours or 4 hours. If you are giving 40 grams, maybe at a time, you have to give it over a period of 4 to 6 hours. So you have to be very slow and do not advise the home albumin. Do not advise. People die at home. They may not inform you.
Dr. Sehgal, just 1 minute. Other than the oncotic use of the albumin, there is also a cardiac effect which can be there. So in patients with alcoholic cirrhosis, those who have cardiomyopathy also, the cardiac output increases, the mean arterial pressure will also increase. So that's an added benefit which can be achieved with the help of the albumin uses. So I don't think it's just to put it throwaway, it's additional things which are coming up which will have to be studied in greater detail.
So I'll conclude this wonderful session. Thank you all the speakers and hand over the mic to the audience.
Thank you all the speakers for such informative discussion and the debate, and thank you all our chairpersons and moderators for moderating the session. The next session is another interesting one based on endoscopic interventions, and the topic is endoscopic journey through the gut. For chairpersons, I would like to invite on the stage Dr. Subhash Bhattarai, Manipal Teaching Hospital, Nepal, Dr. Mayank Chugh, Chugh Hospital, Haryana, Dr. M.S. Paul, Fortis Hospital, New Delhi, Dr. Nirmal Yadav, Shri Ram Murthy Smarak Institute of Medical Sciences, Bareilly, and Dr. Prasann Bir Singh, Metro Hospital, Kathmandu. And for moderators, I would like to invite on the stage Dr. Munish Sachdeva, Sir Gangaram Hospital, New Delhi, Dr. Rahul Pathak, Nepal, Dr. Sharad Chandra, Meghraj Memorial Shrad Gastro and Liver Care Center, Jhansi, UP. Dr. Mahendra Agarwal, Agarwal Gastro and Liver Super Specialty Center, Sikar. And Dr. Roop Jyoti Datta, Dr. Damani Nursing Home, Dibrugarh. As we are still lagging behind time, so we still won't be able to take any questions post discussion. We are still have regret for the same. I would now request our chairpersons to kindly come on this to call the respective speakers on the stage.
At the outset, I thank Dr. Arora, his excellent team for giving me this opportunity, and I'm being part of this wonderful meeting. What I'm going to talk is not so rare, also not very common, but very difficult to treat. So duodenal carcinoids are 1 to 3% of all NETs in GI or pancreas. Usually they are solitary, usually are small, and usually they are detected while we do endoscopy. But they can be non-functional sporadic or can be functional. Most of the times what we see in duodenum, they are the gastrin producing sporadic small carcinoids or NENs or NETs, and they are smaller than 2 centimeter. They are limited to mucosa and submucosa mainly, but they do have lymph node metastasis potential to the tune of 11 to 50%, and they do have some metastasis potential. Somatostatinoma is another one which happens in second part of duodenum, near or at the ampulla. Usually they are bigger, they have a higher metastatic risk, and even if they are small, they have a higher lymph node metastasis risk, and that's why they are important. Another one is gangliocytic paraganglionoma. If you have it, it's the best one because it runs a relatively benign course. If the patient is unfortunate, then they can have poorly differentiated neuroendocrine tumor, which fortunately is rare but very advanced tumor. Functional duodenal NENs mainly are the gastrinomas. They are sporadic, they are gastrin producing, they are associated with ZES, that is Zollinger-Ellison syndrome, mostly located into proximal duodenum. Most of the times they are well differentiated, slow growing tumors, but they have a very high metastatic potential to the tune of 50%. Even if they are small, they have lymph node metastasis, and many a times when we investigate this patient, we see a large paraduodenal lymph node, or we think it is pancreatic NET, but actually it's a gastrinoma into the duodenum which has metastasized into the lymph node, and that is giving that appearance. It can be a part of gastrinoma, can be a part of MEN1, where you have parathyroid and anterior pituitary gland involvement. It happens into 20 to 30% of them. They can be multiple, again, higher lymph node metastasis, higher metastatic potential. Again, slow growing tumor, so 10-year survival is 60%, and they rarely secrete serotonin, so carcinoid syndrome is not common. So how do you work them up? You find it in endoscopy, get a gastrin done, get a chromogranin done. EUS is must in duodenal carcinoid because you need to see what is the depth, what is the characteristic, and you have perilesional lymph nodes or regional lymph nodes or not. CT is again important, again to see whether these patients have lymph nodes. DOTA is should be done if they have a higher risk of metastasis. What are these lesions? They are the lesions having size more than 2. They have muscularis propria involvement. They have G2, G3. That is, we know that the Ki index and the mitotic index is higher. So if you have G2, G3, you have to do DOTA scan. If you taken biopsy, there is lymphovascular invasion, all lymph nodes on CT scan, and all gastrinomas need a DOTA scan examination. How do you treat? Once you find it out, you have to take it out. And how do you take it out? Depending on size, depending on what the invasion is, if it is mucosa, submucosa, muscularis propria, whether they have lymph nodes, whether they have lymphovascular proliferation. So whether this lesion has a low chance of metastasis or high chance of metastasis. Low chance of metastasis, small lesion, we can do endoscopic resection. But if it is bigger lesion, surgery, and big lesion with low chance of metastasis, then probably endoscopic resection in form of endoscopic submucosal dissection. However, if they have high chance of metastasis, meaning they have a G1, G2, but angio invasion, lymph node involvement, or G3, you have to do a oncosurgical resection. This patient should not go for surgery. Ampullary entities are different than other duodenal entities in the sense that they are high grade, they have a higher chance of metastasis, small lymph node metastasis, and lower survival. And the things are different. So you can do endoscopic therapy only in G1 mucosal or submucosal lesion. Otherwise, this patient should go for surgery. So ampullary is different, higher chance of metastasis. Gastrinoma is multifocal thing, meaning that it needs surgical resection, but you have to treat Zollinger-Ellison syndrome with high dose of PPI, and many of these patients, straight away patient present with comorbid metastasis, and there probably you can't do anything and you have to do a palliative therapy. If it is a part of M.I.C.E syndrome, extensive surgery if it is possible or can be done, and if it is hyperparathyroidism, you have to take out 3.5, so just keep a half of the parathyroid out of 4 parathyroid, and that is what you need to do. What are the endoscopic management of duodenal? One is conventional EMR, modified EMR, ligation. So you just ligate and leave it alone and let the tumor run its own course. But the problem is you can't get the histopathology, and you can have delayed bleeding or delayed perforation with that. And of course, endoscopic submucosal dissection. End block resection. I'll take this slide later. EMR for duodenal entity is the simplest one, but you cannot do conventional EMR for duodenal carcinoid, meaning put saline, elevate the lesion and cut it with a snare. Why? Because these lesions are mainly submucosal. You do it, you cut across the lesion and the half of the tumor remains there. So what you need is something called band EMR, where you apply a band. So this is a video, you can see carcinoid not involving muscularis propria. This is the carcinoid just at and beyond the pylorus. So band application with the esophageal band ligation device, and you can see that it has become brown after band. You go beneath the band and you cut it. That's the safest way to do it. Once you cut it, you observe the defect. As you can see over here, you can see the muscle, duodenal wall is thick, so always close it. And how we close it? By simple clips, or sometimes you have to use an over the clip device, over the scope clip device to cut it, to close it. So end block resection is good. Problem is R0 resection, which can be anything between 60 to 90%. But the best thing is, even if you have a positive free margin, they usually don't have a horrible course as other lesions. What about ESD? End block resection is higher than EMR. R0 resection can go up to the tune of 100%, but the problem is high rate of perforation and bleeding. So again, this is D1 just at the pylorus and beyond the pylorus in D1. So you mark it out, do dissection at the distal margin, do a circular, go from the distal to proximal, so anal to oral, and then start from the oral side and do a dissection. As you can see, very difficult lesion because it's at the pylorus and just beyond the pylorus, and then you do endoscopic submucosal dissection and take out the end block tumor, as you can see over here. And now we have another method which is called EFTR, where the R0 resection will go up to the tune of 100%. This is a D1, D2 lesion. You can see ampulla. We have to be cautious when we are doing EFTRD in this kind of, because you cannot take ampulla with it. Because the device is too big, you have to do dilatation both at the cricopharynx and in pylorus, has to be passed over the wire, and then you have to grab the lesion, gentle suction, and the snare is applied. Along with the snare, you cut the lesion. Resection rate to the tune of 100%. Best thing about it, it's a full thickness, so chances of perforation are less. It can be used as a salvage procedure if someone has done EMR and the tumor is left inside, or ESD and the tumor is left inside. This is the method of to go. So I'll take the previous slide, which unfortunately had come there. So if you compare all the series of endoscopic treatment, you can see end block resection is good to the tune of 80 to 90%. Problem is the problem is R0 resection, which is like margins are positive to the tune of 30 to 40 and sometimes 60%. Fortunately, even though the margins are positive, the recurrence rate is not high, and that's why endoscopy treatment will remain as primary modality to treat this sort of lesions. If I want to summarize, when would I do band EMR? If the lesion is less than 10 millimeter, it's in first part of duodenum, my treatment of choice, and if it is mucosal, mucosa or submucosa, I do band EMR. It's quick, fast, very easy. Problem is positive pathological margin, but as I told you, recurrence is not high. ESD, if the lesion is anything between 10 to 20 millimeter, first or second part, preferably with the first part of duodenum. Mucosa or submucosa, again it should not be muscularis propria invasion, then I'll do ESD. When I will do EFTR, if the lesion again is 10 to 20 millimeter, I am not sure whether the muscularis propria is involved or the muscularis propria is involved, but there is DOTA is not showing any lymph node involvement, DOTA is not showing any metastasis, then I'll do EFTR. And there is also one study which compared endoscopic resection, surgical resection, either the laparoscopic local resection or pancreatoduodenectomy. What it showed that pancreatoduodenectomy was associated with good resection but with a higher morbidity. ER had higher positive resection but less complications. So as I told you, my first modality is endoscopic resection if the lesion is mucosa or submucosal. So to summarize, duodenal entities are not very rare but also not very uncommon. Most duodenal entities are detected when we are doing endoscopy. They have to be resected. EUS is must because it is important for treatment planning. Endoscopic resection is preferred for small entities less than 1 centimeter or can go up to 2 centimeter if there are no high risk of metastasis. Ampullary is a different ball game. One should do ampullary resection only if the tumor is G1 and it is mucosa and submucosa. Surgery is preferred for larger lesions, lesions having higher chances of metastasis, ampullary lesions which are more than 1 or maybe more than 2 centimeter, all functional duodenal entities like gastrinoma. But many a times this gastrinoma and entities, they present with advanced disease with many comorbidities where we can just provide palliative care. Thank you very much.
Thank you, Dr. Nile, for a very brilliant presentation. The next speaker will be Dr. Amol Bapai, and I have a very humble request from the audience. As told to me by the organizers, in view of the time constraints, it is requested that we ask the questions from the speaker after the meeting, after this session.
Good evening, and thanks to Dr. Arora and his team for this invitation to share our thoughts about large colonic polyps. So Dr. Arora wanted me to talk about large colonic polyps, and particularly on this question as to are we stretching the boundaries of endoscopic resection. So we know that colorectal polyps, this is the Paris classification, we may have the type 1 or the type 2, and the type 2 are further, they might be flat or depressed. And endoscopic resection of colonic polyps, we know that polypectomy is the standard for pedunculated polyps, and that's a no-brainer, and we're not going to be discussing that further much in this talk. But whenever we're talking about flat or sessile polyps, EMR is usually the way to go for lesions up to 2 centimeters, and a piecemeal EMR or an ESD for larger lesions. That is how it is. The risk of cancer in colonic polyps increases, as we all know, as the size of the polyp increases, and lesions more than 15 millimeters, the risk is significantly higher. It goes up to 18% and then even up to 75% when even larger lesions, and that is what is important. At the same time, we need to understand that in early colorectal cancer, if we compare the 5-year survival of endoscopic resection versus surgery, it is very much comparable. So for early colorectal cancer, 5-year survival rates are above 90% in both, whether we treat them endoscopically or surgically. And this was actually a study which compared surgery versus endoscopic resections, ESD, for early colorectal cancers. And we can see that both the groups were quite comparable. And in terms of the short-term outcomes, we can see that the procedure times, post-operative stays, and everything, most of them are comparable. Short-term complications were also much lower in the ESD group. And performance indicators wise, what they mentioned was en-bloc resection and R0 resection, perforation and lead bleeding. These were the parameters that were assessed. And the results showed that the results were very much comparable, and endoscopy was superior in short-term clinical outcomes as compared to surgery. Also, the length of stay was superior in endoscopy, and adverse events were also lower in the endoscopy group, although that was not significant. If that is the case, is that all that we need to discuss about? Because the question was, are we stretching the boundaries? And obviously it shows that probably endoscopy is as good, if not better. But it's not that simple. When we look at the surgical anatomy, we know that cancer arises at the mucosa on the surface and burrows deeper. And it is actually the 1000 micrometers or the microns distance or the depth which becomes very significant, because the submucosa is further divided into SM1, 2 and 3 layers. The lymphovascular plexus resides in the SM2 layer, and that typically corresponds around 1000 microns. And if the tumor is infiltrating deeper than 1000 microns, then the chances of lymphovascular embolization and infiltration is much higher. And as we can see over here, the risk of lymph node invasion goes up if the tumor is infiltrating into the SM2 layer. And therefore, true early cancers are those which have penetrated not beyond the SM1 layer. And that is the reason depth of lesion infiltration is the most important consideration, because the incidence of lymph node metastasis increases as the depth goes deeper and deeper. And that is a very important consideration that we have to make when we are choosing patients for endoscopic resection. Therefore, whenever we are looking at colorectal lesions, we can perform an EMR for very surface lesions, probably an ESD for early cancers, and surgery for those cancers which are more invasive and which have gone deeper into this thing. So this classification and this distribution is quite clear. And therefore, prediction of submucosal invasion becomes the key to selecting optimal candidates when we are looking at selecting these patients. There are two classifications, the NICE classification, which describes which patients can be taken up for endoscopic resection, as well as the JNET classification, which is currently considered as a standard. And in this, the type 2A and B are considered the ones which are suitable for endoscopic resection. The other component that we need to look at is that majority of the endoscopic resections, they are always preferable to be performed as an en bloc resection, because by performing an en bloc resection, we have a better chance of achieving a curative resection. Also, the pathologist can opine on the specimen in a much better manner and assess the specimen and assess the risk for lymph node metastasis in a much better manner. The recurrence rates after an en bloc versus a piecemeal resection also show that en bloc resection rates provide much better outcomes. So there are basically two techniques, and I don't want to discuss show too much of the video of this thing. One is the piecemeal EMR. This is on the left hand side. We can see that using a snare we can elevate the lesion and then in a piecemeal manner resect the entire specimen. Whereas in an ESD we are actually performing submucosal dissection to lift the lesion off and dissect it off from the submucosal, from the muscle layer. And ESD is necessarily always an en bloc resection, whereas EMR can be a piecemeal or very often a piecemeal for large lesions, and up to 2 centimeters it can be an en bloc. So that is how it is. So the ideal endoscopic resection technique has to be cost effective. It needs to give us a high en bloc or a curative resection with an acceptable risk profile, reduced recurrent intervention, and one that can avoid surgery. And neither EMR nor ESD completely fulfill these criteria at the moment. And why is that? Piecemeal EMR has its limitations because only up to 2 centimeters we can provide an en bloc resection. Beyond that, it can, it needs to be piecemeal. And somewhat it can be a blind procedure because the peripheral margin can be compromised, and that may be evident only on the histological specimen. Also, diathermy artifacts at the resection margins makes the pathologist assessment difficult, and assessment of the specimen becomes difficult. The plane of dissection is also relatively superficial in the SM1 layer often, because of which one can have more recurrence rates, and that is what we know, and that can necessitate more frequent follow-ups and re-interventions as may be required. So the concept of ESD developed from EMR because of the need of an en bloc resection, and whenever we were trying to resect larger lesions, and because the recurrence risk was higher with piecemeal, and because the pathological diagnosis was not confident enough, that we started performing ESD as compared to EMR. Although ESD gives us improved en bloc resection rates, but in the colorectum, the problem is that the colonic wall is thin. There is a higher risk of perforation as well as a delayed perforation, and positioning and maneuvering the scope and visualization also can sometimes be difficult, except for the distal rectum where it is relatively easy because it is extraperitoneal and has a thicker wall. So the recent Japanese guidelines very clearly demonstrate which lesions should be resected by EMR or by ESD. And this is the list, but what I would like to point out is that there are certain salient features which are important, that pre-endoscopic resection assessment is very important, and one should not be performing a biopsy for lesions that are going to be subjected for an endoscopic resection, because there is a higher risk of fibrosis and the biopsy may not be representative as well. ESD is the procedure of choice for larger colorectal lesions because that is the best chance of an R0 resection, and it is the preferred option for the non-granular variety more than 2 centimeters and granular variety up more than 3 centimeters, and lesions which are involving more than half the circumference. And even if for an EMR, even if we are performing an EMR, whenever there is a depressed area, one should never perform an EMR, a piecemeal resection in that area, because that can harbor cancer. The Achilles heel, however, of all endoscopic resection techniques currently is to correctly identify submucosal invasion, And despite the JNET classification being the standard of care currently, it is not foolproof and has an accuracy only of about 80%. And it has to be considered along with other factors like spray endoscopy, the non-lifting sign or a lifting sign, and the size and location of the lesion. And this systematic meta-analysis demonstrates that ESD results, outcomes of ESD are far superior to EMR, particularly piecemeal EMR for large lesions. Similarly, another meta-analysis shows that en-bloc resection rates as well as R0 resection rates are superior with ESD, and local resection rates are also favoring ESD. However, the procedure time and procedure related adverse events in these two groups, EMR scores over ESD. And an important factor for all of us to remember that rates of, success rates of ESD are far superior in Asian countries as compared to non-Asian countries for factors probably which we can discuss at a later time, not in this discussion. But that makes endoscopic resection a very feasible option for many of these patients. Therefore, when we are talking about large colorectal polyps, the curative resection rates by en-bloc endoscopic resection and surgery are comparable, whereas en-bloc endoscopic resection rates usually will have reduced procedure times and length of stay, and it is relatively less invasive as compared to surgery. However, endoscopic resection is comparable or superior to surgery only when the patient selection has been appropriate, absence of deep submucosal invasion has been confirmed, and en-bloc endoscopic resection can be achieved, and it can be achieved safely. This review article by Nori Ofukami in this GI endoscopic clinics actually describes this very clearly. Whenever we have a large colonic lesion, a detailed examination with advanced imaging either at the primary or at a referral center should be performed. When there are no concerning features, an EMR can be performed, but if there are any concerning features, an ESD should be performed, and whenever there is a suspicion of deep submucosal invasion, a surgical consult should be performed. And therefore, friends, to answer the question, are we stretching the boundaries? No, we are not stretching the boundaries. There is a definite role for endoscopic resection for carefully selected polyps. However, accurate lesion characterization and refinement of en-bloc endoscopic resection techniques needs to be implemented to achieve good outcomes. Thank you so much.
Thank you, sir. And now I'll call upon the next speaker, Dr. Ajay K. Jain. He will be talking on pre-op biliary decompression, indications and limitations.
Thank you, chairpersons. At the outset, I would like to thank Professor Arora, Professor Ashish, and Professor Praveen for this wonderful invitation for this meeting. I bring you the greetings from the cleanest city of this country. The preoperative biliary decompressions is a very controversial topic. As we know that there are benign causes of obstructive jaundice and malignant causes of obstructive jaundice. We all know as an endoscopist we can treat all obstructive jaundice and benign causes. But the controversy is regarding how to manage obstructive jaundice and malignant causes, because if it goes to an endoscopist, he would like to do a stenting. If it goes to a surgeon, he would like to do a surgery. But where is the line where one should refer to the other? And the reason for this thing is that obstructive jaundice leads to a high degree of morbidity and mortality in patients who undergo surgery without the decompression. Earlier studies have shown that almost 16 to 18% of patients have a mortality following a surgery in patients who have a high degree of jaundice. This paper, published in Annals of Surgery way back in 1935, suggested that patient cannot survive a major operation until the associated condition of obstructive jaundice was relieved. They devised a pancreatoduodenectomy, that is Whipple surgery, in two stages. The stage one was cholecystogastrostomy to relieve the jaundice, and almost after 4 weeks, they did the pancreatic resection for the adenocarcinoma and the results were better. This particular paper published in American College of Surgeons journal suggested that severe jaundice increases morbidity and mortality with long-term survival after pancreatoduodenectomy being reduced significantly. Therefore, there was another paper which was published in Anesthesia journal, and they suggested that surgery was a very challenging subject while giving anesthesia in patients who have severe jaundice. And this was not only a challenge for the anesthetist, it was a challenge for intensive care unit team also following the surgery. So the question is preoperative biliary drainage necessary for patients with jaundice? And what is the optimal interval for preoperative biliary drainage? And what method is most appropriate for preoperative biliary drainage? I will be concentrating only on the question 1 because that has been the task given to me. We know that there are a large number of pathophysiological changes which are caused by obstructive jaundice, which ultimately leads to increased morbidity and mortality. And these changes are coagulopathies, infections, systemic endotoxemia, renal dysfunction, effect of jaundice on cardiovascular system, effect on the metabolism of drugs given during anesthesia, nutritional deficits, sometimes hypotensive shock. And all these leads to a multi-organ failure in perioperative period. These obstructive jaundice also lead to hepatic injuries, and this hepatic injury is due to endotoxemia, infiltration by inflammatory cells, microvascular perfusion failure, activation of toll-like receptors, increased circulation of TNF-alpha, IL-6 and IL-1 beta, and these ultimately leads to hepatocellular necrosis, bile duct epithelial cell proliferation and liver fibrosis. There is an increased chance of infection because of obstructive jaundice, and this is because that cholestasis leads to bacterial proliferation and bacterial translocation into the circulation. The absence of bile salts in the intestinal tract follows the increased proliferation of resident gut microbiome. And these microbiome, because of the dysfunction of hepatocytes and reduction in hepatic blood flow, resulting into a downstream effect on immune cell functions. There is a mucosal cell dysfunction, mucosal barrier dysfunction, which leads to translocation, endotoxemia. Further, there is a reduced bile and pancreatic secretion, leading to exacerbation of malnutrition, which ultimately increases the chances of infection and endotoxemia and sepsis. We all know that there is a malabsorption of vitamin K, which leading to a decreased synthesis of factor 7, 9, 10, and this leads to increased chances of bleeding. But however, this is a reversible phenomena and can be corrected before the surgery by just vitamin K intravenous injection. There is a significant chance of kidney injury due to obstructive jaundice. As far as 6 to 18% of patients in post-operative period presents with renal failure. This renal failure patients, about 8 to 10% of these renal failure patients may ultimately lead to a mortality which may be as high as 70 to 80% in post-op period. So post-operative creatinine clearance is significantly decreased in these jaundice patients as compared to jaundice patients. The factors responsible for kidney injury in these patients are because of depletion of extracellular fluid, myocardial dysfunction, hypotension, sepsis, hypoproteinemia, hyponatremia and hypokalemia. At present, it is believed that damage to the normal function of the circulatory system and decompensation of circulatory system is also a factor responsible for renal failure. Cardiovascular function in jaundice patient is depressed. There is a decreased responsiveness to vasoactive substance such as alpha and beta adrenoreceptors, and angiotensin II stimulation is also blunted. And even these drugs to improve the minimal arterial pressure is not working in these patients. And these factors reduce the blood flow and they damage the renal function further. Obstructive jaundice does affect the circulatory system. In a dog model, it was reported that cholemia may impair the left ventricular performance. It was further reported that serum from cholestatic rats to cultured myocardial cell reduced the beating rate. It caused an early cessation of beating and increased production of lactate in the media. Bradycardia was also observed in these patients. And the term jaundice heart, which is ascribed to the hepatic cardiomyopathy, leads to altered beta-adrenergic receptor signaling, membrane fluidity, downregulation of cardiac beta-adrenoreceptor density, peripheral vascular resistance is decreased, blood pressure is declined, and blood vessels become insensitive to endogenous as well as exogenous stressors in obstructive jaundice. And therefore, the concept of preoperative biliary drainage became a reality, and people started questioning, is it necessary for patients with obstructive jaundice? There are certain definitive indications of preoperative biliary drainage. If patient requires a relief of symptomatic jaundice, especially patients who have cholangitis, sepsis, and septic shock, there is no contraindication. The first thing one has to do is to do a preoperative biliary drainage before patient is subjected for surgery. If patient cannot be subjected for surgery but is a candidate for neoadjuvant chemotherapy, then also patient needs a preoperative drainage, because patients can only be given the chemotherapy once the bilirubin level comes back to normal. For some medical condition, if surgery has to be delayed to optimize the patient, then also a preoperative biliary drainage is a definitive indication. But the problem is, if the patient has a resectable tumor and you have to decide whether this jaundice patient should be subjected for a preoperative biliary drainage or patient should be sent straight away to a surgeon. This paper looked at the preoperative percutaneous transhepatic biliary decompression in about more than 4,000 patients, and this study concluded that after the preoperative biliary drainage, hepatic function returned to normal. The time gained because of the relief of bilirubin can be used for adequate preoperative preparation for the patient. Use of this technique make it possible for operative treatment of obstructive jaundice into a two-stage procedure, with the first stage being the percutaneous or an endoscopic transhepatic biliary decompression. It lowers the operative morbidity in these patients. These findings suggest that biliary stenting is appropriately indicated before the pancreatoduodenectomy or Whipple surgery in patient with distal biliary obstruction or in the proximal biliary obstruction. Another study published in 2015, 1200 patients, median follow-up of 21 months. The operative mortality was about 4%, and they found, but there is a negative relationship between survival at 12 months or later and higher rates of bilirubin. Presence of biliary stent did not influence early or long-term results, and this study concluded that severe jaundice increases early severe morbidity and decreases long-term survival after the pancreatoduodenectomy for pancreatic adenocarcinoma. Pancreatobiliary drainage was not associated with increase. This study, which was published in 2022, suggested that preoperative biliary drainage is not associated with 30-day mortality or major morbidity, but it increases the surgical site infection, and preoperative drainage should be limited only to the symptomatic profoundly jaundiced patient or those with a delay prior to pancreatoduodenectomy. Therefore, the mantra of selective biliary drainage remains valid. Surgeons should stay vigilant with wound complication in the post-operative course of stented patients. They found that INR, it is not the bilirubin, but it is the INR which predict the post-operative morbidity in patient with malignant obstructive jaundice, and INR is the suitable predictor for post-operative outcome, while serum bilirubin levels had no predictive value. The current trends for the preoperative biliary stenting in patient with pancreatic cancer, because the stenting rate has doubled in last 2 decades, the majority of stenting occurred prior to surgical consultation, and it is associated with significant delay in time to surgery. Stenting will remain a common practice, but we have to recognize increasing rates of complication associated with stent placement, and we should analyze the risk-benefit placement. What is the optimal interval of preoperative biliary drainage? There are no guidelines, there are no studies. Aim is not only to decrease the bilirubin, but to improve the nutrition, renal function and control the infection. Once a drainage has been done, operation should be performed at least after 4 weeks to decrease the risk of severe post-operative complication with no fear of disease progress. So ladies and gentlemen, carry home messages that not all patients of obstructive jaundice are candidate for surgery who require a biliary drainage. Select group of patients with severe jaundice, almost more than 10 to 12 mg/% are the one who can be benefited by preoperative biliary drainage. But in these patients, post-operative surgical site infections are more common. A prior surgical consultation before the drainage can help in avoiding unnecessary biliary decompression prior to surgery. Thank you very much for your patient hearing.
Very nice lecture, Dr. Ajay. And now, since there is a time limitation, I will invite the next person. The next person is somebody is still landing, so we will go on to. I will request Dr. Sadavati to come for the lecture. Salapati Rao Vakchenta.
Good evening, everybody. At the outset, I would like to thank the organizers, Dr. Anil Arora sir and his team. So the topic allotted to me is the small bowel enteroscopy, have we conquered the frontier? So we know that small intestine is a long convoluted tube with a lot of mesenteric attachments. It is composed of duodenum, jejunum and ileum. Jejunum is of proximal to 2/5 of the small intestine and the ileum is distal 3/5 of the intestine. So for many decades it has become a very enigmatic area and it remained in darkness for all means of explorations. We used to depend on the intraoperative enteroscopy or a diagnostic laparoscopy, or for that matter in any patients with undiagnosed occult GI bleeds, extended right hemicolectomy used to be the diagnosis, so which is very difficult to accept because of lot of morbidities and mortalities which are reported in the literature. And so we need a non-surgical enteroscopy for all these list of indications which can arise in the small bowel. Suspected small bowel bleed, iron deficiency anemia with a negative endo and colonoscopy, positive findings on cross-sectional imaging or capsule endoscopy, patient with malabsorption due to chronic unexplained diarrhea, any patient with subacute intestinal obstruction because of polyps, strictures or tumors, and for any retrieval of foreign bodies from the small bowel. So if you see the evolution of small intestinal enteroscopy right from 1971 with the old ropeway and Sondi type enteroscope, push enteroscopes were being used with long enteroscopes up in 1980s. Capsule endoscopy came into picture in 2000s and then quickly followed by balloon enteroscopy, double balloon enteroscopy, single balloon enteroscopy, and then the spiral enteroscopy, initially the manual version and then the motorized version. So this is published way back in 2000 in Nature by Paul Swain's group. This is wireless capsule endoscopy, and it was felt at that time that the discomfort of internal GI examination may soon be a thing of the past. It is excellent modality with a sensitivity in occult GI bleed up to 38 to 83% with a specificity of 84%. Detection of Crohn's disease with sensitivity of 100% and specificity of 91%, celiac disease 70 to 95%. In acute GI bleeds, the diagnostic yield is up to 87%, and any patient with chronic abdominal pains, 21% is the diagnostic yield, and so on and so forth for NSAID enteropathy, familial adenomatous polyposis, and Peutz-Jeghers syndrome. So the advantages of capsular, it is very simple, non-invasive, it is easily acceptable. It can be followed up with repeated studies and it can be done on OPD based procedure. But it involves with a cost, it is only a diagnostic procedure, there is limited battery time, it is a time consuming procedure, the reading times are higher, and the luminal contents if it is filled with blood or any kind of feces, it can hinder the study. It cannot insufflate the small bowel, so the lesion which is actually submerged within the folds cannot be detected, and there is a risk of capsule retention proximal to the tight strictures. So this led to the invention of device-assisted enteroscopies, and there are many device-assisted enteroscopies. The push enteroscopy is without any device, and then balloons and spirals can be fitted. So this is double balloon enteroscopy, this is single balloon enteroscopy, this is spiral enteroscopy, both manual as well as motorized versions. So this is way back in 2001 from Yamamoto's group, which was published as total enteroscopy with a non-surgical and steerable double balloon method. Around 6 to 7 years later, Hartmann's group has actually come out with a single balloon version, and then Paul Eckermann has actually used this Discovery SB overtube, which can be fitted onto the enteroscope, and with a manual version this can be used. And then quickly over a period of time the motorized version has come into picture, and in 2016 the first report was published in Video GIE from the German group. So if you see the experience of double balloon enteroscope, this has been for a long time, more than 2 decades now. And initial 1 decade of experience, 66 studies, more than 12,000 procedures, the pool detection rates are 68%, total enteroscopy rates of up to 44% with acceptable adverse events, the minor in around 9% and major in around 0.72%. The experience with single balloon enteroscopy over a decade, again 54 studies, more than 6,000 procedures. The pooled insertion depth is up to 209 to 216 centimeter through the antegrade route and 98 centimeters via the anal route. Total procedure time is around 56 minutes, 57 minutes in the oral route and 65 minutes in the anal route. Total enteroscopy rates ranged between 0 to 71%. The pool diagnostic rate is up to 62%. Adverse events were 0.5% severe and 2.5% mild adverse events. So if you see many comparative studies, the meta-analysis is out. The diagnostic yield of wireless capsule endoscopy is slightly higher as per the latest meta-analysis, 58% versus 41% compared to double balloon enteroscopy. So multiple meta-analyses were there, and now wireless capsule endoscopy is actually the first choice in any patient with obscure or occult GI bleeds. Balloon enteroscopy versus manual spiral enteroscopy meta-analysis published in 2017 showed that 615 procedures across 8 studies, it has similar diagnostic and therapeutic yield and also depth of maximum insertion. But spiral enteroscopy is a quicker procedure and with lesser procedure time compared to the balloon enteroscopy. Double balloon enteroscopy is better than single balloon enteroscopy as per some 3 or 4 randomized control trials, like in this European study. If you see the total complete enteroscopy rates are 66% versus 22% reported by May et al. In AJG in 2007. Diagnostic yield and therapeutic yield is much better in double balloon enteroscopy versus single balloon enteroscopy. Compared to, if you see the complete enteroscopy rates, in Japanese study it is around 57% and in European study it is 18 versus 11%. So if you see the overall thing, the double balloon enteroscopy scores over single balloon enteroscopy, especially with complete enteroscopy rates and diagnostic yield. What about novel motorized spiral enteroscopy? There is a comparative study, propensity matched cohort study with double balloon enteroscopy, where it was shown that the technical success, the procedure time, everything is similar. The diagnostic and therapeutic yield is also similar. But if you see the minor adverse events, especially the mucosal lacerations and the abrasions, were higher in the motorized spiral group versus the double balloon enteroscopy group. If you see the comparison between single balloon enteroscopy and novel motorized spiral enteroscopy, the total enteroscopy rates are higher with the motorized spiral with a quicker procedure time, 40 minutes versus 60 minutes. The depth of insertion is higher in the motorized spiral group, 400 centimeters versus 180 centimeters, and the diagnostic yield is almost similar with similar technical success rates. But the message from this study is actually, if you are suspecting a lesion beyond distal jejunum and proximal ileum, it is better to prefer the novel motorized spiral enteroscopy over single balloon enteroscopy. So meta-analysis of this novel motorized spiral enteroscopy just published few months back of 9 studies of more than 950 patients. The diagnostic yield is around 78%, total enteroscopy is 51%, technical success is 97%, with adverse events up to 16%. So if you see the various enteroscopies, push enteroscopy needs a short sedation, that is the advantage, and it's widely available, but it can evaluate only up to the proximal jejunum. Balloon enteroscopy has higher depth of insertion and total enteroscopy rates, and it is most studied technique, but the procedure time is longer and it needs two operators. Single balloon enteroscopy, the diagnostic yield is lesser, the total enteroscopy rates are lesser, but the procedure time is actually less and it is easier to use compared to double balloon. Balloon guided endoscopy, it is Navigate system. It needs no special preloading of this equipment, but there is very limited data of its safety and efficacy. Manual spiral, it is actually withdrawn from the market. It has shorter procedure time compared to balloon enteroscopy, but it is very difficult to do it through the retrograde route, and total enteroscopy rates are also not very much high. Motorized spiral enteroscopy, again it is withdrawn from the market, but we should understand that it has a very large overtube, but the procedure time is very short and it is very easy to use, and there is highest total enteroscopy rates reaching up to 80% as per reported in some studies. But it needs, we need to dilate the esophagus in certain cases, and there is limited availability, and there are a lot of concerns about the mucosal abrasions and lacerations reported in the literature. So there are some advances to the existing enteroscopes to improve the safety, improve the diagnosis, depth of maximum insertion, and also to perform certain ERCP kind of procedures. If it is capsule endoscopy, panoramic capsule is available. It is fitted with virtual chroma endoscopy. Dual headed capsule endoscopy is available. Pan-enteric capsule endoscopy for Crohn's disease is available. AI is also now coming up in a big way with wireless capsule endoscopy to improve its efficiency. Coming to balloon enteroscopy platforms, there are ultra thin scopes, there are short scopes, which helps in actually preventing pancreatitis with less pancreatitis rates compared to the thicker ones. Short balloon enteroscopes are useful in patients to do ERCP in surgically altered anatomy. Also, other novel methods like water exchange colonoscopy allows improvement in the depth of maximal insertion and pan enteroscopy rates, and we can also use CO2, wherein there is increase in depth of maximal insertion up to 30% compared to the air insufflation method. And one study showed that using a transparent hood also might improve the depth of maximal insertion. So coming to therapeutic interventions, we can do many therapeutics, as we know, in any other segment in the GI system: APC, polypectomy, clipping, foreign body, removal, jejunostomy tubes, stricture dilatations, ERCPs, luminal stunting, and pre-surgical markings. A meta-analysis showed that the pooled diagnostic yield in small bowel bleeding for device-assisted enteroscopy is up to 73% if it is done very early, and we can control it in a better way. Stricture dilatation, meta-analysis of 18 studies in up to 463 patients, the technical success is 94%, short-term clinical efficacy in 82%, major complications are 1.82 per dilatation, amounting to around 5.3 overall. Symptom recurrence is in around 48% at 1 year, and requiring repeat dilatation in up to 38%, and ultimately 1/4 of these patients require surgery. Polyp resection, 216 polyps as in this study, in 8.6 polyps per patient ranging from 6 to 60 mm. Over a period of 5 years, it was noted that 76% achieved complete treatment with an acceptable risk of 6%, including perforation, bleeding, and pancreatitis. So have we conquered the final frontier? This is actually the editorial written by Dr. Simon Lowe way back in 2007. What I feel is actually we need better solutions, especially when we actually evaluate the small bowel. We need shorter scopes done by a single operator in under conscious sedation. We need effective, quick, and stable platform which can give a small bowel bleeding. We need to have short learning curves. There need to be scopes which provide both diagnostic and therapeutic potential. We need to work only on the standard accessories rather than the long accessories. We should achieve a deeper enteroscopy and parenteroscopy whenever it is possible. It has to have a safe therapeutic utility. It is to be safe to the small bowel and adjacent organs as well as dysentery. It should be suitable and safe in pediatric and geriatric patients, and it should be safe and suitable in patients with surgically altered anatomy. So to conclude, ladies and gentlemen, small bowel endoscopy was once cumbersome and impossible. Wireless capsule endoscopy has opened the new avenue of small bowel examination. It remained predominantly diagnostic, but still the first choice in small bowel bleeding. Device-assisted enteroscopies, they provide effective diagnostic capability and offers therapy. Balloon enteroscopy allows deeper insertion with acceptable total enteroscopy rates, but it has a downside of longer procedure times. Spiral enteroscopics, we know that they are withdrawn because of limited availability and safety issues, but it used to give us faster and deeper insertion and better total enteroscopy rates. Thank you so much for your patient listening.
Thank you, Dr. Chalapati Rao Chanta, for a wonderful talk. Now I'd like to call upon our next speaker, Dr. Ajay Kumar, who will be delivering his talk on benign luminal strictures, when and how much to dilate.
Thank you, Mr. Chairman, and thanks, Anil, for a wonderful meeting. Friends, the topic allotted was the luminal strictures. I restrict myself to small bowel strictures because of the time. It's difficult to cover the entire thing in the allotted time. Question that Anil posed is when to dilate and how much to dilate. First, let's be clear about the definition of small bowel strictures, that when we look at any radiological imaging, we have to look at the three things. The narrowed segment, which would compare the diameter reduction of at least 50% as compared to the adjacent normal bowel. Thickening of the bowel wall, that is a 25% increase in bowel wall thickness compared to the nearby normal bowel loops. And third element in a benign stricture is a pre-stenotic dilatation. So when we have to fulfill these criteria, and if you look at the common causes, that is inflammatory. We all know that Crohn's and tuberculosis are the common. In our country, though, we used to say that it used to be all tuberculosis, but I personally believe, I don't have data, that actually Crohn's strictures are even more than tuberculosis in today's time. And you look at the other categories of anastomotic, NSAIDs, and the ischemic stricture. Though there are a number of other causes, but they are extremely rare, and I'm not touching on that, in fact, just to mention that. If you look at Crohn's disease, whatever the phenotype, whether it is the initially just an inflammatory B1, or it will, in the natural history, almost 60% will develop stricture or penetrating complications at about 20 years. So we should always take every patient, whether it's a mild or this thing, as a potential candidate who can get into that. And second thing that we need to know, that there is a discordance between the diameter of the bowel and the symptoms. Almost 17% of Crohn's strictures can be asymptomatic. And so it happens even in tuberculosis. If you know the famous Dr. B.S. Anand's trial from G.B. Pant, actually when I was working there, famous study published in GERD, he showed that after treatment of tubercular strictures, the large number of them become asymptomatic, but the strictures do persist. So the first question that is put, that when to dilate, and the answer is that whenever there is symptoms, intestinal colic, obstructive symptoms, or a partial obstruction or total obstruction, there is a clear indication of an intervention. So all symptomatic cases need dilatation. Now we have the other option of a surgery. So the question is, what do we do? All those who need dilatation are not necessarily the right cases for endoscopic dilatation. And here is what we have to define which are the right cases, which are predominantly fibrotic stricture. And we have to differentiate between inflammatory stricture and a fibrotic stricture. I'll touch upon that in a short while. Short strictures are best for the endoscopic thing. Somebody will say 4 centimeter, Butterworth's trial talked about less than 5 centimeter. But the longer the stricture, more difficult for the endoscopy. And single or multiple, up to 4 strictures close by can be handled by endoscopy, while the angulated strictures or multiple strictures with angulated lumen are associated with abscesses are a difficult thing for endoscopy, and surgery should be preferred there. And of course, strictures far away from the fistula orifice, if it is there, of the proximal bowel. So the right type of strictures, then there's another thing, that if there's a web-like stricture, as is shown in this particular thing, they are better thing. But if they are spindle-like, like this, or you have a ulcerated, then they are not the best strictures for the endoscopic dilatation. Right timing of dilatation, it should be elective and not emergency. Patient comes to you in emergency with obstruction, don't immediately move for that. Let the patient settle down. Ideally, patient should be off steroids, but one should bring it down to at least 20 milligram, less than 20, and then go for it, not for high this thing. And patients, those who are on biological agents, it is advisable to keep them off the immunosuppressants. And all these procedures can have complications, and they are elective procedures, so avoid on a Saturday evening, preferably to do on a working day morning. And you should have the right team and the right, we should know that the best response is like colonic, earlier, and then less than that is ileum and then jejunum and then the duodenal. Now that's about the symptomatic strictures. Boshen wrote something very interesting from Cleveland, that is no inflammation, no stricture, no fistula, no abscess. If you look at this, if it is stricture proximal to that dilatation, sometime or the other it may lead on to fistula and abscess formation. So that raises the possibility, should we dilate asymptomatic strictures? You have a patient of a Crohn's disease with asymptomatic strictures, there is a rationale behind it, not that we regularly follow that. It could ultimately lead to acute partial obstruction, to abscess, fistula, and success rate is better in these patients. In tuberculosis, we have no such experience, we do not know, so we don't practice that. What do you do once you decide that this has to be treated? What information that needs dilatation, what information do you require? I mentioned earlier that you need to differentiate whether it's inflammatory, because there you need to wait for the treatment to work. But if it is a fibrotic, the best investigations is the CT or MR enterography. Some people believe MR is better with a significant specificity and sensitivity. Modifications of intestinal ultrasound are evolving, but none of these is 100% to determine which is the best modality. Ultrasound, the number of, I've just given you the different technologies, but the sensitivity is reported to be good, but the specificity not all that high. I'm not going to the details of this because time does not permit, but there are features to suggest on CT or on MRI, and main thing is the hyper enhancement, especially the delayed enhancement, which will tell you that it's more like inflammatory, and so you should wait for the medical treatment to work. But none of the current cross-sectional radiological modality give appropriate quantification of the fibrosis. So once you have taken a call that it's a fibrotic stricture, needs dilatation, I'm hurriedly going through that. I usually like to have conscious sedation. I usually like to hospitalize them, and we like to use CO2, and I don't usually use fluoroscopic guidance. Most of the time you don't need that. And of course, management of antithrombotics needs to be kept in mind, and steroids and biologicals, I've already talked about that. Endoscopic treatment, you have endoscopic balloon dilatation. In addition, the option of stricturotomy is available. Again, I'm not going, but I just talked about technical issues of balloon dilatation. There's a terminology called retrograde. Basically, what does it mean? That scope is able to negotiate the stricture, and then you inflate the balloon and bring it out, and then you dilate it. It's the safest thing. But every case it is not possible. If it is possible, that this is a better approach. Otherwise, you do the antegrade and put in the guide wire, but make sure that the guide wire is beyond the balloon so that you don't cause damage to the other scope. And there are these are two videos which show you the different ways. One is endoscopic balloon dilatation. The other is of stricturotomy. It is something like that you would have seen in esophageal strictures. In a Schatzky ring, sometimes we use sometimes we use a needle knife, sometimes we use to burn the thing and to break the sphincter and then dilate. So it doesn't take much time, usually safe technique, and one is able to push the scope beyond that. The second question that Dr. Anil has put, how much to dilate? Now, the data on that is scanty. This is another study from in inflammatory biology in 2017, which has shown that 16 to 18, look at the green, there has a surgery-free survival is the highest with that. So even if you go beyond 16 to 18 millimeter, then again it comes down, and possibly it is not because of the size of the balloon, it's more of to do with the difficult strictures. So current thing is that 16 to 18 millimeter is seems to provide the best results. And there is a good success in Crohn's. Technical success rate is almost 90%, and immediate clinical efficacy is around 80%, and at rate of dilatation at 24 months is around 73%. Complications are within acceptable limits, and if you are actually expert, you hardly ever face, and you select the right cases, you don't face much difficulties. Tuberculosis data much less, because this is the disease where we are supposed to provide the data, but the small series by Vishal from PGI Chandigarh showed a technical success of 88% and a clinical success around 82%. So friends, I sum up that in obstructive small bowel symptoms, cross-sectional imaging with CT enterography or MR enterography is must, and then you proceed for enteroscopy. You note down the activity, the number of the stricture, the severity of the stricture, and the inflammation, define the etiology, and then you have a medical treatment you optimize, or you go for balloon dilatation or surgical, depending upon how you decide about that. So the other way that you look at the warfarin, you should discontinue for 5 days, and antiplatelets you can continue. There's no clear guidelines on that, and you should have a clinical clues to etiology and severity. Same thing that I've said, if it is an inflammatory stricture, please optimize medical management first. If it is a fiber optic stricture, if it is less than 5 centimeters, some people say 4 centimeters, is less than 4 in number, and there is an absence of deep ulcerations, I think this particular thing carries the entire answer to the question that Dr. Anil had put to me, and then you go for endoscopic balloon dilatation. If it is not there, please call your surgical colleague, let them intervene in that. But and if dilatation fails, then you again go for surgery. Thank you very much.
Thank you, Ajay sir. A beautiful talk. And now, if Dr. Mahesh Goenka is ready, I'd like to call upon him. Dr. Mahesh Goenka, sir.
Thank you, Dr. Paul, other chairpersons, moderators, and good evening, everybody. Today the flights are crazy, and I'm sorry I'm late, and that's why the order has to be changed. But I promise I'll finish in 12 minutes. So the topic which has been given to me by Dr. Arora and Dr. Ashish was to talk about do's and don'ts in hilar block. So I have made 10 commandments, which I'll go through in the next 12 minutes. First, as an endoscopist, whenever we get a patient of hilar block, we must not ignore the possibility of resectability. I must say the resectability is possible in general only in about 25 to 30% of the patient, but we must not have this barber chair phenomenon that anybody sitting with us or coming to us, we start thinking about endoscopy. So we must find out by the relevant investigations, and the most important being CCT and MRI, whether the tumor or the block is resectable or not. And so these are the contraindication to curative resection, mostly metastasis, distal regional involvement, but more significantly, it's portal vein, main portal vein, and the main hepatic artery or contralateral hepatic artery, which makes it involvement, which makes it non-resectable. If there is a large tumor which is to be removed, then we may consider doing a portal vein embolization for a hypertrophy of the remnant tumor. The second do's or don'ts is about preoperative biliary drainage in select cases. I just heard Dr. Ajay Jain talking about this while I was traveling from the airport through the YouTube, and I think he's covered most of it. But when you talk of hilar cancers or hilar tumors, these will be the real world scenario indications for doing preoperative biliary drainage. Cholangitis, something like this, intense pruritus, delayed surgery as he talked about, role of when we are planning neoadjuvant therapy, when the bilirubin is very high, and peculiar to Klatskin tumor would be when there is large liver resection which is planned, which tells us that future remnant liver may be small. In practice, actually, more than 50% of the patients with hyalid tumor in US database were found to have received preoperative drainage. So what is the third do or don't? Do try for a tissue diagnosis. I think this is very, very relevant. While we know there's a huge list of benign pathologies, and I've just ticked them red mark for the hilar ones, we also know that 80% of the patients with hilar blocks are because of malignancy, which can be cholangiocarcinoma, gallbladder cancer, metastatic disease, lymphomas, and so on. But it is important to make all attempts, at least in majority of patients, to reach a diagnosis. So these are 3 hilar tumors or perihilar tumors. Each of them can be either inflammatory, tubercular, or malignant. And if we finally worked out, the first one was malignant, second was tuberculosis, and third was inflammatory. So I think tissue diagnosis is important, and this can start with a cross-sectional imaging, either a CT or MRI, which I talked about. If you're doing an ERCP, we can do a brush cytology and a biopsy, which has less than 50% sensitivity, whatever you do. Of course, you can improve this by doing digital image analysis, and more commonly we nowadays do FISH to find out, to increase the sensitivity of brush cytology. Now, EUS is important and is now catching up as one of the initial investigations for bile duct stricture, not only for mapping, but for getting a tissue diagnosis as well. And sensitivity overall can be very high, specificity also very high, but most of the data show that while it's a very good investigation for lower bile duct malignancy, it is not so for the hilar malignancies. Now, Spyglass, particularly the DS2 system, has changed our approach to the tissue diagnosis of hilar blocks. Now we have this DS2 system as well as SpyMax, which takes bigger biopsy tissue. This was an article which we published in Endoscopy, a multinational study, and we found out that sensitivity and specificity of direct visualization as well as biopsy was pretty high. Biopsy was of course 100% specific, and sensitivity of visual examination was as high as 86%. Now these are some of the examples of malignant biliary obstruction from our database. You can see the polypoid lesions, eccentricity, and in the third one you see neovascularization, which is suggestive of malignant lesions. And these are some of examples of our patients with benign strictures. You see that lesions are central, there is no neovascularization in these, and there is no projections. Now if you look at the various parameters which differentiate at cholangioscopy between benign and malignant, the last one is most important. The neovascularization is almost 100% specific for the diagnosis of malignancy. Now this is a case which I dwelt with only yesterday afternoon, and I just collected the biopsy report on my way back to this place. This is a patient who was referred to us with a diagnosis of filling defects in the hilum, and the initial impression was this may be stones collected at a particular place. But when we did a cholangioscopy, and this was yesterday only, we found that this was actually polypoidal mass at the hilum. You can see the polypoidal mass, and I'm taking the biopsies, and this, to my surprise, I was told today that this is benign intraductal papillary neoplasm, a distinctly rare disease to have. Now the fourth point to discuss about do's and don'ts is do a disease mapping, assess the dilatation and atrophy of the liver before you proceed. So this is a very age-old slide of Bismuth classification for perihilar tumors, type 1, type 2, type 3A, type 3B, and type 4. And it is very important to define this, and this is best done by M.I.C.E. So the question 5 is you must plan what you're going to do if you're doing a palliative procedure. Whether you're going to put a single stent, multiple stents, whether you're going to put a stent in the right system, the left system, what route, and so on. So the important, as I said, is MRCP mapping is a must. All patients, if there is cholangitis, everything should be drained. Otherwise, at least 50% of the liver volume should be drained. We avoid atrophied lobe drainage, and you also look for some evidence of hypertrophy of any segment or lobe. In general, right lobe constitutes about 60% of the liver, left lobe about 30% of the liver, and caudate lobe about 10% of the liver. So for type 1, where the confluence is intact, a single stent, whether you place in the right ductal system or the left ductal system, is fine. You don't need to put specifically any duct because they are communicating. When there's a type 2, again you can put a single stent, and I would prefer to put it in the right ductal system rather than left ductal system, because as I said, right lobe constitutes usually about 60% of the liver. Now when there's a type 3A, then you can put two stents, either two stents in the two segments of the right lobe of the liver, or one in the right and one in the left, and this will drain more than 50%. But for the type 3B, you need to put two stents, one in the right, one in the left ductal system, because if you put only in the left ductal system, you'll drain only about 30%. For type 4, of course, you have to put multiple stents in both the right and the left. We must also assess the biliary segmental anatomy, either at MRCP or while we're doing the ERCP. While this is the standard conventional anatomy, we must understand there may be variation. The right posterior duct may be arising from the confluence. Sometimes it may be arising from the left duct, and this is important when you plan stenting in these patients. And as I said, there's an impact of volume of the lobe of the segment. This is in a normal volume, type 3A disease. You need to put two stents, as I said, in this case, whereas if the left lobe is hypertrophied, which it does in a small number of patients, and there it constitutes about 55%, only a single stent in the left lobe may be enough. And of course, you avoid segments or the lobes where there is atrophy of the lobes. There is no purpose of draining them. Now, what about route? While we are all endoscopists, we must not forget that there are other routes which are available. For the patient's benefit, we must consider them in specific situations. So I'm again coming back to that slide. Type 1 and type 2, usually the initial approach will be ERCP. For type 3 and type 4, we have both ERCP and PTBD, percutaneous procedure, which is now becoming gradually less and less being utilized as we are doing more and more endoscopy, and particularly US. When you talk of Klatskin tumor, US role will be primarily, as of today, only to deal with the left ductal system, either when you put a single stent or when you are completing the procedure and have put a stent on the right system by the ERCP. Now we must not only look at the endoscopy literature. There are literature which is available, and robust literature which is available in radiological journals, which have shown that advanced hilar strictures can sometimes be better treated percutaneously than by endoscopy. Now it is easier to select a particular segment or a branch while you are doing a percutaneous approach than while you are doing the ERCP approach. These are some of the percutaneous stenting. In the first case, it is two stents, and in this case, there are three stents placed percutaneously. What about EUS? I think EUS is also important, particularly in surgically altered anatomy, failed ERCP, incomplete drainage by ERCP, such as the situations which I have shown, duodenal infiltration and duodenal stent. This is one of our patients where we did left hepaticogastrostomy, as you can see, and we put a stent in the left hepatic duct in a patient with hilar block. Now, I just want to spend about half a minute on this particular article, which interested me a lot. This is an article which has come from Bangkok. A very renowned group of people who have compared percutaneous transhepatic biliary drainage with endoscopic and ultrasound approach. What they did is that in one arm, they put a stent either in the right duct or the left duct through the ERCP, and the other stent was placed either by the US, this is left hepaticogastrostomy, or in the right duct by US approach on the right duct, which I think technically is still very demanding. And they showed that in all peak significant difference was that combination of ERCP US was better than PTBD. But when you look into this article, they have compared a 10 millimeter endoscopy stent with a 2.5 millimeter PDPD catheters. I think this is not a justified comparison, and we should not compare apples with oranges. Now let me just move on for the last 1.5 minutes. We must do a safe and effective endotherapy. So contrast-free cannulation or limited contrast is what is important, that you don't, unless you have a guide wire inserted into one of the duct, you don't inject contrast, drain all opacified ducts, and you use cholangioscopy for selective cannulation. And then there's a debate of stent in stent versus stent side-by-side stent. So this is air cholangiogram. You can do with carbon dioxide also. You can see how nicely the ducts have been outlined, and this reduces the risk of cholangitis significantly. It has been shown in a couple of articles. Now we also sometimes use spyglass cholangioscopy to negotiate a tough wire, a tough stricture at the hilum, or selectively enter the right or the left duct, as was done in this case in one of our patients. What about side by side to stent and stent? I think the two are comparable. Technical success has been shown in multiple studies to be slightly better for stent and stent, but re-intervention, for obvious reason, you have both the stents hanging from the duodenum papilla, is easier for side by side than by stent in stent. Do add techniques to improve results, and we routinely do in majority of our patients radiofrequency ablation, which we believe will increase the stent patency as well as the longevity in these patients. Let me skip some of these slides. We must follow some algorithm, and the simplest algorithm will be do a cross-sectional imaging, mass at the porta, no mass at the porta, look for IgG4, HIV, rectal biopsy. You do try an US guided fine needle biopsy. If it doesn't work, then ERCP with cytology or biopsy combined with cholangioscopy, and then decide whether it's a benign stricture or malignant stricture. If you suspect it's a benign stricture, you can treat it conservatively. Don't harm. There is no ego in referring, and this is a patient which was referred to me about 22 years back, and this is what was done in another center in a hilar stricture. A pigtail single stent placed in one of the duct. I think this is not acceptable as of today. So with that, I would conclude that there are lots of do's and don'ts while you're dealing with hilar blocks. I could not dwell on the benign blocks in detail, primarily malignant blocks I talked about. Thank you very much. I'm sure there's no time for questions.
Thank you, sir. Now do we have our last speaker, Dr. Sandeep Nijawan. He'll be talking on upper esophageal strictures.
Good evening, ladies and gentlemen. Thanks to Anil for the kind invite. I bring greetings from Indian Society of Gastroenterology. My topic is upper esophageal stricture causes and management. Normal diameter is 3 centimeter, and if it is less than 13 millimeter, it causes dysphagia. So luminal narrowing can happen because of the mucosal disease, muscle disease, and extrinsic compression. All lead to symptoms of dysphagia, and the prevalence is 1.1 per 10,000 person years. And the mechanism is inflammation, fibrosis, or neoplasia. Its early recognition is important because the person is not eating. It can occur in any age. Caustic and eosinophilic are in children and young patients. Iatrogenic and drug-induced in adults, and malignant, of course, older population. Esophageal strictures can be actually divided into benign or malignant. Benign can be simple or complex. Simple ones are actually smooth surface, less than 2 centimeter, concentric, and the luminal diameter usually is more than 10 millimeter. Complex strictures are irregular, more than 2 centimeter, tortuous, and severe narrowing is there, less than 10 millimeter, and of course malignant are totally different. As far as etiology of benign upper and mid esophageal stricture is concerned, it can be developmental anomaly, that is esophageal atresia and webs. Iatrogenic, it can be because of radiation, because post-surgery, prolonged NG tube, post-endoscopic therapies, EMR, ESD. It can be drug-induced, and caustic injection is more common, what we see in thermal injuries. As far as inflammation is concerned, eosinophilic esophagitis and various mucosal conditions with connective tissue disorders, and compression is by intramural and extrinsic compressions. Malignant strictures, lower end we have adenocarcinoma, and in the upper end we have squamous cell carcinoma, and metastatic neoplasms usually from the lung cancer and other metastatic diseases in the mediastinum can lead to dysphagia. History is very important, so it's not only history for dysphagia where there is mechanical, because it is more for solids than liquid, and associated more significant loss of weight and loss of appetite goes in favor of malignant stricture, and there has to be other histories to be taken, like history of pill ingestion, history of corrosive, etc. Examination, presence of pallor, lymph nodes in the neck, axilla points towards malignant condition, and systemic examination of the chest also can reveal carcinoma lung findings, and abdomen, of course, secondary sitting in the liver. As far as the laboratory tests are concerned, CBC can show anemia, which actually points towards bleeding from severe esophagitis or carcinoma. Liver profile can be abnormal because of metastatic liver disease, and complete metabolic profile should be done in patients who have got chronic dysphagia to see the nutritional status. Barium study, it gives you actually a roadmap, and it has to be done before the therapy of endoscopic intervention. It tells you about the location, length and diameter of the stricture, smoothness of the stricture and irregularity of the wall. It gives you more information of the subtle narrowing which can be missed by thinner endoscopes. And as far as endoscopy is concerned, it establishes the diagnosis of the cause of dysphagia. It is more sensitive than the barium studies, and it is more sensitive for subtle mucosal lesions. Subtle mucosal lesions are missed whenever they are smaller, and thinner endoscopes actually do miss subtle strictures. So for the subtle strictures, barium is more important. A chest radiograph will tell you problems of lung diseases like tuberculosis and carcinoma. CT stages the malignancy, especially of esophagus and carcinoma lung, and of course COX in the lungs also are seen by CT scan, HRCT. EUS actually tells you about the extent of local invasion, and esophageal manometry tells you about the motility causing dysphagia. As far as treatment is concerned, we have medical treatment. So all actually etiological treatment are to be done before subjecting them to endoscopic dilatation, and of course there is a role of surgery. The goal is to relieve dysphagia, and this dilatation is continuing for last 5 centuries, started way back in 16th century by wax bands, and the goal is to have a more than 18 millimeter diameter to actually relieve dysphagia for solids, 15 to 17 for soft diet, and around 13-14 which are actually thick liquid diet is possible to be taken. Contraindications for dilatation: esophageal perforation, disorder of hemostasis, as has been alluded by Dr. Ajay also. Hemodynamically unstable patient, you can't do dilatation. Patient with a severe esophagitis with a recent food impaction, so it should not be dilated. We should remove the food impacted and do the dilatation later, otherwise it can lead to perforation. All patients with suspected diagnosis of eosinophilic esophagitis is to be confirmed, should be put on treatment, and then stricture has to be dilated, otherwise it can lead to perforation. The increased risk, but it is not absolutely contraindicated if you are doing dilatation within 4 weeks of surgery, and a large thoracic aneurysm or more than 5 aortic aneurysm, more than 5.5 centimeter, you should not dilate. If you are dilating, then use a TTS balloon rather than the boogie. Preparation, again 2 hours of clear fluids and 6 hours, that means overnight fasting. Most medications can be continued except for antiplatelet anticoagulants, which are to be actually stopped 5 days before. OHA should not be given as the patients are fasting. Antibiotic prophylaxis should be given only when you have a complicated strictures with past history of perforations and associated fistulas. Anesthesia, actually, it is usually performed under moderate sedation. The rule is rule of 3. For simple strictures, once you get the resistance, you can go to 3 upsize with a difference of 2 millimeter. But for complex strictures, there should be increment not more than 1, otherwise actually you can actually develop complications. And it all depends on the initial stricture size to start with, and what is the size you reach at the index dilatation, and the patient's symptomatic response. That's how actually we deal with the simple strictures. For complex strictures, we do 1 to 2 week interval, and we reach to a maximum size of more than 13 millimeter at 2 weeks. Every 2 weeks, 5 dilatations. Type of dilators, we have TTS balloons, which are actually through the scope over the wire, and then we have push boogie dilators, which not only do a radial force but also have a longitudinal shearing force. Usually we do with a wire guided, non-wire guided. Usually nowadays we don't actually prefer these dilators. And as far as selecting the dilator is concerned, it depends on the efficacy and safety of dilators. Wire guided push dilators and TTS balloons seems to have a comparable safety and efficacy profile. The choice of dilator depends on the stricture type, the endoscopic preference, and the local expertise and the availability of the equipment with that endoscopy center. Non-wire guided push dilators we should not use because it can lead to perforations. So technique, again, left lateral position, carbon dioxide insufflation, size of the dilator depending on the size of the stricture, and a rule of 3 to be followed. And fluoroscopy is very important, especially in the setting of complex strictures, where we can actually decide the length, diameter of the stricture and the fistulous connections. And the outcome actually, we call it success when we do dilatation at the interval of 2 weeks, 5 dilatations reaching to the 14 size. If it doesn't happen, then it is a resistant stricture. And we call it recurrent stricture when there is improvement in symptoms after 5 dilatations, but there is recurrence of the symptoms within 4 weeks. As far as the causes of refractory upper and mid esophageal strictures are concerned, we have intrinsic diseases like eosinophilic diseases and all diseases related to mucosal diseases with connective tissue disorders. As far as iatrogenesis is concerned, post-surgical anastomosis, post-radiation, post-ESD, post-EMR, and prolonged NG tube caustic injection are the causes of resistant strictures. Steroid injections should be done in complex strictures when they are not responding to endoscopic dilatation, and we have shown in a study done by us that if you combine boogie dilatation with steroid injection, it is better than boogie alone in resistant strictures. Mitomycin-C, again we have done a case series in children where we applied actually mitomycin-C in resistant strictures and found to be useful in resistant strictures. Stent insertion, again it has to be done in a selected group of patients, those who have not. Metallic stents are easy to do, and the efficacy of all 3 stents are almost similar with similar adverse events. Incisional therapy, short strictures, less than actually 1 centimeter, you can do 4 quadrant stricturoplasty, and retrograde dilatation only in strictures where they are in the upper end and they are actually not accessible by pushing in a wire, so you can go in a retrograde manner from the stomach and do. And self-bouginage, again a very well motivated patient, especially of a corrosive stricture, where actually he can himself dilate if it is a long standing this thing. And this I have already alluded to, that it is quite good, that is around 41% in refractory strictures. Surgical resection, again it is only reserved for patients who are not responding to medical and endoscopic therapy and in a malignant operable disease causing esophageal stricture. Surgery, as far as malignant stricture are concerned, non-endoscopic method, surgery choice if it is operable, radiation to be given, radiotherapy to be given to a locally advanced disease combining with chemotherapy. Endoscopic treatment, there are various endoscopic treatments which are available, but nowadays we actually settle with using them partially covered SEMS in an inoperable disease to palliate dysphagia. Complications, food impaction, food aspiration, chest pain are the complications in this, and treatment related, it is esophageal perforation, bleeding, anesthesia related complications, bacteremia, displacement of stent, and the epithelialization of uncovered stems. So this is my last but one slide. Simple strictures, dilatation done, no fluoroscopy. You can use fluoroscopy in the first attempt. Eosinophilic esophagitis, you do PPI, topical steroids, some dietary management, controlled inflammation and do dilatation. Lynchen planners, immunosuppression therapy, controlled inflammation. Web is there, single dilatation is sufficient. In patients with complex strictures, always use a fluoroscopy, wire-guided balloons, TTS balloon. If there is a poor response, we go for intralesional steroids, cautery incision. If it is short, mitomycin-C can be tried, fully covered SEMS, and if it doesn't respond, then surgery. Finally, I like to conclude by saying that esophageal strictures are common clinical entity. They can be of various etiologies. It can be complex or simple, and variety of endoscopic therapies are available for endoscopic dilatation, which is the mainstay of treatment. And there are several options for dilatation available. A careful selection of the type of dilator and technique is essential. The choice of therapy must be individualized for each patient based on the underlying etiology and anatomy of the stricture, and there has to be future research, especially in the setting of a complex and refractory esophageal strictures. Thanks for your kind attention.
Thank you, Dr. Nijavan. With this, we come to the end of the session, And I'd like to thank Dr. Anil Arora for having us here to chair the sessions. Thank you.
Thank you all our respected speakers for taking us to such an exploratory endoscopic journey through the gut. Thank you all our chairpersons and moderators for conducting the session. So, continuing the journey, the topic of our second last session of the day is EUS Unveiled, Exploring the Depths of Endoscopic Ultrasound. For this, for chairpersons, I would like to invite on the stage Dr. Nishant Nagpal, M.I.C.E Super Specialty Hospital, New Delhi, Dr. N.M. Tiku, Indraprasth Apollo Hospital, New Delhi, Dr. Ajay Gupta, Liver and Gastro Clinic, Ghaziabad, Dr. Arvind Joshi, Grande City Hospital, Kathmandu, Nepal, Dr. Neha Berry, BLK M.I.C.E Super Specialty Hospital, New Delhi. And for moderators, I would request to come up on the stage Dr. Munish Agrawal, Agrawal Liver and Gut Multi-Specialty Hospital, Jalandhar, Dr. Mandhir Kumar, Sir Gangaram Hospital, New Delhi, Dr. D.K. Bhargav, Indraprasth Apollo Hospital, New Delhi, Dr. Reshma Kaushik, Himalayan Institute of Medical Science, Dehradun, and Dr. Pukar Thapa, Bir Hospital, Kathmandu, Nepal. I would like to request our respected chairpersons to call the respected speakers on the stage for their talks.
With time constraints, first of all, thank you, Arora sir, for giving us a chance to do the session. At the outset, I would like to invite Dr. Vipul Roy Rathod sir. Sir is a well-known entity in the US, and everybody here functioning with the US has worked with sir. He'll be speaking on amalgamation of US and ERCP, a cosmetic effect or therapeutic effect. Reality.
Good evening, everyone. Thank you very much, Chairperson, Moderator, and Anil. Thanks a lot. EUS ERCP interface. I coined this term in '98 for this country and this continent and perhaps the world. And we are asking the same question after 25 years. Is it relevant? Let's see whether it's relevant. Okay? No disclosure. So just giving you a little historical perspective of two major advances in biliary pancreatic imaging in the last 40 years. Revolutionize biliary pancreatic sciences. So I'll just give you a little brief history. We started our quest in 1920 to try and figure out to look at the bile duct. 100 years ago. We struggled. Japanese brought some form of ERCP in '69. Then, of course, Klassen and Kawai opened the floodgates of the ampulla. And I think what M.I.C.E Sohendra allowed us is to start decompressing the biliary system, which paved way for pancreatic interventions. I think we cannot ignore the contribution of these giants in this field. And of course, I was so lucky at that point in time in history that M.I.C.E Sohendra trained me for ERCP and Kenneth Binmoller trained me for endosonography. What a fantastic period in time, 25 years ago. So I think I am very grateful to my mentors. And of course, we started the journey with basic scopes and then came the linear scope. But the first EUS symposium happened in 1981, almost 42 years ago. It was attended by 15 endosonographers from the whole world. And now see what has happened in the last 4 decades. So I am very, very happy to see the progress in this area. The evolution of equipment and technology also kept the pace. Till recent times, we have more advanced equipment. And of course, we have to acknowledge the inputs of the pioneer, Dr. Peter Willman, who made the first USFNA of the planet long time, 30 years ago. So just to give you a little idea why EUS ERCP interface is important, and I'm going to not go through too much of studies because there are no randomized studies on this subject even today. Though there are anecdotal, retrospective reports and things like that. So I'm just going to show you what we need to look for and why it maximizes our potential to treat biliary pancreatic pathology in the most scientific possible way with patient-centric outcomes. So I am going to tell you something, that why EUS is so important before doing ERCP, or can we do EUS and avoid ERCP, and that's where this convergence comes. So I always believe the staging and diagnostic accuracy of especially malignancy or benign disease, proper accurate diagnosis will alter the treatment strategy. So coming to role of EUS, this is all EUS can do. It can find stones, strictures, helminths, and lymph nodes and cancers, and so a lot of things we can do, and I'm just going to show you where the conventional imaging falls short and EUS fills the gap. Say for instance, I'll just give you this example of a patient who had 2 MRCPs for suspected bile duct stone, and you can see here there is a gallbladder full of small, very, very tiny stones. On a radial endosonography, I still do radial endosonography, and you can see a normal size CBD. This is 4 millimeter, 5 millimeter CBD. Can you see the whole bile duct like a cholangiogram? It looks normal. But very careful observation, we pick up a 4 millimeter stone just above the ampulla. Now MRCP will miss this. And therefore, at least for me in my practice, 25 years, no MRCP. Common hepatic down up to the ampulla, always EUS. Look at the size of the duct, very small duct. You have to be very careful so there are no negative ERCP because of the accuracy of picking up even the smallest stone. And I think this is very, very important because we cannot afford a negative ERCP in the era of MRCP and EUS. Okay? I'm going to skip some slides, but in children also we can extend the same indication, especially in cholangitis. So what we do is we actually identify the number of the stones, and if there is cholangitis, I avoid injecting contrast. So for last 10 years, I don't inject contrast in ERCP when there is cholangitis, or when we know that there is a specific obstruction. You just put wire, aspirate bile, deploy a metal stent if it's a short stricture, and that's why EUS is very, very helpful. Now, hilar stricture, I think Mahesh very well aptly mentioned that hilar strictures, we can have tissue diagnosis for those cases where surgery is ruled out for any other comorbid reason or patient or the disease is very advanced. So what we do, we have been doing for almost 15-20 years now, that we always identify the lesion and we go transgastric in hilar lesion for an FNB, and I think the results are probably slightly superior than the brushing. But now with peroral cholangioscopy it has changed. Now coming to very rare cases. Now this was a patient who had multiple imaging, and you can see something floating in the bile duct here. Now these are the rare cases where biliary pancreatic pain, symptoms, abnormal LFT, and we are not getting anywhere. You think of a good EUS, you'll pick up something in the bile duct, and we picked up a floating fasciola gigantica, and it changed the management. What I'm showing you here is essentially all those cases which conventional radiology missed, and therefore I think EUS ERCP makes a lot of sense. So I'm just going to quickly go through this slide, and you can see this was a live fasciola which was floating, and that's why it was very difficult on conventional imaging to pick it up. Okay. Now coming to pancreas, we all know that, and I know that Rajesh is speaking on acute pancreatitis, but I want to share with you how specific we can be with endosonography. Look at this patient with one solitary gallstone, one episode of pancreatitis. It's a standard practice in my unit to do EUS in gallstone pancreatitis in pancreatitis, okay, immediately. You can see the whole bile duct here, look like a cholangiogram. So what happened, the gallbladder stone came down of the bile duct, went up to ampulla, and from ampulla it reflux in the pancreatic duct. This is the pathophysiology of biliary pancreatitis. A small stone actually reflux back in the pancreatic duct. So I don't chase the bile duct, I chase the pancreatic duct. Selective cannulation of pancreatic duct without contrast, because I already mapped the pancreas on EUS. This is the beauty of endosonography. We have a beautiful mapping of the ducts, and you intervene specifically for the pathology. See, I'm cannulating the pancreatic duct, wire, no contrast, because I've seen on EUS that there is only one small stone, do a pancreatic sphincterotomy, and we deliver this cholesterol solitaire, yellow cholesterol stone, which reflux in the pancreatic duct. Okay, so this is something which is very, very important. Recurrent acute pancreatitis. Now, I'm intervening in patient with acute pancreatitis. This is a patient who has acute pancreatitis in RAP. Okay, and see what we pick up. Multiple CT, MR, missed everything. See what we pick up. A small 3 millimeter stone in minor papilla. This is the CBD. This is the main pancreatic duct, and this is the minor papilla here. Can you see the minor papilla with a small stone? 3 millimeter stone. No imaging can pick it up for me in this as of now. Nothing can pick up. So what do? We go in, we do major papilla sphincterotomy, and now you see the minor papilla. Now this is what we are missing. Recurrent acute pancreatitis, small duct, we need to intervene. See the stone here. I am cutting the minor papilla, needle knife pre-cut, and the stones popped out. This is what we are missing in recurrent acute pancreatitis. So guys, small duct, you do EUS mapping, intervene. Okay? This is what is the message. And I've been saying this for last 20 odd years. I think we need to wake up. More good EUS centers need to be there. Now I'm going to skip that, but there are certain cases where young patients with recurrent pancreatitis with helminth, especially in the pancreatic duct. Here you can see a normal CBD. Now when the duct is not dilated, it is very difficult for other imaging to identify pathology, like an MRCP or something. So here, you can see here, there is a roundworm in the pancreatic duct. This is the CBD. This kind of diagnostic accuracy will guide your therapy. And therefore, I think EUS-ERCP interface is extremely important for even pancreatic disease. I'm going to skip, but I'm sure a lot of people would agree that when you do endotherapy for chronic pancreatitis, we always map. Look at this fluid collection in the tail of the pancreas. Now, when you have a chronic pancreatic fluid collection and you have to do endotherapy of chronic pancreatitis, we always map the pancreas. These are stones in the pancreatic duct. Look at this, this is a dilated pancreatic duct in the body with multiple stones. So what will I do? I'll cannulate the pancreatic duct. Okay? See what we do. Yes, I'll just finish in few minutes. And then of course we take out all the stones and then we put 2 stents. Always whenever there are multiple stones, I prefer to put, if it's a dilated duct, 2 5 or 2 7-French stents in the pilot endotherapy. Okay? For 20 years we are doing this. And then what I'll do, I'll aspirate out this small fluid collection where there could be inadvertent leakage of contrast, though there was no obvious contrast leakage in this cavity. And this combination of pancreatic endotherapy, EUS aspiration will make sure that patient has a good outcome. Coming to my last few slides, patient with a mass in the head of the pancreas. Why EUS is important? Because the brushing we did on ERCP in this patient was negative. And EUS FNB proved it was a primary tuberculosis of pancreas. And that changed the entire management of this patient, 18-year-old patient. And therefore, I think a combination of EUS, ERCP is very, very vital. So I'm going to skip that and go over to the biliary drainage, which I think Mahesh has already mentioned, EUS guided. So I'm just going to ask some final few questions for youngsters who are in the audience and even those who are doing EUS, that you need multi-center randomized control trial on these things. Nobody is doing it. And I think we hope that somebody will take it up. And I personally feel that endoscopic surgical intervention in biliary pancreatic area more aggressively, I think EUS evaluation will have a major role to play on deciding what kind of pancreatic endotherapy is beyond the scope of this time and talk today. I think units dedicated to deliver the highest quality of pancreatobiliary science, they cannot avoid EUS ERCP interface. Now it's up to you to decide. Jai Hind. Thank you very much.
On to our next talk. I would like to invite Dr. Rajesh Puri, who needs no introduction. Sir is a leading name in US and ERCP from all over India. Currently the chairman of gastroenterology at Medanta Hospital. And sir will be speaking on ERCP in acute pancreatitis.
Good evening, everyone. At the outset, would like to thank Dr. Anil for giving this opportunity. And I'm going to talk the role of ERCP in acute pancreatitis. I'm sure we all are aware now in 2023 when you should do the ERCP in acute pancreatitis, but let's recapitulate our knowledge where the place of ERCP in acute pancreatitis. So the quest is, if you look at 4 decades before, in the various animal and the human study, it has shown that the biliary obstruction lasting for more than 48 hours or the longer the duration of obstruction, that create more severe necrosis. And 4 decades before, people did the surgery for the biliary decompression, but it was associated with the high morbidity and mortality. And with an advent of ERCP, which is minimally invasive, people started doing the ERCP in a patient of acute biliary pancreatitis. So 3 landmark publication. First was in 1986 by Neoptolemus. Second is by Fan in 1993. These 2 trials favors that if you do an ERCP within 24 to 72 hours is going to decrease the morbidity and mortality and decrease the amount of necrosis going to happen. But the third trial, which was published by Follish in 1997 in NEJM, and that was completely contradictory to the first 2 trials, and according to trial which was published in NEJM, that if you do an early ERCP associated with the more morbidity and mortality. So there was a 2 difference of opinion till 3 decades before, and there was 2 thought: should we do early ERCP or should we do the conservative management? And the rationale for doing the early ERCP, as I said, the duration of the biliary obstruction is a major factor in determining the severity of pancreatitis. Longer the duration of obstruction, more severe will be pancreatitis, and if you decompress the biliary system, it is going to decrease the morbidity and mortality and prevent the progression of acute severe pancreatitis to the necrotizing pancreatitis. While in conservative group, the rationale was severity and progression is not depend on the duration of obstruction, it happened at the inception. And stone passed off in more than 90% of the cases within 72 hours, so there's no need to do the ERCP. So there is always be a debate which patient should go for an early ERCP and what should be the timing of ERCP, and that debate is still continuing, and I think in the recent year this doubt has been cleared, in which I am going to discuss. So the queries are, is the offending stone still at the papilla or it has passed off? Does the patient has a persistent biliary obstruction or patient has cholangitis? And what should be the timing or ERCP? Urgent is within 24 hours and early within 72 hours. So the urgent ERCP, as I said, within 24 hours and early ERCP within 72 hours. What has changed in the last 3 decades? There is an advent and evolution of imaging, as Dr. Vipul has nicely shown in his US images. You can map the entire CBD with the help of endoscopic ultrasound right from the porta to the ampulla, or places we have got an advance of the MRCP, we can clearly visualize both intrahepatic and extrahepatic biliary system, and there is improved understanding about the pathophysiology of acute pancreatitis according to the Atlanta classification. So let's talk about the 4 common clinical scenario. Patient might have a mild pancreatitis or severe pancreatitis and with or without cholestasis. And what is the place of ERCP in these scenario? So mild pancreatitis without cholangitis, 3 important studies or a meta-analysis, more than 700 patients, and all 3 meta-analysis shows there is no role of ERCP in a patient who has a mild pancreatitis without cholangitis. So the message is ERCP should not be recommended in a patient who has mild pancreatitis without cholangitis. Now let's talk about the severe acute biliary pancreatitis without cholangitis. And as I said, Follish study, which was a prospective multi-center study, and this study was prematurely terminated because in the ERCP group there was more morbidity and the mortality and more respiratory complication. So the overall rate of morbidity and mortality was similar, but the complication was more severe in the ERCP group. Mortality in acute severe pancreatitis was more in a ERCP group in comparison to conservative, and same the respiratory failure was high. And because of that, this trial was terminated. That shows that you should avoid even in the severe acute biliary pancreatitis without cholangitis. Again, a meta-analysis of randomized controlled trial, more than 450 patients, that shows early ERCP in acute severe pancreatitis, no reduction in the complication, no reduction in the mortality. The recently published paper in Lancet 2020 with the name of APEX study, that is a patient who has a predicted severe acute gallstone pancreatitis, multi-center randomized controlled trial, more than 450 patients, and the primary endpoint was mortality or the major complication, and the secondary endpoint was the complication. And this study shows that there was no difference if you do an ERCP or if you do a conservative treatment. They did the subgroup analysis and they compare a patient of predicted acute severe pancreatitis with cholestatic jaundice or without cholestatic jaundice. Again, there was no difference in the primary endpoint in terms of mortality and the major complication. This is a recently published, I think 3 months before, in Gut, again by the same group, that is an APEC-2 study, multi-center control trial, 83 patients. And what they did is, they did an EUS in those patients within 24 hours of acute biliary pancreatitis, and again the endpoint was major complication or mortality within 6 months, and that shows there was no difference even if EUS shows a CBD stone in the bile duct and you do an ERCP in first 24 hours or you treat these patients in the conservative group. So severe pancreatitis without cholangitis, the answer is no need of ERCP. Now let's talk about the severe pancreatitis with cholangitis. I have talked about the neoplasm study which shows ERCP is useful. Sanford, which shows when you do an ERCP versus conservative, less complication in the ERCP group, less necrosis in the ERCP group, and mortality was less in patient of an ERCP group if there is a cholangitis. This is a Cochrane meta-analysis, which is a meta-analysis of 5 randomized control trial, more than 600 patients, again early ERCP versus conservative, and it has shown that a patient with cholangitis, if you do an early ERCP, it decreases the necrosis, it decreases the major complication in terms of morbidity and mortality. So this is an ESG recommendation 2018 that an urgent ERCP and biliary drainage in patient with acute biliary pancreatitis combined with the cholangitis. ERCP should be performed within 72 hours in patient with ongoing biliary obstruction without cholangitis, but this is a weak recommendation with a moderate quality of evidence. And ERCP should not be performed in patient with acute biliary pancreatitis. Either patient has no cholangitis or no ongoing biliary obstruction. So according to the ESG, there was no difference in the outcome with or without ERCP, and according to the timing of ERCP, except in a patient of cholangitis. Now the biggest question comes, and I'm very sure audience is going to ask me, how to differentiate a patient has a surge within 24 hours in acute predicted severe pancreatitis versus cholangitis. So this is the biggest question, how will you differentiate? Because patient has leukocytosis, patient might have fever, mental confusion, hypotension and the jaundice, both in the surge as well as in acute cholangitis. So this can happen in both the conditions, and ultrasound has a poor sensitivity, dilated CBD also has a poor sensitivity of diagnosing. So the two important modalities, MRCP and EUS, I just want to differ from little bit from Dr. Vipul. The places where the EUS is not available, it's always better to do an MRCP rather than doing an ERCP. And MRCP has a very good sensitivity and specificity for picking up the stone. The only specificity goes down if the stone is less than 6 millimeter, where the EUS score over this. So if you have a facilities of EUS and ERCP, MRCP both, it's better to do an EUS, but if EUS facilities are not available, it is better to do the MRCP. As I said, MRCP has a limited accuracy for the stone of less than 6 millimeter. In a patient of predicted acute severe pancreatitis, there's a breath holding is difficult, fluid sequestration may impact the image quality, and there is always be a lag You do an MRCP today and you are doing the ERCP on the next day, there's a probable patient stone might have passed off from the bile duct. And again, the MRCP is operator and the scan dependent. While the EURCP, EUS is superior accuracy, real-time dynamic imaging in the same table with the same sedation, just changing the scope from EUS to the ERCP without any lag. So I think EUS score over that, but EUS is again operator dependent and EUS access is not universal. So algorithm wise, if patient of acute pancreatitis comes, mild pancreatitis, if has an acute cholangitis, do an ERCP. If there is no cholangitis, then it is better to do a conservative treatment. Severe pancreatitis, suspected biliary obstruction, do EUS and MRCP, find out if there is a cholangitis, do an ERCP, otherwise do a conservative treatment. So to summarize, ladies and gentlemen, ERCP in acute biliary pancreatitis with cholangitis should be performed. Biliary obstruction should be confirmed before doing the ERCP, because I still remember when I was a resident, a patient of acute pancreatitis with a mild biliary obstruction. Patient has a hyperbilirubinemia with a raised SGOT, SGPT, and patient is subjected to ERCP. ERCP, although is still an invasive procedure, and you may deteriorate these patients and mainly the respiratory issues. So EUS and MRCP are comparable for the diagnosis of biliary obstruction. Presence of the CBD stone is not the indication of ERCP. Presence of a cholangitis is an indication of ERCP. Aggressive hydration must be done even while shifting the patient from ward to the ERCP table, because this happens, there is a lag, patient shifted from ward to the endoscopy room and from endoscopy to the ward, and there is a lag of time for more than 4 to 5 hours, and that is a crucial golden time to replace the IV fluid. So never forget, even you are subjecting these patients for MRCP, EUS or ERCP, don't forget to hydrate the patient. If I were given one life advice, it should be think before you do, don't repent after doing. Thank you for the patience hearing.
Thank you, sir, for a wonderful talk. I think it clears a lot of doubts about EUS in or ERCP in pancreatitis.
Now for the next presentation, I would like to call upon Dr. Naresh Bhatt, and the presentation is Screening of Early Gastric Cancer, When, to Whom, and How.
Thank you. It's late in the day and I know a lot of you are tired, so I'll try to make it as brief as possible. Address some of these issues. We know that early gastric cancer is important because, in contrast to advanced gastric cancer, if the cancer is limited to the mucosa or even in the submucosa, the 5-year survivals are upwards of 95%. So you have a great prognosis if you can diagnose this early. So the first question is, how do you pick up these lesions? And it starts off with your history, who may be having these lesions, and they are people who are smokers or users of tobacco, patients who have chronic H. pylori with atrophy, they have an upper aerodigestive cancer, so they can be synchronous or metachronous lesions, which can occur in up to 15% of patients can have a gastric neoplasm, and up to 7 to 8% can have an esophageal neoplasm. And of course, a family history of cancer in the upper aerodigestive tract again is a risk factor. So if you have any of these patients in your endoscopy room, be on guard and look at them more closely. We all know about the Corias cascade, and that we know that H. pylori is a major driver for gastric cancer, and it goes through several phases, right from a multifocal atrophic gastritis to intestinal metaplasia, dysplasia, and cancer. While this can take many years, it's important that we learn how to recognize chronic H. pylori infection when we do an endoscopy. And I've just put a little slide here. which tells you that there are different things which tell you about atrophy. The presence of a xanthoma is a sign of chronicity. You have these enlarged folds and reddish spots. You have hyperplastic polyps. You have a kind of a nodular gastritis or intestinal metaplasia. Now all these, one needs to train yourself in recognizing these, because if you have this, then you know, yes, that this patient has got a much higher risk of an early gastric cancer, and you would invest more time in interrogating the mucosa of these patients. Now in this, two things are important. One is the amount of gastric atrophy, and you find that the gastric atrophy which is most severe, the higher the incidence of gastric cancer. Second is intestinal metaplasia, especially if it's both in the antrum and the corpus, the rates are much higher. And of course, it's a no-brainer that if you have dysplasia, then they are likely to have cancer. So one must train your eyes to recognize atrophy, especially severe. If there's intestinal metaplasia, especially if it is widespread, and of course, look for dysplastic lesions. Gastric atrophy generally looks that there's a discoloration of the mucosa. It looks a little pale, the vessels are prominent, and there may be a little rough surface, and the folds disappear. So this, if you see it not only in the antrum but in the corpus, again we know that this is a widespread gastric atrophy. Now these are pictures of intestinal metaplasia. I'm sure you see this quite often in endoscopy rooms, but might not have given it importance. But these are silvery areas that you see, or they may just be flat red areas that just get dismissed as gastritis. No, I think we need to call it intestinal metaplasia because there's a substantially higher risk of finding EGC in these group of patients. And there is something called the LBC, which if you use NBI and magnification, you can pick up these kind of little bluish lines there, which tell you that this is almost very specific for intestinal metaplasia. You can see this on the thing, those whitish, bluish lines that are seen are very, very typical. Now, when do we start suspecting? This is, we know that the background mucosa is something, there is some chronic problem there, so he may be having a lesion. So the suspicious lesion is, there are three characteristics. Either it has an irregular margin, an irregular color, or irregular surface. Any of these should alert you to the fact that this may be an early gastric cancer, and hence you need to interrogate it appropriately. You can use advanced imaging modalities like NBI or LCI, whatever you have, which will tell you, like in the upper panel you'll find that using LCI you can find those silvery areas very well brought out. This is obviously, they're showing a lot of intestinal metaplasia, and using LCI, if you just, with the press of a button, you can find that on the lower panel on the right side, you find a kind of a purplish hue. Now this is very strongly predictive that there may be a malignancy in that area. So just think, these don't take too much of time. Just by using these modalities, these are red flag techniques which help us predict and interrogate these lesions more carefully. So the sequence therefore goes, recognize an area of abnormality, look at it closer, use chromo endoscopy or digital chroma endoscopy or magnification endoscopy, and then prove that you have a sinister lesion. Believe me, these lesions are not more than 7 or 8 mm in size. But if you see, once you magnify, you can clearly make out that is an area which is definitely abnormal. You can take a biopsy and prove the diagnosis. And with the current endoscopes that are now available, the surface of the mucosa can be characterized very accurately just by looking at the microvessels and the microsurface. And here you can clearly make out this is an area which is clearly abnormal with abnormal vessels, and very easy to make out that this is an early gastric cancer. And one small biopsy which is targeted will give you the diagnosis. When I went to Japan, I was observing a lot of endoscopies, and I kept asking these guys, is this EGC, is this EGC? They said, be patient. EGC is not as common as you think. So I looked at this recent study that looked at about 4,500 patients with high risk for EGC. High risk meaning these were patients who had had a previous esophageal or gastric cancer. So they were really the very high risk group. And we found that white light endoscopy picked up 1.9%. The newer generation of NBI scope picked up about 2.4%. About 25% of EGCs were missed, even with these techniques. And when they biopsied these suspicious lesions, at most 20% turned out to be malignancy. So therefore, the number of early gastric cancers in the community, even in Japan, is not very high. It is low, but if you look for it carefully, you will find those patients, and over a period of time, you will have your first 5 patients, 10 patients, and 20, 30, and in that sequence you keep accumulating. So in India, we do not pick up EGC to any great extent. And why is this? As I said, even in Japan, in high-risk patients, the number was about 3%. And even those lesions that they biopsied, only about 20% came positive. So that means we over-suspect, but are not able to prove in a lot of them. And what are these patients? These patients, their mean age was about 70 years. They excluded those patients on antiplatelet drugs to avoid interrogating those erosions that we keep seeing in these patients. They eliminated patients who had a previous gastrectomy or serious comorbidity, and they eliminated patients who have an emergency endoscopy. In India, our mean ages are perhaps much lower. All endoscopies are emergency endoscopies because we do 2-minute and 3-minute endoscopies. So obviously our pickup rate is not going to be high. So while we can say that yes, our numbers are high, the total number of EGs are low, and hence we are not picking, but the simple fact is that we are not making enough attempts. And those people, I know there are a lot of people in the audience who are making that effort, and they are finding EGCs. So what do? We need to improve our quality of endoscopy, have a clean field, use simethicone, acetylcysteine, use magnification, use a high definition monitor to give you better images, use a water jet to clean the mucosal surface, use imaging techniques like M.I.C.E, chroma or equivalent technologies, use a cap-assisted endoscopy, you are able to interrogate them better. But most important is give time and patience. Evaluate every bit of the gastric surface systematically. Interrogate every suspicious lesion, and believe me, it does not take more than 7 to 10 minutes to finish that procedure. And biopsy liberally and make it targeted so that you don't take 4 or 5 biopsies. Just go to that thing and take 1 biopsy, but make it a targeted biopsy. And so, whom do? You can screen patients as much as you want, but remember, every endoscopy is an opportunity to pick up a lesion. Thank you.
Thank you, sir, for the excellent talk. We have now discussed regarding EUS being extremely useful in biliary pathologies, pancreatitis, as well as early gastric cancer. We shall now discuss about the future of endoscopic ultrasonography. I request Dr. Malli Sharma to please guide us regarding the future of EUS. Thank you, sir.
Thank you very much. I thank Dr. Anil Arora to discuss this topic. And so what are the roles? 5. Tissue acquisition. There will be radio frequency ablation. So this is 40, 40, 10, 10. In the percentage I decide, I thought that I will divide this is 40%, 40%. So it will be risk reduction already discussed because CP is the most dangerous procedure and we have to reduce the risk, and this is a case where we found endoscopic ultrasound and we found microlithosis in a patient. So guidelines are not rules. Don't form guidelines, follow guidelines, because in this case, if you had followed guidelines, you would have fumbled. There is a stone in pancreatic duct, there is a stone in bile duct, and there are these 2 stones, and how did this stone ever come back? Because it's migrated back from the pancreatic duct. So we have to be careful. EUS is important when you're doing ERCP. Be careful because this is a stone which has migrated back into the pancreatic duct, and these stones are going to hide in the pancreatic duct. So where is the rule that you should be doing is these small stones in the ampulla. These small stones are there in the ampulla and they need to be seen. Although this has been discussed, and as again said, MRCP versus EUS, nothing beats EUS, sorry about that. You have to do a dedicated EUS, it allows, and it is better for ampullary stone, and it is better for those stones which have slipped back. So 2 heads are better, but certainly I would say EUS would be reducing the risk. Second is staging. Staging is the real test. I find it surprising that there are pancreatic protocol, there are different kinds of protocol, and I find it that gastric cancer, EUS is not included as a protocol. Why? Because somebody in Japan or somebody who was deciding the protocol decided not to include it. So I don't know why. But tumor staging, it is a multimodality staging where there is a feedback is given in tumor board, and when they are fighting together, then the histopathologists are telling, no, you are right, you are wrong. Where are those nodes I told on EUS of 5 millimeter nodes? Who missed it? CT scan people missed it. So the third indication would be establishing bypass, and what bypasses will be there? Bowel to biliary tract, bowel to pancreatic collections, and then bowel to pancreatic duct. Just a figure that this is bowel to pancreatic duct. Anastomosis, they will be more and more common, and I am finding it more useful, especially when there is pancreatic, acute traumatic pancreatitis followed by pancreatic ascites or leak, to be able to drain these this disconnected duct, permanently disconnected duct by pancreaticogastrostomy in acute traumatic situation. So bowel to pancreas and then bowel to bowel. Now which part of bowel can be anastomosed to another part of bowel? Okay, broad principle. Stomach is a part of supracholic compartment of peritoneal cavity, and rest of the compartments are infracholic. So when you are doing bowel to cyst, you are going from peritoneal cavity to retroperitoneal cavity. But you are going from bowel to bowel, you are going from supracholic compartment of peritoneal cavity to infracholic compartment. So this is stomach to jejunum, stomach to ileum, stomach to colon, ileum to colon. These are the different combinations that you can do. Colon to bladder, when there is a tumor, rupture, colon to and then colon to ureter. So these are the different kind of anastomosis. Bowel to not bowel, bowel to lumen to lumen, lumen to lumen. The third will be vascular obliteration. So this will be 10%. I am trying to give a rough percentage. So diagnostic evaluation 40%, tissue acquisition 40%, establishing bypass between different lumens, whatever lumens can be used, vascular obliteration or revascularization. So vascular intervention will be the real future, because the blocked vessels will be opened and the opened up vessels will be blocked. So this is an uncharted territory, and though we have done, this is the number of cases that I mentioned. This is a slide, is older slide. We have done much more now. We have done more than 250 cases. So what is the principle of chartering? Because you have to block the unblocked vessel which is bleeding, and then this is identified. So there are experts, seniors, my seniors, all these, my teachers are there. But if I ask them to show the figure, one figure is from the stomach, one figure is from the duodenal bulb, and I ask them to figure it out. What is this? And this is the figure again, unblocked vessel. This is after, the third figure is after fundal varix. Patient is bleeding. And then this is the fourth figure in the middle is again a fundal varices, and the last figure, which is on the right hand side, is, so this you figure. The problem is, if I go back, the first, this is a satellite varix after two. The second one is a duodenal varix. The third one is a base of ulcer after extrusion of the glue. And the fourth one in the middle is a gastric varix. And the last one is a rectal varix. So we will be knowing the territories of EUS guided vascular intervention. We will be deciding how do we handle these varices, and there will be vascular intervention will be the most common feature, because these are the different type of issues which will be there. For example, there is bleeding from the ampulla, and we will be able to diagnose hemosuccus pancreaticus. Then there is again an ulcer. We are not sure ulcer or dewlaphoid, but this is a dewlaphoid ulcer, and we will be seeing dewlaphoid ulcer by diagnostic. Then there is requiring puncture of portal vein. The portal vein will be punctured, the aorta will be punctured, all vessels will be punctured, just diagnostic issue or whatsoever reason. There is no problem. Our friend anesthetists have been puncturing all these vessels into the jugular vein. So why can't we? Even we will be going through the aorta, and we will be puncturing the aortas and the jugular veins when we have to obtain a diagnosis. So we will be going through the aorta. So this is the puncture of portal vein thrombolysis. Diagnostic punctures will be done for portal vein thrombosis, and from puncture we will move to intervention, and there will be blocking of vessels. And what vessels will be blocked? Arteries, veins, everything will be blocked by coils and glues, and then there will be coils in more precision, as I am seeing, and we are following the practice, will be replaced, especially in fundal varices. There will be no more coils, because the clear-cut papers are coming that all you have to do is just properly inject glue at the correct place. So this is the muscularis mucosa, and we are seeing that in this case we have injected coils, and in the coil when we injected, they went into this place, and then the coils were injected. The evaluation of ectopic varices will be done. They will be done properly. There will be duodenal varices, and they will be banded again like. Then apart from the duodenal varices, these are the duodenal varices again. You will see the inflow, outflow coming from below upward, and the duodenal varices should ideally be taken care of very easily by application of band rather than a very complicated procedure of banding. There should be routine evaluation. We are finding it a lot, doing it a lot, finding it a lot is the sense, because there will be rectal variceal evaluation. When you find blood in patients who are losing blood, and then we see follow the theory that the rectal varices is a downflow, same as esophageal, the downflow, and the varices should be obliterated at the highest point of inflow at 10 centimeter distance from the anus, and not at the lowest end as people say or as people think. So this is the bleed in rectum. As I said to a few of the figure, this bleeds in rectum was a rectal varix which was banded, but there was rebleed, similar appearance, surprisingly, and rebanded. Why? Because this was rectal varices masquerading as a duodenal ulcer, and that is why always will be banding of the varices. So this will be intervention. Then will be management of non-variceal bleed. For example, this is extrinsic tumor bleeding, we couldn't stop it. So we were able to inject the coil directly into the gastroduodenal artery So there will be US guided intervention of gastroduodenal artery, which can be very easily seen once you see. So this is the, then there will be management of pseudoaneurysm, which is largely at our center. Interventional angiography in India practically is not easily available at many centers. I think the ratio of availability of EUS versus good interventional angiography facility is 1:10. So people who use EUS will be doing EUS guided intervention of these pseudoaneurysm, and these pseudoaneurysm